Edwards was founded in 1958, and our focus has always been on the patient. For the last 60 years, we have been attempting to improve the quality of life of every patient that our valves treat. In 1981, Edwards introduced the first tissue valves based on technology that was developed by Dr. Carpentier. Since then, we've enhanced that technology and the performance and the designs of our valves to meet our customers' expectations. Our transcatheter valves have built on the technology we developed in our surgical valves. We've been using those known proven technologies to further enhance the development of the transcatheter products. Our processes and leaflet selection have been engineered to enhance the long-term performance of our valves.
With SAPIEN 3, we've leveraged our experiences with our earlier generations of balloon expandable platforms and combined that with new technology and new learnings from our team. SAPIEN 3 was designed for circularity, which is important because it helps lower stresses on the valve and also helps to reduce the risk of calcification. SAPIEN 3's cobalt chromium frame was built to resist fatigue. In product design, we utilized a lot of different tools to analyze and develop the right frame structure. One of these tools was FEA, or finite element analysis, which was used to analyze the stresses all around the valve frame and to ultimately strengthen it even more.
When we have a new concept, we have to take that from the drawing board into a prototype. And that prototype has to meet the same requirements that our finished products will have.
Once we're ready to commercialize a valve concept, we do a lot of feasibility and iterative design testing. We then can move forward with the design verification testing. Edwards must achieve 100% pass rate on every test we perform. And not only do we require that we pass our own standards, but we are also required to pass the rigorous ISO standards, which include tests for hydrodynamic performance, effective orifice area, pressure gradient, regurgitation.
We are testing valves that are under-deployed, valves that are over-deployed, and valves that are even in oval shapes.
In addition, we also perform accelerated wear testing, which simulates the aggressive environment of the valve inside the body. When we place the valve in the tester, we are running these valves at about 1,000 RPM. Every Edwards valve is cycled up to 200 million cycles, which is equivalent to 5 years of in vivo testing. And we've even tested our SAPIEN 3 valves up to 1 billion cycles, which is equivalent to 25 years, and we've seen no evidence of valve degradation.
Here at Edwards, our product development really depends on a close relationship with our customers. And we are very confident that the technology and testing performed here leads to products that meet the performance expectations of both our clinicians and our patients.
Kalimera. Good morning. Welcome to the second day of the Transcatheter Heart Valve Meetings 2022. It's my pleasure to open this early morning session in which we're going to listen a lot about the latest developments, trials, device iterations on transcatheter edge-to-edge repair in mitral valve, tricuspid valves, and also in transcatheter mitral valve replacement and tricuspid valve replacement. We're very pleased to have today with us Professor Toutezas from the University of Athens, who is going to give us the first lecture with all the latest about the MitraClip and the TriClip devices, iterations, and trials. Kostas, good morning. Welcome.
Good morning, Kostas. Thank you very much for again being here, and congratulations for your very good, very nice transcatheter symposium that you are having for 2 days. Now, I have, I think, 12 minutes. This is the time limit that I have, so I'll skip on and go fast enough. We had, regarding the tier guidelines, you can see that the evolution was really slow compared to other transcatheter therapies like TAVI. However, the last years, we had an evolution regarding guidelines and the clinical practice of TIR. Very quickly, just to take as a take-home message, as a 2A, we have the edge-to-edge mitral valve repair should be considered in carefully selected patients with secondary mitral devastation, not eligible for surgery and not needing coronary revascularization, and who are symptomatic despite optical medical therapy and fulfill criteria to achieve a reduction in heart failure hospitalizations. It was very important regarding the upgrade of TIR therapy because we now have really opened the field and the numbers of doing. The primary is still to be TIR may be considered in symptomatic patients who fulfill the echo criteria of eligibility. That's the same as previous. And these patients have been judged as inoperable or at high risk, surgical risk by the heart team, and who are the procedures don't consider futile. So the take-home message is for secondary, we upgraded. For primary, we have the same findings like before, with the same recommendations. Now, this is a case I want to share with you. 82 years old, secondary MVR. You can see it. It's important, it's significant. LV remodeling. This case has been upgraded by the guidelines. We treat it by TIR, transcatheter edge-to-edge, and we are following the steps of the proper puncture of the ASD, the proper distances, and you can see, of course, the procedure that we are very familiar with. We're trying to be vertical to the mitral annulus, and after that, we're trying to achieve a better, the best result that we can achieve by getting this to, the mitral valves, the mitral valve. I don't know why it stopped now. This problem here. I didn't have such problems with the computer, and now I'm again back to that. Okay. I have opened it twice, that's why, that's it. Okay. After the implantation of after the TIR, you can see how the mitral valve regurgitation has improved compared to the previous echo study. So this gives us, the upgrade has given us this opportunity. Now, regarding the prolapse, the mitral valve prolapse that we have in this patient who is 71 years old, we are still following the previous guidelines to be. However, such patients, we can treat them, we could treat them, and we can treat them. This is a special substrate of hypertrophic cardiomyopathy, as we may appreciate by the echo. who have a prolapse, some non-significant LVA2 obstruction, no previous surgery. The patient was really symptomatic, and we had to treat him again with TEER. We did it successfully. You can see it after two clips. You can see the hazing in the contrast, the hazing in the left atrium, demonstrating that we really improved mitral valve regurgitation. And we are doing also our study demonstrating the pressure volume loops before, after the first clip, after the second clip, and this is accompanied by the real improvement of pressure. Now it's under consideration to be published in international journal. Regarding the later clinical trials, I think the most important thing that we've seen the last year was the expand of G4 study. This was really important, and you all know the advantages of G4 now, which is especially the XTW, has given us much more comfortability in the procedure. These were the latest trials with the expand study with 1,000 patients in expand G4 study phase 1, 101 patients, and phase 2, which is an observational study, which is still ongoing with over 1,000 patients demonstrating this. They are trying to demonstrate the advantages of this study. The expand study very quickly with 1 year outcomes with primary and secondary MR, and you may appreciate that it was a very high risk population, almost 17, 80 years of primary and 75 years old in the secondary group, 84 overall study follow-up, and you may appreciate that mitral cardiac regurgitation at the baseline was really significant, +4, 3, and you can see that it's almost gray in the follow-up in the majority of the patients, achieving almost 91 and 92% improvement of MR. So it's a sustainable result, and it's really a comfort for us in the cath lab. This was also accompanied by very great improvement in the quality of life. I'm skipping this for time. There was a 63% reduction in heart failure hospitalization rate at 1 year post-mitral clip, and there was unparalleled clinical outcomes with the expand study demonstrating higher MR reduction, largest 1 year improvement in quality of life, highest reduction of annualized heart failure state, and generally was very well accepted. Now, regarding the phase 2, expand 4, up to date we have 529 patients, again very high risk, 77 years old, STS replacement score 7.5, and the majority in atrial fibrillation, with an ejection fraction of 47%. And you can see here the differences. Now, the clip mix that we have now were 3 combinations. The majority was treated by the XTW only with 1 clip. This is very important because now we have really discomfort to use it compared to the previous years. And the implant rate was 97.2%, acute procedural success 97%, device time very low, 34 minutes. This is really important. And the length of the stay of the patients was down to 3 days. Really important. And this was accompanied by very significant, very nice improvement in all these parameters. NIHA class also very substantially improved from the baseline to the 30 days, and we have an improvement of the quality of score. So in the expand G4, in this 500 patients, almost 500 patients, we have, of course, the added experience with 1.5 all-cause death at 30 days, and a significant reduction of all the complications that were observed in the previous studies. So I think it's really important, and without compromising the result, we have a mitral gradient of 4.4 compared to almost 4 in the expand study, with this difference of 1.6, not significantly different. So again, we have very important outcomes that I already demonstrated you, but enables this therapy to be easier and faster and safer. Now, regarding the TriClip, we're also gaining some experience. Kostas has greater experience in TriClip. We are trying to, actually, technically, I think it's not so demanding. The problem is which patients should we select. We have the 2 years outcomes from the TriLuminate, and it shows that TR reduced by more than 1 grade in 85% of the subjects, consistent with this observation at 30 days. The TR reduced to moderate or less at 30 days at 62%, and it was sustainable, this result. Here is the baseline at 30 days, and it was sustained improvement of NICA class. Over 2 years, this is important, and this was also accompanied by improvement of the quality of life, sustainable at 2 years. Again, important findings, with all-cause mortality rate remained low at almost 19% at 2 years. So it's low because we are dealing with a very high-risk population. The BRIGHT study with the TriClip, which was a retrospective multi-center arm, this analysis, they have all the echo data, and they are trying to gain experience with TriClip in this population. In 200 patients, you may see that the annual diameter was 4.7, very heavy, significant improvements in all these patients. The primary endpoints, acute procedural success, and secondary all-cause mortality at 1 year. They include patients symptomatic with very severe TR, high risk for tricuspid surgery. Characteristics, 78 years old, with a very low NICA class, functional class, 3 or 4, so significantly symptomatic patients with very increased PA pressure and pro-BNP. Clip usage, 94%. The XT and the XW. This is also an advantage that we have in these subjects. The TR rate reduction at 30 days was in 115 patients. In 42%, it was more than 3. And in 30% was more than 2. So in 72, if you add them, we have a good result at 30 days. Successful procedures in a wide range of annular sizes, especially if we go to the right graph. And the acute procedural success, as I told you, was 94%. NICA functional class, very improved, 76%, very improved, 7 out of 10. This one case that we performed also, you may appreciate, it was a massive PR. I don't want to get to many technical details now, but after implantation of the TriClip was really improvement of the TR in this patient. So, to conclude, optimal guideline directed medical therapy is the backbone of every, of course, patient. However, patients with persisting and progressive symptoms, mitral or tricuspid regurgitation, seem to be a guideline directed medical therapy and should be referred to specialized facilities. Patient-specific treatment recommendations should be discussed by the heart team. Thank you very much, Kostas, for your attention.
Kostas, thank you very much. It was an excellent presentation, and you showed us all the latest developments with MitraClip and TriClip. It appears that there were a lot of clinical needs that were unmet and are now met with the newer iteration of these devices. And it seems that the thinner devices, the NT, are almost abandoned, and in more than 90% now of the patients we're using the wider device. So this was a very welcome development on the part of MitraClip. Do you see any other needs that are still unmet in this field? Would you like to see something in future device, some features that you believe they're missing now?
Yes, very interesting question. I wouldn't tell for the tricuspid. Tricuspid, you have great experience in that. We're trying to gain our learning curve. I would say only one word, maybe imaging should be improved in this procedure. I mean, technically, it's not so demanding. However, we don't know exactly which patients are really gaining the procedure improvements. You saw that in 72% we had improvement, great improvement. So we need to find more. So we have to meet all this, as you said, needs. So imaging, clinical selection of these patients is there are two needs that we need to get improved. Regarding the MitraClip and the therapy for the mitral valve, I think now with, as you said, with the technology improvement, we are very satisfied. We are in a very good, safe environment. We are having great improvement of the MR. So I think we are getting a plateau over there. Of course, if we have other devices like Pascal that we also have great experience, and you are one of the pioneers in the Pascal device. I don't know if it will be improved really significant, but I think we are in the right projection, in the right way. And finally, the guidelines are dedicating now and they are upgrading the tier in mitral valve. We will see also in the tricuspid valve in the future.
I agree. I think we're reaching a plateau in the technical developments. We now have in our devices independent clasping or grasping in both devices. We have continuous hemodynamic monitoring, and we have taken the SLDA incidence down to 1%, as you've told us in the latest Expand G4. These numbers are really very satisfying, and it's difficult to see newer iterations in these devices unless we reach to a point when we can completely implant and then recapture a device after complete implantation. That will be the ultimate safety, I think, endpoint. We have Dr. Kourouklis here who has a question for you, Kostas.
I cannot hear you very clearly.
Spiros, why don't you come here?
Good morning, Kostas. I'm Spiros Kourouklis from Aegea. How are you? Thank you very much for the excellent lecture. I would like to ask you something about the first case you showed us, about secondary MR. I saw that the patient has a pacemaker, a VVI pacemaker. And if ventricular pacing was more than 20%, we know that electrical and mechanical desynchrony might play a crucial role for the MR. Do you think that in this patient would first be upgrade the VVI system to a CRTP system and then to put a MitraClip, or the right sequence is first MitraClip and then CRTP? What's your opinion? It's a very often clinical problem.
I fully agree with you, Spiros. I don't remember now the case that I'm sure that we've already talked with your colleagues, electrophysiologists. I cannot give you now details, but I fully agree with you. We have to go after OMT to a fully resynchronization therapy. And I'm glad that I heard during the last 15 days that you are also pointing out to go to the HIS bundle to have better resynchronization therapy. So in the following years, I believe that if this his bundle pacing will improve also the resynchronization, we're going to see less MVRs actually take a this is a question that you should tell us what's your feeling, what's your in this future project.
Yes, till now the strong indication is to upgrade to CRT, as you know, but of course in cases that we cannot implant the CRT or the CRT the patient is not responder, we can have a plan B to go for his bundle pacing or left bundle pacing with excellent results. But we still need randomized trials to have more data on this. Thank you, Kostas.
Just a word of caution about his bundle pacing. I don't know if the positioning of the electrode in this situation increases the possibility to impede the tricuspid valve and have more tricuspid regurgitation when we do this mode of pacing.
Yes, you are absolutely right, because we have to implant the lead very, very high near the septum, and you know that the septal leaflet is just there, so we may have a worsening of TR, and but we don't have many data till now, only case reports in cases, so we still need data.
And there are trade-offs for everything we do sometimes. That's why we need to research and investigate well before we go. Kostas, thank you very much. And now we have back to MitraClip and TriClip, and the newest about Pascal and Ace by Dr. Christo Harris. Dr. Christo Harris, the podium is yours.
Good morning. I will present the Pascal platform for treatment of mitral and tricuspid regurgitation, what developments we have in this very important device. We see the timeline of Edwards Life Sciences portfolio of therapies for mitral and tricuspid interventions. We were very happy to be part of the early studies of the Pascal device. We actually had the second implant in the world done in our institution. And since we've been through this technology all these years, and we're very happy to see it flourish. So Pascal's adoption is driven by an increasingly large and compelling body of mitral evidence and experience. We have over 4,500 patients totally treated with the Pascal mitral device, with more than 3,800 patients with reported data, and more than 450 patients in studies with at least 1 year follow-up. As we know, the Pascal device features broad and contoured paddles that create a wide area for simplified leaflet capture with less wall stress on the leaflets. The skeleton of this device is nitinol, which provides for an elastic, super elastic frame that flexes when loaded. In addition, we have the spacer, which is a very important feature of this device, with the goal of decreasing filling the regurgitant orifice and decreasing regurgitation. In addition, the spacer offers the benefit of reducing leaflet stress and also improves open orifice area, allowing lower gradients. We see on this schematic on the right-hand side that when we had without the spacer, we have an opening orifice here that is, for instance, in this model 156. If you have the spacer in position as well, that allows for a larger diastolic orifice area. In addition, that decreases the stress on the leaflets, and that's a very important feature. The Pascal ACE is a newer iteration of the Pascal device. It features narrower paddles at 6 millimeters instead of 10 millimeters. It is designed to navigate through dense chordal structures, especially in the commissure areas or in the tricuspid space. It's thinner than the regular Pascal device. It also allows easier visualization during leaflet capture. And again, the clasp width is similar to the paddle with the Pascal Ace device. The other major advancement with the Pascal device has to do with the delivery system and the stabilizer on the table. Now we have a rail-based system with a single table that allows for axially alignment of the catheters with secure stabilizers. This is designed to reduce unintended movements and enhance procedural efficiency. We see before on the top screen, we have the two-table configuration, but the newer device will have the stabilizer with a rail system with single table, and everything will be actually aligned and secured in a different position. Now, we know for the Pascal device, we have two ways of capturing leaflets. One could be synchronous, both paddles, clasps dropping simultaneously, with the option then of optimization. You see on the left side of the image that we have simultaneous clasping of the leaflets, and then opening of one of the clasps to better insert one of the leaflets and full enclosure. The other way of doing it is to go first for one leaflet, and then move on to go to the second leaflet, which is also a feature that we occasionally use in the mitral space, but we use it even more in the tricuspid space. In addition, also we know from the Pascal device that they have the feature of elongation. That means that if we get caught in the subvalvular apparatus in the cords, it is the feature of elongation has to do with the fact that the device becomes very thin, like an arrow, and it's easy to escape a difficult situation. So that means there's less risk of entanglement in the subvalve apparatus. You see here on the fluoroscopy this elongation feature and how the device is able to be withdrawn from the ventricle by doing that. In all, TMTT is delivering a rapid cadence of innovation in transcatheter edge-to-edge repair. We have a versatile implant to safely navigate even challenging anatomies, atraumatic clasp control to optimize patient outcomes, and a compliant implant that is designed to respect native anatomy. And this is expanded now with the use of the Pascal Precision system for the delivery, which is engineered for intuitive user experience. We have optimization of the catheter to enhance navigation and enhance performance in clinical use. It is expected that the Pascal Precision will obtain FDA approval in late 2022 for degenerative mitral regurgitation cases. As far as the tricuspid clinical evidence, we have promising clinical evidence that demonstrate the diversity of the ability to offer edge-to-edge repair in patients with tricuspid regurgitation in a safe manner. In general, Edwards has over 1,500 patients totally treated with tricuspid portfolio, which primarily includes Cardioband for the tricuspid annulus, Pascal device, and also the Evoke that you're going to hear about later. There's more than 500 patients with reported data and over 150 patients, study patients with more than 1 year follow-up. What we're looking forward to is the CLASP II TR study, which is essentially a study comparing a TriClip device for severe tricuspid regurgitation, the Pascal device for severe tricuspid regurgitation with a comparison arm of medical therapy with a plan to enroll 800 patients and follow up 5 years with clinical outcomes being primarily all-cause mortality, heart failure hospitalizations at 2 years post procedure. And with this, I would like to conclude the presentation on Pascal device and the latest on this device. Thank you very much.
Thank you, Michalis. I'll ask you the same question I asked Kostas earlier. Clearly, Pascal came to give us many solutions and to meet a lot of clinical needs that were unmet before, like independent grasping, like a different mode of capturing the leaflets. Do you see any other needs that are still unmet, and what would you like to see in the Pascal device in the future? Do you see any further improvements there?
Yeah, I think, especially for the tricuspid space, I think guide-to-edge repair is very promising. There's a large unmet need, and the main issue we have at this point is, number one, imaging. We have, despite all the developments that we've had, still imaging remains a problem, and we have fluoroscopy times that sometimes are significant, and procedures that take further time than we would like. But I think if we can improve on imaging, and especially possibly the advent of 3D intracardiac echocardiography may give us an edge that will allow a more efficient view of the device as it engages the tricuspid space, especially, and the tricuspid valve. That may improve our efficiency. I think the other thing that is needed is possibly the use of artificial intelligence in facilitating these procedures. Right now, these procedures depend heavily on operator experience and a combination of imaging and operator maneuvering. However, we don't have at this point any assistance from artificial intelligence that might facilitate the way we move into this space and the way we do our maneuvering. It is still very operator dependent, and but I think that may improve things as well.
It's interesting that you reiterated what Costa said earlier, and your first point was imaging. So especially for the tricuspid side, it seems that if we had a magical way to improve our imaging, we would be faster, more sufficient, and efficient and safer. So this is the part of the imaging. It seems that with transesophageal echocardiography, we're happy in the mitral, on the mitral side, but not very happy still on the tricuspid side. There is a lot of commotion in that field. But on the device side, do you see anything else that can be done? We have the independent grasping, we have a different mode of closure with the two devices we have available. Do you see anything else?
I think in the tricuspid space, we still have a 7% SLDA rate, which is too much. That we need to improve, and the only way to improve that is, number one, being able to confirm adequate leaflet insertion, which is difficult sometimes, especially in the tricuspid space. So we need to maybe have a way of understanding that we have enough leaflet inside the device. That would be maybe one improvement in the system that we could, that would confirm that we have enough leaflet inside, if possible. Or anything we can do to decrease the SLDA rate would be very beneficial, I think.
You're right. We're just in 1 to 2% SLDA rate on the mitral valve, but unfortunately still between 4 and 6, 7% on the tricuspid valve. Thank you very much, Michalis. And I think Kostas Pereas.
Just one question.
Yes.
Excellent talk. Do we need surgical backup to perform tricuspid interventions?
Not really. For edge-to-edge repair, we don't routinely have surgical backup, either for the mitral or for the tricuspid space. They're fairly safe procedures, and we don't anticipate any issues that may require, in contrast to TAVI, where we have routinely the surgeon backup as always available.
These procedures are remarkably safe, and because you're on the venous side, a low pressure system, and you have all the time to make the advancement of the devices, it's more like simulating electrophysiology procedure than an interventional procedure on the arterial side. So it has nothing to do with TAVI, and surgical backup is rarely needed. Surgical intervention only when you have, the cases we know is when you have a problem to disengage the device. So you are there and you cannot disengage, which is a technical problem of the devices, fortunately happening extremely rarely. Any other questions? Thank you, Michalis. I'll continue till we have Dr. Perez with us for his talk on 10-9 with Intrepid. So, moving from transcatheter edge-to-edge repair to transcatheter valve replacement, which is something we are hearing a lot about it in the last 10 years, but the development there and the progress is very slow. There are many problems that need to be solved because mitral valve is not like aortic valve. There are many issues there. It's much more complex. But the problem we all know of mitral regurgitation is here, and is the most frequent valve disease in the general population, going up with increasing age. And why we need another treatment other than the mitral tear. Certainly there are a lot of patients. Transcatheter edge-to-edge repair has currently a class 2A recommendation, is not class 1 still, and TEER procedures certainly are safe and efficacious, but there are many anatomies and patients that are unsuitable for these therapies, and there is it's very challenging to treat them. And then we know again from the TEER landscape that when we have residual MR after we position our devices, this is not good for the patients and is associated with increased mortality. Even grade 2 MR, as you can see in primary MR patients from the TVT registry, and in secondary MR patients from the COAPT study, you see that if you have a residual mitral regurgitation, then you have an increased mortality in the follow-up. And how often we have this residual MR? You see here in all this spectrum of the studies over the years, we started with the amazing 58% of MR grade 2 or more in the Everest 2 trial many, many years ago. And you can see that it's going down, but it's still a double-digit number, even in the recent EXPAND registry, where we're using all the latest generation G4 devices. In the COAPT, it was 31% of patients at 1 year that they had MR grade 2 or more, and now we are between 10 and 15%. So this is not a small percentage of patients that, despite undergoing this, let's say, easy and low-risk benign procedure, they still remain with a good chunk of MR, and certainly this has been shown to be associated with worse mortality. So what can we do with these patients? We have the straightforward tear anatomy, we have the complex tear anatomy that is still feasible and acceptable, and then we have the prohibitively complex anatomy for tear, and certainly the borders are not very clear, and there is an overlap here, and this is exactly the soft spot of the patients who are looking to investigate the transcatheter devices. And here, the Medtronic developed this device that is a double stent, self-expanding nitinol with a device inside with diameter of 27 millimeters from bovine pericardium. You see how compressible and flexible it is, double stent device, and we participated in the pilot study with the first implantations in the world back, as you can see, in 2016 from the dates on this echo here. So these were our first implantation. You see a patient with a FMR, very large gap in all the coaptation line of the mitral valve that we thought it would be very difficult to treat with TEER because we would need multiple devices. And at that time, this device, the Intrepid by Medtronic, was only transapical delivery with a 40 French sheath. And this is the delivery. You see how the device flares first in the left atrium, and then gradually, by pulling it back, we release it. And we follow this echocardiographically. The implantation is like 80% echocardiographic, 20% fluoroscopy. And then the deployment of the device. This is how it appears on fluoroscopy. It's a large device, 45 and 48 millimeters diameters. And the immediate result is like this. It sits very well and stays very safely on the mitral valve annulus, and it gives us this immediate abolition of the mitral regurgitation. And indeed, we're very happy with those first implantations. So we have data to 2 years from this device, and actually some patients to 5 years, like our initial patients. And we've seen that we have a sustained abolition of the MR by using this device, transcatheter mitral valve with Intrepid. Now, there is a lot of progress over the years, and now this system is developed for transeptal delivery. With this delivery system, it's the same device, and the transfemoral access dilator is 35 French, still very big, but certainly not the 40 or 42 French that we had. And there is also a new valve size under development, the 54, because very often we have this large annuli in the mitral valve. And here you see a demonstration of the transeptal delivery of this device. So it's the same mode of delivery from up to down, but as you can see, the capsule is completely distal, and when you release the device, then you pull it through the device back. And the program, the research program, as you can see here, it started in 2014 with a pilot study, and then the initial design for the Apollo study was to be a randomized trial comparing with surgery, but it became obvious after the development in the TEER field that a study like that couldn't go on, so it was redesigned to the Apollo single-arm study that we only get patients that are not good for TEER or for surgery, and they go for this device. And of course, again, during these years, we had the development of the transfemoral system. So now we have the Apollo single-arm study that is ongoing with both transapical and transfemoral devices. And we had the initial early feasibility study of the transfemoral device that we're going to see now. So this is the early feasibility study with the device we've just seen, and 15 patients were included, average age 80, STS score around 5%, and most of them were primary MR, almost 70%. And you see here some procedural factors and outcomes. Successful implants in all but one patient, conversion to surgery in one patient because of valve migration, and air embolism with myocardial infarction in one patient. Two sizes were used here, and the skin-to-skin, not skin-to-skin, delivery catheter insertion to removal was 46 minutes. That is satisfactory. All-cause mortality was 0, 30 days in these patients, and most of the complications were, as you can see, bleeding. And the result, as expected, was almost complete abolition of the MR, just 20% mild whiff of MR. At 30 days, it was 0%, and very little and very mild, if any, paravalvular leak with this transeptal transfemoral device. LVOT obstruction was also extremely rare, moderate, as you can see at these charts, in 15% of patients, but certainly these patients were screened very well for this endpoint or potential complication before enrolling into the study. And as you would expect, we had this improvement in the clinical symptoms of these patients. And the Apollo pivotal trial update now, 65 center sites are activated. Many patients, as you can see, are consented and approved. So we expect a fast recruitment rate in the following months to years. And hopefully we will participate in this study as well here at the year. So this study is the one that I described earlier. We have the single-arm primary cohort of patients, up to 550 patients with primary and secondary MR, where the heart team will judge them that they are not suitable for TEER or for surgical valve replacement. This would be going into the TMVR Intrepid implantation, both transapical and transfemoral, depending on the patient anatomy. And before the sites start to enroll patients, they get their roll-in subjects, so they get some experience with 2, 3, 4 cases that do not count in the study, and then they start the patients that they count in the study. And then there will be a mitral annulus calcification MAC cohort in this study, with up to 300 patients. That patients with MAC will be accepted and will be going in this cohort. So this study aims in this prohibitive complex TEER anatomy patient that cannot have a good, or is not expected to have a good result with TEER. And if you see here the TEER non-suitability evaluation criteria used in this study, we'll get a very good idea of what kind of patients are good for TMVR. And so it's, these criteria are developed by the most prominent figures in the field, so I find it very useful to go through them for you. So first of all, anatomic classification that is associated with mitral valve stenosis. So patients that are in cardiac class 3A, which is reduced leaflet motion with thickening or fusion of the leaflets, severe MAC, or severe calcification fibrotic leaflets, mean mitral valve gradient greater than 5 millimeters of mercury, then anatomic classification associated with inadequate reduction of MR with TEER, like extreme valve complexity, clefts, big clefts in the leaflets, short posterior leaflet, multiple jets, large coaptation gaps, and finally patient factors that are associated with inability to perform TEER, like inability to have a good imaging that we've discussed earlier, caval interruption by filters, and devices, septal devices from past procedures that preclude us to go transeptally. So these are the criteria that are considered that the patient is not suitable for TEER and will be going into this study. And the MAC cohort criteria, patients that have moderate to severe or severe MR with MAC will be included, or patients with moderate MR and moderate mitral stenosis with MAC will be included. It has been shown from some cases that have been done so far that this valve can work very well when we have MAC, not the extreme MAC, as you can see, this is avoided, but up to moderate MAC. So in summary, the 30 days transfemoral Intrepid early feasibility study results are encouraging, and the time, the duration of the procedure was short, 0% mortality as we have seen, just one case that we had migration of the valve, and the patients were improved. MR disappeared in almost all of them and clinically improved. So we are expecting now the results from the ongoing Apollo study, and here we'll see just the roll-ins and the pilot study, so all the patients that this valve were implanted transapically, so data from transapical implantation only from the initial global study, the Apollo randomized that was stopped, the roll-in, and the roll-in cohort of the Apollo single arm. So this is a total of 208 patients, I repeat, transapical only. Average age 75 years, STS score 6.5%, most of them were secondary MR, and the all-cause mortality at 30 days in these transapical patients were, as you can see, 12.6% and going up to 16.3% at 1 year. And if you see again, most complications were related to bleeding events, but there was also a remarkable 13% that required reintervention for bleeding or tamponade. So these are the problems of the transapical access. That's why all the devices, all the manufacturers are trying to develop systems for transeptal, transfemoral delivery. And these are the results. Certainly, there's no doubt that this valve works. Once you position, if you position it correctly, then you solve the problem of mitral regurgitation. You get 0 MR. You don't see those 10, 20, 30% we've seen with TEER, with residual MR of grade 2 or above. Patients improve, most of them, as you can see, the majority of them, and the mean gradient over 2 years in these patients remained stable, so we didn't have any signs of late mitral stenosis. And with that, I would like to thank you. And if we have Dr. Pereas with us, we can...
Yes, hello. Hi, Kostas.
First of all, are there any questions about this talk, about Intrepid? No questions about Intrepid. So, Kostas, we're all ears for you.
Thank you very much for... can you see me and hear me?
Yes, we can see you very well, and you're going to tell us about the TMVR device of Abbott, the Tendyne valve. Thank you.
Indeed. You've made my job amazingly easy because a surgeon has to be very humble when presenting a transcatheter technique. So with our small experience of transapical TAVIs, we have tried to expand to TMVR atonasis. And I think most of the comments that you made were very valuable to my presentation. So hopefully I will scroll through very quickly. Next slide, please. Next slide, please. I'm sorry, I don't have control. Hopefully someone from the control room can...
Our technicians are trying to get your presentation up, Kostas.
Thank you. So just briefly, my first few slides basically comment on what you just touched. Number one, mitral valve disease is here to stay. Epidemiology shows that is the most prevalent valvulopathy, combined with rheumatic disease, which is hopefully dying in the developed countries. MR is actually on the rise. So these are my disclosures, and thank you very much, Kostas, for having me again. Next slide, please. And the financial burden is quite clearly huge for all the developing and developed countries' health systems, and it relates mostly to the FMR, which is largely left untreated. Next slide, please. And as you quite clearly commented, for DMR, TEER has received a 2B recommendation, while for functional MR, it has received 2A. And here I'm just touching on the small detail that the recent guidelines comment on transcatheter valve implantation therapies with a 2B Class C recommendation. Next slide, please. And we do have some information, and I'm touching on the discussion you had for TriClip and the MitraClip. This is old data that we have. Next, please. That show basically that following MitraClip, adding an annuloplasty would definitely improve the results in the long run. This is what we already know because, as you know, the Alfieri stitch is there for long, and we do use it sometimes, but it's not our preferred technique, especially when we do minimal invasive endoscopic mitral valve replacement and repair. Most of the time, we actually prefer to use annuloplasty in addition to chordate. So next slide, please. There you are. We think that one of the reasons, if I may add a comment, for this long discussion between the COAPT and the mitral trials of disproportionate and proportionate MR, next please, is based on the fact that the actual mitral apparatus is very complicated, and sometimes the papillary muscles do not interact positively after just approximation of two edges of the leaflets. Next, please. So there we are, as you quite mentioned, we know that there is still an unmet need for further techniques, and this is just a recent paper for patients referred for TEER, to realize that only 16% went for surgery, 16% did get the transcatheter edge-to-edge repair, but a huge percentage remained untreated. Next, please. So the previous one, please. Many companies, just the previous slide, yes. Many companies have gone through intensive investigations to increase the armamentarium of what can be offered to these patients. The first implantation of this Abbott-designed valve, which is a transapical transcatheter mitral valve, has been done in 2014. After a study of 30 patients, the CE mark was received in 2020. It is a valve that is positioned, as I said, through the apex in a transcatheter way on the beating heart. It's repositionable fully, and it has a tethered design and an apical pad keeping it to the, fixed and anchored to the mitral valve annulus. Next, please. So far, we have more than 1,000 implantations worldwide, and this is one of the first seminal trials, which was the initial feasibility study of this new transcatheter prosthesis. Mean age of 75. Mostly, as you can see, are patients that have functional MR, and the STS is about 8, with 90% also having functional MR. Next one, please. And as expected, as most of these valves do, the strong point is that MR is eliminated. For those patients that do well, there is almost complete abolition of the mitral regurgitation. There were no intraoperative, interprocedural deaths with this valve in this cohort of 100 patients. Technical success was reported to 96%. Having said that, it is of note that 30-day mortality was 6% and 1-year mortality was 26%, possibly reflecting, at least to a degree, the specimen of patients who were inoperable and at high risk. Next, please. We also have a publication from November from the same cohort that went up to 2 years. The good results of very good function with no MR persist. Next, please. And the rehospitalizations decrease significantly, as you can see on this slide. Having said that, mortality again is noted to be up to 40% in 2 years. Next, please. And likewise, the good results of abolition of MR are reflected in the NYHA classification, which is significantly improved, with 50% just being in class 2 and a good 33% being in class 1. And likewise, Kansas City quality scoring is also very acceptable, up to 2 years, 70% having a score above 60. Next, please. And what about long-term results? Of course, this valve is a new valve, so we can only comment on 5 cases that were done back in 2014 from a single unit. It was at the Brompton. 6 years out, 4 of 5 patients who were still alive, still live at home, have independent activities, and their valve function is normal. So good news, we know that up to 6 years this valve is good and functioning. Next, please. Now, MAC is a much more difficult situation, and there is a cohort, a small cohort of 30 patients that received MAC with very good procedural results, as you can also see here. Just 1 out of 30 patients had a procedural problem, and then most of the patients likewise improved their NY classification. Next, please. So you touched on that, Kostas, very nicely, which is the unmet need, the gap of tier that TMVR could fill. And you mentioned quite nicely from that slide, just to touch on it again quickly, Barlow disease with multiple JES may not be very easily amenable to edge-to-edge repair, rheumatic disease, commissural leaks, cleft perforations. Of course, the mixed mitral valve disease, which you have to start with a small effective orifice area of the mitral annulus, multi-flare segments, excessive flare width and gap, even though I gather with experience this can be dealt with, and small grasping length. Next, please. And Abbott is trying to resolve one of these questions, even though it's quite clear that some patients are finely suited with edge-to-edge repair, and some patients might be only suited for transcatheter mitral valve replacement. But there is a study which is soon to be completed of randomization 1-to-1 between Tendyne and MitraClip. The results are expected this year. And this study includes a MAC cohort and also the non-repairable cohort where TEER is not an option. Next, please. This valve comes in 2 profiles, basically, a low and a standard profile with some differences, as you can see here in this slide. The smaller one has a 2.2 centimeter effective orifice area, the larger one 3 square centimeters orifice area. Next, please. And here you can see, next please, just let the film play, and with leaps, please, if possible. So here you can see just an animation of the procedure, which relates to using a 36 French catheter. So again, a relatively large catheter, slightly smaller than the Intrepid, but still fairly large. You need to be experienced and have some familiarity with the transapical access to be safe. And a guide wire, just fast forward, please. And a guide wire is pushed through the mitral annulus, and then, yes, please go towards the end just to save time. Yes, thank you. Yes, next. Faster towards the end, please. Okay, next, please. Never mind. As you quite mentioned, Kostas, this is a complicated procedure, and a lot of details need to be assessed before the actual operation, and that helps a lot in the operation planning. Echo plays a very significant role, and next, please. Ecg Gated Ct Scan. This is the scan results of one of our cases at Onassis, where we did not only see the mitral valve, but also the LVOT, both in systole, next please, and diastole, just to confirm that we have adequate LVOT. This is one of the Achilles problems probably of this valve, that as you can see, it sits on the anterior mitral leaflet, and you need to be sure that you're well clear of the outflow tract. Next, please. And here you can see an animation provided by the company of how this valve would look after implantation. And really what we check, again, is that we have adequate clearance from the left ventricular outflow tract, which is the case in this patient. Next, please. There are some procedural challenges that we have realized ourselves. So as I said, I commented on the neo-LVOT that is formed. The LV apex, for those of us who have done transapical TAVI, is a different apex. It's not the TAVI apex, it's a thinner left ventricle that obviously is the ventricle that relates to MR and not to aortic valve stenosis. And very importantly, as we said, very much unlike the edge-to-edge repair, after fixing the MR with one effort, just in a few seconds, the MR is completely abolished. You have an acute LV stress that needs to be managed medically and anesthetically appropriately, because suddenly the left ventricle starts ejecting without having the relief of the chronic MR. Next, please. And the valve comes in many sizes, the standard or the low profile. And after adding the measurements from the CT scan and the echo, the company provides a good response of the actual size that can be used for each specific patient. This is one of the calculators for a patient. Next, please. And basically, as Kostas quite rightly said again, fluoro is useful. Play, please. And here you can see one of our cases. This is the flaring of the valve through the echo, and this is what it looks like on fluoroscopy. But the echo is the most important tool during this procedure. And after the valve is checked that the longer part of it is sitting on the anterior mitral leaflet, just opposite the aortic annulus, then the procedure is completed. And this is what, yes, play please, and this is what it looks like on 3D echo, large valve with a skirt of cloth anchored on the atrial side of the mitral annulus. Next, please. Oh, okay, so yes, this is last to be shown. As you can see, this patient had a previous aortic valve replacement. So coming into conclusion, transcatheter transapical mitral valve implantation with Tendyne has exceeded 1,000 implantations worldwide. It offers an attractive alternative to inoperable, high risk, and not suitable for TEER patients, and the exact role needs to be better specified. Mid and long-term results are awaited eagerly, as early mid-term results on high-risk patients carried a significant mortality risk. It does have a high rate of complete MR correction and symptomatic improvement. I should say much higher than the MitraClip. Despite transapical approach's relative challenges, it presents a very high periprocedural success rate with very low early mortality. And thank you for having me again.
Thank you, Kostas. Excellent talk. Congratulations for your experience. And if you have time, you can stay with us. I'd rather continue with the presentation of Evoke, which is a similar presentation for 5 minutes, and then have some time for discussion of all these devices. So I noticed that the 30-day mortality with a Tendyne experience that Kostas saw earlier was 6-point-something%, which is lower than the intrepid 30-day mortality that I showed you earlier, which was 12%, double. But if you notice, the 1-year mortality in these two early experiences was the same, 26%, 26%. So, can Okay, continuing with the Evoke device, which is the Edwards solution to TMVR. It's one of the many devices in the Edwards portfolio for tricuspid and mitral, and we know that Edwards was probably the first company that they started exploring TMVR devices many years ago, and you can see the progress and the evolution of the devices that they have developed and researched, investigated in Edwards from 40s to a number of iterations of the cardiac valve, then continuing to Evoke, which is the current design, and the Evoke EOS, which is the future design that is now under development and actually in human studies already. So transeptal delivery, why we want transeptal delivery? It's obvious that transapical is still surgery, and it's associated with, we know, like a 5% mortality or very serious adverse event on its own. So if we can get away from the apex and go transeptally, we're safer, and probably we have better outcomes, not probably, certainly, we avoid that mortality that is associated to transapical, especially in mitral valve disease. It's not like aortic stenosis where we have hypertrophied myocardium. Here we have a dilated ventricle, low ejection fraction in most patients, and thin ventricular wall that makes transapical even more challenging. And of course, it's less invasive, and it gives us the opportunity to treat more patients. So this is the current Evoke device. As you can see, the devices started to converge they are similar now. If you see it, it's not far away from the Intrepid device that I've shown you earlier. And they are both tried now for transeptal delivery. It comes in two sizes, 44 and 48, but there is one larger size that is under development. So it's two stents, one outer stent and one inner stent with these hooks that are multiple, and they are going below the leaflets. This is the Evoke delivery system, and this is a cartoon of how this valve is delivered transeptally, and there is the possibility to bend, as you can see, the capsule on 2 dimensions, so you can go anywhere you want to go, and it's very important to be like vertical to the annulus plane when you do TMVR procedures, and this is how the steps, the sequential steps of the implantations are done. First below, and then when you have the leaflets, you release the device, and this is how it works. So the compassionate use and the early feasibility experience of the transeptal delivery of this device, it's in 15 patients. 15 patients was in Intrepid that I showed you earlier. So a similar small number of patients in this initial transapical delivery in very few centers in the US and Canada, as you have seen, 6 centers. And these are the patients, and average age is close to 80, STS score 5%, etiology mixed disease, most of them, as you see, but with good average ejection fraction. Technical success was 93%, so in all but 1 patient, similar to Intrepid that we've seen earlier. Conversion to surgery in 1 patient, skin-to-skin time much longer than the catheter delivery time in the Intrepid, so different way of measurement the procedure time, but it's, as you can see, close to 3 hours, but the device time is 1 hour. Of course, there were no embolization of devices, and the result was very good, with almost all patients having 0 MR after implantation. There was 1 death, so mortality 7% in this initial cohort, and 0 of the rest of complications, you notice we don't have bleeding complications here. MR severity was down, and improvement in functional class as early as 30 days after the procedure. And notice this small reduction of the ejection fraction at 30 days. So the conclusions were self-evident that it can be done safely. So the program now, it moved to this new iteration of the EVOQUE EOS in the MESCENT trial that is ongoing, and it's early feasibility study, and the results are encouraging, but we haven't seen them yet. And of course, we have the other platform of Edwards, which is the SAPIEN M3, which is two devices, one dock, you position the dock, and then you come with a SAPIEN valve that it has a skirt all the way on the scaffold, and you implant this SAPIEN valve within the dock. And this is still under investigation in the Circle trial, and it seems to work, but probably it's a bit more complicated for general use than a direct TMVR. And going to the tricuspid valve, even more complex than the mitral valve, certainly associated with increased mortality. And probably this is here where the EVOQUE will get permission and CE mark to be used first, because of the very encouraging results in the tricuspid. And they expect to get CE mark sometime in autumn this year. So it's the same valve, the EVOQUE valve, but with a different delivery system that is specifically designed for the tricuspid valve. And if we want to see the procedure, I think, yes, here, you go into the right atrium. You don't have to get the wire up in the pulmonary vein, just into the right ventricle, and it's a similar mode of implantation as we've seen in the cartoon of the mitral valve, so no need to stay here. And we have the initial experience in 25 patients of the EVOQUE with, as expected, very good results in terms of reduction of TR severity, and successful in all but one patients. And recently we've seen the results of the TRISCEND study, 6 months outcome. This is a large study, single-arm, multi-center study of the EVOQUE in the tricuspid valve in all these US sites. 132 patients, 6 months results reported. Average age of the patient was again 80. A Euroscore 2, 5%, STS score 7%. Most of them were functional, of course, which is true for tricuspid valve. Percutaneous in all of them. Device success, 96%. Device time, 72 minutes, less than the mitral valve. And they stayed in the hospital 3 days on average, and these are the results. You see here cardiovascular mortality of just 2.4%, all-cause mortality 3.2% at 30 days. Most of the side of the adverse events were severe bleedings, despite going transfemoral. And we had, this is of note, is 10% need for new pacemaker. Apparently, we caused some injury in the conduction system on the tricuspid side. And you see that during follow-up at 6 months, there were no more adverse event. It was just the initial that were associated to the procedure, and improvement in symptoms, 6-minute walk test, and quality of life scores. And with this, I would like to thank you for the attention, and I think we can now open a discussion about TMVR, like for 5 minutes. So, from the audience first, any questions about the TMVR devices we have seen and discussed so far? No questions from the audience. Kostas, you have any comments?
Well, I think there is very interesting technology to come, and we have to accept that transfemoral has a general advantage. I think the main problem, as you mentioned, is the size of the catheters that we use for the transapical approach. On the other hand, the same, I suppose, is applicable relating to the ASD. So just a question, how exactly do you treat the small remaining ASD after, say, 36 to 42 French puncture that you go through? Of course, it's not the size that you're left with. I fully understand that the QPQS may be very small, but is there any data on that?
Yes, there is some data from these early feasibility studies. I didn't stay long on the slides for the sake of time, but with these devices that are approximately 30 French, the Evoque and the Intrepid, they had to close about 50% of those holes. So this is something to expect to see for the transfemoral access in the future. Certainly it won't be like MitraClip or Pascal, that there is a zero need to close the iatrogenic ASD at the end. Probably here we'll end up with a 10 to 20% because the devices are going down to 26, 24 French. They're now both on 28 French, the new iterations of the Intrepid and the Evoque. So 28 French is not far from 22, 24 French that we have MitraClip and Pascal. So I suspect they will come down to 24 French, and then the need will be very low. But I see that finally we see some light at the end of the tunnel with a TMVR, transfemoral TMVR device coming closer, and I think that will be the future. So Tendyne and Intrepid and Evoque, the initial transapical implantations were just the introduction, I think. The real future will be the transfemoral transeptal devices, and I think probably Intrepid will be the first one to get CE mark. This is how I see their studies, their rolling out of their studies, how they are going. Evoque will be probably next, but Evoque has a history of many changes in the designs and iterations. So Evoque EOS is now under investigation, which is the next iteration of Evoque. So probably we'll see the first transfemoral device sometime in 2023 or 2024, and my personal belief is that the first transfemoral device will be Intrepid. Michael, any comments?
Yeah, in my opinion, in my sense is that the tricuspid space will probably precede the mitral space for the Evoque valve, because they've gone far ahead with the TriScend study, and it's it seems to be fairly safe and effective. So I think that the Evoque valve will flourish in the tricuspid space in the beginning. Like I think it'll be in clinical application there first. That's my impression.
Great. So Kostas, do you have any other comment before we close?
Well, just a very quick comment. I'm sure you're right. I understand that the reason the mitral has taken that much longer than the TAVI is the complicated anatomy of the mitral annulus and the relation to the aortic valve and the LV outflow tract. So until then, I think you will agree that the Tendyne, having this anchorage system, manages to have zero risk of valve dislocation and provides a reasonable result. But I think you're absolutely right that once 3D printing and AI, as you mentioned before, improves and we have a better understanding of the form of the mitral annulus, which we do nowadays, I think, yes, the future will be a transfemoral approach.
I think the ideal transfemoral TMVR valve would be the one that you would implant, see it functioning assess it, and if you are not happy, then recapture it and withdraw it completely. And this is what they say the Evoke EOS is. It's completely resethable, removable, and repositionable after complete deployment and function. So thank you very much, Kostas, and all the other speakers in this session. And I think we can now move to the next session with a small delay. So we have with us Dr. Triantis, Dr. Igopoulos, Dr. Sinatos, and Dr. Zais. Please come on the podium for the next session.
Dear colleagues, it's a great pleasure to participate as a commentator in this interesting round table. Without delay, I will introduce the first speaker, that is Manoharan, who will give his lecture about the incidents and clinical consequences of conduction disturbances in TAVI. Dr. Manoharan, please.
Good morning. I hope you can hear me and see my slides. Can you hear me and see my slides?
Yeah.
Okay,
You are
good.
hearing clearly.
Well, first of all,
okay.
good morning. Thank you so much for this opportunity. I would like to thank the organizers for this. I'll get quickly into it. So just an overview, I think, most people understand that one of the key reasons for conduction abnormality during TAVI and the triggering of the pacemaker is the relationship of the his bundle or the conduction system of the patient that is very, very close to the area we are landing our very big devices. And on histological assessments and EP assessments, that distance is about 6 millimeters. So if you deploy your valve below 6 millimeters into the LVOT, you significantly increase the risk of needing a permanent pacemaker. And the more shallow you implant this, the less the risk is. And this very large series of clinical trials and registries have shown that when you are below 6 and the lower you go, your need for permanent pacemaker is sub 10%. And the deeper you are in the LVOT, your need for permanent pacemaker really goes up into very high 20s and 30s. And that's what we experienced in the olden days, at least with the self-expand technology, really high implant rates. But over time, with resheathable technologies, newer technologies and technique, we are now roughly around the 10 to 12% pacing rate. Although some of the more recent registries have shown even up to the 15 to 17%. That is, when you compare the self-expand technology to balloon expandable, balloon expandable repeatedly and reassuringly always has sub 10% pacing rates. And the Centera valve, although being a self-expanding technology, has so far shown one of the lowest pacing rates, sub 5%. It's equally important that when you look at conduction abnormality during TAVI, a reasonable number of these conduction abnormalities do improve and resolve with time. If you have significant mechanical injury, either due to valve being too low, very large balloons that has triggered significant inflammation and edema, it's unlikely that the conduction will improve. But if it's due to transient conduction change, due to either ischemia or transient balloon injury or hypotension, a lot of these will improve. For example, if you have complete heart block during the procedure that recovers very quickly during the procedure to become near normal, I wouldn't rush to put a permanent pacemaker in this patient, especially if your valve deployment height is around 3 to 4 millimeters. I would wait for 24, 48 hours before triggering the need to put a permanent pacemaker. So what's the long-term impact of putting a pacemaker or conduction abnormality in these patients? Reassuringly, even up to 3-year follow-up in these various series of clinical trials using predominantly balloon self-expanding technology, there are some looking at even balloon expandable, up to 1 to 3-year follow-up, there is no increased risk of mortality in these patients when compared to those who did not get a permanent pacemaker. And similarly, in the advanced registry, again, these are old studies, when you follow them up to nearly 5-year follow-up, looking at new permanent pacemakers, no permanent pacemakers, and pre-existing permanent pacemakers, there is no difference in mortality. But mortality alone is not, of course, the key risks we look at when we implant a device. All of you are aware as clinicians, the procedure itself carries risk. And if you speak to your EP colleagues, they'll tell you that increasingly they are explanting a lot of pacemaker leads due to lead fracture and infection. All of these, of course, add to resource implications during the procedure, post-procedure, and the unnecessary impact this has on the patient itself. So we can broadly then divide the need for a permanent pacemaker that's been triggered by conduction abnormality into 4 areas. The technology, and you remember, it's not available anymore, but the Lotus valve had a pacemaker rate nearly 30% of patients. Anatomical characteristic of the patient will come to it now that you can't modify there and you have to deal with it. I think the area that we can most impact on is to operate and procedure technique. Of course, when you do a TAVI and the patient's on high-dose beta blocker, it's usually not going to end very well. So when you look at non-modifiable features, there are patient characteristics as listed here, and also there are pre-existing conduction abnormalities that are listed here. Of these, the right bundle branch block is what I think and has been shown in a lot of other series to be the strongest predictor of needing a permanent pacemaker. So much so in our unit, if I see a patient in the clinic who already has existing right bundle branch block pattern, with discussion with our EP colleagues, these patients now admitted 2 to 3 weeks before the TAVI date and have a prophylactic permanent pacemaker already implanted. They heal from it and then they come for the TAVI. And you know what? The TAVI procedure then becomes really, really a comfortable, enjoyable experience without worrying about what is the impact on this patient. And more importantly, when these patients go home, you're not concerned that there may be a late conduction challenge for these patients. So what is modifiable characteristics is listed here. I think if you are aggressively manipulating the wire or pre-dilating with significant oversizing, post-dilating aggressively, and the implant techniques, which we'll come to in a minute, and significantly oversizing the valve they're using, these are, I think, areas that lead to needing for conduction abnormality that's not reversible and end up getting a permanent pacemaker. So pre-implant BAV, I must say I tend to pre-dilate in almost 98% of my cases, but the key is to make sure your balloon size is related to the minimum diameter of the annulus and not significantly oversize the balloon. So in my procedures, the vast majority of balloons are 18 millimeters. And if I'm putting a 34 evolute R or something like that, I may take up to 20 balloon. I tend not to go any bigger unless it's a bicuspid valve. So implant techniques, I think, are the areas where we all, I think, can pay attention to improve our pacing rates. I'm going to first of all start with the balloon expandable. You will all remember, for those of you who use Sapien technologies, the tradition was the 70-30 positioning depth. And then you deploy the valve and you get very predictable, really good results. Increasingly, certainly now, we've also adopted this. we look at this line of translucency. It's a suturing line that is radio opaque or radiolucent. And you can see this really halo-like effect. And what you do now is you deploy your valve, positioning initially the halo-like effect just at the base of the sinus, and then the marker that you come with the valve at the level of the pigtail. Now, in order to get this right, you have to make sure you are on the 3 cusp line so that you don't miss any of the cusps. And then you deploy the valve as standard. And what we've noticed that by definition, the valve is slightly higher, and therefore the trauma from the balloon from the sapien is not on the conduction. And we have seen really very nice results with almost no impact even on the conduction, no impact on left bundle either. Now, I'm not going to talk too much about left bundle because my next speaker is going to be talking about it, so I'm going to avoid the left bundle story. In the self-experiment technology, we have moved, I think most of us have moved from the 3 cusp alignment to other techniques. And one of the other techniques which has been pushed very hard by Medtronic is the cusp overlay technique, where you align the right coronary cusp and the left coronary cusp in one plane, and the non-coronary cusp is isolated with the pigtail sitting in the non-coronary cusp, and then you deploy the valve in that view. This is always almost the right, the RAO caudal angulation, and this angulation is obtained from CT. And a lot of centers have reported really improvement in the pacemaker rate to single-digit numbers. And using that technique, you can see in the US most recent presented TVT registry with almost 50,000 patients, by changing the technique and other parameters being applied, they've now gone in the large bunch of patients in the US to sub 10% outcome data, which is really, really encouraging. However, cusp overlay techniques do have challenges. It does require good quality CT. It does require good dedicated software to allow you to align the 2 cusps. What people may not be aware of, if you take the systolic phase of the CT and the diastolic phase of the CT, you get 2 different angulation measurements for the patient. Which one do you follow? It doesn't account for the patient moving or lying on the table slightly differently. And the emphasis of the cusp overlay is on high implant. Now, when you do that, there's always a risk of valve pop-out. Other areas that I think cusp overlay can be challenging, it cannot be used if you're coming on the right side, where the valve is pushed to the left side on the anatomy. So if you're coming on the right subclavian, right carotid, or direct aortic, you really can't use this technique very well. Other areas, again, if you have a traditional, typical type 0 bicuspid or type 2 bicuspid, very fused sinuses, again, this technique has challenges. Of course, valve in valve, TAV in valve, you can't use it. And also, you still need an LEO projection to confirm that your valve is below the left cusp. So most recently, I've been doing another way of doing it for the last 5 years, but I've consistently did a very small registry looking at consecutive patients treated from the 1st of September 2020 to November 21, and was fortunate enough to present the data at CRT meeting. And very briefly, the frame alignment technique, which I'm proposing, it does not require pre-procedure CT analysis for procedure planning or deployment. You do need CT, of course, to look at all the other stuff. You deploy the valve in real time, as clinicians would do, like putting a stent in. It can be used for any annular anatomy, any self-expand technology, and even in valve procedures very safely. So very briefly, the technique is very simple. Pigtail and non-coronary sinus, you advance the valve to the annulus. You first of all align the base of the valve in a coplanar or remove the parallax. You then release the valve to 1/3, and you then keep going LAO only, no caudal or cranial tilt, LAO only until the base of the frame is aligned, and you remove the parallax. You then go to 2/3 as shown here. You align the valve again. In this case, I did not need to, so I was remaining the LAO 44 angulation. Remember, no caudal or cranial tilt, and you check. Now, the important thing is, between the 1/3, step 2 to step 3, it's important then you to pull the wire back to pull the nose cone away from the LVOT. And I think this part, removing the nose cone away from the LVOT, is an essential part of the step, because I believe that the nose cone interacts constantly with the conduction system, constantly traumatizing the conduction system, triggering trauma, triggering conduction abnormality. The emphasis is not on zero deployment. You deploy 3 to 4 millimeters as shown here, Then the other step of the procedure is to go to an ariocaudal angulation, again to frame alignment. So I always take typically Ario 10, keep going caudal. In this case, we went up to caudal nearly 50. Frame is aligned, take another angiogram, and you'll notice that the picture between the LAO, pure LAO view and the ariocaudal view, the depth is exactly the same. You're reassured, in two views, the deployment depth and positioning looks good. You can see that the coronary filling is normal. There's no trauma at the aorta. Then I deploy the valve, and typically and reassuringly, you always get really good results. You again, of course, need to realign your frame. So in the final angiogram, I'm now gone to LAO 25, align the frame, took a picture, and looks good. So very briefly, 1st of September 20 to November 21, 30-day follow-up, permanent pacemaker. These are consecutive patients. Permanent pacemaker rate of 1.9%. So in conclusion, ladies and gentlemen, new permanent pacemaker post-TAVI is unwelcome and potentially harmful. There are wide variations still exist between regions and implanting sites. However, thankfully with new techniques, new technologies, and sharing of knowledge, we are all seeing a reduction in pacemaker rates. The cause is multifactorial. There are things you cannot change. So patient-related factors are non-modifiable. But procedural improvements will result in lower rates. Reducing conduction trauma by less aggressive wire techniques, undersized pre-dilatation, optimized implant depth, less post-dilatation, and using novel implant techniques, cusp overlay, frame alignment technique, or other techniques people are developing, reduces the need for permanent pacemakers post-TAVI. However, if you see a patient who we are worried about, for example, somebody who has transient complete heart block procedure time, post-procedure has a very ugly looking left bundle, a first degree heart block, and you're thinking, should I not? I think it's always important to err on the side of caution and implant a pacemaker, or keep them in for 3 to 5 days and reassess again. It's important not to rush just to send them home without a pacemaker. I think we all should aim for pacemaker rates of less than 10%, but ideally sub 5%, especially when you start dealing with younger and low risk patients. With that, I shall stop. Thank you so much for your attention.
It was a comprehensive, fruitful, and didactic presentation. Thank you in advance, Professor Manoharan. Are there any comments or questions for the audience? Dr. Rigopoulos?
Yes, thank you. Dr. Manoharan, this was a very concise presentation of the risks concerning permanent pacemaker dependence in patients who undergo TAVI. However, there are many technical considerations that you showed, and I have seen a presentation from UCLA who they incorporate a virtual EP-guided TAVI procedure with CT fusion. What are your thoughts about this evolution of our techniques in TAVI procedure?
I think I would, in very short, I think any iteration that allows our procedure to be predictable and safe should be embraced and tried out, I think a lot of cath labs, when they're now changing the cath lab, they do have this multimodality fusion technology, which is great. So if you are spending a lot of money buying this fancy technology, not applying it and seeing, okay, can I make my procedure safer? And the other area that I haven't touched on is, all of us are increasingly being exposed to a lot of radiation, right? I mean, for the kind of procedure we did 10 years ago, 15 years ago, PCI, a couple of stents, type A lesion. What we're doing now is lots and lots of radiation. But if you go to an EP room, they almost do most of their procedures with almost no radiation. So I think we can learn a lot on stereotechnic techniques, overlap techniques to minimize radiation, because perhaps not my generation, but the next generation with tricuspid, lovely presentation with the previous speaker, with tricuspid technologies, mitral technologies, atrial appendage closure, ASD closure, TAVIs, heart failure therapies, radiation is just going to go increase and increase and increase, and we need to find ways of improving and reducing radiation exposure to us as operators as well. So yes, any technology and technique that can improve our ability to get predictable, good outcome should be welcomed, encouraged, tried, and tested.
Thank you. If there are no other comments.
Can I have a comment? I'm Dr. Sinotos from Hippocration. First of all, congratulations for the excellent presentation. I think that you showed us too many things about a very important drawback of the TAVI procedures. Usually the surgeons, they accuse us of this is one of the most important problems that we have. And actually, it's a very important problem now that we try to move on to lower risk, which means younger population, that actually it's not accepted to have a pacemaker in a younger age. However, I think it's very important to consider in terms of the prediction that you very nicely told us. The RBBB is a very important predictor. Usually, we started with the right bundle branch block and we ended with the right bundle branch block. This is the most important ECG predictor. It's very funny because it started 15 years ago. And actually, one of the very good predictors is from the echocardiography is the LVOT annulus ratio. Actually, when we're speaking about hypertrophic hearts, even if we go with a high implantation, the risk of pacing is quite high, even in high implantations. So maybe in these patients, we should go mainly with balloon expandable valves that they have the less percentages for pacing. Thank you.
That's a really good. Can I just come back on that? I think that you brought up a really important point. You're absolutely right. I don't believe that the depth implantation on its own is a precursor pacemaker. I think it's one of it. And I strongly believe that interaction of the device with the LVOT is a much stronger predictor of permanent pacemaker. And that's one of the biggest difference between the SAPIEN device and the self-expanding device today. When you take the SAPIEN device, and you can see it historically, their pacemaker rate significantly dropped once the retroflex technology came into the delivery system. So when you implant a SAPIEN device, as you're crossing the arch and into the annulus, you apply a lot of retroflexion, so the nose cone is pulled away from the LVOT already. So that's why in the technique I've been trying to develop and teach, the minute you cross the valve, and as you're releasing and the nose cone is disengaged from the capsule, from the sleeve, you already pull the wire back. That lifts the nose cone away, almost mimicking the SAPIEN retroflex concept. So you pull the wire, the pre-shaped wire back, and that lifts the nose cone away from the LVOT. And I've deployed valves now, even like 5 millimeters in small LVOTs, and I don't see, it's amazing, you don't see the conduction. And I think and people forget, they always look at the valve and they don't look at this really big 6 French nose cone. It's not soft, it's quite traumatic. I think pulling the wire back, lifting the nose cone away from the LVOT is part and parcel of minimizing trauma and minimizing conduction. So thank you for bringing that point. It's a really important point. The LVOT, size, positioning, not touching it, not traumatizing it is equally important. And you've seen diagnostic catheters today, 5 French diagnostic catheter on the right diagnostic engagement. If it transiently dips into the LVOT, you can see transient LBB. We all see it. So a 5 French softed catheter can traumatize LBB. 6 French nose cone, do you know what that's going to do to the left bundle? It's not going to be nice. So yes, thank you for that point. Really important. Yeah.
Thank you in advance, Professor Manoharan. Now, Andreas, we can proceed presenting the next speaker. Thank you.
Well, it's a great honor to go to Dr. Kruglis for a very important topic. It's about the management of the new LBBB in patients after TAVI. Dr. Kruglis is director at Ecg Hospital, and we're looking forward for your presentation.
Thank you very much. Good morning from me, and I want to thank personally Dr. Spargias for the honored invitation to cover an issue that is very interesting It's new. How? Okay, my disclosures. About new disturbances, electrical disturbances after TAVI, and especially LBBB. And these are the 4 parts that my lecture will cover. And first, we have the epidemiology data. We know that the now reported incident is 15% of new onset LBBB. During the first generation valves, it was almost 25%, ranging from 5 to 65%. And the rates are higher for self-expandable valves compared to balloon expandable valves. You heard in detail from the previous speaker all the pathophysiology of the conduction disturbances, and this is the first official definition of left bundle branch block from the American Association. The main problem is that with this definition, we cannot always distinguish true LBBB from non-specific intraventricular conduction delays. And this study proposed that we have to include 2 novel criteria in order to define LBBB. One is the notching or slurring of the air wave in at least one of the lateral leads, 1 AVL V5, V6, and an air wave duration less than 20 milliseconds in V1, in order to increase our specificity for true LBBB. And as the previous speaker said, it's very significant the QRS width and the implantation depth for the persistence of LBBB. If QRS is more than 150 milliseconds and implantation depth more than 3 millimeters, we have persistence of about 70%. I would like to remind you that when we are speaking for trifascicular block, it means alternating block, that is alternating LBBB with RBBB or RBBB with left anterior, alternating with RBBB with left posterior. When we have bifascicular block and first degree AV block, it's not trifascicular. And this is true for LBBB patient with first degree AV block. I would also like to underline that bradycardia-dependent LBBB is always a sign of a very diseased bundle branch, because this block is always something that will persist. Here is a very nice example of the disturbances progression over time. You can see upright left, the initial ECG of the patient with only left anterior hemi block. Some years after, we have bifascicular block, RBBB, and left anterior. And you see in the telemetry, the day after TAVI, that we have alternated blunt block. You see here these 3 complexes, entirely different from all the other QRS complexes. And of course, next day, we have complete AV block with the need of pacemaker implantation. Let's see what guideline says. The first position paper was 2019, and in new onset LBBB, the proposal was if the QRS wide was more than 150 milliseconds or PR more than 240 milliseconds, these patients were characterized as very high risk, and the proposal was to proceed with EP study or continuous monitoring or even direct pacemaker implantation. And I think that this paper was mirroring the results of the Partner 2 trial, where after 2 years of follow-up, 15% was new onset LBBB, and this was related with increased all-cause and cardiovascular mortality, rehospitalization, new pacemaker implantation, and worsening heart failure. So this is something that worried us, but some months after, in JACC, this trial with 3 years follow-up was not confirmed the results of Partner 2, and new LBBB was not associated with a higher mortality or heart failure hospitalizations, only with high rates of pacemaker implantations. And we have the very recent guidelines, our guidelines for pacing, where we have a clear indication for pacing in patients with persistent high-degree AV block, nuanced and alternating valve branch block, pre-existing RBBB, as Dr. Stenosis said before, with new procedural, post-procedural conduction disturbances, in patients with persistent new LBBB, when QRS duration is more than 150, and PR interval more than 240 milliseconds, with no further prolongation during the first 48 hours after procedure, we have to proceed with EP study or with a prolonged Holter monitoring. While when there are pre-existing conduction disturbances that we have after procedure prolongation of QRS or PR of more than 20 milliseconds, then we have a weak indication for EP study or monitoring. And here is a survey that ERA announced in the recent Congress, where we see the practical strategy that many centers in Europe have after TAVI, and you see that, of course, telemetry is the major thing that we do for our patients, and the implantation of a pacemaker just for new or pre-existing BBB is lower than 20%, and this study compared the direct implantation of a pacemaker in patients with only LBBB, a liberal strategy, versus a constrictive strategy where the implantation was performed in patients only having LBBB and first-degree AV block. And you see that we don't have any difference in mortality rates. And of course, in the restrictive strategy, we have a much lower implantation of pacemakers. And about the dependency of pacemaker when we implant with an indication of LBBB, you see that if we implant a pacemaker for LBBB and first-degree AV block, on 4th month follow-up, only 59 of patients required ventricular pacing of more than 1%. I repeat, 1%. And the main dilemma we have to deal is what pacemaker we have to implant in our patient, because all the patients are not the same. And of course, nothing compares with war horror, but of course, we have to deal with patients, and we want to make harm. And we know from most study with pacemakers and David's study with ICDs that if we pace the right ventricle of more than 40%, we may provoke systolic dysfunction. And this study showed that even lower rates of more than 20% may provoke the same result. And this is something that in guidelines included. And we don't want to have complication in our patients, and the worst complication is this one, is infection. And you know that extraction of a pacemaker is a very hard process with high mortality rates. And I don't know if your patient is so lucky that the pacemaker will save his life with a bullet like this one, but of course, infection increases mortality. And we have also to select the pacing modality that is most suitable for our patient. And if the patient is with normal ejection fraction, conventional pacing or leadless pacing or physiological pacing will be a choice. But it's entirely different when we deal with patients with low ejection fraction, less than 35%, where our first choice will be CRT or physiological pacing in the future, while in the middle of ejection fraction between 35 and 50%, according to the results of blocker failure study, we have to prefer CRTs. And I will give you some examples of our work with Dr. Sparias in Ecg Hospital. Here is a very challenging case of a TAVI procedure in a patient with dextrocardia with C20 inversus, needed pacemaker after the procedure due to symptomatic log poses and persistent new LBBB. You see that we have a conventional VVI pacemaker implanted. In this patient, acute severe MR after TAVI happened with an ejection fraction of 35 to 40%, complete heart block in a patient with pre-existing RBBB, and we had to proceed in an urgent CRTP implantation, and the patient improved dramatically in less than 48 hours. And here, very recently, we have implanted a micro AV device in a patient with persistent AV block after TAVI, no sign of sinus node disease, and good ejection fractions. So, in conclusion, in patients with new persistent LBBB of more than 150 milliseconds and PR more than 240 milliseconds, we should proceed with EP study or long Holter monitoring. No clear indication for urgent pacemaker implantations. In patients with pre-existing LBBB or first-degree AV block and prolongation of more than 20 milliseconds, we may proceed with EP study or Holter. In patients with pre-existing RBBB and new persistent conduction disturbance, we should implant the pacemaker. And individualization of pacing modality is very crucial for these patients. Thank you very much for your attention.
Well, thank you, Dr. Kourouklis, for the excellent presentation. Although sometimes it's very difficult to follow EP cardiologists, it was an excellent presentation with very clear conclusions. I think that there is rather conflicting data still exists about the role of new disturbances and the LBBB in patients after TAVI. I was very surprised about the role of the EP studies in these patients, which is something that, to tell you the truth, we don't use it in Hippocratian Hospital, and I was really surprised. And one question that before we give to the audience, just to tell us what is, according to your opinion, the best pacing method in these patients? If in these patients, especially in patients with heart failure, it's better to go earlier to biventricular pacing to prevent the LV remodeling?
Yes. As I told before, where we have a discussion with Dr. Toutzouzas, is class 1 indication to proceed in this patient till now with CRT, with the classical CRT pacing methods. Of course, we have very good results with physiological pacing, his valve pacing or left valve pacing, but till now this is only a plan B after a failure of CRT. We need more randomized trials to see if physiological pacing can replace the conventional CRT pacing.
I apologize, I cannot see if there's any question from the audience, so I don't know if Dr. Rigopoulos or Dr. Triandis can help us with this.
If I may, I also have a question. You showed us that about half of the patients will not be pacemaker dependent after 30 days.
So after 4 months.
After 4 months. So is there a solution? Is there a discussion on this problem? I mean, why should we rush to implant a pacemaker with all the problems of pacemakers that you showed us if we know, or if we don't know, this is the matter we have to discuss, if the patient will need the pacemaker after all?
This is why the guidelines didn't give a clear indication for pacing with new onset LBBB and say that we have first to perform EP study or a Holter monitoring, because the dependency is very low, and I remind you, and I think that I said in my presentation that this 59% needed pacing more than 1%, very low percentage. So I think that we don't have any indication to pace this patient directly. We don't have to hurry up. We have to wait and see if there are symptoms or there is new AV block in Holter monitoring.
And an EP study to all of them?
All of them I don't think it's very practical to do in all patients, but if we have a very wide QRS, or if we have a very wide PR interval, we have to see if the HV interval is prolonged. The recommendation is for all patients, but I think that in clinical practice, this is not true.
Okay, thank you very much.
Just a very quick comment. I just wanted to stress what you said for us to understand where we stand now. If we have an LBBB with a QRS of more than 150, 160, 170, 180, this is a clear indication. This is a very high-risk patient. We should implant a pacemaker. Or if we have an LBBB with a PR interval, let's say 150 before, and after implantation it goes to 250, this is also another sign of high risk. So if we have them both prolongation of the QRS after the implantation and the prolongation of the PR interval, this is the highest risk patient. So I think we should stress this for all to understand where we are now. So an LBBB that pre-exists, or a new LBBB that we see with a very wide QRS, or a new prolongation on top of the pre-existing on the PR interval, these are the signs we have to follow.
Yes, I agree. And of course, you know that according to the guidelines, there are always gray zones, because if you have all these characteristics together, you don't know if you have to direct implant a pacemaker or not. But these are the criteria for high-risk patients. We don't have such a... I don't think that the companies are trying to fight something like this. And of course, if it's something not permanent, you know that there is higher infection rates. And if infection happens, especially endocarditis, in a patient with a pacemaker and a valve, probably is a nightmare.
Would you mind giving us some information about the use of modern or smart devices for patients after TAVI who demand a closed monitoring?
Yes. If the patient has only mild symptoms, smartwatch will be useful. But if the patient is syncopal, he will not have the time to press the button to write an ECG. So it also depending on the symptoms that will come after, that is unpredictable. So I think that Holter monitoring for at least 14 days is safer, at least at the beginning.
I think I will have one last comment. Is there any place for monitoring, ECG monitoring before the TAVI? Would we have more information regarding the need for a pacemaker afterwards?
Also, the guideline says that we have to probably an electrophysiologist to see our patient before TAVI and have a very in detail search for conduction delays or disturbances before TAVI, because we know that we have syncope patients that are not due to severe aortic stenosis before TAVI, but due to disturbances of the electrical system. So I think, yes, that before TAVI we have to check our patient in detail.
Okay, thank you very much, Dr. Kourouklis. And we proceed to the next speaker. This is Professor Zondergaard. I don't think Professor Zondergaard needs a special introduction. Unfortunately, we have only a video of his talk, and he will not be available for further discussion. So please, the video.
So thank you for the invitation to give this talk about how to implant transcatheter heart valve in order to minimize the risk of new onset conduction abnormality, but to still preserve access to the coronary arteries. So we know there's a close proximity between the aortic annulus and the conduction system. It's actually only the membranous septum which is separating these two structures. And that also means that if we implant these transcatheter heart valves too deep, they're going to interfere with the conduction system, which may result in new left bundle branch block or even a complete AV block with the need for permanent pacemaker. So when we started the TAVI program, most of us has been using what we call a classical tricuspid coplanar view, which is placing the C-arm in an LAO cranial projection. And that also means that the three aortic cusps are aligned with the imaging plane, but at the same time, we often have a parallax in our delivery system. We can compensate for that by moving the C-arm still in this LAO projection in order to get the parallax out. But then at the same time, we're going to introduce a similar parallax in the three aortic cusp, which is of course not an ideal scenario if you want to understand exactly how deep or how high are you with your valve during the TAVI procedure. So what we ideally want is a C-arm projection where both the three aortic cusps are aligned with the imaging plane and where we have no parallax in our delivery system. And actually, that is possible to get that because we are often looking just at one S-curve. That's the one which is depicted with a blue line here, which is all the C-arm projections where the three aortic cusps are aligned with the imaging plane. But there's actually also an S-curve for the delivery system with all the C-arm projection where we have no parallax in our delivery system. And of course, if you can have a C-arm projection where these two S-curves are crossing, that's where we have no parallax in the three aortic cusp and no parallax in our delivery system. And for most patients, that's in an REO caudal projection. And another advantage of working in an REO caudal projection is that in this projection, the left ventricular outflow tract is elongated and not foreshortened as we see in a classical LAO cranial projection. So there's a lot of argument for why to use a right REO caudal projection instead of a traditional LAO cranial projection. And that's why it's been suggested to use this left-right cusp overlap view, moving the C-arm towards an REO caudal projection. Again, as I said before, this is going to take the parallax out of the delivery system in most cases and still have the three aortic cusp aligned with the imaging plane, and at the same time have elongation of the left ventricular outflow tract. And that means that most sites have moved away from using this LAO cranial projection during valve deployment towards an REO caudal projection. It's also illustrated here, so you can see if you're working in an LAO projection, you will have a quite long separation between these two S-curves, the one for the aortic annulus and the one from the transcatheter system. So if you try to take the parallax out, you're going to introduce quite a lot of tilting of the aortic annulus plane. So ideally, as I said before, we want to work where these two S-curves are crossing, and the cusp overlap view is going to bring us very near to this with very small distance between these two S-curves. Does it work? I think there's been quite a few reports on that. This is just one study we did in Copenhagen here, looking at 183 patients treated with a traditional LAO view and 183 patients treated in a cusp overlap view. Patient was matched with regard to age, gender, STS score, pre-procedural right bundle branch block, LVOT calcification, and bicuspid aortic valve. And all patients was actually treated with a Navitor or portico valve. And what we could see here, looking at this, the indication for pacemaker was 50% reduced by working in a cusp overlap view, coming down from 15.3% to 8.2%. But implanting these transcatheter heart valve in a high position also potentially can impact the access to the coronary arteries. We can divide all transcatheter heart valve into three groups, those with a low stent frame and intra-annular leaflet position, and those with a high stent frame where the leaflet can be positioned intra-annular or supraannular. And particularly for the last one, where you have supraannular leaflet position, it may be difficult and in some cases even impossible to access the coronary arteries. It was illustrated nicely in this re-access study, 300 patients undergoing TAVI. Physician was asked to cannulate the left and the right coronary arteries right before valve implantation and repeat it again after the valve was deployed. And in 23 patients, 7.7% of the patient cohort, it was impossible to access both coronary arteries after valve deployment. And out of those 23 patients, 22 patients was actually treated with the Evolut platform, supra-annular leaflet position. So for that platform, it was almost 20% of the cases where it was impossible to access both coronary arteries after a TAVI procedure. And of course, that's going to be unacceptable, particularly if you're going to treat patients with longer life expectancy or patients with pre-existing coronary artery disease. Often the issue is that when we implant these valves, they're going to be orientated randomly in the aortic annulus. And if you end up in a situation here, as on the left-hand side, with the leaflet post right in front of the coronary arteries, it may be difficult, or in some cases even impossible, to access the coronary arteries. So what we should aim for is commissural alignment. These valves should be orientated the same way as the native valve. That's what the surgeons are doing when they implant a surgical biprosthetic aortic valve. That's going to facilitate both easier access to the coronary arteries, but probably also better durability of these transcatheter heart valves. It's been suggested to orientate your delivery system in a certain way to try to have a kind of a near commissural alignment in most patients. For the Evolut platform, instead of having the flush port at 12 o'clock pointing towards the ceiling of the room, rotated so the flush port is at 3 o'clock to the patient's left side. And it's been demonstrated here that actually have a significant impact of the rate of severe commissural misalignment coming down from 40 to 20%. But it's still 20% of the patients, still 1 out of 5 patients, just as we saw in the re-access study. So instead, we should try to have what we can call a patient-specific commissural alignment. And again, going back to this left-right cusp overlap view, which is used in order to implant in a higher position and reduce the risk of conductance abnormality, this view is actually also an ideal view to try to have patient-specific commissural alignment. Because if we have this view, you see here on the right-hand side, the red and the green dot are overlapping, meaning it's a right-left cusp overlap view, and the commissure between the left and the right cusp are pointing to the right of the fluoroscreen. So when you got your transcatheter heart valve across the aortic annulus, the only thing you need to make sure of is that one of the leaflet posts are positioned to the right on the fluoroscreen. For the Evolut valve, there are 2 paddles used to attach the stent frame to the delivery system. One is marked with a C, the C paddle, and you see that C paddle is positioned right over one of the leaflet posts. So when you have crossed the valve with the delivery system, you go to this left-right cusp overlap view, you need to see that the C paddle is on the right on the fluoroscreen, and also at the inflow portion of the stent frame, this hat mark should have this configuration so you can actually see the hat. That's going to ensure that you got patient-specific commissural alignment. It's also illustrated here in a different way. Again, you see the eye is the C-arm, green and red dots are overlapping. This is a left-right cusp overlap view, and you see here having the C mark on the right of the screen, and this hat mark configuration is going to ensure patient-specific commissural alignment. This is just one example how it looks on the fluoroscopy. If you don't have it, you can do some torquing on your delivery system in order to make it small rotation until you see that when it's in the right position, you let go of the torque, bring it into a neutral position, and then you can deploy your valve. And after deployment, still in a left-right cusp overlap view, you can immediately have confirmation that you have patient-specific commissural alignment. The C paddle is on the right side of the screen, the non-C paddle on the left side of the screen. So just to summarize here, new onset conductance abnormality is going to impact the outcome for the patient after TAVI. It's associated with a higher rate of mortality and hospitalization for heart failure. A high implantation of this transcatheter heart valve will mitigate the risk of conductance abnormality, but on the other hand, it may impede the future access to the coronary arteries. However, if you use this patient-specific commissural alignment, you will still have the option to access the coronary arteries despite you implant this valve at a high position. Thank you.
I believe we...
So good morning, and we will proceed with our next very interesting discussion, which revolves around the tricuspid transcatheter edge-to-edge repair. We will co-host this table with Dr. Aristeo Hispano, cardiothoracic surgeon, and Dr. Cristina Chrysochou, who is a clinical cardiologist at Hippocrates Hospital. And we will initiate our discussion with Dr. Economidis, from Attikon Nosocom Hospital with the discussion on RV dysfunction, how to assess and when is it too late to intervene. It's a very important discussion. Thank you very much. Dr. Economidis? Can you open your camera, Dr. Economidis? If Dr. Economidis is not available, we could proceed with the presentation from Dr. Rebecca Hahn, who needs no introductions. Rebecca Hahn is well respected in the field of interventional echocardiography, professor of cardiology at Columbia University, with a very interesting discussion on echo guidance for transcatheter edge-to-edge repair, screening, and procedural considerations. Thank you.
I'd like to thank the conference organizers for inviting me to speak on the echo guidance for tricuspid transcatheter edge-to-edge repair screening and intraprocedural guidance. I'm Rebecca Hahn, and these are my disclosures. We just recently published this review on tricuspid regurgitation, in which there is a table on the possible eligibility criteria for transcatheter TEER devices. In that table, we define some of the ideal pathoanatomy for optimal tricuspid TEER outcomes, including the leaflet lengths and mobility and the coaptation gaps in TR severity and location. However, there are challenging pathoanatomies that can still be adequately treated with the TEER devices, as you can see here. In addition to these anatomic criteria, however, there are also physiologic criteria that have been shown to predict poor outcomes in the tricuspid TEER population. And these may be anatomic criteria that are relevant to all devices, but that remains to be seen. Now, when we're making a device choice, and particularly for the leaflet repair, again, we have to consider that leaflet tethering and leaflet coaptation gaps are going to really determine whether or not the devices are feasible, but where we have a little difficulty sometimes is the TEE imaging. Toward that end, we've just published the recommended standards for performance of TEE screening for structural heart interventions, and defined all the views that are required for the tricuspid valve. Briefly, the newest imaging level is the deep esophageal view, and this allows us to image the tricuspid valve without the intervening left heart. Again, we are now deeper in the esophagus and very close to the tricuspid valve. So again, near field imaging, which will improve our resolution, as well as avoiding the acoustic shadowing of any structures on the left. These are examples of the mid-esophageal view, the four-chamber and its biplane image, which are always the initial images that we acquire, not only to determine whether or not we have primary or secondary disease, but also to look at right ventricular size and function. The same images can be acquired from that deep esophageal view, as you see here. The main working view that we use is going to be the Inflow-Outflow view or commissural view, because the coaptation gap typically is along the entire coaptation zone of the septal leaflet, and therefore this Inflow-Outflow view allows us to do a sweep from the anterior portion of the annulus near the aorta to the posterior portion, and therefore helping us to define the length and width of that regurgitant orifice. The same type of sweep can be performed from the deep esophageal view. As you can see here, there is a flail leaflet, an flail anterior leaflet that is well seen when we do the sweep across the valve. But one of the most useful views for the tricuspid valve is the transgastric short axis view. As you can see here, the short axis view allows us to see all the leaflets and therefore count the number of leaflets, which we've now found don't always have the number 3. We can also see the regurgitant orifice and the shape of that regurgitant orifice, and that helps us define the number of devices that we may need in order to reduce the tricuspid regurgitation to moderate or less. Now, we use the transgastric view, both color and non-color views, as well as three-dimensional imaging from any of the levels in order to help define the morphology of the tricuspid valve. And we found that in 579 patients, that 54% of them had a trileaflet valve, but the rest had combinations of 2, 4, and even greater numbers of leaflets. In order to make that determination, we had to look at 3 anatomic structures and landmarks, and those were the anteroseptal commissure, defined by the location of the aortic valve, so that commissure is always adjacent to the aortic valve. To look for the anterior papillary muscle, because that allowed us to separate the anterior from the posterior leaflet, and then look for the length of the interventricular septum, which would define the length of that septal leaflet. And what we found was that type 1 or 3 leaflet valves occurred in 54% of patients, that 2 leaflet conformations or a bileaflet valve occurred in less than 5%, and that the most common, more complex leaflet morphology was the 3B, which has 2 posterior leaflets. Now, to help define the number of leaflets, again, one needs to define the location of the anterior papillary muscle. So you can do that, again, on the transgastric short axis view or three-dimensional short axis view, again, from the transgastric imaging window. And here we see a 3B morphology, so 2 posterior leaflets, because the anterior papillary muscle is here close to the RV outflow tract, and therefore these are 2 posterior leaflets. Now, the deep transgastric view allows us to do a lot of quantification, and sometimes it's the only view that we see the leaflets very, very well, and therefore don't forget that you can always do three-dimensional imaging from any of the imaging planes. But these are examples of how we use the deep transgastric view in order to do quantitation of regurgitant orifice. This is a summary slide, again, with all the measurements that are required in order to quantify TR, either by average vena contracta widths, but also by proximal isovelocity surface area, or PISA, quantitative Doppler, and 3D vena contracta area. When we're guiding the procedures, we need to use all the new imaging tools that we have. So 3D real-time multiplanar reconstruction is very, very useful, and you can see the new tools that we have. We can now change the orthogonal imaging angulation. We don't have to be orthogonal, don't have to be 90 degrees, and therefore we can typically find the angle at which we see both device arms. And then we use real-time multiplanar reconstruction to align the clip arms, and also to help orient it based on the three-dimensional image. But the new imaging modalities of 3D intracardiac echo and echofloral fusion are going to be also very useful for this procedure. So let me give you an example of the use of both TEE and ICE in the same patient. This is a patient, again, where you will require imaging of transgastric short axis view, which the TEE is the best for. But the ICE is going to be very helpful for imaging the long axis of the device. So here's the TEE views, guiding the device down to the tricuspid annulus and making sure that the orientation is well aligned. And then in order to confirm the clasp identity, we really require better resolution of the long axis of the device, and that's where ICE can be quite useful, as you can see. The TEE, however, is used again to orient the device. It requires a larger field of view to see the full short axis view and to make sure that you understand where the septal, anterior, posterior, or multiple leaflets are. And in this case, because it was a quadricuspid valve, we wanted to grab P1 and septal, and therefore we had to clockwise rotate. And as you can see in the short axis views only, so single plane imaging. But when we decided to grab the leaflets, we went back to ICE imaging. You can really see the beautiful leaflet definition, the leaflets falling onto the device arms, and then closure of the device arms with the leaflets fully engaged. And then from the TEE view, either from three-dimensional imaging, or in this case, two-dimensional imaging as well, we can see the tissue bridge and the reduction in tricuspid regurgitation and confirm that reduction using ICE imaging for the long axis of the device. TEE was used for the final assessment of the regurgitant orifice and reduction down to mild. And in summary, we really want to understand that screening requires a determination of the coaptation gap, the leaflet lengths and mobility, and the morphology, determination of whether the pacemaker is impinging on those leaflets and where the location of the regurgitant orifice is. But to do the intraprocedural imaging, we really require the use of all imaging levels and all imaging modalities, including 2D, biplane, 3D rendered, and 3D multiplanar reconstruction, understanding that the adjunctive advanced imaging of fusion and 3D ICE will remain very useful for this particular device. Thanks for your attention.
We'd like to really thank Dr. Hahn for this very important contribution to the Congress. Are there any questions in general? Unfortunately, we don't have Dr. Hahn available. We can have the question later. We will proceed with Dr. Economidis, who is able to... Christina, Makous?
Yes, I can hear you. I have a question in order just to open a discussion, if I can. Dr. Hahn referred to, can you hear me?
Dr. Hahn is not online, so she's
yes,
not...
I know she's not online, I know. But
yes, we can hear you very well.
Okay, I was referring the question to you because I know that you have a great experience on both valves, especially now in tricuspid regurgitation. And my question is just to open a discussion and be more educated to new people like me that I am not in so much interfered with imaging of tricuspid regurgitation in order to have an edge-to-edge repair. And I would like to ask, there's any differences in the anatomic eligibility criteria according to the pathophysiology of tricuspid regurgitation? I mean, do you use the same anatomical eligibility criteria for tricuspid regurgitation due to atrial enlargement, like in the case of heart failure PEF, or in the same heart?
Sorry, I can't hear you very well. I apologize, Christina. I can't hear you very well. Can you repeat the question? I apologize.
Yes. I would like to ask if we use the same anatomically eligibility criteria for edge-to-edge repair of tricuspid regurgitation in the case of heart failure PEF and in the case of heart failure REF.
So if I understand the question correctly, if we use the same anatomic criteria for edge-to-edge repair, depending on valve morphology, depending on if it's a tricuspid valve or a bicuspid valve or other...
And also it will have a small left ventricle, like in the case of heart failure PEF, when we have the
atrial functional, yes.
Yes. Or in the case of total heart failure, when we have enlarged chambers overall.
Well, in general, when patients are referred for repair of severe tricuspid regurgitation, the majority of these patients have functional tricuspid regurgitation, most commonly ventricular functional TR, but now we see more and more atrial functional TR. In those patients, anatomically, we do a screening imaging to assess eligibility, and eligibility number one, whether we can see well the valve from all imaging planes with the transesophageal echo. Number two, that we can approximate the leaflets, that we have that we don't have large coaptation gaps that may preclude the position of the device. It is important for these patients to be well prepared for these evaluations, because if we have a patient who is in decompensated heart failure, we need to first of all bring them to a more compensated state, diurese them, because that may change the image, the appearance of the tricuspid leaflets, and the coaptation gaps may become smaller, as well as the size of the right ventricle. And technically speaking, if we don't have a large coaptation gap, if we have gaps that are less than 8 to 9 millimeters, those, technically speaking, are feasible to be repaired with edge-to-edge repair, number one. And usually we aim for the septal anterior commissure, where the majority of devices are placed, or posterior septal commissure, which is the next more common area for implantation of devices. We avoid anterior and posterior. Obviously, we don't do anterior-posterior devices. So technically speaking, we will make our decision based on anatomic factors, on clinical factors, and imaging factors, very importantly. Thank you. Thank you very much for the question.
Professor Harris, just to summarize, which would be the typical patient you would refer to for edge-to-edge repair for the tricuspid valve?
even for surgical patients, sometimes we're very hesitating according to which level of evidence or recommendation level we would apply.
Yeah, number one is to understand the patient's surgical risk, and we like to use the Tri-score developed by Dreyfus that gives us an idea of in-hospital mortality after isolated tricuspid valve surgical repair or replacement. But the majority of these patients with functional tricuspid regurgitation are usually not going to surgery because there's no other surgical indication for these patients, and they're considered at high risk. Those patients, we assess all of these patients for edge-to-edge repair. Edge-to-edge repair is a low morbidity procedure. It's fairly safe, it's patient-friendly overall, and the benefits of successful edge-to-edge repair are really very important, and we can obtain these without a very risky operation. So we need to understand clinical and anatomic features, especially anatomic features, whether we can approximate the leaflets, whether we have anatomy that is desirable for edge-to-edge repair. At this point, this is the only modality practically that we have available. The main issue we have sometimes is, commonly is imaging. If we cannot really image the valve very well, that's a problem. And the second thing that is whether we have large gaps that preclude approximation by devices. But these are modifiable by optimizing the patient's volume status and preparing them for these procedures. So we'll proceed with Dr. Economidis, and we need to understand the right ventricle in addition to the tricuspid valve. The right ventricle plays a very important role in these patients. So assessing a right ventricular dysfunction, how to assess and when is it too late to intervene is a very important topic. Dr. Economidis is well suited to address this issue. Thank you very much.
Thank you for the kind invitation to this very well-established meeting. And right ventricle, of course, has a difficult architecture. We know that it consists of subepicardial circumferential fibers in continuation with the LV fibers, and that's why there is a lot of LV-RV interaction, particularly through interventricular septum. But most of the job is done by the subendocardial longitudinal fibers. Now we know that there is a significant prognostic value of right ventricular function in heart failure, in ischemic heart disease, in cardiomyopathies, in pulmonary hypertension, and of course in valvular heart disease. We do have gold standards to assess RV function, and this is the MRI, and we do have normal values, and you can see that the lower limits of the ejection fraction, for example, is something like 50%. However, in the daily clinical practice in cardiology, we need to use echocardiography. This is by the side of the patient. It's easily applicable, and we do have normal values to assess RV function. However, because of the shape of the right ventricle, we are obliged to use several views, longitudinal views, apical views, to assess the dimension. And of course, we have the novel 3D echocardiography means to assess in a better way the LV volumes and function. Furthermore, other indices like TAPSE and the tissue Doppler S-wave of the right ventricular free wall and the right ventricular strain of the free wall, but also of the overall right ventricle from the apical view have been used to assess RV function with pros and cons each one of these indices. What we have to know is when we assess the right ventricle, we have to use the RV-focused views and not the usual four-chamber views that we use, because these produce the least variability between the operators and the more consistency with the gold standard, which is the MRI. Now, we do have right ventricular dilation. However, we have to assess if there is congenital heart disease, pulmonary hypertension, arrhythmogenic right ventricle. It can appear in athletes in sleep apnea, in chemotherapy, and of course, we are interested in valvular heart disease, and of course, we have to know that ischemic right ventricular dilatation and wall motion abnormalities may also exist in cases of an inferior myocardial infarction. Now, the questions we answer is, are we dilated? Is it hypertrophied? What is the systolic function? And what we need also to know is the right ventricle to pulmonary artery coupling, and of course to assess any anatomical abnormality that explain RV dysfunction. Now, we have a normal apical view with small right ventricle compared to left ventricle. However, we have a dilated right ventricle with a dilated tricuspid annulus and impaired, mildly impaired, and here we have a severely impaired RV wall thickening with severe dilated tricuspid annulus, dilation of right ventricle and left atrium, and you can see how the interatrial septal bumps into the left atrium because of the elevated right atrial pressure. So we can have an estimation if function is mildly impaired and the dimensions are mildly increased, or severely impaired and severely increased. Of course, we have to quantify RV longitudinal function, and TAPSE is one of the indices used. And I would like to point out that the value of 17 millimeters is a cutoff with significant prognostic value. It has a very good reproducibility. However, it assesses only the longitudinal function of the right ventricle, not the radial function. And of course, it can be impaired after surgery. Another index which is very useful is the functional areal assessment, and this is an easily applied method to have an idea of both longitudinal and radial function, and the value, as you can see here, has to be greater than 35%. It requires, however, a good right ventricular imaging, and it has less reproducibility compared to TAPSE measurement, but better correlation with right ventricular ejection fraction. And of course, 3D imaging gives us a lot of information and is the closest to the MRI assessment of the volume. Here you can see a normal right ventricle and a right ventricle in a patient with severe pulmonary hypertension. And again, we have normal values, and an ejection fraction greater than 45% is considered normal. And here you can see the good association with the gold standard MRI volumes in terms of diastolic and systolic and ejection fraction. However, not all indices are equivalent diagnostic in different diseases and different situations. For example, here in the upper panel, you can see that the TAPS and S values are normal. However, if we use the FIC, you can see this is impaired because the longitudinal function is good. However, the radial function, as assessed by the 3D echocardiography, is impaired in a patient with pulmonary hypertension. And this is a patient with a tetralogy of a lobe because of previous surgery. The TAPS and the S wave from TTI are reduced, which is expected. FAC is normal again. However, 3D ejection fraction is reduced, and this is because of the large dyskinetic area, as you can see in the RVOT in this patient. So we have to know the underlying disease to choose which is the best index to assess RV function. Just to remind you, for the pulse wave Doppler, a normal value greater than 9.5 has a prognostic value. TAE index using the intervals, the IVCT intervals for TDI has been also used. However, the most useful is the right ventricular strain, and a value less than 30% is considered abnormal. Of course, we can have values reduced even in patients with preserved left ventricular ejection fraction. And of course, we have new methods which very quickly can give us at the same time the right ventricular strain, the global, including the interventricular septum and the TAPSE value, as in this patient, you can see a severely dilated ventricle and a significantly reduced TAPSE. Now we know that the right ventricular strain has significant prognostic value in various settings, like pulmonary hypertension, inferior MI, advanced heart failure. And of course, we should never forget to assess right ventricular systolic pressure using the Doppler imaging of the tricuspid regurgitation, and to assess, of course, the RA pressure in order to have a good estimate of the right ventricular systolic pressure. And novel indices regarding the ventricular arterial coupling are emerging, and these they usually assess a right ventricular contractility in relation to right ventricular afterload. This can be done either invasively by assessing the pulmonary vascular resistance or the pulmonary artery pressure, or non-invasively. These are some of the methods where they use TAPSE to assess right ventricular contractility, and they use the presence of a notch indicating severe pulmonary hypertension or the lack of a notch as a semi-quantitative assessment of RVPA coupling estimation. However, we have novel methods. We know that we can construct for the left ventricle the strain pressure loops, and this has been applied for the right ventricle, where we can measure the systolic and diastolic pulmonary pressure using these equations non-invasively, just using data from the Doppler of the right ventricle. We can assess the right ventricular strain, and we can assess the timing by the tricuspid valve opening and closure and the pulmonary artery opening and closure, and then we can have the pressure strain curves, and these curves can show us how much of the work is constructive and how much is wasted, is outside of the systolic ejection period of the right ventricle. And these indices, like the constructive work, has been correlated with invasively measured stroke volume and stroke volume index in this setting. Now we have always the gray zones. This is a patient with severely impaired, at least with eyeballing right ventricle. When we quantified it, we have from TDI 9 centimeters, we have a TAPSE 16, to remind you 17 has a great prognostic significance, and of course we have a significant tricuspid regurgitation. When we apply the 3D echocardiography, again, you can see that the fraction area is about 42%, is borderline but not bad. The ejection fraction is about 37%, which is impaired. Now, an option here is to apply dobutamine and see the response and the contractile reserve. And in this patient, you can see that the TDI increased from 0.09 meters per second to 0.12, which is a good greater than 30% increase. Similarly, TAPSE has increased from 14 millimeters to 22 millimeters, which is a good response. And of course, we have an increase in RVSP, and again, the RV strain from 12 increases to 16, which is also a good response to dobutamine, indicating a good contractile reserve. What should we expect normally when we apply any kind of exercise test, either bicycle or dobutamine? We have to have at least a 30% increase in TAPSE, a 25% in FAC and in fractional area, and 50% they say for S-wave, that is in normal patients, normal subjects, and a 55% of pulmonary artery pressure and about a 40% for RV strain. TAPSE and FAC and S-wave are the most visible indices during echocardiography. Now this is another patient that has been already operated. This is a young patient, about 44 years old. She had an operation at a younger age because of rheumatic valve disease of the mitral valve. You can see here the prosthetic valve, but here you can see an impaired right ventricle, dilated right ventricle, dilated tricuspid annulus, and you can see here there is even a gap, and we have a significant tricuspid regurgitation. This is the 3D recording of this patient, and you can see the gap between the leaflets of the tricuspid valve. Now the question from the surgeon is, should I proceed to correct this tricuspid valve, because the patient was symptomatic, had edema, had signs of right heart failure, and we applied again dobutamine to see the contractile result. And again, you can see the TAPSE has increased from 18 to 22. We had a VTI increase from 11 to 21, so a 50% increase of the right ventricular volume by recording of the flow in the pulmonary artery in the RVOT. And of course, we had a good response to dobutamine in terms of RV strain and in terms of S-wave by TTI. And this is the post-op echo. The patient was successfully operated, and you can see here the volumes and the ejection fraction. On before it was something like 49%, increased by dobutamine to 59%, but you can see that the volumes were significantly increased, 140 diastolic, 71 systolic, and you can see here the significant improvement post-operatively, and the ejection fraction was 40%, so it was maintained a good ejection fraction post-operatively. So dobutamine gave us a hint to carry on in a second operation in this young patient. Now, are these indices predictive of adverse outcome? This is a study indicating that when we have an RV dilation as assessed by annulus diameter greater than 40, or TAPSE less than 17, then this indicates a bad outcome in patients with tricuspid regurgitation, particularly when these are associated and are combined with symptoms and the need to use diuretics. This is another very recent study suggesting again that a large orifice area by three-dimensional echocardiography, but also the contractile reserve as assessed by the ratio of TAPSE to systolic pulmonary artery pressure assessed by echocardiography are predictors of adverse outcome of all-cause mortality at a follow-up of about 600 days. Now we know from the guidelines, the very recent guidelines, that if we have severe right ventricular or LV dysfunction or severe pulmonary hypertension, we may choose a medical therapy instead of intervention. However, apart from a value of TAPSE with 70 millimeters, no definitely cut-off points defining the severe right ventricular dysfunction have been established until now. What we know that increased tricuspid annular diameter indicates the comeback of severe tricuspid regurgitation after intervention. And we know for the Transcatheter tricuspid valve repair, the inclusion criteria was a good LV ejection fraction greater than 35, a TAPSE greater than 13 millimeters, indicating a somewhat preserved right ventricular function, and of course, tricuspid valve annular diameters between 40 and 55. And this is an observational study with a large number of patients that had a transcatheter operation, and the 1-year survival period and the survival free from hospitalization, these patients were 83 and 78%, which is quite good. But when they assessed the baseline echocardiographic characteristics in these patients like TAPSE, FAC, fractional artery change, and end-diastolic area and pulmonary artery presence, these were not different, indicating that these simple measures, the baseline measures, may not predict outcome after transcatheter repair of tricuspid valve. So maybe dobutamine stress echocardiography or any kind of stress echocardiography by biopsy may give us some insight and show us who of these patients will respond better to these interventions in the future. So in my conclusion, I would say that LV function assessment is necessary in any patient with heart failure or valve disease. We need optimal images. Right ventricular strain is a good marker with good reproducibility between operators. 3D echo has an increasing value in the assessment of RV function. RV-POA coupling should be taken in mind, and you can see that contractile reserve, as assessed by these markers, can be very useful in determining the prognostics of patients with tricuspid regurgitation. However, we do not have definite cutoff points for severe LV dysfunction to exclude intervention at the moment. Thank you for your attention.
Dr. Konomidis, thank you very much for this very concise discussion. We'll have reserve questions for the end, and we'll proceed with Dr. Stefan von Bardeleben. It's a pleasure to introduce him, who will discuss technical considerations and strategies for optimal tricuspid edge-to-edge repair with either TriClip or Pascal. Stefan? Hi, can you unmute, Stefan? You have to unmute your microphone.
Now you should hear me.
Yes,
Hello?
yes, we hear you very well. Good morning.
Good morning to Greece. Good morning. Thanks for having me here at this very good meeting. It's, I think, my fourth or fifth time at the RIA meeting. And I'm happy to introduce the technical considerations and also strategies for T-tier, as we now call it. So I will just shortly go into the anatomy. We already heard about it. We have a situation that the tricuspid valve has dense chordae, thin and variable leaflets, and of course a large annulus. We already heard by Becky Hahn the TR classification that is very important in different types, and this also influences the results and also the procedural success of the device. Bicuspid valves, for instance, type B or 2, are very successfully treated with a low number of clips. Also tricuspid situations where the septal leaflet is homogeneous and one leaflet only, A, C, and D, are very successful. Four leaflets in the tricuspid valve, as well as multiple leaflets, are less likely to have a good result with TR strategies. We already heard in the previous talk that the majority of etiologies is secondary TR. We're now likely to put in between the two groups of primary TR and secondary TR. The group that was also presented by the previous speaker as the last point, that is actually a pacemaker-related CIED, which does not belong truly to primary disease. As you see here, there's a high variability of cords, and the septal cords enter into the septum itself. So they tether and they roll likely when the right ventricle enlarges. And this is one of the main pathophysiology situations why also annuloplasty does not work in all cases of right ventricle enlargements. We know this proposal, which was not going into the guidelines in 2021 of 5 grades, but which were used in all trials actually in the last 4 years of 5 grades. And here we see that, of course, we should not treat too late the patient. This is from the tricuspid focus group that we do together with Francesco Maisano and Fabian Prats at the ESC level. And here you also see the cutoff of a gap of approximately 8.5 millimeters for successful procedures. We already saw that the guidelines now acknowledge in Europe, the only in the world actually, for the first time also a transcatheter therapy with a very weak recommendation of 2B, but which is the same than MitraClip in the previous 10 years. Tricuspid valve regurgitation strategies, this was already mentioned by the chairs, is 70% C, an anterior to septal actually tier treatment that you can nicely see in the simulator on the other side, which also approximates the posterior leaflet. Clover is an alternative. Looking into the devices, you can very nicely see that we have many iterations since 2003, and beginning 2016, we also used the MitraClip and later the TriClip with various sizes. We now have 4 different sizes available. If you look into these sizes, there are 2 widths, which is the NT or the NTW, but in the tricuspid valve, we rather use the longer clips, which is the XT and the XTW, which have actually an arm length of 12 millimeters. Becky Hahn already talked about the transgastric view as being very important to really see the subleaflets and to guide the procedures. And I will give you some examples here. You see the transgastric view in 3D or in 2D with 2 different etiologies. And here you can also see a pacemaker involvement of the posterior septal with 2 separate septal leaflets. And this second case below is much more difficult to treat. So the main goal is to create coaptation and TR reduction. Becky Hahn already spoke about the mid-esophageal and the right, the deep esophageal view, where you scan across the right atrium. This gives you better imaging of the septal leaflet. And also if you have prosthetic valve devices, this is a much better situation to engage. Here you see the typical situation with rolling leaflet here in the tricuspid valve. You can see that we can use MPR during the procedures. This is not ICE, this is TOE with MPR enabling, and we use this to really anatomically relate to the pathology. Here is the discharge of this patient, and you see even after 1 month, and later I have examples for 2 years and 4 years now, we have a very stable finding. We looked into the 3rd generation longer arms for the success, and you see that the success is going down if the gap extends beyond 1 centimeter. This is too large. We have some data on the 1-year results. You see here we have a hospitalization reduction of 40% published in JACC last year, and there is also time free of hospitalization or death for 160 days if you receive a TR1 or 2 after your procedure. There are also other platforms like the Pascal or the Pascal ACE, which is more likely used in the tricuspid space. And you can see that we can swing over. We have the chance to independently engage the clasps into the leaflets so we can more easily bridge gaps before we close the device, or we can do secondary optimization of leaflet entry in these procedures. So the technical tools are getting better and better, and then we close the arms. And the nitinol concept of the Pascal allows the arms to open and close a little bit so they can respond to volume change, which is also something that is brand new. What has also been introduced last year is the rail system, which simulates a little bit the keying of the TriClip system with the Pascal. So you don't rotate a second device part like the sheath or the implant catheter if you rotate one. And this gives you more stability. So it's like an external keying system that you can completely open, and it allows you for better actually procedures, as you can see here. To some of the technical differences, the classic Pascal implant has a spacer that is larger, and you see the Pascal Ace implant is a little bit slimmer. One is 10 millimeters width and the other one is 6 millimeters width, even though it's called P5. And you can also see that the spacer is a little bit more gentle. What is more important is, and this is rarely communicated, that the Pascal Ace has a longer effective clasp entry situation, so it can foreshorten the leaflets better and can produce more coaptation length. And this is why the Pascal Ace is predominantly 99% used in the tricuspid space, also because of the width, as you see here with 6 millimeters, that enters easier between the cords. This is preferable, especially in the tricuspid space. This is a tricuspid situation where we put a bridge here, and this time anterior is to the right. You can nicely see how this works. So we build a bridge, create coaptation, and by doing this, we also change the other leaflet. What is also important is that the frictional element is very high, these 4 teeth that engage into the fiber orientation more at the annular level, where also the tricuspid leaflet is more stable. Here's an example of a situation pre-treatment and 2 Pascal systems on the right-hand side, and you can easily see that there are 3 trace regurgitations after the procedure, so these situations work. And it's also very atraumatic, which you can see here, that the device can open and close. This is a 4-chamber view, and you nicely see on the right-hand side that the device arms and pedals, they really open and close every heartbeat. So this engages the clip device on closure and systole, but in diastole it can open a little bit, and this creates lower gradients across the valve and more flexibility, at least in the early years. We don't have data on 8-year follow-ups yet, but it's important to see this. And this is like occluders that we use for over 30 years. So if we continue, what is about the future? You see the staged leaflet capture is possible, a very rolling leaflet on the left-hand side. And we simply engage this by first engaging the free anterior leaflet, then moving under the septal leaflet, and on the right-hand side, you see we get a perfect result, even in this very, very difficult anatomy. So the new device iterations, both on TriClip and on Pascal, really help us to proceed easier. And here you can also see this in dense chordae. The ACE system is more easy to enter in between because it's a little bit more narrow, and you can elongate the system, which is also important. Here, just an example again, a rolling leaflet septally on the side, and then engaging first the anterior leaflet, moving over, flipping over to the septal leaflet, then nicely engaging it to the center of the device, putting the second clasp down and closing the device. So I think you see very nicely how these iterations can be done in a very modern world. So I would like to show you the future. Where do we go in strategies? This is the first data that is now submitted on the 2-year data of the Triluminate trial. And we have, sorry for getting automatically off, this is now from 40% to 50% reduction at a very low mortality. Cardiovascular mortality at 2 years is 15% only, less than co-op at 1 year, and all-cause mortality 18.7% in the Triluminate trial. So very good results. Here I show you the first worldwide implementation of the release 4 of a class view, not only for mitral as shown here, but also tricuspid space, where we can automatically detect the right ventricle. You see the different iterations of software. It's all the same valve. So this is classic 3D view. This is true view, tissue view. This is glass view. And you see with 12 volumes per second, 3-dimensional total tricuspid valve, including color Doppler. So we're moving ahead with faster and faster echo scanners. In the cath lab situation, we can automatically display the right atrium and the right ventricle over the fluoroscopy system. While doing the implant, we can do tricuspid transgastric views. And here I show you the first images ever on tricuspid glass view, no regurgitation, and here a triple implant from the atrium, right ventricle, and all long axis views on the anterior posterior 4-chamber view and the transgastric view, all generated from one 3D volume simultaneously at 30 volumes per second. If you look up here, this is a 30 volumes per second registration that shows everything on the tricuspid valve in a single motion. So this is the future of TriClip intervention that we will see in the next upcoming 2 years. So for tricuspid valve technical issues and strategies, secondary FDR interventional treatment is a new class 2D ESC recommendation. There are benefits in quality of life, all-cause hospitalization, functional parameters and remodeling showing in single-arm trials up to 2 years. The TR reduction to less than equal 2/5 depends on patient anatomic situation and allows for an even better outcome for the patients. So there should be an individualized patient therapy that we do both in surgery and in all transcatheter interventions. Thank you very much for your kind attention, and I'm ready for any questions that may come up. Thank you very much to Athens.
Stefan, we really appreciate this very interesting discussion. It was really amazing. We will reserve questions and discussion for the end. We will listen to Fabienne for the next few minutes, and then we'll come back. We'll have Fabienne Praz give us a video discussion of cardiac leads and tricuspid regurgitation, cause, bystander, or obstacle in treatment.
Good morning, everybody. Thank you very much for the opportunity to speak about this very interesting topic, cardiac leads and tricuspid regurgitation, cause, bystander, on obstacle in treatment. I will try to answer as much as possible this question according to the data we have so far. I would like to recall about the prevalence of tricuspid regurgitation, a frequent disease, second most frequent valvular heart disease in elderly patient, age 75 and more, often linked to left ventricular and left valvular pathology, but also to the presence of a right ventricular pacemaker lead. And you can see that pathologic tricuspid regurgitation is present in about 20 to 30% of the patient with a right ventricular pacemaker lead. So the lead is at least a bystander, but also maybe the cause. I will show some example during this talk of tricuspid regurgitation. What we know from retrospective study is that patients having a pacemaker lead or defibrillator lead are at risk to develop severe tricuspid regurgitation over long term, as shown in this elegant study, including more than 1,000 patients and followed during about 10 years. And if this occurs, if there is tricuspid regurgitation associated with a right ventricular lead, then the prognosis of the patient regarding survival, but also rehospitalization, is worse. As an attempt to account for the particularity of right ventricular lead-related tricuspid regurgitation, we have proposed a classification of TR in this recent state-of-the-art article published in Neurointervention. And this classification has a separated category for right ventricular lead-associated tricuspid regurgitation due to the particular mechanism of action, but also due to the particular multidisciplinary evaluation and the particular management of that kind of tricuspid regurgitation. You can see that the mechanisms are are diverging from each other, with leaflet impingement on one side, leaflet entanglement, perforation, adherence to the right ventricular lead, but also the consequences of lead extraction with leaflet avulsion. So, for example, lead extraction that can damage the tricuspid valve and aggravate tricuspid regurgitation in some instances. These require a very precise assessment of the location of the lead, interaction of the lead with the leaflet, but also in more granularity, even more with the adhesion of the lead with the leaflet, the entanglement into the subvalvular apparatus, and depending on these different mechanisms, a lead extraction should be considered in selected patients. As you can see, a quite complex situation requiring multidisciplinary evaluation, the involvement of an electrophysiologist, of course, but also of other medical specialties to manage the comorbidities of this very often complex patient. You can see an example here with an old patient we have seen at our valve clinic a few days ago. You can see that this patient have 3 right ventricular leads, which in that situation can really represent an obstacle in the treatment of tricuspid regurgitation. You can see that there is a movement of this lead and also potentially interaction with the leaflet, creating tricuspid regurgitation. And this is, of course, complex situation requiring also an advanced imaging study, computer tomogram, to be sure to localize appropriately these different leads. Another situation with a clear interaction between a lead that has been implanted, as you can see on the left side, implanted into the septum with a lot of slack, and this particular anatomy of the lead will result into a interaction over a year between the septal leaflet. You can see that the leaflet is retracted and thickened, and this interaction finally lead to scarring of the leaflet and severe tricuspid regurgitation, as you can see on color Doppler. In this particular patient where there is a clear interaction with the leaflet, maybe an adhesion and tricuspid regurgitation that is clearly induced by the right ventricular lead, repositioning or removal can be considered. But this has to be done in very selected patients because the experience show that removal of the lead will not improve tricuspid regurgitation in any situation and can even worsen tricuspid regurgitation to additional damage of the valve in some patients. In addition, the risk of surgery procedure has to be taken into consideration. It has a risk of about 1% of severe complication with the need for conversion to open heart surgery. In most of the patients not requiring this kind of procedure, transcatheter solution, and the one we have already approved, leaflet approximation, direct annuloplasty with a cardioband device, and in the future also valve replacement, is an appropriate treatment for patients with right ventricular lead that is not really the cause of tricuspid regurgitation, but rather a bystander. You can see that in this particular case, transcatheter edge-to-edge repair leads to similar procedural success between patients having a right ventricular lead or not. In the trivalve registry, for example, you can see also that the durability of the result and the symptomatic improvement does not differ between these different categories of patients. And this is confirmed also by more recent data using the TriClip device in the BRIGHT study. You can see that procedural success as defined by the reduction of tricuspid regurgitation by at least 1 grade is also possible in patients with right ventricular lead. You can see that and that's the same in all study, about 10 to 15% of patients included in study had a right ventricular lead in place. Here's an example of a patient treated with transcatheter edge-to-edge repair. You can see this massive tricuspid regurgitation located mainly in the anterior septal commissure, with a lead located in the other commissure, in the posterior septal commissure. And as you can see also on the 3D view, this lead is moving inside of the coaptation defect, which is always a very reassuring sign that there is no adhesion and no entanglement of this lead, and that this lead will also be able to be moved, to be displaced slightly during the procedure by the clip implantation in order to address the coaptation defect. And that's what we did in that particular patient. You can see that we could work here around the lead located in the posterior septal commissure. We have implanted a first clip with, as you can see, a modest reduction of tricuspid regurgitation. We've then implanted a second clip anteroseptally as a zipping technique in order to achieve bicuspidization of the valve. You can see as the implantation of the second mitral clip, there is still significant tricuspid regurgitation towards the posterior septal commissure. You can see the right ventricular lead that does not interact with the therapy. And finally, we implanted a third clip in the posterior septal commissure more posteriorly, but still anteriorly from the lead. You can see that the lead has been moved a little bit towards the posterior septal commissure, but is not the final result with a good reduction of tricuspid regurgitation in that patient. And these results are also durable, as you can see in the follow-up of that patient. 3 months after treatment, the patient has a good response to the therapy with a weight loss of 4 kilograms and reduction of ankle edema, and also reduction from 1,300 picogram per milliliter NT-proBNP to 608. And the situation is now stable 2 years after the procedure with still mild tricuspid regurgitation. The lead is still in place and the pacemaker is still functioning. And you can see that the patient has no sign of heart failure and a stable NT-proBNP of 640 picogram per milliliter. Valve replacement is also another option in patients with pacemaker, and you can see that the proportion of patients with pacemaker included into the study and the EVOQUE study is quite high, 35% of patients with pacemaker at baseline. And also another important point I want to make in that presentation is that the implantation of a right ventricular lead or a pacemaker can not only be an obstacle or a bystander during a procedure, but is also sometimes a consequence of the procedure as well. And this has been observed in about 10% of the patients following implantation of the EVOQUE valve. You can see an example of a patient with a pacemaker lead, quite a mobile lead and very severe tricuspid regurgitation, who has been treated with implantation of an EVOQUE valve from the transfemoral access. And you can see that at no time actually this lead located in the posterior septal commissure interact with the therapy. The lead is then jailed after implantation of the valve. You can see that there is still enough slack for the lead to move into the right ventricle. And finally, we have not observed any change in terms of function of the pacemaker in this patient. Generally, patients implanted with the EVOQUE valve are not completely pacemaker dependent, but there are no major dysfunction associated with jailing of the lead, as you can see here, between the tricuspid annulus and the new implanted valve. Another interesting example, and I have mentioned that pacemaker implantation can be a consequence of valve implantation. It can also be a consequence of other therapy, of cardioband implantation. You can see a patient with very severe tricuspid regurgitation, and at that time, no pacemaker. We have then implanted a cardioband. You can see here that the cardioband implantation is almost finished and that we are implanting the last screw. And this last screw came into contact with the septum of the left ventricle and probably also with the AV node. You can see that during screwing of this screw, the patient becomes quite bradycardic, but this resolved during the procedure and also after cinching of the valve completely. And what happened then on the ward can be seen here. The patient had a long pause and syncope on the ward, probably due to damage of the conduction system and the AV node. And in that particular situation, the implantation of a micro pacemaker, a leadless pacemaker, is also possible through the cardioband, but also through an EVOQUE valve, and has already been performed in some patient needing pacemaker after transcatheter intervention. So let me conclude this talk by saying that right ventricular lead is present in about 1/3 of the patient with relevant tricuspid regurgitation. There is a need for careful imaging assessment to identify the interacting lead and the lead causing tricuspid regurgitation, because the management of this patient is different. Transcatheter treatment is safe and effective in patients with right ventricular lead. And finally, new permanent pacemaker implantation is needed in a small proportion of patients undergoing direct annuloplasty, that's basically the cardioband device, or transcatheter valve implantation. Thank you very much for your attention.
We would like to thank Fabien Praz for this very important and detailed contribution. We'll proceed with discussion on these 4 topics that we heard. And do we have any questions by the audience to begin with?
I have one for Professor Economidis. Thank you for this very clear presentation, indeed, for a cardiac surgeon. And I would like to know if there is still a place for the MRI or the right cardiac catheterization for in the assessment of the right ventricle and tricuspid regurgitation.
Well, you can see that there is a variety of indices combining, for example, TAPSE with for example, the pulmonary vascular resistance assessed by catheterization, or the pulmonary artery pressure assessed by catheterization. So I think that whatever is in our hands, any detail and any information given either by RV catheterization or by other techniques are needed in order to assess RV function, because it is one of the determinants of the success of our intervention. And unfortunately, there are no studies giving cutoff values for all the markers or giving a hint which is the best. TAPSE is the most used one. It's very it's very reproducible. And it is a validated index, as I have shown you during my talk, for outcome in patients with severe tricuspid regurgitation. However, contractile reserve, I think, is something that is an emerging issue in the literature, and this is something that we should have in mind and use it in our clinical daily practice.
Thank you. Stefan, hi, I have a question for you. Are you here with us?
Yes, Kostas.
Hi,
hello.
it's Kostas. Hi, thanks for being with us. And again this year, and hopefully next year you'll be here physically. And I want to ask you, if you were to choose between an advance in imaging in the tricuspid valve and an advance in the device, which one do you think it's more desirable at this stage? Would you prefer to have better imaging or better device?
It depends whether we want to go for repair. I think the TEER devices are very mature. I'm not looking into a lot of changes there. I think 1 or 2 millimeters, then maybe even smaller devices. That would be something, but this takes typically 3-4 years to develop. I think we need more device sizes in the tricuspid replacement program, and we need changes in imaging. And Becky has already shown some of the hints, and we're also using, and we used in a TriClip procedure 2 days ago, ICE by Siemens. There is ICE coming by Philips, and we have also the Nuvera system. So I think there will be innovation very shortly, in the next 2 years already, on the possibility to treat patients with tricuspid disease, especially without TOE or without intubation. So this will become, in my opinion, a totally awake, conscious, no sedation procedure together with ICE, because it's very easy to have a second venous puncture in the other groin. It's a 12 French system that's totally steerable, like a TOE probe. and you already get excellent or pretty good images, I must say. So it's slightly minor to TOE in a good patient. But every patient that has problems with the esophagus, every patient that has problems with prosthetic valve replacements in the aortic or mitral position, I think the future is ice. Does this answer partly your question,
Yes,
Doctor?
yes. I hope your dream will come true, because it's also our dream. And because intervention, transcatheter intervention in the tricuspid valve is very low risk. And if it can be done quickly and safely with an ICE probe from the jugular vein or from the other leg, it will be a very welcome advance. And finally, we all saw your study about the gap in the tricuspid valve and the failure of the TER. And I think you alluded to that earlier. You said you would like 1 or 2 millimeters more in the devices. Do you think a longer tri-clip or a longer ACE size will be desirable for those large gaps?
Yes, I think so, especially if we combine it, as I showed, with the nitinol, either in the situation that the clip, even a tri-clip, could open a little bit, so you could change the lock mechanism slightly, so that you get less tension on the device, or you could include the arms with a more flexible option at the end. This would not cause leaflet tear. Many people were concerned in 2016 with leaflet tear on the tricuspid valve because the leaflets are thin, and the rupture pressure is about 40% lower than on the mitral valve, but almost nothing happened. And we can even reduce annular size over a leaflet treatment, which was not deemed possible by many heart surgeons that I know of. And also this works. So I think we can improve it a little bit more. And you saw that even the Pascal to the Pascal ACE got an increase by 1 millimeter in the clasping area length, and there will be more changes. So I think we need multiple sizes. And I can also tell you that I now treated patients with more than 5.5 centimeters that screen failed for replacement. I thought I cannot do a TEER on them, so I was forced to do a TEER, and they were successful. 4 patients that failed for a transcatheter replacement and failed for surgical evaluation. So the time is going on, and I think repair will remain a strong partner because there are no pacemaker needs, unlike replacement, and there's also almost no anticoagulation needs compared to the replacement systems we currently have that all need to be anticoagulated, even if you use biological leaflets. So this is, I think, a very important message, that we may cause thrombi by replacement, and there is an ongoing evaluation of these situations. TEER is absolutely safe.
Dr. Bardeleben, thank you for these comments. I have, what is your opinion about the Tricento in very ill patients? Is there a place or not? Is a Swiss system, I think, a Swiss-German system?
I'm cautious, very cautious. Why is that? Because I think heterotopic versus orthotopic valve replacement will always be inferior. And we know from the Spanish and from the Polish ongoing trials that we do not see a big problem in the procedure, but we see a 30-day problem. And you will see that in the upcoming meetings, that you ventricularize the atrium, which may not be too bad, but people are looking too much at the pressures in the vena cava. If you look at the system of contraction, and if you look back into congenital heart disease, if you only have a weak contractile situation in the ventricle, you combine the ventricle with an even weaker right atrium, it is like a big aneurysm in the left ventricle. So this is a non-contractile pouch that has a dyskinesia, and your effective contractile and systolic function will decrease over time significantly. So unlike Nina Braunwald, who put in circulation 1970, the tricuspid valve is not needed because there are patients without that were very young, 20 years, 25 years. I think this comment in circulation 1970 by the wife of Eugene Braunwald was wrong in comparison to the comments on the aortic valve, which needed treatment at that time. So I think Tricento may be a bailout, but it's a bailout with a high mortality and bad physiologic function.
you get extremely elevated BNP levels, you get a dilatation of the coronary sinus, you put ventricular pressure to the atrium, and you have a pouch that has dyskinesia and doesn't contribute to contraction. So I'm not very fond of heterotropic cable valves, in my opinion. Be very cautious with that.
Thank you.
Do we have any more questions? We have a question by Dr. Nikas.
Thank you very much. I have one question for Professor Ioannidis and Economidis and Dr. Prats. Apart from the mechanical, pure mechanical interaction between the lead, the pacemaker lead, and the tricuspid valve, should we also consider the difference in electrical synchronization of the right ventricle, especially when the lead is placed in the apical part of the right ventricle as a cause for tricuspid regurgitation, annulus dilatation, and tricuspid regurgitation? That's the first one. The second one is just a topic I'm always thinking about. Instead of trying repairing these tricuspid valves that caused regurgitation through the lead, should we also try to persuade our electrophysiologists to put the pacemaker much more carefully instead of just throw a cable in the right ventricle?
I think that was a very, very important comment. I mean, and the prevention of wire-induced tricuspid regurgitation is something that evades us for whatever reason. I'm not sure why that we cannot, we haven't reached the point that we can detect this at the point of implantation. Stefan, what do you think?
I think there are too little echo studies in EP departments. That's the big problem. You know, the total implant process mainly has been a wiper movement in the atrium, simply bring the probe in, anchor it securely, do not produce a pericardial effusion. That was all in training, even in Germany. So I think if you start to do echoes and send every patient either intra-procedurally or post-procedurally to an echo department, we would see many things earlier. But the comment in the audience was perfect, because we also see, and this is true, and I have patients that had a good tricuspid function, that had a good right ventricular function, that have no coronary artery disease, etc., that deteriorate after 3 years of pacing, right ventricular pacing. And also these entities have to be watched much closer, and then you secondarily induce TR, not even by the cable, but by the pacing itself. So I think this comment was extremely valuable, and we should raise our awareness. You know, if we look back 10 years, nobody cared about tricuspid regurgitation so much because a small number was operated, and cardiologists, even if I look into the German echo departments, they did not know exactly about the reason for tricuspid regurgitation. Now that cardiologists also treat together with heart surgeons this disease, the number of procedures has tripled or quadrupled. Also, the number of annuloplasty sales in surgery has augmented, doubled in Germany. So it's not that actually the surgeons suffer from transcatheter therapies. They gain volume, they double their volume in Germany because the awareness is up. And I think the same is needed for the EP departments, that they have to cooperate with preventive departments, like with our colleague Economidis. And this is extremely important, that we work together as cardiologists and heart medicine doctors, that includes heart surgeons, in one team, and that we not say, we want to do this and we embrace this and we show nobody else, and the patient comes with a bad heart failure, tricuspid or right ventricular heart failure after 3 years. Nobody knows why this developed. This is not enough care for the patient and doing a procedure for the procedure only, not caring for the total heart of the patient. I think this is an extremely important outlook for the future. What do you think? Sorry, my colleagues in Greece, what do you think?
I agree, and this is a particular problem because as the patients grow older, they develop atrial fibrillation. So we have a combined problem, and tricuspid regurgitation begets tricuspid regurgitation, and we get patients without any problem actually with the left ventricle because they have this desynchronized contractility because of the right ventricle. They do get tricuspid regurgitation, they do get atrial fibrillation, they increase their annulus, so we have a combined problem. Tricuspid regurgitation because of the valve distraction at implantation, or because there is an obstacle to the valve itself and plus the atrial fibrillation that increases the tricuspid annulus, and we get patients with RV heart failure just because they have implanted a pacemaker. And this is something that we should try, as Dr. Bardeleben said, to try to put it correctly, and particularly in patients that they already have atrial fibrillation in their context.
Just to add, the number of atrial fibrillation in TAVR patients is 30%. The number in mitral patients is 60%. The number in tricuspid patients is 90%, as a rule of thumb. And also tricuspid is the only disease where females are predominant. Aortic valve disease treatments, males are predominant, 56%. Mitral, males are predominant. In tricuspid, females are predominant worldwide. And also the atrial part, and Fabian Prats slightly mentioned this, the role of atrial enlargement, right atrial enlargement, is highest in tricuspid regurgitation. So functional disease is only, I guess, 60% ventricular, and 40% is atrial. And this is more than in the mitral field, just to remember. So patients have long-standing atrial fibrillations for 5 years in their history. It's persistent, and then they develop tricuspid regurgitation, exactly as you mentioned this.
So we will proceed. Thank you very much, Stefan. We will have a case live in a box of a tricuspid repair. Thank you very much.
Shall I stay or shall I?
Absolutely.
Okay, okay.
So the patient we're going to present is an elderly patient, 86 years old, who had severe tricuspid regurgitation with one recent hospitalization for volume overload, a prior history of surgical aortic valve replacement, mitral valve repair, and a Lima to the LAD. On good medical therapy, here we have some basic images for the left ventricle, some desynchrony and some evidence of an old infarction. Evaluation of the left ventricle ejection fraction about 40%, with impairment of the global strain. The right ventricle significantly dilated with an annular dimension of about 45 to 48 millimeters, with impaired systolic markers with the TAPSE at 15 and STDI at 8.7. The global strain of the free wall of the right ventricle was estimated at 12%, which is impaired. And by 3D volumetrics, we see a right ventricle that's significantly dilated with an EDV of 235 mL and an EF of 37 to 40%. The bioprosthesis in the aortic area was functioning normally, and the previous annuloplasty had a good effect with the mild MR. And no gradient. Here we see the tricuspid valve, tricuspid regurgitation, which is severe, torrential. We see that there is, we have an ability to obtain a good signal to measure tricuspid systolic pressures of the right ventricle. And we have a torrential TR with an ERO of 1.6 square centimeters. By mid-esophageal views with biplane, we see torrential color, and we try to interrogate the valve. This is looking at the anteroseptal commissure. The mid of the valve will have a large coaptation gap which exceeded 9 millimeters. And here we go to the posterior septal area of the valve and see the area as well. With 3D color, torrential color, and we see there's a big coaptation gap at the center of the valve and moving towards the posterior septal commissure. So in essence, we will proceed with the case. We can show the recorded case. Yorgos? Just allow me to modify the can we okay. So here we have already obtained access to the ventricular to the venous system, and here we see introduction of a wire up into the SVC. Baseline imaging, as we saw before, this is 3D color of the tricuspid valve from the mid-esophageal view, and we see torrential color from a wide area of the coaptation zone. Mid-esophageal is the primary imaging angle that we use, position that we use. This is live 3D with, from the mid-esophageal, looking at the tricuspid from anterior. So in this stage, we are going to proceed a little bit further. Excuse me? Yeah. Can I have a pointer, please? A laser pointer, please? Το έχουν σταματήσει. So here we're mid-esophageal. And this is moving on to transgastric, which is the other major position that we use during these procedures. This is a shallow transgastric, and if we up to 30 degrees, we see a short axis view of the tricuspid, where we can see all the leaflets and the coaptation zones, as well as some evidence, some the chordal insertions into the leaflets as well. Septal is to the right hand of the image, and anterior is at 7 o'clock, and posterior is at 11 o'clock in this image. If we superimpose color, we may see also the distribution of color along the coaptation zones. This is a very important view because we align our devices based on what we see here. Okay. So we see that we have a color jet that it's in the middle of the valve. Depending on what our position is, if we move too ventricular, we may not see it. If we go a bit more atrial, we'll see the color. Okay. So already we have inserted the guide sheath into the right atrium. And we're getting ready to insert the Pascal device. The guide catheter is up into the mid-right atrium. Here we do biplane imaging of the short axis transgastric view. And here we have a sort of a long axis image of the tricuspid, now moving short axis. Short axis here, and we have the corresponding view here. So as you can see here, we have much clarity in terms of the leaflets. We are able to better understand if we're going to position the device here, we have to put it in this orientation. We put a device in the posterior, in septal posterior area, we have to put it in a different orientation. This is a critical view for edge-to-edge repair of the tricuspid valve. We like to use the live 3D because it's easy and fast in obtaining these images. It's essentially a 2D view with a little bit of depth. So whatever we see in a short axis transgastric view, it adds some depth to it. So that's what makes it, live 3D is very, very useful. Moving back to the mid-esophagus views and the bicaval view, to visualize the insertion of the Pascal device into the right atrium. And now the device has been steered over the tricuspid. And now we'll go to the mid-esophageal position as we are right now and switch to biplane imaging to better understand our position and location and trajectory. This is live 3D imaging from the mid-esophageal view. The device is somewhere up here. We haven't seen it yet in focus. Here. So here we're looking at on-fast view of the tricuspid. The aortic valve is a very important marker because it shows us where the septal anterior commissure is. So it's a very important landmark for us during these procedures. The septal leaflet is up here, and this is the anterior leaflet, the posterior leaflet somewhere in this area here. So we'll move a little bit forward to the. So here we have the device over the tricuspid in a biplane view. Again, we have the aortic valve as a landmark. This is moving towards the aortic valve is anterior. Moving away from the aortic valve, we will go posterior. And we see the corresponding long axis view here in different positions. So here we engage a bit closer to the valve. And the next step is to open the device and assess our perpendicularity to the coaptation zone. So our device is now open. We assess the clasps, which one is the posterior and which the septal, and which one is going to be the lateral clasp. And we shift to transgastric views to try and assess, while we're still in the right atrium, what our orientation is. Our orientation right now is not perpendicular to the coaptation zone. It's actually a bit, it's parallel to the septal leaflet, so we have to rotate our device in order to be able to grasp in this area, in this orientation. So we need to grasp the septal leaflet with the anterior leaflet so it's very important to have a high quality transgastric view to be able to say that. Sometimes if we have some difficulty, we may go to mid-esophageal, do a 3D data set and try to align our device with the septal anterior commissure line in this view as well. It's something we can do. Based on the fact that the aortic valve is here, this is the septal anterior commissure is there. So moving on with the presentation a bit, for the interest of time, we're going to move into the right ventricle. And once we're below the valve, we again go to a transgastric view to try and assess our perpendicularity to the line of coaptation. Our goal was to put one device in this septal anterior commissure area, not too deep in the commissure, but here we have clasping of the lateral leaflet on this view, of the anterior leaflet. We did it in this view because we had a very nice projection. And then we moved on to a mid-esophageal biplane image to try and get the septal leaflet. We already have the anterior leaflet nicely in, but we have to shift our system towards the septum to get the septal leaflet. However, that was very, very difficult, and we eventually had to abandon this position. We opened the clasp and released the anterior leaflet. We tried several other approaches, and there was much difficulty. At some point, we had difficulty with imaging. We had deterioration of imaging. We couldn't see very well in the detail that we wanted the leaflets. And that delayed the procedure significantly. I think this is the last attempt that we were able to do, and we were successful in clasping the anterior and septal leaflets. And we optimized the septal insertion. We have already clasped the anterior leaflet, and we're going for the septal leaflet in this view here. Independent clasping of the septal leaflet, which is something that's very, it's a feature that we like to use in the tricuspid in these difficult situations. And here we have the first device positioned in this septal anterior area. We knew that there's going to be significant residual TR. This is more than one device case. And here we assess the position of this device. Just going to move ahead a little bit because it was a very long and challenging case. Try and get you to the final clasping of the leaflets, which is here. Here we have clasping of the anterior leaflet and subsequently clasping of the septal leaflet, which we could see in good detail. And we switch to our transthoracic probe, which is something that we sometimes get significantly very clear images. And here is a RV inflow view where we assess the insertion of the anterior and septal leaflets into the device. We have very good imaging from transthoracic. And here we open the device as well to get a better idea how much leaflet we have inside. So we closed it again. It's back in the closed position. We can see in a short axis subxiphoid view that we have grasped the septal and anterior leaflets nicely. And moving back to our TE, we proceeded to release this device. And this is after releasing this device, we knew we had significant color medial to that, more posterior to this. So we decided to go with a second device in the septal posterior commissure. This is the original device that we implanted, looking at it from a transthoracic. And here we have introduction of a second device coming in. Again, Pascal ACE, both of them are Pascal ACE devices, which is our default for the tricuspid when we use the Pascal device. Positioning again over the tricuspid, this time more near the posterior septal commissure. We see here the device is in, this is, the aortic valve is here. This is our first device between anterior and septal, and we move this device more posteriorly. We check the clasps again before we advance. And we proceed into the right ventricle. Again, from a mid-esophageal, we can assess with 3D volume our orientation, which we assessed that it was, we needed to adjust our rotation. We were very clocked, so we counterclocked the device to come more perpendicular to the coaptation zone here. And this is a clasping of the posterior septal area. Clasping first the posterior leaflet and then moving on to the septal leaflet. And this is our final position with this device in the septal posterior area. There is color between the devices from the center of the valve. We like to use this deep transgastric view to assess the septal and posterior leaflet insertion on the device, which was adequate. And we went ahead to release this device. This is a deep transgastric with live 3D image, visual, seeing very well the insertion of the septal and the anterior leaflets in the device. And with that, we essentially concluded the procedure with two devices, nicely visualized here, the one in the septal anterior and the one here in the septal posterior area. Yeah. And patient did very well clinically, was able to be discharged home in 3 days, and has a very good clinical follow-up. Thank you very much.
Yeah, Mihaly, this was a great presentation. I think we all understood why the question before of Dr. Sparias, imaging is what we need. There was such complex imaging you did here. Started with classic esophageal, then you moved to transthoracic, then you had to use transgastric. It was all these various complex, really, attempts to see. For the most time, we work on 3D. Occasionally, we work on 2D. Occasionally, we go on 3D. But really, the only understandable picture to, I would say, most echocardiographers was the last one. After all the equipment goes off and after the repair was done, then they get it. But during the procedure, it's really difficult to kind of figure it out. So a better imaging is really the key, I think, for the tricuspid. And let alone something that didn't come up, if there is there may be echoes from either hardware that may be in another valve, perhaps. So although you think it's easy sometimes, when you go in at the shadowing, it just doesn't make the windows good. So I think we see that even more so, I think, than in the mitral. And that's an interesting problem.
Yeah, I think the tricuspid valve has the potential, if we can improve imaging, especially with maybe intracardiac 3D, to be a procedure that can be a one-day hospitalization for the patient coming one day, leave the next. But right now we have to do general anesthesia, intubation. Imaging is very difficult, so it has become, it's fairly complex still.
Yeah, one question also engage our heart surgeon here. Dr. Panos is a very expert surgeon. Surgeons fix all the valves at once, and they're used to doing so. And there is an art in deciding, should you fix a little bit of a moderate lesion in the valve or maybe leave it. But now with a transcatheter, we kind of space out sometimes. Would that affect maybe your approach in some of the multiple valve problems? If it's a moderate problem, maybe you leave behind, or what is it? It was a different mindset. I go in, I fix all the valves, versus I have a stepwise approach and see how things go over several times. Obviously, if a patient is very sick, that's what we do, the last part. But most people now, with the expansion of these techniques, may not be that sick, and there will be always a question of, a great surgeon can fix everything, versus we kind of go through one by one and many times anesthesias and all that.
Thank you for this question. I don't think great surgery is to do everything at once, but really evaluate what we have to really do. When we are doing mitral valve repair, we have very often to intervene also in the tricuspid, at least when the annulus is 40 and more millimeters, or we have prolapses on the mitral valve with moderate to severe regurg. Now, all of this surgery, when it's not done at the first time, we can have a redo operation. Now we can offer also to the patient the minimally invasive techniques, endoscopic, for the tricuspid valve only, as a solo operation. And as you know, we can do it also on the beating heart, CPB, but on the beating heart, and through thoracoscopic approaches. So I do not think it's a very heavy technique for the patient, and we are still operate on the forgotten valve, which became a remembered valve now. Thank you.
Stefan, are you still with us?
I am, yes.
Oh.
Hello.
So what do you think about this case? I had this case in mind earlier when I told you about large gaps and material for previous surgery that affect your imaging. This was exactly that case. We wanted to put something more centrally, but it was impossible. So we went at the edges. We were very happy at the end. We had at least 60–70% reduction from the initial TR, but I think this case demonstrates, all the difficulties we face with tricuspid valve. What's your opinion?
Absolutely. It was like our discussion. I said when both valves on the left side are operated, you lose some of the mid-esophageal and possibilities of imaging with TOE only. So this is already mentioned in the room. Imaging is key, but I would add one thing is also training of the interventional imager. That's also one key. One is structural capabilities of your machines, but the other one is also the training of the persons. And I agree in this case with a Cosgrove band, with a prosthesis in the aortic valve, ICE becomes more interesting. You also used TTE in this case, which is feasible. We rarely do it because of radiation situations and concerns, but it's feasible. The images were very nice. You could also see that the 2 Pascals aligned to each other in the final position when they were released. So independent of how you entered, they come into a natural position. And the last situation is perhaps that we saw in the planning images already that we had very dense caudal strands in the middle of the septal leaflet, and we also had 2 prominent papillary muscles on the other side. So also from anatomic situations, this was not a trivial but a very challenging case, but with a reasonably very good result. So congratulations for doing this to the team in Athens.
Dr. Nikas has a question.
Forgive my practical and very basic question. First of all, I would like to ask, especially in this case, which leaflets are we tagging to grasp? I mean, absolutely the septal, we know that, but all the other ones are mediated by the anatomy, by the physiology, or whatever we can grasp, it's okay. This is the first question. The second one is regarding anticoagulation. We know that the right atrium, right ventricle, it's a low flow chamber, so therefore, do we have any second thoughts about the coagulation spaces as compared with the mitral clip procedures? And the third one is, which one was the third one? I think I forgot, I'm sorry. Okay.
We can add the third one later. Starting with your first question, you should, like with a heart surgeon, you should always repair the valve by its normal leaflet motion. So I'm a big fan of doing exact rotations in looking how, before we repair the valve, the individual leaflets open and close. In this case, we had a very anterior and small anterior leaflet. Then we had 1 papillary muscle, and then we had something you can discuss, either an A2, a posterior anterior, or an anterior posterior, a P1 and P2 leaflet. So there were triple large leaflets in this case with 2 prominent papillary muscles. And this always is a more difficult scenario. Also, normally the septal leaflet, very anterior, is short, and it becomes longer, more posterior. So in this case, I would have addressed the middle leaflet, femoral leaflet, to the septal leaflet, either anterior or posterior to this thick caudal strand that you could see very prominent in these images. But it's important to maintain the line of perpendicularity. And you saw that the angulation to come to the posterior position and to the anterior were quite different. So this is caused, of course, by the imaging and because of this leaflet anatomy. Coming to your question of anticoagulation, the question is always answered by the high number of atrial fibrillation. I've told you that in our experience, 85 to 93% of all patients have AFib. So they need basic oral anticoagulation, but nothing else. So typically they are kept on DOACs or NOACs. In our instances, we typically take 2-day doses. So we like to have a Bixaban, which has a very low gastrointestinal bleeding situation and has 2 times 2.5 to 2 times 5 milligrams. That's everything you need. Or in sinus rhythm, even with a clip in the tricuspid position, we can give aspirin and 3 months of clopidogrel, which we then phase out. This is totally different to replacement, as I said before. The clips are extremely forgiving. I have not seen in 350 procedures that we have done, we had no thrombi on the clips, but we had thrombi on replacement systems. So, and there we have only done 15. So you see, it's a totally different game, and you have to be more cautious with lots of material in the tricuspid field than with little material. So the clips are the better choice, as the surgeons know it for years. They prefer repair over replacement, and also bioprosthetic material over mechanical valves in the tricuspid because of the high possibility to have thrombi in the right atrium in the low flow area. So I think that are key messages.
Yeah, the question is whether you've been using intracardiac echo now for tricuspid. I think you mentioned
Yes.
that you do. You started.
We do it. We do have a hands-on training next week in Paris. So on Tuesday, and I think there are still some places left, there is an ICE session, hands-on training, practical training with simulator and with case samples from Mainz on ICE procedures, total ICE procedures in tricuspid.
Very good.
I have to add also a comment on your topic concerning the resistance of the cusps, the tricuspid cusp, and I agree completely because we surgeons we were doing this as a clover technique, even suturing the 3 leaflets together at the middle and having a schema of like a trefoil. And this is very resistant over time. So I agree completely that these leaflets are very resistant despite their appearance, very fragile appearance.
Exactly. I can only share this, and we were very concerned, very cautious in the first 12 patients, but now having repaired 350, I've not seen a single leaflet here actually, and we also see that using longer clips get much better results. So we also for next week we have Pascal and tri-clip cases for EuroPCR live in the box, and actually we wanted to film 1 or 2 good results, and we did 3 cases and all were trace to mild. So I think with experience in longer clips you get much better results than the early Triluminate situation where we used only NT clips with 9mm length. So I think more is better. And Pascal has 10mm and XTW has 12mm clip arms. Those 2 devices are the most preferred ones.
Okay, thank you very much, and we will conclude this session. Thank you very much.
Thank you.
to be late, more late than we have some technical problems here, but I think that from the internet is everything perfect, and it's a great honor to be here. For me, and many thanks to Kostas Parias and all the organizing committee. It's a very special session about transcatheter edge-to-edge repairs. And let's start with Dr. Raz Makar from the States about redo TR for MRI relapse. When and how? It's a very technical issue. We have already some patients with some clips positions, and now, due to complications or to progression of the disease, we have to re-intervene. It's not something simple, it's something complicated, but let's hear our presenter. Thank you.
Hello, everyone. I want to thank the course directors for the kind invitation. Hopefully next year it'll be in person in Greece. But let me go ahead and talk to you a little bit about the TEER treatment of mitral regurgitation and about pushing the limits a little bit with this technology. These are my disclosures. So I'm going to show you, there are two technologies, as you know. One is MitraClip, and MitraClip has the most experience with more than 150,000 cases worldwide. At Cedars-Sinai, we've done about 1,500. And of course, then there's also the Pascal device by Edwards Life Sciences, which is rapidly gaining significant usage around the world. I want to make some key arguments about the liberal use of MitraClip or TEER technology. And the first argument is that the clip is versatile and effective in treating wide spectrum of mitral valve pathology. So let me show you some examples. Of course, everybody knows about the central pathology, and here is an example of a flail of A2, anterior A2. After transeptal puncture, use of one clip in 15 minutes results here in trivial residual mitral regurgitation. So this is the simple case affecting the central part of the leaflet. But the indications have expanded now as more experience is gathered, and we are now treating more and more commissural pathologies. And here is an example of P3 prolapse with severe mitral regurgitation. You can see that there is a medial commissural pathology here with severe prolapse. And we used two clips using the G4 system with mild residual regurgitation. And here is a patient who actually has lateral pathology as well as some central pathology, and then you can see severe mitral regurgitation, and we've actually used two clips here in the center as well as in the lateral part, and there is once again mild residual regurgitation. So you can treat pathologies that are not just central but are also commissural. The further expansion of this technology is in patients who have failed surgical repairs. So here is a patient who's had a ring done, a repair using a ring, but now actually has a flail of medial P3. And you can see the jet there in 3D, this very severe medial commissural jet. And once again, we were able to go ahead and place one clip in the medial commissure, closing off that commissure essentially with very little residual mitral regurgitation. So, and here is a patient that's yet another case. So, this patient has a ring, but the ring is actually dehisced, as you can see, in the posterior part, and there's actually leakage through there. But the leakage originates from the tip of the leaflets. So in this particular case, we went ahead and in fact, we did a clip procedure, and you can see, of course, there is careful steering that is actually needed, but we were able to place two clips, in the middle part on the leaflets, and there is mild residual regurgitation because that's where the regurgitation actually originates from. Yet, Another indication for the use of edge-to-edge repair is patients who have severe hypertrophic cardiomyopathy associated with septal anterior motion, which results in severe MR and also some LVOT obstruction. And here is a 35-year-old gentleman that we couldn't do a septal ablation, didn't want surgery, and so we actually treated him with a clip. So look at the SAM there, right? It just goes into the LVOT, the antemitral leaflet, and there is severe MR. We were able to actually use one clip here. We have grasped. You can see that the turbulence in the LVOT has diminished and there is no residual mitral regurgitation. And this is, basically treating the central part. The gradients have actually come down in the LVOT, as you can see there. And this is follow-up transthoracic echo, essentially showing no significant residual mitral regurgitation. And more cases are now accumulated, and we've treated quite a few of these cases at our institution where patients are transferred. So here is a patient in cardiogenic shock transferred. This is a patient that is anuric. The surgeons don't really want to take this patient because they think if we can treat this with mitral clip. And this is ruptured posteromedial papillary muscle with torrential mitral regurgitation. We ended up placing multiple clips here and a plug and essentially reduced the regurgitation to very little. This stabilized the patient, and the patient was actually able to discharge. Now, is this patient going to require mitral valve replacement perhaps in the future? The answer is most likely yes, but it was effective in saving this patient's life. So we can actually treat, and this is the follow-up echo at 30 days. As you can see, the gradients are a little bit higher, and of course, this patient will need more treatment in the future. And essentially, a growing, expanding use of clips also is in patients who have really bad cardiomyopathy, who end up being on inotropes, are often transferred to a hospital because we've got a large transplant service. And here is one such patient with very poor EF on milrinone, severe MR, and we placed multiple clips here. There is still some residual jet between the clips. So you can see there are 4 clips. Then we go ahead, use the Agilis catheter, multi-purpose catheter, and essentially go ahead and put a plug. And this is the follow-up. You can look at the 3D picture at baseline and then at follow-up with multiple clips and a plug. There's no significant residual MR. We were able to wean this patient off milrinone and, of course, delay the cardiac transplant, which is perhaps going to be inevitable, but nonetheless, these patients can be stabilized. And this is the follow-up echo in this particular patient. I think the important thing to also point out is that my second argument is for functional MR. There is essentially no other treatment that has been shown to improve survival. And here are these 2 clinical trials, and they were somewhat, the information was, or the results were not exactly the same, the COAP trial and MitraFrance trial, but nonetheless, I don't have time to go into why the MitraFrance failed, but COAP, which was a beautifully done study, essentially showed a reduction in heart failure hospitalization and all-cause mortality all the way up to 3 years. The other argument is that CLIP has an impeccable safety track record. And so if you look at, this is the TVT registry and the COAPT and MitraFrance trials, and look at the death rates and stroke rates, these are very sick patients, all comers, right? Once again, the 30-day mortality is not unacceptable. This is quite acceptable given that these patients are extremely sick. And these are some of the data from the TVT registry. Once again, you can see these are essentially pretty good results. And if you look at once again, some of the safety endpoints in the COAP trial, once again, they are actually quite good. So, essentially, things such as conversion to open heart surgery, etc., are extremely low with the use of CLIP procedure. And these are real-life data from the TVT registry. Once again, you can see the mortality rates are actually quite acceptable. The stroke rates, again, are also quite low. Now, I think when CLIP first started, it was used both right? In the Everest trial, it was used both in degenerative as well as in functional mitral regurgitation. The reintervention rates or the number of patients switching to surgery was not insignificant. But nonetheless, I think clip technology has come a long way. Imaging has significantly improved. And if you look at, this is one of our papers, when the G4 clip first came out. And now our experience is actually, much, much higher. This is just, in the first early patients in 2020, you can see that the results were in fact superb. If you look at the number of patients with, you can attain 2+ or less, residual mitral regurgitation in almost 95% of patients. So I think we all have patients that come back and need repeat MitraClip, but I think these rates are low when you look at the published literature. And I think part of it is, you have to be honest, that these are one-year reintervention rates and they're low. I think as we are seeing longer follow-ups, more patients are coming back. But you can see that the mitral valve intervention or surgery rates in the COAP trial were actually quite low. In fact, about 4%. So I think that what I'd like to do is just show you some examples, because at our institution, we started doing clip almost 15 years ago, along with, Cybele. And, these are the cases, some of these cases that we did. And here's an example of a patient that we did almost 11 years ago. All right, in 2009, a patient with severe MR due to restriction of posterior mitral leaflet, you can see there. All right, and we put 2 clips, we got a reasonably good result. And this is 11 years later, in fact, not bad outcome, right? So I think still mild, maybe a little bit moderate, but I think very, very acceptable results. Here is a patient with degenerative mitral regurgitation, essentially 5 years later, actually had good result. I'm sorry, I didn't show you those pictures here. But nonetheless, the other thing that I wanted to point out is that if MitraClip fails, an experienced surgeon can actually remove the clip and still repair the valve. And this is just a list of some cases, at our institution where Dr. Trento has mastered in case of residual MR, still removing the clip and actually repairing the valve. Here is a patient who had bileaflet mitral valve prolapse in 2008. We put 2 clips. We actually had an SLDA and residual severe mitral regurgitation. And then Dr. Trento, a year and a half later, in fact, here did a mitral valve repair. And you can see this patient did not need replacement, but we were able to treat this patient with repair. And of course, there are other things that are being tried, such as removing or cutting out the clips and then actually deploying transcatheter heart valves, as for example, in this particular case, using the Tendyne valve. So, this is an example of that Paul Saraja has done. So I think that, these are the arguments, for being aggressive with the use of the MitraClip or edge-to-edge repair, and then the same things would probably hold true for using the other edge-to-edge repair device. So I think, but it's also important to know that not all patients with degenerative MR are candidates for percutaneous mitral valve repair or edge-to-edge repair. And, there are patients who have small valves and mitral annular calcium and leaflet perforation and high baseline gradients. So I think we do have to, and when we did not have a choice, we were forced, and we have all done and pushed the limits with the edge-to-edge repair, and I think we still need to do that. But I think something that is very exciting is the percutaneous mitral valve replacement, and my talk is not on that, but this is one technology that we have significant experience with at Cedars-Sinai. And I'm showing you a case example of the Evoque EOS valve, which is a new generation valve, which is in fact a valve that can be retrieved. Okay, so even after you have deployed the valve, before you release it, you can recapture the valve and actually remove the valve. It's phenomenal technology. And here is a case example. And we've done quite a few cases now. We are still part of the EFS. And I'm just showing you a case example here. And now we have some patients who are actually even out all the way up to a year. And you can see that this device completely eliminates mitral regurgitation. And here is a live case that we did for TCT 2021. So, once again, we can do these procedures with a procedure time of about 1 hour. And this was a case that we did live. So I think the edge-to-edge repair is amazing. I think it's very helpful to us as we take care of patients with mitral regurgitation, and I think we all have pushed envelope. But I think as percutaneous mitral valve replacement becomes more of a reality, and of course we need to demonstrate that in larger numbers, and if the safety of percutaneous mitral valve replacement can be the same as edge-to-edge repair, I think we may be treating some of those patients that we are treating with TIA right now with percutaneous mitral valve replacement. So I hope I've given you a flavor of the edge-to-edge repair as to how it is being used in my institution, and how we are also testing out some very interesting transcatheter mitral valve replacement therapies, and I showed you an example. So thank you for your attention. I wish you all a great conference. Thank you.
It was very reassuring what we heard from Dr. Makar. He reassured us about the relapses. He showed us how we can treat them. And finally, he showed us this phenomenal technology we also discussed in the morning with the Evoke EOS that can be completely recaptured after positioning and fully functioning. So if you're not happy with the position, you completely move it. So we decided to make some alterations in the sequence of the program here with my co-chair, because the only live presentation will be Dr. Hausleiter, who's with us. Jörg, are you there?
Yes, I'm here. Hello.
Welcome. Thank you for being with us. And my presentation. So we're thinking, if you agree, Jörg, to listen to Fabien's and Francesco record the talks, and then you continue and I close, and we have a final discussion at the end.
Okay, that's fine.
Perfect. Thank you. So we'll continue with Fabien's talk, M-tier in difficult DMR, high-risk Barlow or multiple Zs.
Good afternoon, everybody. Thank you very much for the invitation and for the very interesting topic, transcatheter edge-to-edge repair in difficult degenerative mitral regurgitation patient. I would like to start my talk by putting some emphasis on the development of transcatheter edge-to-edge repair during the last years, since the first implantation in 2003 of the mitral clip, with the entrance in 2016 of the market by a competitor to the mitral clip, and finally now the fourth generation of the mitral clip, enabling the implantation of 4 different sizes of the implant with a much more individualized approach of complex anatomy, Barlow anatomy as well. And this has a consequence, positive consequence in the outcome of transcatheter edge-to-edge repair, as you can see on this graph, with a tremendous improvement of the outcome, in particular of the proportion of patients with post-procedural mitral regurgitation grade 1 or 0, as well as a number of complications. And this is, of course, due to technical device evolution, but also to growing operator and center experience. It's not only the interventional cardiologist, but also the imaging specialists who are able to improve the outcome of this therapy. The mitral valve is a complex structure, and the anatomy matters. That's what we are learned during the year. And from the very beginning, in the Everest trial, you can see that already anatomical inclusion criteria have been included in order to ensure that the most appropriate patients are treated. Anatomies matter. Anatomies has also an impact on the mitral regurgitation reduction after the procedure and on the prognosis. And this is Also true for surgery. We have learned this from the surgeon as well in primary mitral regurgitation. If patients leave the operating room with residual mild mitral regurgitation or more, they are at risk of having recurrent mitral regurgitation during follow-up, during long-term follow-up. You can see here over 15 years, and their survival is then as a consequence of it less. Very important message. We have also seen in the TVT registry, one of the largest transcatheter edge-to-edge repair registry, including mainly patients with primary mitral regurgitation. In this patient having grade 1 or known mitral regurgitation after transcatheter edge-to-edge repair is a predictor of good outcome. And the mortality differs significantly between patients having grade 1 or grade 2 mitral regurgitation at 12 months. If we now look specifically into the population of patients with Barlow disease and look at the surgical result, we see that surgery has also limitation in that particular population of patients. Comparing to fibroelastic disease, patients with Barlow disease have much more mitral regurgitation recurrence during long-term follow-up. About 40% of the patients are more than moderate mitral regurgitation at 7 years. But more importantly, a low rate of patients are repaired, and about 15% of these patients receive a mitral valve instead of a mitral valve repair. And this is a very important message as well when making decisions between surgery and transcatheter edge-to-edge repair in patients with complex mitral valve disease. If we look at anatomical complexity in a transcatheter edge-to-edge population, we see that this is a quite frequent issue in about 30% of the patients. And among these 30% of patients, some of them have multiple jets, some of them are Barlow disease, some of them have very wide jet that are difficult to treat with transcatheter edge-to-edge repair. Even with the latest generation of the device, you can see that in patients with complex anatomy, the reduction of mitral regurgitation is about 10% less. Reduction to grade 1 or 0 is 10% less as in patients with non-complex anatomy. Looking now specifically at Barlow disease in a retrospective study by the group from Mara Gavazzoni and Maurizio Taramasso, you can see again that mitral regurgitation reduction at discharge is less compared to non-Barlow patient. And that's also a very important message, that the durability of the result is less than in non-Barlow patient. You can see that the durability is quite stable in the non-Barlow patient with 81% discharge with mitral regurgitation grade 2 or less, and 80% then at 3 years, whereas we have a progression of the disease in patients with Barlow disease. And this reflects into clinical outcome, into heart failure hospitalization. The mortality was not significantly different in this small study, but certainly this has an impact on long-term follow-up. So all this information, anatomical complexity, but also the experience of the center treating the patient, need to be considered when deciding about the treatment strategy of a patient with complex mitral valve disease. Barlow patients are clearly in that domain of complex disease and should be treated by experienced center. In that patient as well, the replacement strategy could be considered and should be probably considered because it has the ability to have more efficacy in reducing mitral regurgitation. A very important factor to be looked at before going into the procedure is also the mitral valve area. And the reason for that is that in patients with complex degenerative mitral regurgitation, we will need to implant several clips, and we will maybe need to implant clips distant from another to address multiple jets and create a triple orifice mitral valve. And this has quite a big impact on mitral valve area with the risk of creating a mitral valve stenosis. And you can see that when you want to create a triple orifice mitral valve, then you need to start with a mitral valve area that is about 6 square centimeters, as described in this work we published in JZ last year. If we look at the different systems on the market now, Pascal versus MitraClip, we see that both systems are able to reduce mitral regurgitation in patients with complex anatomy about in the same way, with a small numerical advantage in that small study for the Pascal device that did not reach statistical significance. I just want now to show two cases, one successful case with complex degenerative mitral regurgitation and one less successful case, and try to show where the problem in the less successful one. An 85-year-old patient has been referred for treatment of mitral regurgitation. You can see that this patient has a severe primary mitral regurgitation, morbus Barlow, left ventricular function is 50%, no that much comorbidity, elevated NT-proBNP, and because of his age, we have decided to go for a transcatheter edge-to-edge repair strategy. You can see the baseline images with certainly what we can call a complex situation, Barlow disease, B-leaflet prolapse, and a wide jet involving the wall coaptation of the mitral valve. You can see here that there is actually two different jets, one lateral big jet and one medial one. We have decided to address with an XTR implantation each of these jets. The first clip was placed on the lateral side of the valve with a good grasp. Grasping is usually not so much a problem in that patient due to the redundant tissue. And then we implanted a second clip medial from the first one, but also what is very important, distant from the first one, with letting actually an orifice in between without MR between the clip, as you can see. And at the final result, you see a triple orifice mitral valve with a high mitral valve area at baseline, enabling this strategy, and a good reduction of mitral regurgitation with this small multiple jet remaining, but overall a very good result. Now we go to a second case, which is about the same age patient, 86-year-old patient. You can see much more comorbidity in that patient, elevated risk, surgical risk, with a severe primary mitral regurgitation, quite a complex one, again, with B-leaflet prolapse and what we can call a commissural leaflet of the lateral commissure with a quite deep cleft. And as you will see, there is mitral regurgitation coming also from this region. So the lateral commissure of the valve is quite complex in terms of anatomy and may be problematic. The other factors is that the anatomy in that patient is quite small, and that's the reason why also he has been excluded for tendon implantation. You can see that there is here a risk of LVOT obstruction and also a small annulus. And we were actually aware that this patient has first no other option, and second that we will not be able to implant multiple clip in this patient. So we went into the procedure, and despite several repositioning of this lateral commissure of the mitral valve, we were not able to address, as you can see here, mitral regurgitation coming from this cleft and from this commissural leaflet that remain at the end of the procedure. And as you can imagine, the clinical course of this patient was not favorable. You can see that we had a little bit of gradient due to the low mitral valve area, with a significant residual mitral regurgitation at 1 month. And what was interesting, the patient decompensated again, and you can see that the evolution is also unfavorable for the right side of the heart, with dilatation of the right ventricle and an increase of tricuspid regurgitation over time. So this kind of patient can typically, if the anatomical possible, can be addressed also by tendon implantation. You see that tendon implantation has the advantage compared to a propensity matched population of mitral clip to achieve more durable and complete MR reduction, to have greater LV remodeling at 3 months, and also to lead to an improvement of the right side of the heart, probably to a more complete, due to the more complete reduction of mitral valve regurgitation. However, in patients who are not candidate for a transcatheter mitral valve implantation, complex patient generally, complex DMR patient, a bailout transcatheter edge-to-edge repair may be beneficial compared to high-risk surgery or letting this patient only on medical therapy. So let me conclude by saying that transcatheter edge-to-edge repair is an option in selected patients with valvular disease at increased surgical risk, but the treatment should be performed in an experienced center, and a very careful anatomical evaluation is needed, but despite of this, results remain not always predictable. Transcatheter mitral valve implantation is available and may play a role, a complementary role in that particular patient, and should be considered. Complex transcatheter edge-to-edge repair, according to the data we have so far, should probably be preferred over high-risk surgery or letting this patient on conservative treatment only. Thank you very much for your attention.
We thank Dr. Pras for his presentation. I think I personally learned a few things, and he covered very well this field. So we'll go to back-to-back lectures from Francesco Maisano and from Dr. Hausleiter, who is with us. First, Francesco recorded the presentation, Technical Consideration and Strategies for Optimal M-Tier with MitraClip and Pascal in DMR, and then Jörg will follow with the same talk, but in FMR. Can we have Francesco's?
Dear colleagues, ladies and gentlemen, I will share with you some technical considerations and strategies for optimal tier with the most commonly used devices. These are my disclosures. And this is a routine case that I can encounter very often in my practice. Is a 80-year-old patient with no comorbidities, potentially a surgical candidate. There is a flail of P2, very simple lesion for any kind of procedure. In these patients, you can go for a minimal invasive mitral. You can do easily even neocords from the apex, or maybe in the last few weeks from the percutaneous approach. But I would say the MitraClip is a great option for these patients, for simplicity, for availability. And in these patients, obviously, you want to achieve an excellent result because these are patients who are operable. And what is the ideal situation? So today we need to understand that MitraClip and Pascal, so TIER as a whole, is expanding its indications. And obviously, we go in the low-risk DMR single-leaflet patients, although still the guidelines are not supporting this. Soon there will be spread of this approach. Obviously, in these patients, the target has to be perfection without compromises, which means no residual MR, no residual gradient, no residual lesions that may evolve over time because we need durability, and obviously we need to work under high safety borders. In the high-risk procedures, high-risk patients, obviously we still can go in the field of DMR, the patients with multi-segmental disease and even patients with calcific lesions. Now the problem is what is low risk and what is high risk and what is simple and what is complex. So this is a very old slide but still valid. And if you look at this, this slide, you see a patient with 3 pictures, which I think are the most important ones. The explain at the level of the regurgitation with and without color, and also 3D. And you can discuss whether this is a difficult, simple procedure or an extreme case, and you can imagine how many clips you think you're gonna need to repair this valve. Now, if you answered that it is an extreme procedure and you will need 2 clips, then you probably will answer like that fairly. If you think it is a difficult, not extreme, and still you need 2 clips, you think like a cyber car. You think it is a simple procedure, but you will go for 3 or more clips, then you have another opinion. So again, we have a number of different opinions, as we still have a very opinionated field. Some effort has been done to stratify the risk of these procedures into 3 categories. This is a 2013 version from the German Society. There is a more recent version which is showing that there are optimal cases which can be also done by beginners, but the most advanced and complex cases have to be done by experts. And when we talk about advanced and complex, we talk about patients with calcium, with a smaller valve area, with posterior leaflet which is not so large, and with clefts and other things. Now, everything starts with the good transeptal for DMR patients, and the requirements of transeptal for mitral and Pascal are a little bit different, but basically the concept is the same. You need a safe introduction of large delivery system. You need to have a coaxial orientation of the clip delivery system to the long axis of the heart, and an appropriate distance from the aorta to avoid aortic hugging, and from the mitral valve to enable efficient handling and grasping. All these features are fundamental. And so how to achieve this in every patient is very clear. We know more or less what are the rules. I want to share with you some differences. So on the left side, you see a patient with a relatively stiff septum, where you can obtain easily a good height of puncture. What you see on the right side is the same situation, basically the same height that can be measured prior to puncture in this 4-chamber view, but you can see a floppy septum, and what you will probably encounter in this patient after transeptal, the transeptal puncture will be lower than expected, and this is the reason in this diagram that shows that if you have a very floppy septum, you should predict that after insertion of the delivery system, the septum will be pushed towards the mitral valve leaflets, and you may be needing, you may be in trouble. So there are many maneuvers that can be done to avoid these procedures. In some cases, we can even use the overstraddling and other very fancy maneuvers. In principle, my suggestion is that for every patient, the ideal puncture site is posterior inferior for all patients, which allows you the best height in most occasions. And whenever the left atrium is very small or you have a very floppy septum, then consider a left groin access for the percutaneous transeptal puncture, because coming from the left will gain between 1 and 3 centimeters height compared to right femoral vein access. This is an example just yesterday where we have basically a very floppy septum as well as a very small septum. You can see here the tenting happening more or less here. And once we go in the 4-chamber view, you can see that it looks like not too bad. It is very posterior. And in 4-chamber, it is probably 2 centimeter height. You can see here, 1 and 2, 2.5. So we measure 2.5. Again, as soon as you release the tension, you will fall down. For this reason, I decided in this particular case to go from left, and we had a good result. We have to understand also that the patient selection plays a role, and to be honest, the Everest criteria today are obsolete. We have to consider different approaches because we have different devices with different sizes. We have also more experience. With the 4 clip sizes of Mitral G4 and 2 sizes of Pascal, we can really achieve much better results. The EXPAND trial shows MR reduction, which is much better than what was originally presented in the Everest trial. And today we have about 80 to 90% of patients who have a MR less than 2+ at 1 year follow-up according to Core Lab. Now, there are many tips and tricks which are very important to obtain these outcomes. And one tip which I really think is very important is to identify the orientation. And to achieve the best orientation, first of all, you need to achieve a very well-oriented 3D surgical view. Sometimes you may have shadows, So it could be a good idea to park the delivery system in the opposite commissure to identify the commissures, and only after having done these maneuvers, you can have a clear-cut idea of the position of the anterior leaflet compared to the posterior leaflet. And with this, you can now open the clip arms and make your orientation according to a precise orientation of the 3D surgical view. This is also something you can find afterwards, much easier. Once you have a nice, well-oriented 3D surgical view, you can see that you are vertical in this picture. But this is not enough. Once you identify the location where you want to grasp leaflets, my strong advice is to breath hold as you cross, because as soon as you cross the leaflets, you will be committed to an area, a section of the mitral leaflets and the subavial apparatus. So precision of crossing makes the final outcome of the procedure. And what to assess afterwards? Obviously, color Doppler is an important feedback, but in many patients, and I would say in most patients, the best way to understand whether you do a good job is to analyze the reduction, instantaneous reduction of LA pressure as you close the clip arms, and measuring the mean pressure, which is a surrogate of both MR reduction and creation of gradients. If LA pressure, the mean LA pressure diminishes after the implantation of the clip, then you have a good result. This is what you want to observe. In yellow is the V wave. The closure of the clip is associated immediately with a reduction of the V wave, but also you can see a reduction of the mean pressure. It goes several millimeters of mercury below the pre-procedural. Another very important assessment is leaflet insertion, because this refers to durability, and this is done in a very careful way, both recording the grasping and analyzing leaflet insertion with partially open clip arms, and also very important with the newly available devices, both MitraClip and Pascal. You can improve leaflet insertion. You see in this case is a MitraClip G4 grasping with excellent result, but you can see some mobility of the posterior leaflet, some little jets coming from both sides, a little bit of smoke, so still a good result, but now you will see an independent ungrasping. So we released only the posterior leaflet, we left the anterior leaflet blocked inside, open the posterior leaflet, optimize so raise the grippers, optimize the position of the, the position of the delivery system. So now the clip is open. The device is rotated clockwise to go more towards the posterior annulus. Now the grippers are closed. The clip is closed. You can see much more smoke. The posterior leaflet now is totally immobilized, and obviously MR is better reduced. And this is going to be not only better outcome in terms of hemodynamics, but also in terms of durability. I've been showing you mostly MitraClip. I think the concepts are very similar between the two devices. With Pascal, Pascal is relatively similar, but with some important differences compared to MitraClip. Is nitinol based, so it has some degree of flexibility, which is improving probably the safety profile, and it's really helping in patients who are very fragile. There is a spacer inside. It is a little bit more bulky and a little bit more complex to be implanted compared to MitraClip. So in our practice, it's mainly used in central regurgitation, although there is more to come and a lot of knowledge behind. there is also some differences between the Pascal Ace and Pascal implant, which is the regular original larger implant. Whatever you use, I think I like to use this slide because this comes from the Alfieri technique, the original surgical technique. The same rules apply to transcatheter edge to edge, and I can read the suture or the edge to edge done with a clip or with a Pascal must incorporate the disease segments completely. You should not leave behind any lesion which may progress over time. The suture length or the number of clips and number of Pascal should be kept to the minimum effective to correct MR in order to avoid stenosis. The depth of suture bites, or let's say the length of the leaflets or the length of the device, is variable according to the nature of the mitral regurgitation. Usually we use more often longer clip arms and larger clip arms for the degenerative MR, while shorter, like the NT, are more often used in the functional MR in many cases. And last but not least, it is very important in this very simple procedure, there is only one important feature: respect the symmetry, otherwise you create distortions. If you apply all these, then it makes sense to have this transcatheter edge to edge as a tool which is incorporated into the decision algorithm of patients with primary MR, and the future you will see even larger proportions of patients who may be treated with transcatheter edge to edge, providing that the technique is well done. Thank you for your attention.
Kostas, I think it was an excellent lecture, nothing less than anticipated from Francesco Marzano. And we have to go on to Professor Jörg Hausleiter from Munich for the same talk, now in functional MR. Please, Professor, we are anticipating your talk.
Yes, thank you very much for the invitation. It's a very nice meeting, what you're doing today. And now it's a privilege for me to talk about the same in terms of the treatment of edge-to-edge repair in functional mitral regurgitation. Let's have a look at the guidelines from last year. When you look into in this magnification, you see that an edge-to-edge repair is going to be guideline recommended in patients who are not appropriate for valve surgery, who are not going to be considered for an heart transplant or LVAD implantation. But if they then fulfill the criteria for an edge-to-edge repair, then they can be treated either in this cohort, which is a 2A indication, when we have more like co-apt-like inclusion criteria, or with the 2B indication for the remaining patients. So this looks like that we do have separate indications for an edge-to-edge repair in secondary MR. Now, maybe we need to discuss if there are different patients, or if the patients are in different stages of the heart failure process, which we will then consider for an edge-to-edge repair. And then indeed, when we're looking at the pathology, the heart failure process starts with the involvement of the left ventricle. Then we're seeing the dilatation of the left atrium. The next step is a pressure and volume overload of the right ventricle with an increase of tricuspid regurgitation, an increase in systolic pulmonary artery pressures. And at the end stage, we have a biventricular failure where the left and the right ventricle are not well functioning. And the question is, is this important for our outcomes? And we looked at our EuroSMR registry, which right now contains more than 1,600. This is still the early cohort of 1,000 patients. And and they compare very well with the COAPT and the mitral clip or mitral FR cohorts, which have been presented earlier. Maybe two aspects which are important also for the later slides is that the left ventricular ejection fraction in those patients with secondary MR is usually somewhere around 30 to 35%, and the left ventricular end diastolic volume is usually more than around 200 milliliters, 200 cc's. So just keep this into your mind. Now, coming back to these stages, what we have observed is that patients in the first two stages with left ventricular involvement or left atrial involvement have a very good long-term outcome in terms of the 2-year survival curves. They're overlapping each other, but as soon as you have a involvement of the right heart and the pulmonary circulation, the mortality is increasing, and if you have a biventricular failure, you have the highest mortality. So treating patients in earlier stages of the heart failure process might be associated with an improved survival if we treat those patients with an edge-to-edge repair. Now let's talk about the imaging aspects in secondary MR. You might well remember that in 2012 and 2017, the ESC guidelines recommended the quantitative parameters for the ERA of 20 square millimeters and a regurg.
Hello, Jörg, we've lost you. Are you there? Okay.
Secondary MR in heart failure. As I said before, we have an ejection fraction usually around 35% and an end diastolic volume around 200 milliliters. So the stroke volume will be around 70 milliliters in such patient. Now, if you consider the regurgitation fraction to be more than 50%, or let's say 50% for a severe secondary MR, then we have a forward stroke volume of 35 cc's and a regurgitant volume also of 35 cc's. Just to make this sound, if you're looking at the cardiac output, 35 milliliters of forward stroke volume with a heart rate of 80 results in a cardiac output of 2.8 liters per minute, so cardiac index somewhere around 1.5 perhaps. But if you take the other parameters, let's say the 45 milliliters of regurgitant volume as suggested in the latest guidelines, then only 25 milliliters will be forward stroke volume. This results in a cardiac output of 2.0 liters per minute, so a cardiac index somewhere around 1.1. And even if we take 60 cc's as suggested in the guidelines as the threshold for regurgitant volume, then we have only 10 cc's of forward stroke volume and 0.8 liters of cardiac output, which will not be compatible with survival in such patients. So we really have to ask ourselves if these guideline recommendations are really useful, if they are really sound, because, as I said, these measurements does not make sense in our daily practice, especially when we're considering that we want to treat our patients earlier in the heart failure disease process. Now, is there a benefit of edge-to-edge repair in patients with an ERA below 30 square millimeters? And we looked into this question with our EuroSMR registry, and the median actually of the ERA was just 0.3, and we divide our cohort in patients with above 0.3 and below 0.3. And what you can see is that the mortality in these two groups, 2-year mortality, is identical between the two groups. There's no difference in survival, and more importantly, both groups with a high ERA, but also with a smaller ERA, had the same symptomatic improvement in New York heart class as seen in this bar graph down here. So to summarize this, that the ERA by PISA is neither predictive for mortality nor predictive for the clinical improvement after edge-to-edge repair, and we have to be very, very careful with the current ESC recommendations in this regard. Now, what is more important perhaps is the residual MR, and Francesco in his previous talk already talked a little bit about that, and we looked also into the into the EuroSMR cohort, because up to now we were thinking if we reduce the MR from a 4 plus or 3 plus MR to 2 plus is already sufficient. But can we do better? And is this associated with a better outcome? Yes, it is. In secondary MR, you see if we obtain a residual MR of 1 plus, the survival curve is significantly better with lower mortality than compared to residual MR of 2 plus in red or with a residual MR of 3 plus in green. So obtaining MR 1 plus is apparently associated with a reduced mortality in secondary MR. Now, how do we get there? Francesco in his previous talk already talked about the importance to be perpendicular with our device to the line of coaptation, because these devices, especially with those with the long arms, will result in a valve distortion if we're not really perpendicular to this line of coaptation, as you will see here. Now, during leaflet grasping, we are using the 2D echo, and we are not having the 3D echo available, but we can use the fluoroscopy to help ourselves. And for this, I think it is important, as you see here, that we orientate our X-ray gantry from this view that we don't see the clip arms anymore. This will help us that we can use this view during leaflet grasping, that we're maintaining a perfect perpendicular while grasping the leaflets. So we have a fluoroscopic feedback on the correct perpendicular device orientation during leaflet grasping. The other important thing is that the latest generation of those devices, and Francesco also already talked a little bit about this, allows us 2 new features. The leaflet capture optimization, and he has shown this in his example, but we can also use, especially with the Pascal system, the staged leaflet capture, and I will show you this here in these videos. So first, the leaflet optimization. So you see the clasps are coming down. The leaflet is not optimally grasped here. We can swing over, grasp again, and have a better leaflet insertion into the device. The staged leaflet capture or the tarsal maneuver will catch in the first leaflet first, swing over to the second leaflet, then focusing on this leaflet, and we're clasping or grasping this leaflet. And this is shown here. First, we're clasping here the anterior leaflet with this Pascal device. Here again, clasp is coming down. And now we're switching from this one to the posterior leaflet, coming over, having a very deep insertion of the posterior leaflet into the device. And then the clasp is coming down, and we have a perfect leaflet insertion in the device. So these 2 procedures, the optimization of the leaflet insertion, but also the staged leaflet capture, are these 2 new techniques which we can use for obtaining really MR1 plus or less results. And these are associated with improved survival. Now, what about guideline-directed medical therapy? There was a huge discussion in terms of COAPT and MITRA-FR. But is this really of importance? And we looked at this in EuroSMR again, with if patients have triple guideline-directed medical therapy incorporating beta blockers, ACE inhibitors, or aldosterone antagonists. Indeed, if the patient were able to tolerate a triple guideline-directed medical therapy, we had a 70% absolute improvement in survival compared to those patients who were not able to tolerate a non-triple guideline-directed medical therapy. So we should do our very best, besides all our interventional aspects, that we keep our patients on a high titrated guideline-directed medical therapy. And last, I want to talk a little bit about tricuspid regurgitation, because this is seen very frequently in patients with secondary MR. I'm coming back to this older manuscript from the TRAMI registry, which showed that with increasing severity of tricuspid regurgitation from no or mild TR to moderate to severe TR, we have an increase in mortality in the 1 year after the procedure. Importantly, TRAMI shows that already the in-hospital mortality was significantly higher in these 106 patients with severe TR, which is also the same at 30 days, which tells us maybe we cannot wait until the 30-day or 3-month outcomes after we're treating the mitral valve and then consider the tricuspid valve. Maybe we need to treat those patients early on. We did a little meta-analysis about the prevalence of TR in TEER patients. So you see the TRAMI registry, which I have shown you before, but then you see the data from Zurich, the Italian data from Hamburg, Mainz, and our Munich unpublished data with a total of 2,300 patients. The prevalence of severe TR is 17%. But if you consider moderate or severe TR, because already moderate TR is associated with poor outcomes, then we see that more than 50% of the patients treated with a mitral edge-to-edge repair had moderate or severe tricuspid regurgitation. Now, we all know that some patients which we treated with an edge-to-edge repair on the mitral side will have a lower TR at follow-up. But indeed, when we're looking at these large patient population from all those different studies, still around 39% had moderate or severe TR at follow-up. So if you're looking at the impact of a mitral edge-to-edge repair, then only in 27% of patients we saw a reduction of TR from 53% to 39%. But 3/4 of our patients still have severe or moderate tricuspid regurgitation. And these are probably the patients which we need to treat right away to improve their outcomes and to avoid the early increased mortality. Because as we have seen in our retrospective analysis, if we're taking these 106 patients from the TRAMI registry, which I have shown you before with severe TR, and compare those with the 122 patients with the TRIVALVE registry, where these 122 patients received a concomitant treatment of both valve diseases, mitral and tricuspid regurgitation, there appears to be a potential benefit in survival when comparing these two patient groups. So let me conclude the following. Treating patients with secondary MR in the early stages of the heart failure process course is associated with improved survival. We should not wait until we see biventricular failure. Then we have probably patients which are more comparable to the mitral FR patients. In secondary MR imaging, we have new thresholds, and these PISA-based thresholds for secondary MR severity are questionable from my point of view, because those are not really compatible with survival in the classic heart failure patient with an ejection fraction of 35%. And we have shown that patients we have treated with an edge-to-edge repair, regardless if the ERA is below or above 30 square millimeters, have comparable outcomes in terms of mortality and in terms of the symptomatic improvement after an edge-to-edge repair. There's a treatment goal change over the last few years. MR2 plus is no longer acceptable. We need to achieve MR1 plus for all patients, regardless if it's DMR, as I've shown by Francesco, or if it's secondary MR patients, as shown in my presentation. We should not forget or be sloppy about our medication. Guideline-directed medical therapies is or are important in these secondary MR patients and are associated with improved survival. And finally, the interventional treatment of tricuspid regurgitation should be considered early on in inappropriate heart failure patients. Thank you very much for your attention.
Thank you. Thank you so much, Professor Hausleiter. We have with us the two co-chairs, Dr. Dardas and Dr. Eftichiou. Dr. Eftichiou will present Kostas Sparias, and afterwards, Panos Dardas will moderate the discussion and the case presentation live in the box by Kostas. Dr. Eftichiou.
So good day from Cyprus, and first I would like to say take the opportunity and say a big thank you to Dr. Sparias for his contribution in adapting and developing transcatheter heart valve treatments in Cyprus, and particularly Nicosia General Hospital. We are all very grateful to you, Dr. Sparias. And now we will listen to you telling us how to do edge-to-edge repair in small valve areas and mitral valve calcifications.
Thank you, Christos. I will complete this series of presentations with talk about mitral M-tier in small valve area and calcification. Then there will be some time for discussion. And thank you for your patience. So, is my presentation on? Yes, it is. So if we go and see the inclusion criteria in all the landmark studies, you'll see that the small valve area was excluded from enrollment. Take, for example, Everest 2, mitral valve area below 4 square centimeters were excluded. Or the COAPT study, again, mitral valve area below 4 were excluded. And if we see the currently valid MVAR criteria, functional failure has the component of mitral stenosis as it is assessed by mitral valve area or mean transmitral valve gradient. So functional failure is defined as a device performing as intended without complications, but with either an inadequate reduction of the degree of mitral regurgitation, MR above 2, or the development of new mitral valve stenosis. And what is the effect of clipping on the mitral valve area? I think the work of Fabian team that was published last year is very, very helpful. What they did was very clever. They checked the positioning, the location of the mitral clips, and they measured the ensuing mitral valve area. And they were able to show that as we move from the commissure to the center of the coaptation area, there were a difference in the mitral valve area reduction. So this is the percentage reduction. So in the green areas in the commissure, the reduction was between 30, as you can see, and 40% of the initial mitral valve area. When you are in the middle of the coaptation zone or close to the commissure, so the reduction was a bit higher, around 50%. But when you are in those hold zones that were like just next to the middle of the leaflets, then you had the greatest decrease in the mitral valve area that was up to 70% of the initial mitral valve area in some patients. So that's why they call these areas the hot zones, because they have the potential to reduce the mitral valve area a lot more than the rest, and the rest are about 50%, except the commissures that are even lower. And what they also found is that when they created a triple orifice with two devices, Fabienne alluded to that earlier, then the mitral valve area reduction was even more. So a second device, when you keep the double orifice, will give you another 25% reduction in the valve area. But when the second device you create a triple orifice, then you have a 35% reduction of the initial area. And what they also saw was that depending on the position of the device, the stresses on the leaflets were becoming less and less when you're going away from this device, as you can see. And then the stresses on the leaflet, when you put a device in the middle, they actually become more when you go away from the middle, because the length of the anterior leaflet is shorter, so it's pulled in, and that's why you have more stress in this area. And as again Fabian told us earlier, you can use this study to make a prediction of what mitral valve area you have to start with, depending on the anatomy and the devices you're going to use. And as you can see, in some patients, the nicest scenario, 3.5 square centimeters is enough. You'll end up with an acceptable mitral valve area. But in some others, you need even more than 6 square centimeters to end up with an acceptable mitral valve orifice. And when is that? When you have multiple lesions, when you create a triple orifice, and when you are in the hot zone that you get the highest reduction. But is that the end of the story? No, it's not, because it's not only the mitral valve area. We always use it's easier and simpler to use the transmitral pressure gradient. But these two are not exactly the same. As we see from this study, there is discordance in about 40% of patients. So when you think that you have a stenosis with a gradient and you measure the mitral valve areas in the two orifices, you see that this is not true. And that's why we have to do both. And another problem is the difference between the transesophageal and transthoracic echo. So to make it more complex, when you check the intraprocedural transesophageal echo and the gradient the following day of transthoracic, in about 36% of the patients from one study, it goes up. It goes down in 26% of the patients and remains the same in the rest. That's why it has been proposed by Cato, this projected transmitral pressure gradient that corrects for the heart rate and for the stroke volume, that are the two main factors that affect the gradient. And as they change, the gradient also can change without reflecting exactly a change in the mitral valve area, but rather changes in the heart rate and the stroke volume. So the initial information we had was from this study from Lubos, that they checked the successful the prediction of the mitral clip failure, and they found that when they had the mitral gradient more than 4, especially when it was together with a small mitral valve area, then a large proportion of their patients were aborted. The cases were aborted or phased. So this is where we started talking about a mean gradient of 4 or above, that is not acceptable. And really, when we see after mitral clips, what is happening if we have a mitral gradient, mean gradient above or below 5, then you get a significant worse prognosis. And actually, this worse prognosis starts from the 4.4 by this study. And again, if you get the mitral valve area, from another study, we see
that the division point is 1.94 in that study square centimeters. So if you had at the end a mitral valve area of below 1.94, you had a worse outcome. And what happens in relation to the pulmonary hypertension and outcomes? From the COAPT trial, we know that there was no difference in the quartiles of gradients, even when the gradient was high in this FMR patient, they didn't have worse outcome, which is in contrast to what we're talking about so far. And that was true for all-cause mortality, cardiovascular mortality, and heart failure. And as you can see here in these graphs, it didn't appear that the gradient at the end of the procedure was predictive of the outcomes. And recently we've seen a series of studies that they all point towards that there is a relationship, mostly when we have patients with DMR after MitraClip. So this study is a study with DMR. They found that there was a relationship in DMR patients, significant, but not in FMR patients at the gradient at the end. And this is a most recent study that they also had similar results. They found this relationship in the DMR patients, so a gradient above 5 was predictive of worse outcome, but not in FMR patients. And there can be a lot of explanations about it, but there is still controversy going on, and this is a study by Yoon, also a very recent publication in patients with DMR, that they failed to find a relationship between the gradient at the end of the procedure and the follow-up. And this is a table by Professor Hausleiter and Becky Hahn, that they put all these studies in a table, and exactly they saw this controversy. Some of them say there is a relationship between the gradient and all patients after MitraClip. Some others say that this relationship holds only in DMR patients, and there can be explanation about it as they wrote in their editorial, but it's not, I think, the right time to discuss all these details. So I'll finish by showing a few cases with extreme calcium and small annulus that we dealt with recently, starting with this one, a patient, a small lady with DMR from P2 prolapse, with calcified, as you can see, annulus and also small annulus that we treated with MitraClip and TEAM. That was the only device that we could use at that time. The area was just 3 square centimeters, and the area we could go was just 1 point in the coaptation zone. The mean gradient at the beginning was already 4. So this is a combination that leads directly to failure, an area of below 3 and a gradient above 4. So you can appreciate the prolapse in P2, and you can see this calcium cells just below the prolapsing segment, and this is the flail width, which was 1.5 centimeters, and you can see the MVQ analysis. This is our device here, one in the center, and the release of the device, and this was the best we could do in this patient, still up to moderate residual MR, but there was no option for a second device. The bridge was satisfactory, and the gradient went up was 5, so a small, if any, increase in the gradient. The Pascal platform, we talked a lot about the differences in the past lectures this morning, and the table with the difference between Pascal and MitraClip, but it's not at the time, so I'll show you a few cases with Pascal that we think it's more appropriate for use in such small and calcified anatomy. So
This is a patient with small anatomy and calcified, as you can see, pillar of calcium in A2 leaflets, that it happens to be exactly at the point of regurgitation. So you'll see that the A2 flail is at the tip of this calcium. So that will be a calcium at the grasping zone that you wouldn't like to go with a mitra clip. And you see exactly this is the area. You see the eccentric jet there from the A2 prolapse, severe MR, a gradient of 4 already at the beginning, and an area of 3.6 already low at the beginning. So this is the release of 1 Pascal ACE device, as you can see here. And this was a result with just 1 Pascal ACE device that was really impressive. So it's the width of MR after the release of this device. And you see in 3D color zoom, and the gradient remain the same, 4 at the end of the procedure. And we do the measurements of the 2 orifices, and you can see 1.3 and 0.9. We had a final orifice above 2 square centimeters. Another case with calcified again and small annulus with mixed etiology MR, both degenerative and also some pulling down of the posterior leaflet. The mitral valve area is just 3.3, and we come again with 1 Pascal ACE just in one area. We can go, there is a calcium shelf below the posterior leaflet that we see only. This is the posterior optimization, so you'll see the posterior clasp that is coming up and down here, up, and then we tilt towards the posterior and down again, and closure of the device, release of the device, a nice bridge, and this is the final result, very acceptable, mild 1, maximum 2 residual MR, and a gradient of 5 in this patient. Final combined mitral valve area of 2 square centimeters, and this is probably one case that nobody would like to deal with. This is a patient that we helped the San Lucas team treat a few months ago in Thessaloniki. So you'll see this torrential MR from everywhere and calcium everywhere in the annulus, in the leaflets, and in the codi below. And again, we had a very specific area that we could only go with an 1 Pascal ACE. We're able to position it there and to get this amazing result with just one device. And with this, we also measure the combined area at the end to 2 square centimeters. And I will finish with this one, which is the last DMR again. You see extensive calcification everywhere and severe MR. You can see here the calcium shelf below the annulus, and there is only one point that you can see the posterior leaflets. There is no posterior leaflet in anywhere else. And again, with 1 Pascal ACE in that area, we're able to get it and reduce the MR to just a trace of MR at the end. And with this, I would like to thank you, and I think now it's time for discussion.
Petros, for the discussion. Congratulations, Costa. And Petros and Christos for the discussion. Where's Petros? Okay.
Everybody's here.
Hi, yeah. Well, fantastic talks and really excellent results, and congratulations to everybody. I was really impressed by the widespread application of the method. Initially started with a simple A2P2, but now over expanding to a lot of disease, and even in cardiogenic shock, in COCOM, and in small anatomies, in calcified valves, and with excellent results. And I think the combination of the mitral clip and the Pascal and application of one of the two according to the anatomy is really very, very impressive. I wanted to ask I saw a case on the use of 3 or 4 mitral clips as a scaffold for to put a closure device, a paravalvular closure device. And this was really impressive. I've never seen that. And I wanted to ask whether you've got any experience, whether this alters, first of all, the anticoagulation, and second, what is the best plug to use? Is the AV3 or the AV2? I saw that they use an AV2, or whether the recently introduced AV4 is an option. And this is the one question they wanted to make, whoever wants to answer. And the other remark I want to say is that by gaining more and more experience with this technique, it is impressive how best results we have when we stick to the details and have less residual MR, better grasping. So all these things really matter.
Jörg, you'd like to answer Petra's question?
I can try. So I have also only very limited experience in the use of edge-to-edge repair devices with vascular plugs or closure devices. The anticoagulation is not going to changing. We know that the majority of patients are on anticoagulation anyway, so we keep this, and even if they're in sinus rhythm, I would not change from a dual antiplatelet therapy to anticoagulation just because of a closure device. I think if we're going to do such combination therapies, there is no one-fits-all strategy. We need to use what kind of devices for the individual anatomy. So these can be such closure devices, but it can also be ASD devices or PFO devices. All different devices have been used in the past with variable results, one has to admit.
Would you go to implant the plug on the same session, or you would worry about dislocating one of the clips you've already positioned and wait for, let's say, 3 months for scar formation and come back later for plugging?
It's a very good point, important point. Usually what we are trying to do is that we're going to wait to see how the patient is improving with the edge-to-edge repair. If there is still a significant MR and significant symptoms, then we consider to treat those patients in a second procedure than with an edge-to-edge with such a plug device. But this is something we do, let's say, one in a year or even less than that. So it's very, very rare. I think it's important, and the new devices, especially the Pascal device, allows us with these independent grasping features to really get the best result already in the first procedure. And this is what we're going to try to achieve. So that we are that there is a low likelihood that we need to come back for a second procedure.
A P10 nowadays or just ACE?
I'm 100% ACE. I don't have a P10 anymore in my lab. I think it's the better device for several reasons. But I know that some labs are still using both and are still considering the P10 for some certain pathologies, I personally don't think that there is a benefit.
We concur. And I understand you're a proponent of simultaneous mitral and tricuspid theory. Is that right? Are you doing that in all patients, or you apply some selection criteria?
Yes, and that was an add-on to Costa's question. At the end of the day, which patients, which percentage of patients with functional MR do you think that will be benefited, or it's cost-effective to use TR in tricuspid valve?
Well, the cost effectiveness is the major point, I think. Right now, I'm not aware of any country who has reimbursement for doing a simultaneous procedure on both valves. We have done this in the past. We're still doing this in some special patients, but very limited numbers because of the reimbursement issue. But our surgical colleagues are doing this more or less even in mild TR, which I don't think we need to do, but there the acceptance rate of treating both leaflets at the same time is significantly higher. And I think we should, of course, we need to study for this, but I think that those patients who have concomitant diseases of both valves do benefit much more at a higher level if we treat both valves at the same time. Of course, you can argue that let's do one first and see if it's improving, and do the second one, let's say 1 month later. On the other hand, we have very old, fragile patients. Every full anesthesia is a small risk to the patient. They have come back to the hospital, which increases the risk. And TRAMI showed that there is already an increase in hospital mortality within the first procedure. So if you want to do it perfect, then probably concomitant would be best. If you want to be almost perfect, then at least bring the patient back 4 weeks later for the treatment.
Can I ask a quick question?
Sure.
So, Dr. Hausleiter, congratulations for your excellent talk and the very clear messages. I was wondering, you have very nicely shown that the benefit of the degree of MR reduction to survival. Is this MR reduction degree benefit independent of the etiology of the heart failure?
Well, this is a good point. This is what I have shown is the residual MR just in secondary MR. So all patients with functional MR reduced left ventricular ejection fraction. We're about to submit a manuscript on a very large 1,500 patient cohort with the prospective registry in Germany, where we evaluated a score which is called the Mitral score, which looks at the residual MR with different components, hemodynamics, echo, and so on. And regardless if it's going to be a primary or secondary MR, if you're going to achieve a very good MR reduction, is associated with reduced mortality, improved survival.
Great. I think since we're discussing about mitral valve, we have a very short life in a box recent case, and Dr. Katsianos will come to present it. So if you'll be with us, it'll be great. If you have to go, you can go. But I think it'll be fun to see this case, how it went. Kyriakos.
Hello, dear colleagues. I'm grateful for the opportunity to present this interesting case of TMVR on behalf of the heart team of Ecg Hospital. A few words about our patient. It is an 87-year-old male with a functional MR due to dilated LV and components of atrial functional. He presented with a dyspnea, NUHA 3, worsening during the past 6 months with hospitalizations due to heart failure, also with ascites, paracentesis, and dialysis due to temporary renal failure. From the medical history, he had back in 2008 a SAVR with bioprosthetic Magna is Edwards 25 millimeter and a gel with aortic graft. The cardiac catheterization showed proximal LAD stenosis until 50%, and the right heart catheterization showed irrelevant pulmonary hypertension. For the medical history, the patient has also a chronic kidney disease, permanent atrial fibrillation, hypertension, had a TIA back in 2015. Transesophageal, we saw a dilated LV and ejection fraction of 50 to 55% with severe MR, a severe LA dilatation, and a coaptation gap between the anterior and posterior leaflet. A TR, grade 1, and we referred the patient for a mitral tear. Maybe we could go on with the live in the box case. We have performed here our low femoral vein puncture and have already inserted a 7 French sheath. Now we insert the catheter, the sheath catheter, the SLO, towards SVC, 3 to 4 centimeters above the cava atrial junction. Now comes the Brockenbrough needle, and then we'll begin an AP projection. I'll pull back towards the fossa vallis. We see it right now. We see the movement of our catheter. And the next video, yeah. We measure the, yeah. It's okay, don't worry. Here we measure the height in 4-chamber view. We accept it, and we pass with a safe set guide wire, and with the help, in this case, of 5 French multi-purpose catheter to navigate us towards the left superior pulmonary vein. Now comes an Amplatz super stiff wire, and we remove our catheter, the multi-purpose. On the right side, we see the simultaneous echo of the patient. Now we remove our SLO sheath, pre-dilate with the 18 French sheath. And we're ready for the guide sheath, the 22 French guide sheath of the Pascal system. We introduce it towards septum. Now we'll see the sheath passing the septum 1 to 2 centimeters in the LA. We remove the dilator. We stabilize the guide sheath. And we remove the dilator and the stiff wire. Now we're ready. We introduce the steerable catheter and the air, of course, our system. On the right side, we see our MR, which is relatively wide. Now we're ready. We stabilize the steerable catheter and introduce the Pascal system, in this case P10. In the left atrium, we close the device. And we're ready to navigate towards the mitral valve under a fluoroscopic and echocardiographic guidance, of course. We check our trajectory and here the perpendicularity of the device in 3D. We turn a bit clockwise, and now we're ready to check the clasps. First, it was the anterior. Now comes the posterior. It's down, and again up. Then we close the device to pass the valve, to cross the valve, which is this case. We're opening slowly the device. Checking the perpendicularity after crossing the valve. We turned a bit clockwise again, and we decided for a separate clasping. First the anterior leaflet. Now we're trying to clasp the posterior, which was actually the difficulty in this case. We see that we didn't clasp it properly, so another attempt. Again, we see the clasping. In this case of both leaflets, we close the system. We check the MR. We see that we were not satisfied with the clasping, so we open again the system, we elongate it, and another attempt. We open the device. Check the perpendicularity in 3D. And again, we decided for a separate clasping. Clasp the anterior, we go for the posterior. This was, again, not successful, so we elongated. Interesting, this was that the device stuck on the anterior leaflet, and we solved the problem we dropped halfway the anterior clasp, and so we could release the device. So this was the final attempt. We opened the device, we moved more medially. See the posterior leaflet sitting on our posterior clasp, and close the device. Better grasping of the posterior leaflet. Taking the MR result. You see here there is tension in the system, and which we will release. Check the stability of our device. Here we see how we release the tension. A trivial MR. A good tissue bridge in the A2P2 area. The nice 3D pictures and videos. Device was stable. Had a mean gradient of 1. Or 2. And nevertheless, we decided, because we were not 100% satisfied, to optimize the anterior leaflet clasping. Which seems very stable now. Close the device. Taking our result. The mean gradient was 1. Final measurements. A nice tissue bridge. So we decide to release the device. So the device is released and stable, with a stable result. And finally, we remove the system with the Z suture. We do not pre-close.
Okay, I think this is enough. We got a very good sense of the case, and this was one of E10 that we used after a long time. I don't know why, Kyriakos, we decided to use this P10 in that day, but we did it, and with this final result, that you can see the smoke in the left atrium. And I think this case demonstrates how important it is to try to get a better result with small movements of your device, medial or lateral. And the problem here was that there was a lot of movement of the device with breathing. So you could see that we aimed to be more centrally, but with breathing, it was moving more laterally all the time. And then we did a breath hold. And the second thing was that we had, as you could see, lateral to medial trajectory of our device because of the anatomy. And that's why we had these multiple attempts to optimize our trajectory and to be in the closer to the center of the valve, although the maximum Z was slightly laterally. So that's why we ended up with the positioning of the device there. And you also saw that there was no change in the residual MR, I would say grade 1 before and after release. Any comments from you guys?
Yes, congratulations. I would like to ask you, Kostas, and our friend here, if another site of transeptal puncture would lead to different results, would make your life more easy, more.
Certainly, it's very. The procedure is very sensitive to the puncture site, and it's by default we go high and posterior, but it's not always possible, especially when the posterior part of the septum is thick, as it was here. So it was preventing you to go more posterior than that. So that was the maximum posterior we could go. So this is a demonstration how even a straightforward case can have the small tips and tricks and difficulties, but certainly the going always high and posterior is our aim in all cases because it makes this procedure easier. Okay. If there are no other comments, I think we close this session here, and I would like to call the moderators, the co-chairs of the next session, Dr. Georgiou, Dr. Zairis, Dr. Pilates, and Dr. Skalidis, to open the next session. Thank you.
I would like to welcome you to this session, which is TAVI in TAVI and TAVI in SAVR. On behalf of the call moderators, which are online, I would like to start. And I'd like to tell you that TAVI in SAVR is a standard procedure. TAVI is a standard actually procedure for degenerated surgical, bioprosthetic surgical aortic valves, and we see a lot of patients coming for that procedure, although we see a lot of difficulties relating to the anatomy of the patient sometimes, and to the anatomy, the kind of the valve that surgeons have used. TAVI in TAVI is not very frequent because most of the patients that we do TAVI are high-risk patients, and they don't survive more than 5 to 8 years. Actually, in the first TAVI trials, only 30 to 35% survive more than 5 years. But as the time goes on, and we do TAVI in patients, younger patients with low risk and with long life expectancy, we foresee a lot of patients coming back a few years later for another TAVI procedure in degenerative TAVI valves. So it's very important for us and for the surgeons to choose the first device in order to facilitate the next procedure if needed. Dr. Kleinman, who is a professor of cardiology at Houston at the Becky Heart Center, will talk to us about this topic, how to choose the first device in a patient with severe aortic stenosis. Dr. Kleinman.
Good afternoon. I'm Neil Kleiman, and I've been asked to talk to you about choosing the first TAVI valve for sequencing. Here are my disclosures. And of course, here's my greatest disclosure. I hope that we can keep debating this issue forever. And like everyone else at this meeting, I look forward to the time when we'll be able to get back together face to face.
Okay.
So when we talk about TAV and TAV, we're really talking about lifetime management of an increasing proportion of patients who are going to have transcatheter aortic valve replacements. And there are several things that one has to think about when one plans this. First, prosthesis durability versus patient survival. Look at the patient and decide, are you going to have to sequence at all? Is the valve going to outlive the patient, or will the patient outlive the valve? If you do so, will you occlude the coronary arteries? Is the patient graft dependent? There's going to be a significant issue as well. Will coronary access become an issue at all? Good afternoon.
Okay.
I'm Neil Kleiman, and I've been asked to talk to you about choosing the first TAVI valve for sequencing. Here are my disclosures. And of course, here's my greatest disclosure. I hope that we can keep debating this issue forever. And like everyone else at this meeting, I look forward to the time when we'll be able to get back together face to face. So when we talk about TAV and TAV, we're really talking about lifetime management of an increasing proportion of patients who are going to have transcatheter aortic valve replacements. And there are several things that one has to think about when one plans this. First, prosthesis durability versus patient survival. Look at the patient and decide, are you going to have to sequence at all? Is the valve going to outlive the patient, or will the patient outlive the valve? If you do so, will you occlude the coronary arteries? Is the patient graft dependent. There's going to be a significant issue as well. Will coronary access become an issue at all? If the coronary arteries are completely normal at the time you do the TAVR, what's the likelihood that the patient's going to develop coronary artery disease during their lifetime? Increasingly, in the last few years, we've seen attention turned to valve orientation. Are you going to make sure that when you insert a valve, you're going to allow coronary access without putting the valve posts in front of the coronary ostia? This is something surgeons have paid attention to for a long time. Finally, in the last 2 years or so, it's something that we've paid attention to. And finally, if you do implant a valve and the patient needs another valve and the coronary ostia are not easily accessible, will a basilica procedure be feasible? So let's dive into these. So first of all, largely, I think we're talking about patients who are at low risk when they receive a TAVR. And if one looks at the 2 low-risk trials that have been published, the median age is about 73 years. And these are US survival statistics as of 2016 for patients in the age groups we're really talking about. So a patient in their 60s is going to live somewhere between 20 and 25 more years. Patient in their 70s, again, this is going to be the mean age group for low-risk patients, somewhere between 15 and 17 years. We don't know survival after TAVR. We do know survival after SAVR, however. And these are data from the STS database, a large cohort of patients undergoing SAVR. And let's just take a look at the top, for example. These are isolated SAVRs. So a patient who's 70 to 79 years old has a median survival, or rather mean survival of about 9.5 years. And that number increases to 12 years between ages 65 and 69. And I've superimposed here the values reported in the 2 low-risk trials at 2 years. Again, that seem to be beating the survival at this point in the STS cohort. And if one looks at the Certavi trial of intermediate risk patients, it just about falls on the 70 to 79 year line, which is dashed. So low risk appears to be beating it at 2 years. Intermediate risk appears to be falling on it. So there is a pretty good chance we'll be talking about TAV in a number of these patients here. How many? We don't know yet. And as the population gets a little bit younger, we may see increasing rates of structural valve deterioration. Well, how frequent is that? These are data that my colleague, Dr. Mike Reardon, presented at the ACC earlier this year. These are the SAPIEN data. At 5 years, fairly high for the SAPIEN XT, but for the SAPIEN, the S3 valve, about 3.9% at 5 years. Pretty comparable to that for surgical valves. And in fact, so again, 9.5% for SAPIEN XT, 3.9% for S3. And if one looks at core valve data, again, presented by Dr. Reardon in a good deal of detail, using sophisticated analysis with a fine gray technique, which is a technique that allows you to adjust for competing risk, such as mortality, which would preclude structural valve deterioration. For surgical valves, it's about 4.5% at 5 years. For TAVR supraannular valves, it's about 2.57 at 5 years. Again, this is a slightly older population. It includes high and intermediate risk. In younger patients, we don't know whether this figure will be higher or not. And it's important to note that the vast majority of structural valve deteriorations are stenoses rather than regurgitant lesions. So what do? Well, we have some data on surgical explant. I've shown some detail of surgically explanted valves. But if one looks at the mortality for this procedure. Over 11 years in 42 centers, 269 patients in the registry, 23% mortality at 1 year. So this is not a typical surgical valve replacement. It is a high mortality procedure. And as TAVR valves are adherent to the aorta, excising them poses varying degrees of challenge to the surgeons who perform the procedure. So when we talk about TAV and TAV, we have to recognize the elephant in the room, and that's this. Placing a TAV within a TAV creates a tube graft, currently known as a neoskirt, that can sequester the sinuses of Valsalva and either occlude the native coronaries or obstruct access to the coronaries later on, particularly when the first valve has a long frame or is supraannular. So the guiding principle here really is that if the first TAV commissure, the commissure of the first TAV is above the ST junction and the stent frame is in close proximity to the ST junction, so it's difficult for either blood or, for that matter, a coronary catheter to get between the valve frame and the native aorta to get into the coronary, whether it be catheter or blood, coronary flow and coronary access can be impaired. And in theory, at least, most of the risk is predicted by the first prosthesis. And this just shows you theoretical considerations in a supraannular evolute pro valve or in an S3 valve, which is annular and has a shorter frame compared with the supraannular evolute valve. Now there are data and there have been measurements about neoskirt height of the TAVR prosthesis. And here you can see that there's quite a wide range, starting with the J valve, and these are for 23 millimeter prostheses. The J valve has a neoskirt height of 13.6 millimeters. Sapien XT down at the bottom, 14 millimeters, slightly higher for an S3 valve, 16.5, all the way up to 30.1 for an accurate neo valve, and 26 millimeter Evolute Pro, 26.7 millimeter valves. Obviously, the largest size valves are going to have higher neoskirt measurements. And frankly, when you're implanting a second valve, at least in S3, and probably so for an Evolute as well, the actual height of the neoskirt is going to depend on how deeply you place it. Now, obviously, you can't place it too deeply, or otherwise you'll be in the ventricle and there won't be adequate tissue to anchor it. But nonetheless, if one looks at the Evolute Pro shown here in the various nodes, starting at the base with node 0 all the way up to node 7, there's quite a range of neoskirt height. And actually, when this group of investigators in Vancouver measured the range for 34 millimeter valves, starting with node 4, an S3 implant as a second TAV would give you a neoskirt height of 19.9 millimeters, whereas if you implanted that same S3 at node number 6, which is way up high, you'd end up with a 27 millimeter neoskirt height. So again, the depth of implantation of the second valve is important as well. So what about the risk? Well, here we've got to recognize that there is a difference between theory, we think, and practice. So in this study of 411 patients, most of whom received an S3 valve, smaller number with Evolute valves, pre and post TAVR CTs were performed. Now again, these are not second TAV implantations, but these are CTs in anticipation of a second TAV should it become necessary. Patients at high risk for sinus sequestration were defined as those with commissure levels above the STJ and TAVR to STJ distances less than 2 millimeters. So here were the observations. Commissures were above the left coronary ostium and 59% of evolute versus 2.3% of S3s. 45% of evolutes and 2% of S3s were at risk of sinus sequestration. And predictors of sinus sequestration were for an evolute and STJ height less than 19 millimeters, STJ diameter less than 27.5 millimeters, whereas for first tab being an S3, STJ height less than 17.5 millimeters, and again STJ diameter of 27.5 millimeters. The caveat, though, is remember this is an S3 predominant center. So in this particular study, patients with smaller annular and aortic dimensions to begin with received evolutes as their first tab. So the patient groups are not identical. Another observation that's been made is that since the posts on the evolute are somewhat wider than the S3, even when you're well aligned, there's a difference in post overlap, which would preclude a basilica procedure for second tab and tab. And in this particular study, again, largely done before we were concerned about coronary alignment, and in which most patients received S3s, 45% of evolutes and 11.1% of S3 patients had post-overlap positions that would preclude basilica for tab and tab. As it turned out, of these 411 patients, 3 patients, which is fewer than 1%, actually did undergo tab and tab without major issue. Now, since that time, there's been a fair amount of attention paid to cusp overlap. We now all try to do that when we implant first valves. And in this particular study published earlier this year, if you implanted in the cusp overlap view, you minimized the amount of deviation of the ostium. So you actually minimized post overlap to less than 20 degrees in about 95% of patients. So when you implant valves in the cusp overlap view as compared to the coplanar view, you're better enabled to adjust your valve placement so that you avoid putting posts in front of the coronary ostia. And it's important to realize that there is a fair amount of deviation in the locations of the coronary ostia. They're not all 120 degrees separated as you might predict if you hadn't studied the CT scans. And in this second study from, I believe from Denmark, optimizing alignment, again, reduced coronary access obstruction risk from about 32% down to 5%. So both studies concordant, showing that, actually I think the second study is from Spain, concordant, showing that you can markedly reduce the risk of coronary obstruction if you take care to align the coronary ostia and make sure that the valve posts are not sitting in front of the ostia. Now, when we talk about younger and younger patients, higher likelihood of redo TAVR, we're obviously talking about a fair number of patients with bicuspid rather than tricuspid valves. And as it turns out, if patients have a type 0 bicuspid valve, then the risk for coronary obstruction is considerably lower than in patients with either type 1 bicuspid valves or tricuspid valves. So that's an important consideration to keep in mind. The risk is going to be considerably lower in patients with Siever's 0 valves. Now, hydrodynamic testing of these valve combinations has been done as well. Here's from a group in Vancouver who used a pulse duplicator and performed multimodality imaging. Most valves, as it turns out, most valve combinations were hemodynamically stable. Now, they didn't and obviously couldn't test every conceivable valve combination, but they did note that cusp overhang, that is, if you put a sapien valve relatively low inside an evolute valve, so that during diastole, the portions of the neoskirt from the old valve overhang the lumen of the second valve. Remember, this occurs primarily in diastole and turned out not to be a hemodynamic issue in the studies. There are a few cautionary notes, though. Anchoring a 27 millimeter Allegra valve was a fairly difficult thing to do. And the bottom line is you don't want to put a small valve inside a larger valve because it's likely to become dislodged. This is something that's very intuitive, but now it's demonstrated in this in vitro model. Okay, so that's theory. What really happens? Well, when you actually look at what's happened, it's not so clear that the results are very catastrophic. This is a study from Denmark, Dr. Sondergaard's group, 45 patients who had a CT scan post-TAV and TAV, so no catastrophes during the implantation. But these were actually first implantations where the first valve wasn't well positioned and a second valve was required, so no catastrophic events. 30 patients had an evolute first, 15 had a sapien first. What were regarded as interfering factors were coronary ostia below the neoskirt, transcatheter heart valve, distance less than 3 millimeters from the aortic wall, distance between the two sets of struts less than 3 millimeters at the coronary crossing zone, coronary ostia, as it turned out, were below the top of the neoskirt in 90% of the evolute first, but also in 2/3 of the sapien first cases. So unlike the CT predictions we saw a little earlier, there doesn't seem to be a lot of difference between the evolute first and sapien first cases. So practice doesn't necessarily reflect what we've seen in theory. Coronary access was predicted to be technically impossible in 27% of evolute first versus 10% of sapien first cases. So advantage sapien, but not quite as profound as predicted in some of the earlier models. Now, here's another piece of data. This is from the Redo TAVR registry, which is the largest TAV and TAV experience that we have so far. Published late last year, and I can tell you that in a short period of time, there will be a more detailed analysis coming up looking at various valve-in-valve combinations and comparing one combination to another. But in this study, at 37 centers who did a total of more than 63,000 TAVRs over a 14-year period, which works out to fewer than one TAV and TAV per year. About half the TAV and TAVs were done as emergencies during a single procedure. They are excluded from this registry because obviously there wasn't much choice in the matter. Elective TAV and TAVs in 212 patients, and they were compared to TAV and SAVs. So again, this works out to fewer than one TAV and TAV per center per year. Now, obviously, as we do more low-risk patients whom we can follow longer, this number is going to increase, but it's still relatively low. And they did propensity score matching. That's not really so important for purposes of this discussion. But it was done nonetheless. I'll show you the results. So they ended up comparing 165 TAV and TAVs versus 165 TAV and SAVs. And take a look. For TAV and TAV, procedural success occurred in 72% of patients, procedural safety in 70% of patients. As you can see, gradients were slightly lower in the TAV and TAV patients. And if one looks at all-cause mortality, we're now talking about 10% or 11% at the end of the year, roughly half what's seen in the TAV explant registry, and very similar for TAV in TAV versus TAV in SAV. Now, again, we become very concerned about coronary access, but the truth is when we look at patients, we have a fair amount of information about them already that can help us predict what the likelihood is that they're going to develop coronary artery disease and require us to get coronary access. And that probably will be for interventional purposes because coronary CTA is getting pretty damn good at delineating coronary anatomy. So let me show you two studies. This is one from Mass General looking at a fairly young group of patients with coronary CTA. And what they asked is if we looked at coronary risk scores in the absence of coronary CTA, and then we added coronary CTA findings and coronary calcium score findings to it, what kind of information would we get? And what you can see in about 1,100 patients, mean age 55, follow-up for 2.5 years, the statistic or discriminatory capacity got pretty good when you took classical coronary risk scores and added coronary CTA findings to it. You really did get pretty good. And remember, every patient now who gets a TAVR has a CT angiogram, so we can look at the coronaries. And in fact, if you look back at the much larger confirmed registry, 12,000 patients, slightly older, looking at MACE events, most of which were revascularization. And one compared the Framingham risk score to, actually when one added coronary CTA findings to the Framingham risk score, one got a net reclassification index, which is an indication of how much you can, or how much further you can refine a score. So an NRI of 0.28 really is pretty good. So take a look. If one had no coronary artery disease, the MACE-free event probability really was pretty low at 6 years, only about 5% risk of requiring an intervention of one sort or another. Non-obstructive coronary artery disease, so it's about 10%. And for patients with obstructive coronary artery disease, it does become considerably higher, about a 30% risk of major adverse cardiac events. And as you can see, particularly in younger patients, when one looks at the risk of in patients with no obstructive or minimal non-obstructive coronary artery disease. So you look at the relative risk in the patient group that we're most interested in for purposes of considering TAV and TAV, they really are relatively low. So if you have a fairly young patient who has no coronary artery disease or non-obstructive coronary artery disease, the likelihood that they're going to need a further coronary intervention down the line, particularly in the current age in which we manage risk factors aggressively with high-dose statins, ezetimibe, PCSK9 inhibitors, really is pretty low. So in conclusion, I think for practical purposes, we have to mind the gap. The predictive models warn of disastrous consequences of TAV and TAV. So far, those haven't panned out, although we're still in a relatively data-free zone. The actual data thus far are limited, but note that the literature is not replete with accounts of catastrophic failures, that is coronary artery occlusions after emergency TAV and TAV for procedural failures with a first valve. And the literature thus far does not reflect a high acute risk during a more elective second procedure. However, as the total number of TAVRs increases, there will be more to come. So what are the considerations in 2022? We're really talking about short frame annular versus long frame supraannular valves, each of which are going to have particular advantages in specific patient groups, largely dependent on their anatomy as defined by the CT. We've got to think about survival considerations. How long is the patient going to live versus how long will the valve last? We've got to look at prediction of CAD in the era of modern aggressive risk factor reduction. We're going to have to think about angular sizing and its effect on gradient when we place a first valve. And I refer you to the ongoing SMART trial, which is going to provide us with some important answers in that arena. And as things evolve, we're going to have to think about the predicted height of a neoskirt associated with the first valve if a second valve is implanted. Will the neoskirt sit above the sinotubular junction? Will the commissures sit above the coronary ostia? Can you align the cusps so you'll permit a basilica procedure if one is needed? Or will we actually have to look at leaflet excision down the line? And what's the distance from the STJ to the neoskirt going to be? Is it going to be less than 2 millimeters? So blood's got a tough time getting in and you can't get a 6 French catheter in, or will there be adequate distance? So these are the things we're going to have to think about as this field evolves. Thank you.
Thank you, Dr. Kleinman. It's a very comprehensive. It was a very comprehensive presentation, and actually, I had a question. That I think that. Can you hear me? Are you with us? No. Okay. So it's just a video. So we'll keep the questions for the end of the talks, and we'll proceed with Dr. Tang, which is from Mount Sinai and Mount Sinai Health System from New York.
Hello.
And he will see his video about the clinical and anatomic considerations for TAVI in younger patients as a follow-up on the previous talk. So we'll see now Dr. Tang's video.
Today, my presentation is on clinical and anatomic considerations for TAVI in younger patients. Here are my disclosures. TAVI is getting now younger and younger in patients, at least in the United States, given the recent low-risk approval. And you can see that last year, the median age is around 75 years. So what do you consider in TAVR versus SAVR in a young low-risk patients? So the first thing is the anatomy. Is it transfemoral, feasible? And can we get a surgical-like results? Is mild paravalvular leak okay? What about new left bundle branch of the pacemaker? Is that benign? Coronary access after TAVR is not straightforward. And of course, lifetime management of aortic valve disease. Can we re-intervene with redo TAVR or do we need surgery? So I'm going to highlight these 5 points, but in the interest of time, I'm going to go through point 1, point 4, and point 5. So transfemoral results, we all need to do a meticulous CT analysis to see what the aortic root anatomy looks like, the valve sizing, and whether we expect none or trace paravalvular leak. We also need to look at the risk of coronary obstruction and also whether potentially redo TAVR may be feasible. Of course, transfemoral has been shown to be superior to alternative access and surgery in high and other extreme risk patients, and at least non-inferior in low risk patients. So we need to make sure that transfemoral access is feasible. What about coronary access for coronary disease? Well, CAD management in post-TAVR is going to be increasingly important because the prevalence is quite high. You can see that even an intermediate risk is over 60%, and low-risk patients over 20%. The issue is that most interventional cardiologists are not familiar with TAVR because they don't do them. So they don't know what the device looks like, and so may have difficulty with access. The aortic root anatomy is also highly variable. And of course, unlike surgery, in TAVR, you have the native aortic valve leaflet in the way, but also the transcatheter valve frame and potential lack of commissure alignment. Here are 2 examples why coronary access may be difficult. You can see that on the left side, there's a bulky left coronary cusp facing the left main, And then the right side, you can see that the left knee is very low. With a tapping SAP situation, it can be very difficult to reaccess the coronary with small STJ. This paper was published a number of weeks ago looking at anatomic and device procedural factors impacting coronary access after TAVR. And we actually had developed an app alongside with Dr. Anna Polakini and Dr. Samin Sharma. And this app is available for free on Android and Apple platform, and also available on this website where you can actually use it offline to understand how to access the coronary. So why may commissural alignment be important in TAVR? You can see that coronary access is important in taller transcatheter valves. It can reduce the risk of coronary obstruction with TAVR and SAVR. There's high likelihood of potential redo TAVR, reducing coronary obstruction. There's also evidence of misalignment causing halt, and high gradients may in fact impact durability. And basilica is not really feasible if you have a coronary facing the commissural pulse of a transcatheter valve. It's important to understand the aortic root anatomy, the TAVR device type. The shorter stent frame valves are likely going to be easier for coronary access, but may still be a problem for redo TAVR if the valve frame extends above the STJ. And of course, taller valves in the self-expanding platform, especially suprarenal valve, will be important for both coronary access and redo TAVR. These are the factors impacting on coronary access and redo TAVR. You can see that commissural alignment is important. And what is commissural alignment, you ask? Well, it's basically on the left side, the transcatheter valve commissures are basically the same position as the native aortic valve commissures. Which is the right side, you can see that the commissures are completely overlapping the coronary, and so you have much less physical space to engage the coronary artery because these transcatheter valve frame and commissural posts can be quite tall. And you can see that here why. The areas shaded in blue represent the commissural posts of these transcatheter valves. And if these faces one of the coronaries, you can see that physically there's going to be less room to reaccess. And this example here shows it very well with the Evolut platform. For example, on the left side, if you have suboptimal alignment, you can see that you have to go from either side of the commissural post where the X marks are to access the coronary, where the red dots are, and you can see the space is not as straightforward and mostly oblique. And if you look at the right side, you can essentially access the coronary artery directly from above or just nearby. Even low coronary height would not be as relevant as an issue. In fact, this paper from Jack Intervention showed that between 11 to 20% of cases, the commissural post will face the coronary, impacting coronary access. And in the case of TAVR and SAVR, if you have a commissural post facing the coronary, you can see that even with the split portion for basilica, that commissural post can still obstruct that split portion. So we've looked at this with 3 different transcatheter valves in the see if we can intentionally align the commissures in Jack intervention. And with the balloon expandable SAPIEN 3 valve, we are unable to do that despite crimping the valve in different orientations. With the Evolut platform, you can see that the C-tab represents the commissural post, and you can see that the hat marker on fluoroscopy is actually 90 degrees away from the C-tab. And so when you deploy the valve, your hat marker may initially, majority of the time, be in the outer curve or center front. And when you release the valve, majority of the time, it should be at the inner curve of the ascending aorta. So what you want to do, essentially, you should position the hat marker initially at the outer curve or center front, so that just like here, where the green bars are, the incidence of coronary overlap will be much lower than if the hat marker were positioned in the inner curve or center back at the time of deployment. How we do this is that we put the flush point at 3 o'clock. You can see the flush point at gray handle rather than facing the ceiling. We just point away from you. And by doing so, you can see that the hat marker can trap in the descending arch and ascending in the outer curve. When we deploy the valve, the hat marker should face you directly in the cusp overlap view. And the C-tab, when you release, should be the inner curve of the ascending aorta. And you can see that in the post-CT analysis of this patient, it aligns very well. So we've now done over 500 cases since 2019, and the most recent experience, you can see that in 2 years of over 350 cases, you can now achieve the hat marker, the outer curve of center front over 97% of the time, with commissural alignment around 80% of the time, which is pretty remarkable given this device is not intended for this purpose initially. And as a result of that, the coronary overlap is much less. And in fact, this paper from Giuseppe Tarantini's group showed that if you have commissure alignment with the supraannular valves, with the evolute and acroneal too, the ability to directly access the coronary is much improved compared to lack of commissure alignment. In fact, other self-expanding valve, you can see them with acroneal too, and portico can also achieve commissure alignment, and you can do that especially with using the cusp overlap view, which we now do that as a standard manner with the evolute platform. You can see that the commissure poles look like that on these 3 different valves. So finally, what about lifetime management of aortic valve disease? Can reintervention be feasible? Well, it really depends on multiple factors. First is sinotubular junction dimension, the transcatheter valve leaflet height, and the implant depth of the transcatheter valve. And the reason being that if you have a small sinotubular junction, even though you can use the shorter frame sapien 3 valve, but if it goes above the SCJ, you can still cause sinus sequestration and coronary obstruction, regardless of which valve you do as a second valve. And in fact, we look this angiographically by looking at the root anatomy of these initial TAVR with the sapien 3 valve. You can see that about 20% of the time, actually, we can't likely redo TAVR because of sinus sequestration and coronary obstruction, especially the type 3 root anatomy. And so the hypothesis is that if you're borderline sizing, rather than oversize the S3 relative to the annulus in a significant manner, perhaps with the ultra valve, you can undersize and overexpand to preserve the ability to redo TAVR, as shown in this case, where you do 80-20 implant or 90-10 implant with a 26 Ultra, you still can preserve the ability to redo TAVR. Because if you do a 29 S3, you upsize it and you implant high, you likely will exclude the ability to redo TAVR in the future. Now, commissure alignment may also increase redo TAVR feasibility by looking at this. So even though the leaflet may go all the way to the top of the valve, if you have the ability to do basilica and you can split the leaflet because of commissure alignment, you may be able to reduce the neomuscular height and actually potentially preserve redo TAVR feasibility in some of these valves and situations. So, and also you can also do balloon-assisted basilica, as is shown here, by actually opening up the transcatheter valve leaflet more so that you can preserve the coronary flow. So this review here from Jack, intervention published last year, well, how do you sequence these events? Should you do TAVR first or should you do salver first? And what should your second intervention be? Well, in reality, a lot of these patients, unless you're extremely young, less than 65 or 60 years old, the likelihood of you needing more than 2 valve intervention is extremely low, because we don't actually see a lot of patients even coming back with failed surgical valves needing TAVR and salver. It's only about 10% of the overall volume in TVT registry. So if you look at this, and most patients would want to do TAVR first, you really want to look at the anatomy to see whether redo TAVR is feasible. If it's not, then you probably have to tell them that you might need to have surgical explant or TAVR explant, and then afterward you can do a TAVR and salver in the future if that surgical valve failed, although it's highly unlikely by that time when the surgical valve is implanted. And so I highly doubt that you're going to need 3 TAVRs in any patient in their lifetime, unless the patient's extremely young, which you probably should consider other alternatives such as mechanical valve or even the Ross procedure. So in summary, TAVR is indicated in all surgical risk categories: in aortic stenosis, high risk anatomy, in lower intermediate risk patient, I think should still probably consider salver as an alternative because TAVR and salve is so easy to do. And surgery should be the default option, I think, in bicuspid valve for young patients with hostile anatomy. And finally, the Ross procedure, as I mentioned, in experienced heads, can restore life expectancy, unlike biological or mechanical valves. And this is particularly important in younger patients with aortic stenosis. I'd like to thank you very much for your attention.
Thank you, Dr. Tang. And we have Dr. Kleinman with us. Professor Kleinman?
Yes, hi.
Thank you very much for your... Okay, thank you very much for your talk. It was very comprehensive and in deep detail. I have a question for you. Let's say you have a patient, 70 years old, and you consider the patient with severe aortic stenosis for a TAVI, in which case you would not use an S3 SAPIEN 3 valve and go with a self-expandable valve?
Well, remember, in most centers, there's a bias, there's a preference, and largely based on what you started with. So that's always a consideration. The big driving force is annular size. So small annulus, right now, many centers, including our own, would lean very heavily toward an Evolut valve. Larger annulus, usually it's a toss-up. We are an Evolut favorable center, so we lean towards Evolut, although if the annulus is large, it probably doesn't matter much because the gradient's going to be very low, assuming you do the TAVR properly. The other thing that we take into consideration is, as I said, every patient who has a transcatheter valve replacement gets a CT scan. And it's pretty clear that if they do not have obstructive coronary artery disease, number one, you know that before you do the TAVR. Number two, it's unlikely that in this patient's 9 to 15-year post-valve survival, they're going to develop obstructive coronary disease that's going to require catheter intervention. Remember, we're very aggressive about reducing risk factors now compared to 15 years ago. So that's our approach.
Okay, because you may need a TAV in the future. So you show us that if you have an S3 valve, it's much easier and safer maybe to do another procedure in the future.
Well, I would take the much out of that statement. That's what one would predict based on the CT-based studies that have been done. But if you look at the two series of TAV and TAV, number one, there are no acute coronary occlusions in either series. Number two, access is predicted to be difficult, but that huge gap that you see in the predictive studies doesn't appear to be present. And I showed you the Redo TAVR registry. There is a paper that's going to be coming out soon. Not in press yet, so I didn't make slides out of it. But it appeared that the first TAVR valve didn't make much of a difference in the outcome of the second TAVR. And it's about a 50-50 split. Now, the caveat is both of these series are underpowered. And we don't know a lot about screening. So we don't know how many patients had a TAVR valve, then had a CT before a second procedure and were ultimately turned down. So there is a gap between the predictive studies and the outcome studies, but largely we're still in the data-free zone.
Okay, thank you very much. Is there any question from the audience or the co-moderators in the discussions?
Hello, thank you for their presentation. I will continue the same question. In small anatomies, in younger age, you will suggest some kind of reconstruction of the annulus with surgery, or to put a relatively small transcatheter valve?
Yes, actually we do. Now, the truth is we do. Our surgeons have become very adept at it and very aggressive about annular reconstruction. One of the challenges we face is that in the US, at least, people read a lot about these things, and often they come in to see us and they're insistent on having a TAVR. And we'll go through the discussion about lifetime management, the advantage of having a larger surgical valve, and then the ease of subsequent procedures. That's not always accepted. So that, unfortunately, people read things and they don't necessarily get the full picture that we think we have.
Okay, thank you very much. Go ahead. So you finished? Okay, thank you very much, Professor Kleinman, and we'll proceed now with the next recorded talk of Dr. Dwyer, who is, Dr. Dwyer is an interventional cardiology from University of Washington, Seattle, and he's actually has a lot of experience in valve therapy, and will now proceed with his talk. Okay.
Hello, and thank you so much for the opportunity to present here again. I'll share my screen. So I will give you an overview regarding device selection considerations in TAVI for treating failed surgical valves and TAVI in failed TAVR devices. In general, it is clear to all of us that we live in the tissue valve era. There are many bioprosthetic valves out there. Some of them are surgical valves, others are transcatheter valves, and they all have something in common. They are all prone for structural valve degeneration. They all can fail either in stenosis or regurgitation. And the valve-in-valve procedure is obviously appealing because it is a less invasive approach for treating these failed bioprosthetic valves using transcatheter devices. And there are many different transcatheter devices that historically were utilized in these. And this is why it is quite complex to understand clinical outcomes and issues related to treating these failed bioprosthetic valves because it's a very heterogeneous group of procedures. But we all know that these patients are doing in general well after being treated, and we have issues with residual stenosis. We'll talk about it, but aortic regurgitation is quite rare after aortic valve-in-valve. The considerations when we talk about these procedures are mainly related to the characteristics of the failed surgical valve or the first valve that is failing. We know that clinical outcomes are not as good when you talk about stenotic and small bioprosthetic valves because we do not have enough room. However, we do see that there are impressive improvements in clinical outcomes after valve-in-valve. Here is data coming from the partner study showing that the average increase in KCCQ score in a valve-in-valve patient is more than 30 points, which is quite astonishing. We also know that valve-in-valve TAVR show better outcomes than native valve TAVR when we do treatment in failed bioprosthetic valve. There is, in average, these patients are a bit younger and a bit with less comorbidities, except for having a need for redo procedure, but the clinical outcomes in general are quite good. In certain conditions, there is a risk of malpositioning, but this is not as common than in the past. But one of the things that we are concerned of is coronary obstruction, and we will talk later during this session about modalities and maneuvers that could be performed in order to reduce the risk of coronary obstruction. Another challenging with this approach is the risk of residual stenosis or having significantly elevated gradients after these procedures. Unfortunately, this is the y-axis, is the post-procedural gradients. We do see that many cases finish with severely elevated gradients, and obviously these cases are prone for not enough clinical improvement and poor durability. Here are 5 cases that finished with mean gradients above 40 millimeter mercury or close to that, having significant stenosis. And this is challenging. This is one of the most problematic issues when we talk about valve-in-valves. We also know that balloon expandable valves implanted in small surgical valves are associated with significantly elevated gradients. The x-axis is the true ID of the device. The y-axis is the post-procedural gradients. We see many cases with elevated gradients when small surgical valves are implanted. with balloon expandable valves. And it is unfortunately not very rare to see small surgical valves. In different registries, we talk about a third of cases having small surgical valves. And related to that, we have the issue of residual stenosis. One of the biggest concerns when we talk about the issue of residual stenosis is having severe prosthetic patient mismatch of the original valve that is failing, because we understand that severe PPM is not having as good clinical outcomes after having valve-in-valve inside that valve. Here you can see the mortality rate when you have severe PPM and when you do not have severe PPM. And this is clearly an issue not only for having residual stenosis after the procedure when you have severe PPM, but also other adverse events that can happen. Especially common when we talk about using balloon expandable valves inside patients with severe PPM. And here in this table, you can appreciate the clinical correlates for residual stenosis after aortic valve-in-valve. Pre-procedural correlates, procedural correlates, and post-procedural correlates. And clearly we can identify patients that will be prone for residual stenosis after these procedures, and we need to prevent it as much as we can. One of the things that we can do is to implant our devices higher. And you can see data coming from one of our previous studies showing evolutes implanted in different heights within a failed bioprosthetic valve. It is clear to all of us now that we need to implant high when we talk about valve-in-valve procedures, but how high is good enough? It seems that higher than 5 millimeter or half the bottom diamond is important in order to achieve good hemodynamics afterwards. Here you can see an example of bench testing of high implantation and low implantation. And you can understand how the high implantation is so important in order to achieve optimal hemodynamics after these procedures. When we talk about SAPIEN 3 implantation inside the failed bioprosthetic valves, it is clear to all of us that we also need to implant the SAPIEN 3 a bit higher. It doesn't allow for a lot of supraannularity, but there is some supraannularity. You can use different techniques in order to achieve that high implantation. In order to do that, we understand that you need to put the central marker a bit above what we conventionally did. It seems that it needs to be implanted when the central marker is more than 3 millimeters above the bottom of the surgical valve, optimally even 6 millimeters in order to achieve optimal hemodynamics. There is an important tool that we commonly use in order to reduce the risk of residual stenosis, which is bioprosthetic valve ring fracture or BVF. We do not have enough clinical data regarding the safety of this approach, but the efficacy is quite good. There are two options to do it: pre-valve-in-valve fracture and post-valve-in-valve fracture, with considerations and concerns for each approach. But obviously, this is a very important tool that we commonly use. One of the issues when we talk about valve-in-valve procedures is the risk of clinical valve thrombosis, not only leaflet thickening or a reduced leaflet motion, but frank thrombosis of the implanted valve, which is probably related to the suboptimal conditions of having several valves in the aortic root. In many of our cases, we treat them with anticoagulation to begin with after aortic valve-in-valve, even for those patients that do not have another indication for anticoagulation. It seems that the risk for clinical thrombosis is higher in certain surgical valves, in certain conditions, such as with mosaics and Hancocks, for an unknown reason. When we talk about adverse events after aortic valve-in-valve, which is one of the most common adverse, most problematic issues, fortunately not very common, is a coronary obstruction that happens in 2 to 3% of cases coming for valve-in-valve procedures. This is much more common in valve-in-valve procedures than in TAVI performed in native valves, as you can see in this slide. We know now that we need to classify the aortic root in each patient according to the relationship between the coronary artery and the failed valve that the patient have. It is clear that the most important thing is the relationship between the deflected leaflet and the coronary ostia. We like that the coronary ostia will emerge above the level of the deflected leaflet, and that the deflection will not cause a short and narrow gap between that area and the wall. So we classified, you can see it in our different papers on how to define these different aortic roots. Some are at risk for coronary obstruction, some are not. And we know how to utilize virtual THV to coronary distance that we defined in our previous papers. And we know that VTC below 4 millimeter is a very significant predictor for risk for coronary obstruction in cases in which the deflected leaflet will go above the level of the ostia of the coronary artery. Cases at risk for coronary obstruction will obviously the adverse event will need to be prevented either by not doing the case or thinking about sending the patient to redo surgery, but there are transcatheter modalities that we commonly utilize. The most common modality worldwide would be stent prevention technique, utilizing stents in order to deflect the leaflet away from the coronary ostium, which we call chimney or snorkel technique. But obviously, this is not a labeled approach in order to reduce the risk for coronary obstruction, and the stent doesn't really treat the origin of the problem, which is the leaflet that is being deflected. There are new modalities, and you'll hear later in the session about basilica, which is an approach to slice a leaflet that may cause coronary obstruction, and by that we can prevent coronary obstruction by not allowing for that leaflet to obstruct the flow towards the ostium. There are issues related to basilica as well, and maybe I'll not go into it, but we do have new tools that are allowing us to do dedicated transcatheter leaflet splitting device. I was fortunate to do also the first shortcut cases worldwide, which is a dedicated device that is allowing us to prevent coronary obstruction, hopefully. There were compassionate cases, and now there is a prospective study undergoing. When we talk about other devices that over the years, we utilized for valve-in-valve procedures, briefly, I can say that the historical portico device was associated with some regurgitation when we talk about valve-in-valve procedures. We do not have enough data about using Navitor during aortic valve-in-valve procedures. Fortunately, the cases that were performed had quite reassuring clinical outcomes. When we talk about accurate neo, this the old device, we need to make sure that the crown will be above the level of the post of the surgical valve, or else there could be a high risk for residual stenosis. So this is one of the important things when we talk about accurate for valve-in-valve procedures, the location of the crown in relation to the frame. When we talk about stentless bioprosthesis coming for valve-in-valve procedures, this could be more problematic cases with regard to malpositioning and residual regurgitation, when certain devices may work better than others. So if I can summarize, one of the dilemmas when we talk about valve-in-valve procedures is when we talk about not the high risk or extreme risk patients, but the more younger patients with the low to intermediate risk that are amenable also for redo open heart surgery with reasonable risk. And for these patients, it is not quite clear what would be the best approach, whether to do it with redo surgery or to do it with valve-in-valve. We commonly do valve-in-valves, but to be honest, we need to respect the option of having redo surgery. So I'll talk briefly about a recent study that we published Regarding long-term clinical outcomes after aortic valve-in-valve, you can see the survival of these patients over the years. Patients with average age of 77, see that the majority died within a couple of years naturally, but those with small bioprosthesis died more commonly than those with large bioprosthesis. You can see independent correlates for all-cause mortality, and again, old patients and those with smaller bioprosthetic valves died more commonly. You can see independent correlates for all-cause reintervention in these patients, and those having balloon expandable valves, those having severe PPM, and those having malpositioning were associated with a higher need for reintervention. And in these graphs, you can see the risk for reintervention according to the device utilized, and the balloon expandable valves were associated with higher rates of reintervention over the years, and also those with severe PPM, higher rates for reintervention. So when we talk about transcatheter heart valve features that are beneficial for valve-in-valve procedures, we can think about the characteristics of that THV device that could be good for a certain condition. You can read about it in our different papers, and I'd like to summarize that survival and major outcomes after valve-in-valves are mainly related to surgical valve characteristics, to the size of it, to the mode of failure. For patients with a relatively short life expectancy, the type of THV selected is probably of minor clinical importance. The failed device location, when we talk about aortic or mitral, etc., may influence the type of THV that we can utilize. In small surgical valves, THV device with supraannular position and with high TAVI implantation is hemodynamically favored, obviously. In cases at risk for malpositioning, a repositionable THV device would be also favored. And in cases at risk for coronary obstruction, a device with leaflet clipping mechanism, like the Jena valve or others, or a fully repositionable device could be favored. And there are other rare conditions that may dictate the TAVI device that could be selected as well. And the essentials to remember is that the size of the original failed valve may influence long-term mortality, and the type of the transcatheter valve may influence the need for intervention after aortic valve-in-valve. And operator decisions during these original tissue valve implantation and or during the valve-in-valve procedures may influence meaningful clinical outcomes. Thank you again for the opportunity to present here.
I would like to thank you very much, Dr. Dvir, for a very comprehensive presentation. Actually, I made a mistake. Dr. Dvir is not in the University of Washington anymore. He's working in Israel with Professor Karnofsky, which I would like to welcome for his talk in TAVI, the data so far and gaps of knowledge. Professor Karnofsky. Can you open your microphone, please?
Hello, do you hear me
Okay,
now?
yeah, we can hear you now. Thank you. Go ahead.
Can you see my screen as well?
You have to share your screen with us. Okay, we can see you now. That's fine. Thank you.
You see
Go
the
on.
screen?
Yes.
Okay, so you hear me and you see the
Yes.
screen.
Go ahead.
Okay, so welcome again, and it's a great opportunity to be part of your wonderful meeting. I really hope next year I'll be able to visit Athens and join you in person. I think it's a very trivial continuation to the previous talk of Danny DeVere, who actually presented the data of TAVI in bioprosthetic valve, but the emerging field is redo TAVI in TAVI intervention, and this is what I'm going to focus in my talk. Now, the background is that structural valve degeneration or deterioration leading to bioprosthetic valve failure is a well characterized clinical problem occurring years following surgical bioprosthetic valve implantation. And over the last decade, growing data has been emerging regarding structural valve deterioration or bioprosthetic valve failure following TAVI procedures as well. This is a very, I think, expected problem of our field. So redo TAVI in TAVI has been proposed as a feasible and safe solution for early or late failures of the THVs in suitable patients and carefully selected clinical cases following TAVI procedures. Now, in 2014, we have published in Your Intervention a case of TAVI in TAVI. This was a patient with chronic renal failure on hemodialysis. We implanted the Sapien XT valve, and after about 2 years, there was a severe degeneration of the Sapien XT that caused severe aortic stenosis. And the patient was at very high risk a priori for any surgical intervention. So our solution by then, which was quite anecdotal and not very often by this period, was to implant a core valve within the Sapien XT. And this is a case that was conducted and actually was very successful. And by then we published it because we didn't find any case in the literature. Maybe there were cases that were done, but we did not find. And we actually concluded that our case points towards an expansion of the future treatment option following late failure of catheter-based valve devices. So this is 10 years later because the case was done early in 2013. So I'm here about 10 years later, and it's quite expected, I would say even trivial, that this emerging problem of TAVI in TAVI is becoming so meaningful because, again, we are doing so many TAVI procedures nowadays, and we are going to face more and more the natural course of bioprosthetic valve. We are going to face deteriorations and failures. So let's try to estimate what is the scope of the problem based on the current knowledge of structural valve deterioration and valve durability in TAVR versus SAVR. So we have three pivotal sets of data. One is derived from the partner group, and we see here that over the course of 5 years follow-up, there was 9.5% of structural valve deterioration using the Sapien XT, which is not in clinical use anymore. There was 3.9%, so some 4% with Sapien 3. This is the current generation that was transferred towards Ultra, and 3.5% using surgery. So over 5 years, 4% structural valve deterioration with Sapien XT. What about core valve? We have very recent data from the NOTION trial. These are low-risk patients, again, randomized between surgery and TAVI. And over 8 years follow-up, if we exclude the definition of patient prosthetic mismatch, which is not the main driver for repeating the TAVI, so we have 8.8% of structural valve deterioration, by the way, versus 15.7% with surgery. But now we are focusing on the magnitude of the problem with TAVI. So we are about 9% structural valve deterioration in the TAVI arm. Very recent, during the ACC, there was a presentation of the combined trials of a core valve, the moderate and high-risk patients, as well as the SURTAVI. And you see here, again, the structural valve deterioration over 5 years follow-up. It was 2.6% with core valve and 4.4% with surgery. So obviously not every case of structural valve deterioration is a candidate for TAVI in TAVI, but in a gross estimate, including some cases with early failures, which are derivatives of failed or suboptimal procedure, I think it would be fair to speculate that over the course of 5 years, we may have the need of around 5% to perform TAV in TAV, and maybe over 8 years, it would increase to 8%. And I think that over 10 years, again, this is a speculation or a prediction, we might come up with even 10% of the need. But even if we look at the valve 3 definition of structural valve deterioration, we have to keep in mind that not all these definitions are candidates for TAV in TAV. These are mainly the structural valve deterioration, the severe form. These are not the patient with structural valve thrombosis. These are not the patient with endocarditis, not the patient with patient prosthetic mishmash. Some of the patient with other form of the non-structural valve dysfunction, probably a minority of this patient, and perhaps a minority of the patient with paravalvular leak. We have to make a careful assessment of the hemodynamic changes because there is no indication to intervene in only the morphological or very mild form of structural deterioration. We have to wait for the more severe form, the structural or the bioprosthetic valve failure, which are the stage 1, or the stage 2, which are actually the aortic valve intervention. What are the current data, the current clinical outcome about redo TAVI in TAVI? The most comprehensive registry was performed by Dr. Uri Landes. Uri Landes from Israel. He used to work in our center. Now he is in Wolfson Medical Center, not too far from us. And he spent a few years in Vancouver with John Webb. And Uri made a very important and elegant analysis that was derived from 37 medical center performing TAVI, overall a cohort of 63,000 patients undergoing TAVI. And among those, 212 underwent stage TAVI in TAVI. So they had redo TAVI. He excluded the single procedure when 2 TAVI valves were needed, and we'll come back to this group later during this lecture. So we have to focus now on 212 patients that underwent TAVI in TAVI. This was about 0.7% of the overall cohort. You see here the distribution of the time frame from the first TAVI to the late or the second TAVI. The range was between within the first year up to 11 years following the first intervention. The first important finding that Uri demonstrated was that this procedure was able to restore hemodynamics in terms of aortic valve area and decrement, a significant decrease of the aortic valve gradient in those patients with TAVI-related aortic stenosis. And also, in the vast majority of patients, this restored the competency of the valve in terms of aortic regurgitation. So this procedure can deal with intravalvular leak and can restore the valve hemodynamics. In terms of the short term, the 30-day outcome, results were very good. Mortality was relatively low, 2.9%. Stroke rate was only 1.4%. Myocardial infarction was 0.9%, which was mainly due to 2 cases only of coronary occlusion. There was around 8 to 9% of new pacemaker implantation and annular rupture only in 1 case. So in summary of these results, you see the incidence, which was low, residual gradient in some patients, coronary obstruction in 0.7%, and mortality. And if we combine these results with the failed TAVR procedure, so the index procedure was suboptimal, the results were similar but somewhat higher coronary obstruction rate and higher mortality rate by 30 days. What about the one-year outcome? The one-year mortality was 13.5%, which, by the way, not very different from some of the TAVI native valve cohorts, and it didn't really make a difference whether the index intervention was due to aortic regurgitation, mixed pathology, or aortic stenosis. So the conclusion of this paper and important work was that in patients with late valve malfunction or dysfunction after TAVI, redo TAVI is associated with significant improvement in valve function, symptoms, and relatively low incidence of procedural complication and reassuring survival rate at 30 days and 1 year. The second question that Uri asked and made another registry.
I'm sorry, Dr. Kronovsky, you have 2 more minutes, please, because we are running short of time.
I'll finish. Whether there was any significant outcome difference between TAVI in TAVI versus TAVI in bioprosthetic valve. And again, he showed that the 1-year survival rate was very similar between the group, and except for the fact that in TAVI within bioprosthetic valve, surgical valve, there was some higher residual gradient compared to the TAVI in TAVI. The next question that Uri asked was also whether there was a difference when the TAVI was implanted in balloon expandable valve versus self-expandable valve, and he showed that procedural results, success, safety was similar, and also when balloon expandable was performed in TAV or self-expandable in previous TAV, again, same findings, except for the fact that the residual high gradients were more often were performed either with self-expandable, residual gradient were more higher when performed with balloon expandable compared to self-expandable valve. The outcome up to 1 year was pretty much the same. The next question that Uri explored was what is the outcome of the need for 2 valves in the index intervention or on emergent basis. So he showed that the reason was either too high or too low or suboptimal despite good positioning. And these are the 30-day outcomes that were more favorable where only 1 TAVR valve was used compared to 2 valves, but this is not translated into 1 year or 2 years worse outcome except for the first 30 days. And this is Uri when he really made such a pivotal contribution to the field of TAVI and TAVI, and I decided to show his picture and his quote from the last PCR meeting. What about the need to explant the TAVI valve? This is associated with very complex surgery and with higher mortality rate. You see here 30% by 30 days. If there is a need to correct something else in the surgery, 24%. This is another registry. So TAVI explant is not associated with a favorable outcome. So the conclusion from this topic is the treatment of TAVI failure mostly due to suboptimal TAVI and later on due to structural valve deterioration, becoming a growing clinical challenge parallel with the wide adoption of TAVI as the default therapeutic strategy in many patients with severe aortic stenosis. Redo TAVI seems to be safe and effective option for suitable patients with severe structural valve deterioration years following TAVI and acutely after failed TAVI procedure with a need for a second valve. Redo TAVI seems to be associated with similar 1-year survival outcome compared to TAVI within failed surgical bioprosthetic valve. And TAVI using either self-expandable or balloon expandable valve seems to be associated with similar procedural success and clinical outcome, although lower gradients were recorded using the self-expandable valve. And more data is needed to characterize the redo TAVI strategy and in order to optimize its procedural success and the short and long-term results. Again, I would like to thank you for the opportunity to present the data. I would like to thank Dr. Uri Landes and hopefully to see you next year as well. Thank you very much.
Professor Karnowski, thank you very much. I would like to, it seems that a lot of data are being accumulated and will be in the near future, more of them. And I would like to ask you to stay with us so after the next presentation, if you have any questions, you can help. Okay. So we'll proceed with Dr. Babayaro's talk. And he's going to talk to us about the Basilica procedure to prevent coronary obstruction in TAVI and in valve-in-valve patients. Dr. Babayaros.
Good afternoon. This is Vasilis Babayaros. Thank you for the invitation to speak at your meeting. I only regret that I could not be with you today. I'm American of Greek origin, as you can tell by my name, and I've been asked to speak about Basilica to prevent coronary obstruction in TAVI. This is a procedure we do a lot at my center at Emory University Hospital in Atlanta, Georgia. Let's go to the next slide. These are my disclosures. I have equity in transmural systems. I'm a consultant for Edwards Life Sciences and Abbott Vascular. And in fact, these are my favorite ice creams when I come summertime to visit you all in Greece. Let's talk about the problem at hand, coronary obstruction. There's 4 different mechanisms in which it can occur, and it can occur in patients with previous surgical valves, in patients with previous transcatheter valves, and in patients with native aortic valves, different mechanisms. But let's go on to situation number A, when there's deficient sinus, and that means the distance from when the valve gets implanted, pushes out the leaflets of the surgical valve, and if there's a deficient sinus, it can directly obstruct the coronary ostium. Situation B, the valve gets expanded, the surgical leaflets get pushed out, and they sequester all the blood in the sinus, though they don't directly obstruct the coronary, called sinus sequestration. Situation C, where the leaflet can be very thick, or there is a mass or a piece of calcium on the tip of the leaflet. This can occur in natives. It's very easy to miss. And when you implant the valve, you get a ball valve affection, this piece of calcium that can obstruct the coronary. Or situation D, you can obstruct by any of these mechanisms, but the leaflet itself is not blocking. It's a skirt obstruction, which we can talk a little bit more about. Here's the next problem besides coronary obstructions, predicting who will obstruct. So we have a few different measurements here. We have the valve to coronary distance and the valve to sinotubular junction distance. And there's been a few papers published on this, some of the early ones from Danny's group. For valve and valve, less than 4 millimeters from valve to coronary distance. And we do this on with our 3D software tools, and we put a phantom, or we put a valve model in there, as you can see from the purple circle. We make these measurements of the coronary ostium. We've noticed for valve and valve, probably 4 is correct. For natives, less than 3, and for obstruction that causes sinus sequestration, less than 2 seem to be good thresholds. When in doubt, cut, but you can see there's a lot of variability in the TAVI procedure, which predicts or creates unpredictability rather. So that's because the valve can be implanted deeper or higher in the annulus, as you can see with this core valve, and as you see the scallop part of the frame can be beneficial to allow more coronary perfusion. But if you implant very high, then you get more into the skirt area of the evolute, and this will be more of a problem. Certainly there is angulation or tilting of the valve. And then looking at balloon expandables that you can flare, as shown in the middle cartoon, or you can stretch the outside of the surgical valve. And finally, with some malorientation, even with appropriate basilica shown at the bottom, you can have a pledget. That's where the commissure is of the valve that can obstruct coronary flow. Here's one solution to the problem. This is called the basilica procedure. This is done a lot at our center. Again, we use two catheters. We introduce retrograde aortic, one traverses the base of the leaflet with energy, and then we catch it, energize the side, pull through, create this opening in the leaflet. And as you can see in this cartoon, we create flow into the coronary. Here's what it looks like in the lab. This is traversal on the left side through the left coronary leaflet. On the right panel, the right coronary leaflet. This is what we call doppio basilica, and it's being caught by a snare in the LVOT. And then we energize the wire after we fold it in half, creating this bend on the wire that we call a flying V, and that is to encourage energy to only come out in one orientation towards the leaflet to make the cut. We infuse 5% dextrose to prevent charring on the wire, and then with slow, steady pressure, we can cut through the majority of leaflets. It's what a final angiogram would look like, a little bit more AI than we'd like, but this valve could be post-dilated without any problem and create even better leaflet display. So it's important to understand that this is an evolution of what we call transcatheter electrosurgery. Some of the earliest clinical applications, at least from our group, was in 2013 with transcaval aortic access. It was first done at Henry Ford by Adam Greenbaum, and these were ideas that came out of the transmural research lab of Robert Letterman at the NIH NHLBI. So in 2013, they were able to electrify an Estado coronary wire and send it from the vena cava into the aorta, then dilate up and make a venous aortic TAVI implant. In 2016, at our center, we performed the first leaflet laceration, that was known as the Lampoon procedure, to create more flow in LVOT after transcatheter mitral valve replacement. This obviously evolved into aortic valve leaflets, first done by Danny DeVere at the University of Washington in Seattle. We've started cutting Alfieri stitches, mitral clips. There's been other groups that have reported the use of energized loops to remove all sorts of intracardiac masses, myxomas, et cetera. And so it's just growing. So here's the group. These are the four that I met when I got involved in 2015, 2016. Jaffer Khan and Toby Rogers that were at the NIH. Now Jaffer will be at St. Francis in New York. Toby is at Washington Hospital Center in DC. Robert Letterman still runs the lab at the NIH, and Adam Greenbaum, who was at Henry Ford, is now with us. And so these folks are organizing the research after the first case with Danny. There was papers coming out about early feasibility, then the report from the 30-patient IDE, both acute and 1-year results. There were subsequent basilica registries reported, some from our group, troubleshooting at pitfalls, and a state-of-the-art paper. So there's been all kinds of activity. Here's just some of the safety data comparing another strategy known as snorkel stenting, is what we call it. Some people call it chimney stenting, but from the registry, the chimney registry of 60 versus a basilica registry of 214, you can see the differences in procedural complications, particularly with myocardial infarction, significantly less in basilica. The need for ECMO or CPR, cardiopulmonary bypass, from 20% down to 2%. Bailout stenting, 100%, of course, down to approximately 5%. 30-day death was lower in the basilica group. Stroke was a little bit higher in basilica. And now we are advocating embolic protection or sentinel devices in all of these procedures to decrease this complication. Here's a special situation, TAVI and TAVI. And you can see here from a display that we've done on an Evolute, some of the problems. The cage itself prevents a very wide splay, so you get this narrow splay to make sure the commissures are aligned appropriately with the second TAVI valve that you put in. These are very, very high commissures in the Evolute, which seems to be the most challenging, though we could have the same problems with the Sapien 3. One of the percutaneous strategies to overcome this is the Bob basilica or balloon assisted basilica. And you can see from the cartoon up here, This is what a simple laceration would look like, which is a smaller splay in the leaflets, or if you traverse the base of the leaflet, then you balloon the base of the leaflet before you cut, you get a much wider base. And this has been successfully performed in repeat or redo TAVI patients and been published by our group. Another strategy that has also recently been published in JACINT this year is putting SAPIEN 3 in Evolute. And the paper went ahead and described different situations, but the most favorable is to put a SAPIEN 3 at the inflow of the Evolute. This certainly could be augmented by basilica, the leaflets, and seems to be a strategy that many will try moving forward. Let me show you one more futuristic strategy, and that's leaflet removal. So you can see here, this is a prolapsing leaflet, which is giving us some problems with basilica, with the leaflet embolizing down the coronary. This patient had a stentless 3L valve. We were able to make the traversal, and then over the flying, we bring an energized snare with 70 watts and some steady pressure. We're able to remove an entire leaflet shown here on the short axis of the echo, and also by 3D echo. This patient, obviously, we had to implant expeditiously right after this was removed, but this is known as the cathedral procedure and will hopefully soon be in publication as some ideas as we move towards leaflet removal. In these patients that have heavy calcification, you may want to consider a different strategy. This is a trifecta valve, very problematic valve because it was used in patients with small aortic roots. And had early degeneration, and then when it degenerates, it's very calcified. But if you cannot find a place to traverse at all, perhaps you should not do basilica in these patients and consider surgery for replacement, or the surplus procedure, which is surgical removal of the leaflets, and they leave the frame in place. So in conclusions, for patients with high risk of coronary obstruction, you should offer them surgery or basilica. We think snorkel stenting is reasonable for palliation or bailout cases. Sinus sequestration is a major risk for TAVI and TAVI. Basilica or balloon-assisted basilica with low SAPIEN 3 implants may have a role. And finally, leaflet removal will be the next strategy for the lifetime management of valvular heart disease. I want to thank you again for your time.
Professor Babayaros, thank you very much. And it seems that basilica is a very safe procedure. And I would like to ask you what's the learning curve? And do you perform basilica in all patients at high risk for coronary obstruction in valve cases, or there are some cases you prefer another technique?
Yeah, our preferred technique at Emory is basilica to prevent coronary obstruction. And we believe it probably has some other beneficial effects, including allowing the washing of the leaflets a little bit better. And there's been some publications out on that. We have some more coming forward, but the risk of valve thrombosis, as we talked about in the previous talks, is not inconsequential. So these patients will get basilica and some Coumadin or some Eliquis. The learning curve, the problem with these procedures that we're showing you is there's no dedicated devices other than what Danny showed earlier with the shortcut, and even that's a research device. So the idea of having dedicated wires or even dedicated catheter shapes to facilitate basilica, or something even better, would make this procedure more generalizable. We have people that visit all the time to watch what we're doing and come and learn. But as you go from one leaflet to multiple leaflets, and as a valve becomes more and more calcified, it is a challenging, or can be a challenging procedure. We are able to succeed because we understand the patient selection and the anatomy very well, but it is a procedure that is begging for innovation and dedicated tools, if that makes sense and answers your question.
Okay, thank you. Dr. Zairis, Dr. Georgiou, and Dr. Skalidis, if you have any questions, Dr. Kornowski and Babayaros, please go on.
Thank you for your presentations. Just a small comment. All these are cheap cases, high risk indicated patients with results, and high risk procedure and complex procedure. Do you know the rejection rate? In how many of them we refuse to do anything?
At our center, it's low because you know we have some high risk surgeons also that would be willing to take them. But if you're saying just for transcatheter, what is your rejection rate? It's less than 5%.
Can I?
Dr. Sparias, please.
Hello, hi everybody. Thank you for being with us this year. And I have a question that I want to be addressed by both Dr. Konowski and Dr. Bobayaros together because it's connected to their talks. According to Yuri's last research run, you told us there was no difference between self-expanding and balloon expandable valve in terms of failure or in terms of coronary obstruction in TAVI. Do you think this is real or this is related to the screening process? So patients who couldn't have TAVI were just excluded. That's why we have this result. And then to Vasilis. Vasilis, do you find any difficulty or any difference when you do basilica in self-expanding or balloon expandable valves? Is there any difference between the two?
So how about Dr. Kornowski, you answer number one and I'll answer number two. That's okay.
So, yeah, I'll answer number one. It's true. I think that the answer to your question, Costa, is mainly derived from the methods of data collection and you know, this is a registry, and in a registry you get what you get. So I don't think it is a definite statement that in self versus balloon expandable TAV in TAV, the results in terms of coronary occlusion, which were very low in both arms in the current registry, are clearly identical. I think it's a matter of pre-screening of the patient and making a decision by very experienced teams which valve should be used to correct the previous valve. And this is probably the reason why the rate was low and not very different between the groups. But having said that, we have to learn more about this specific complication.
If I can dovetail onto what Dr. Kornowski said, we have noticed that things have changed for redo TAV and TAV. And the reason is initially core valves were implanted in a lower position. For example, now with cusp overlap and so forth, we're seeing core valves that are implanted almost 100-0, 90-10, whereas kind of historically or from a legacy standpoint, you know, 4 or 6 millimeters below was more common. And I think in the patients where the valves are implanted a little bit lower, it makes it easier. When the patients are having the valves implanted very high, and we're all doing that now, right? We're avoiding pacemakers, we're trying to get better hemodynamics, et cetera. It is getting more complicated to redo these things. And I think all these registries suffer from referral bias and so forth. But to answer your question, Kostas, about, you know, basilica in a core valve versus SAPIEN 3. So the core valve is a porcine leaflet. They are very soft and they're very easy to traverse. They're very easy to balloon. They have the outer frame, which kind of guides your catheters down into the nadir of the leaflet. So in many ways, it's very hospitable for basilica. The SAPIEN is also, I would say, easier to traverse than a trifecta, which is very calcified, because most of them have some thrombosis, et cetera, though they do have some calcium too. You know, doable, but a lot of times in the SAPIENs that were being referred, you know, just with this core valve implantation, you know, you don't even need any basilica work. the idea that the leaflets don't splay very much in a TAVI valve after you do basilica is real, and that's why we balloon at the base of the leaflet to try and make a little bit wider. But these things they're going to have some limitations, and you're going to see the next gen of ideas coming forward. But it's a very interesting problem, particularly for our patients with congenital aortic valve disease, because then you're talking about lifetime, not just ages 60 to 80. You're talking, from teens until they get older, and it would be a good group to study.
Okay, thank you very much. I will now close the session because we ran out of time. But before we leave, we would like to ask Dr. Mack to say a couple of words because he has to.
So unfortunately, Dr. Mack had to go to the airport to fly to AATS in Boston, which we totally understand. But Dr. Babilaros and everybody else from the section, Dr. Kornowski, thanks so much for being with us live online. We really appreciate it. If you have the time to hang out and be with us online and continue the chat, Dr. Kodali from New York, from Columbia, is coming up next and is going to give us a wonderful talk on TAVI. So whoever has the time, we'd love to have you continue on into the next session with us. Dr. Kodali, if you're there online and if you can share your slides, we have a video from you pre-recorded, but we would rather have you give the talk live if everything's okay.
Great. Can you? Thank you so much. Can you see my slides?
We see you, and your slides should be coming up soon. If you share slides, there we are. Perfect. We're good to go. Thanks so much. The microphone's all yours.
Thank you, and thank you for the invitation. And I wish I could be there. It is hard to follow all the amazing, cool stuff that Vasilis talked about. What I'm talking about is a little bit much less exciting, but it's worth the discussion. And it's something that doesn't come up, and it was sort of about emergent, urgent TAVI, and sort of considerations. These are my disclosures. So, part of the background is, TAVR really in 2022 has really become the dominant therapy for patients with AS. And, the majority of patients are going to get TAVI over surgery. And it's because it's become a predictable procedure with excellent results and minimal morbidity, majority of patients done awake, short hospital stays, next day discharge. But it's important to keep in mind, it's really over the last 10 plus years that it's evolved into this. And a lot of the reason it's evolved into this type of predictable procedure is because of pre-procedural planning. And, with CTAs, understanding what's high-risk features, patterns of calcium, vascular access, bicuspid or tricuspid, effaced sinuses, risk of left main occlusion, as he talked about in the earlier session. Understanding those risks with pre-procedural planning has been an integral part of obtaining these successful results. But not every patient is that way. And I think it's important to keep in mind and start with a case example. This is a patient of ours about a year or two ago, or maybe a little longer, but an 80-year-old woman with AFib, CKD, with COPD, who was admitted with chest pain and shortness of breath. She's 80, has a fair amount of comorbidities, but lives alone, functional, independent, does everything. And here you see her echo. She's got very calcified aortic valve, tri-leaflet, hyperdynamic, thick LV with normal function, but really critical AS with a peak velocity of 6.1 and a mean grade of 65 and a valve area of 0.4. And really minimal AI. So, and she underwent coronary angiography. And you see here, she's got critical disease, osteo-LAD extending into the left main, a lot of calcium, mid-LAD disease at a branching point of a diag, as well as sort of minimal stuff in the RCA. But the real issue is this distal left main osteo-LAD lesion, as well as that mid-LAD. So what do we do in this scenario here with this patient? And what are the best treatment options for her? Do we do surgery? She's 80, but independent, functional, normal LV function, and really but came in heart failure, high filling pressures, volume overloaded, but can be managed. And so the surgeon saw her STS was over 10. She was felt to be a high-risk candidate, but importantly, the patient also refused surgery. So then once you go down the I'm not going to pursue surgery path, what are the options? You can do TAVI first, but do you feel comfortable doing that and ignoring the coronary disease? One of the things that, again, this was years ago, we didn't get the CTA first. And that's one of the things I would say any of these possibilities, and this patient came in acute, and we're trying to manage her acute heart failure and her acute chest pain. She had a non-STEMI, but she didn't have a CTA, so I didn't understand her TAVI anatomy. But if you're going to do TAVI first, you have to understand what is my access to the coronaries going to be, what do the sinuses look like, am I going to be able to access the coronaries later, and also importantly, what is the risk of the coronary disease during the TAVI? You know, critical left main disease with elevated filling pressures, you don't have a lot of wiggle room. If the patient gets hypotensive, they can arrest. So that's one of the issues with doing TAVI first. So then do you do PCI first? If you do PCI, is it safe to do in the setting of critical AS with a velocity of 6? And if you're going to do that, do you do a BAV PCI? And this was several years ago, and our strategy at this point was to do a BAV followed by a PCI. But things don't always go according to plan. We did a single inflation of a 20 millimeter Z-bed balloon on the LVOT or annulus measured around 20 to 21. But patient became hypotensive. Diastolic dropped to 5. She got transient heart block. You see this is an echo done later, and obviously it's a TE, and this procedure wasn't done asleep, but this was a later echo. But we put a transthoracic probe in. She had severe AI, wide open AI, and so and there's this question of does Impella or support work in the setting of AI? We put a TVP, we put an Impella, we gave pressor, she got intubated, and she stabilized with that. Her blood pressure stabilized, but she was on pressors, intubated with an Impella. So now what do? Do you send to urgent surgery? She was felt to be high risk before, but now she's going to be extreme risk. Do you send to the CCU and she's stable on pressors and hope that things get better? In the setting of severe AA, that may not work. Or do you just go ahead and do the PCI, or do you do TAVI? And I think there are important considerations. And if you're going to go the TAVI route, the challenge is the patient is hemodynamically unstable. You don't have the heart team present. At least in the US, the industry is who crimps the valve. They're not available. And we don't, as I said, we didn't do preoperative planning. I don't have a CT. I don't know the vascular you can deal with on a fluoroscopic basis, but I don't have angular sizing. So we decided, to make these decisions, you got to get the team together. You got to get the surgeons, obviously, to make decisions about urgent surgery, but you got anesthesia there to intubate, stabilize the patient. We had our echo team there. They put the TE probe down, called for additional support, additional nursing, and we also alerted industry in case we go the TAVI route. And what we elected to do in this case was do the PCI. Sorry, these videos don't play, but we did osteo-LED into the left main PCI under Impella support. But now the patient's stable on pressors, but there's still severe AI. And I think once you've gone this route of doing the PCI and you have severe AI, you're all in. And if you want to give this patient the best chance, you got to fix the aortic valve. And so the question of proceed with TAVI or not, I think the answer is you have to. If the AI is still there, the PCI isn't going to really resolve the issue. And if you're going to do it, one of the challenges is which valve. Do you just put a core valve based on the LVOT measurement on TE or do you do a sapien? How do you do it? We have a very advanced echo group that we do a lot of 3D sizing. We've got no contrast TAVIs, and we size and we do everything with TE sizing. So we sized it for a 23 millimeter sapien. We ended up getting a good result. You see here minimal AI, normal valve function, and the Impella was out obviously to put the valve in, and immediately the hemodynamics improved and we didn't need to go back on support. So part of the keys in this scenario is stabilizing the patient, activating the team, getting, although we don't think of Impella in severe AI, it does work. We activated the heart team, we called in support, and we made a procedural plan as a team and we stuck with it. And I think that's one of the keys in these scenarios is to get the support, get a teamwork, make a plan, but don't forget to manage the hemodynamics. And that's what the anesthesiologists were key in helping us with. So there are scenarios where you can do urgent TAVI and failed BAV like this with severe AR, but there are also other patients with refractory heart failure. Patients come in shock and they have too much AR you can't do a BAV. And so in those scenarios, you might need to go forward. Or another scenario is refractory heart failure due to acute AI. And this is a patient that we had recently, 66-year-old gentleman with sort of a autoimmune disease, had a strep pneumobacteremia, discharged with IV antibiotics, but presented 2 months later in shock with severe AI. And you see here, wide open AI. He went within 24 hours of coming in, multi-organ failure, creatinine 2.4, shock liver, surgeons felt he was not a surgical candidate or at least at extreme risk for surgery because of his ongoing therapies and his autoimmune and multiple myeloma. And by sizing, the area was 520, perimeter of 84. So how do you treat? And Raj Makar from Cedars has published a lot of, using TAVI off-label in acute AR. And you could oversize the 34 core valve, you could oversize the sapient, and hope for the best. And one of the things, we had access to JenaValve as part of an emergency use basis, and JenaValve obviously is designed for AI, and we got a nice result here, no AI, and you see here a very large valve with that trivial jet of AI. I mean, it went well, and the patient quickly recovered. I think in acute AI, this is where urgent TAVI works. Unfortunately, we don't have the devices for it, but when you get rid of acute AI or acute AI in the setting of a bioprosthetic valve failure, those are scenarios where you got to take your chances quickly. The longer you sit on those patients, the worse they do. When they go into progressive multi-organ failure, you've lost the game. So quickly, the patient comes in with a flail leaflet and a bioprosthetic valve. Doing the valve urgently within 24, 36 hours makes a big difference. And this patient, it did really well. But you don't want to do urgent TAVI in active endocarditis or in a patient that's stable. If they're stable and you can complete the workup, do that. That's how we get better results. And you also should never forget about surgery in these scenarios. A young guy who's not extreme risk but in shock, TAVI is not the not the answer, and they should go to surgery. But the availability of TAVI and being a predictable procedure has provided therapeutic outcomes options for patients with cardiogenic shock, secondary valve disease. Urgent TAVI can be performed, but still really requires teamwork. And the risks of urgent TAVI are higher than for elective procedures, but it requires careful procedural management and post-procedural management as well. Thank you very much, and look forward to some discussion.
Thanks so much, Sushil. We really appreciate your talk. And I have to explain to the audience, and thanks to everybody, because you couldn't make it yesterday. So even though this is going to be a mitral session, we absolutely wanted to have a talk from you. I have Mike Chris O'Harris, who's an interventional cardiologist and an echocardiographer up here moderating with me as well. And I especially wanted to give him the microphone to ask you a question because he's one of the few people I know who can do everything, including crimp a valve. So when we have an emergent case, it's good to have a situation where we don't need to wait for somebody from industry to come. Mike.
Yeah, so we really appreciated your discussion. This is a very interesting aspect of TAVI, the emergency cases, the urgent cases that come in the middle of the night, in a sense. We've had a couple of these cases, and they really did dramatically well with TAVI. We've had some cases in the past that we thought about that we were a bit more conservative and just did a balloon valvuloplasty, and some of them didn't do well. So definitely giving a definitive answer, as you mentioned, with urgent TAVI can really make a tremendous difference. And the main issue is sizing. We're not exactly, if the patient hasn't had the pre-op CT, then we have to rely on echocardiography. We do try to get them downstairs to the CT and do, even with minimal amount of contrast, to get an idea what the size of the annulus is. Because we haven't had much experience with 3D annulus sizing, we really haven't had faith in this measurements, in the TE-based measurements. But it doesn't tell us a lot about the calcium extension and whether there's a risk of annular rupture by echocardiography. It makes it a bit more difficult. But it seems that you've had a lot of experience with transesophageal echo for sizing.
We do, and early on, that's how we sized a lot of our valves using 3D TE, and we used the mitral package actually to size. Initially, we used that mitral package alone to size. The reality is, though, I think an LV, when we first started doing TAVI, we just used the LVOT measurement, and I think in an urgent scenario, that's actually fine. You can size adequately enough to get it. It's not going to be a perfect, but you're trying to get this patient out of shock. The question of whether you're better off doing a core valve, where you can oversize more and the risks of annular rupture and those things that you mentioned are less, is a consideration in some of these. So if you have an LVOT of 21, putting a 26 core valve and sort of going with those results is probably not unreasonable.
Okay. And would you prefer in a patient who needs an urgent TAVI a SAPIEN, a balloon expandable valve for the fact that it can be deployed with less maybe contrast, less in a faster fashion than a self-expanding valve?
Yeah, I mean, that's my gut, that's my preference, but I think people have to do what they're most experienced with. So if somebody does, 99% core valve, they're going to be quick at it. That's their best, trying to do SAPIEN at that point is probably not ideal. So I prefer SAPIEN, but I think either one is fine in this scenario.
Okay.
Great. Thanks so much, Dr. Kodali. If you have time to hang around and be with us online for some question and answer later towards the end, that'd be great. If you have to run to your multiple obligations, we totally understand as well. We have,
Thank you again, and sorry about yesterday.
Not a problem at all, not a problem at all, we understand. Thanks so much for your talk. Next up, we have Dr. Payman Sardari-Nia coming to us from Barbados or Fiji or somewhere exotic. And he's going to be speaking to us about when transapical TMVR is appropriate today. Dr. Sardari, thank you so much for being with us.
Good afternoon, all. Thank you for the kind invitation. I'm actually in a very nice cabana here in Athens, in a nice beach. So I would recommend everyone to come next time to Athens. Obviously, we had to operate some patients, so I was here, but I mean, this is great here. So I'm going to try to share my screen, and the organizers have given me a very tough job to do, because actually the question of this presentation is very difficult to answer, because actually nobody can answer this question. There is so little data on this subject, but as you know, surgeons are very creative, and I have put some slides together. And I think this is also very important for future in the field. As you know, so many devices are being developed. And obviously everybody could agree about the anatomical suitability of some devices, but clinical application and when to use these different treatment modalities is something that is open to be answered. These are my disclosures. So probably, as you know, more than 70 different devices being developed or in development, or some of them have already reached the clinical practice. None is going to be effective in all patients, but probably in some. Nobody is going to be an expert in all of them, but probably you can gain expertise in the broad heterogeneous pathology like mitral in some subset of patients. And success lies in choosing the right patient for the right treatment for the right patient. And all of this dictate a different approach to mitral valve pathology, which a proponent of is a dedicated heart team approach. So let's look at the guidelines for primary or secondary. The only indication for transcatheter mitral valve therapy is obviously TEER, which has a class 2B indication, both for the primary and secondary mitral regurgitation in Europe. And it is offered to patients for the primary, obviously, when they are not fit for surgical therapy, and in secondary mitral regurgitation, when there are specific criteria that we think that the patients will benefit, most importantly, co-opt criteria, and they are not fit for a surgical treatment. So let's look at the some data which is coming just published recently. There are 96 patients here matched, undergone MitraClip or TEER treatment and TMVR. And these patients have a mixed pathology, around 80% functional mitral regurgitation. But if you look very carefully, you see that 90% of those underwent replacement. They had functional mitral regurgitation. And if you look at the results with regard to the resolution of mitral regurgitation at 3 months, in TMVR group, you had almost 100% resolution of less than grade 2, but in a TEER, the results were around 70%. And most importantly, apical mitral replacement led to much improve or remodeling of the right and left ventricle, and which was absent in a TEER group. And the decision making which patient received in this study TEER or TMVR was based on the fact that patients got TMVR, those patients who were not eligible for the TEER procedure. This is also a study published recently, just a few months ago, from Choice Registry, which is actually results from more than 26 centers, and they have included all patients being evaluated, have been evaluated for TMVR, and about 760 patients included, and only 229 patients that had received the TMVR. So majority were excluded because of the anatomical, being anatomical not suitable. And those patients who were not anatomically suitable were provided a bailout TEER or surgery or conservative or medical therapy. And if you see, and this is all the results of the treatment on the resolution of the mitral valve regurgitation, you see that actually TMVR doing much better than surgery than TEER. And it's also very important to note that those patients offered TMVR had in 60% of cases secondary mitral regurgitation compared to 40% in TEER. And if you look at the all-cause mortality or hospitalization for heart failure at 1 year or 30-day mortality, these are the results, which is around 30%. And if you look at the surgery, TEER, and medical therapy, we see that actually MitraClip or TEER does much a better job. And it is also logical because obviously there are some issues related to the access still with very large device, first generation device. So what to choose from? And basically in Maastricht, we have the availability of all those treatment modalities, and we use the surgical therapy, the TEER, as a default, and all those other therapies we use in specific cases that we think that the patients will benefit. And how we do it, obviously the central questions we always ask when we evaluate the patient with mitral valve pathology is mechanism, severity, and etiology. And the first question is always, do we need to intervene? And if we need to intervene, for which therapies is the patient more suitable, and for which therapies would the patient, from which therapies would the patient benefit the most? And there are two different questions, because you can have a 80-year-old patient in a good clinical health condition with a P2 problem, for example, and we can do surgery, we can do TEER, we can do transapical neocord placement. But essentially, the benefiting from the treatment is also the quality of life and symptom relief, which is much more important when you are 80 years old than if you are 40 years old. That's much more important to look at the durability of the procedure. So how we have organized it, we have we not only decide in a heart team, we make decisions, but we treat together under the heart team, dedicated heart team, treating, deciding over the indication together, but also treating and following the patient together. And this concept of the dedicated heart team is focused, that we not only focus on what we provide the patient in the operating theater or in cath lab, but the whole trajectory, and very importantly, the concept of smart surgery or smart intervention, which is also, as previous speaker indicated, the success of TAVI is that we plan things much better. and obviously working with a dedicated team. As you know, volume and outcome is a predominant predictor of quality of care in everything we do. So for the primary mitral regurgitation, that is very clear. We're following strictly the guidelines, and we offer TMVR or transcatheter mitral valve therapy, and in case mitral clip in the cases not fit for surgery. Obviously, if we decide that we are going to follow transcatheter mitral therapy, then there are two other questions that we have to answer as well, and I will come back to that. For the secondary mitral regurgitation, what we always do, we look at the medication of the patient, and what we see, because we do not treat and see patients that only referred for a treatment, but we get patients for the whole region. Any mitral pathology comes to us, and we give we give a recommendation, and we see a lot of patients that are not on the optimal medical. So first and foremost, we optimize that, and we see the patient after 3 months. We do an echo, and if they are symptomatic, and we provide the transcatheter TEER procedure based on the COAPT criteria, which you already all know. What is also important, if we consider the TEER procedure, is the anatomical suitability. And as you all know, and based on the data, TEER procedure works best in central degenerative pathology. Obviously, in experienced center, we can provide also this procedure with the more complex pathologies. But when you have more tools in your toolbox, and when you work together as a one team with ownership about the whole program, it is much easier to make decisions, and we rarely go and provide patients with a complex procedure if we can provide the patient with much simpler solution. What is also important to consider that the result of surgery are excellent. This is just a publication on all the mitral valves being operated in Netherlands in the last 5 years, up to 2018, and 30-day mortality 1%, repair rate 80%, and freedom from mitral reintervention was 97%. So the result of the surgery are very excellent. So and this is also not because we do a much better job in Netherlands, but because in Netherlands the cardiac surgery is very centralized. We have only 16 centers for 17 million people. So that is also important to consider your the quality of care that you can provide.
Dr. Sardari, sorry to interrupt. We have around 2 minutes remaining for your talk. Sorry to interrupt.
So just the last couple of slides. With regard to the reoperation and also EuroScore, is also very important to consider that this is also based on registry, that the EuroScore and EST score doesn't provide a very clear prediction of the mortality. And this is of the same database, 30-day mortality around 3%, while the patient had an EuroScore around 11%. What is also important to consider age, because from age of 75, we see that the result of the surgery and the mortality will increase. And that is also something that we always consider when we provide different therapies for the patient. So this is, for example, a 72 years patient with dialysis patient, comorbid patient. This is a patient with functional mitral regurgitation that we have offered, for example, transapical mitral valve replacement. This is a patient of 85 years old with P2 prolapse, central prolapse, that's a perfect anatomy. And we offered this patient with transapical neocord position. This is the other patient with a P2 prolapse, but not, this is an old patient with comorbid disease. We offered this patient with the mitral, which works very perfect. So in a sense, what I want to say is working in a dedicated heart team and working with a team that not only make a decision, but also treat the patient along the trajectory of the care of the patient is important. And as we have published that recently, it impacts the survival. And I think that is crucial if you want to set up a good quality of care. With regard to which procedure will be beneficial in which treatment, especially in transcatheter mitral valve replacement, that is a question that is still open because we need to have much more data on that. But in general, we see that those patients that they are not suitable anatomically for the mitral clip, especially patients with the functional mitral regurgitation, that are the patients that you should offer this kind of therapy. And lastly, that's my last slide. Obviously, in future, we need to have a more objectivity in what we decide and to give the patients. And that is the concept that you use virtual simulation, computer simulation to first, what is best to treat this pathology, digital twin, to see what is best to provide this treatment to which intervention, because you have, and then obviously you need, if you know what to do with the valve, what to provide the patient, you still need to have a team to provide that in a good fashion. So thank you. Sorry that took longer than it
Wonderful.
anticipated.
We really appreciate it, Dr. Sardari. I think we're going to leave questions for the end because we're running so behind time. So if you want to take a dip in the pool, now's the time.
Great. Thank you.
Thank you very much for having me here.
Okay, sorry. Thank you very much to the organizers for having me here. In the interest of time, I'll try to be as efficient as possible here. My disclosures. That was me a week ago in Canada, so you can see Canada is very different than Athens, weather-wise, but still great places to live. I'll talk a little bit about mitral valve and re-interventions, valve in valve, valve in ring, and also valve in MAC. And as you've seen with some of the discussions already, you'll see that a lot of this is going to become redundant, and a lot of this, these therapies are not going to be therapies in the future because I think we're going to have better solutions for some of them. But we know that repeat mitral valve surgery has a risk of about 10% across the board. Urgent patients higher, as seen in the Vancouver series, and elective patients less. But no matter where you go, it seems to be around 10%. Looking at the mitral valve in valve SAPIEN 3 aortic transcatheter heart valve TVT registry, and that's in a period of about 4 years in the 2015 and 2019, about 1,500 patients underwent valve in valve. Most of them now are undergoing transeptal, so it's about 1,300. So that's a big database to review. And you can see as lately as it's growing because valves are failing. And also people are becoming more comfortable with interventions. However, most centers do not do many of these. And you look at the median is about 4 over that time period. So that's 1 a year. So this is not something that's done by most centers well, I don't believe, or with any real comfort. Again, we'll concentrate on the transeptal. You see the procedural. Most of the procedures are quite successful. There are a few issues, but this is a quite predictable procedure, especially done with physicians and surgeons who are Hello, everyone. Hello, everyone. I got a little echo here. Testing. Good? Okay. Hello, everyone. I'd like to thank the organizers, and it's great to be back in Athens live, and it's been missed by many of us here. I'll talk today about mitral valve and valve and ring, and MAC update, and what is the actual end game, because many of these treatments are going to go off out of line soon because we have better treatments in the future. Disclosure. That's me a week ago in Canada. You can see the weather's very different there, at least in certain parts compared to Athens, but both places are great to be in. Repeat mitral valve surgery is high-risk surgery, approximately 10%. And these are all very capable centers, and it depends on whether it's urgent or non-urgent, but it's significant morbidity involved and mortality. Therefore, other ways have been thought of to treat this. And over the last number of years, we've been using our TAVR technology in the mitral space. You look, there's approximately 1,300 patients that were treated between 2015 and 2019 with a transeptal approach. I'll leave transapical approach because most now are not done. And you can see it's increasing on a yearly basis. However, most centers are not doing much of this. So on average, it may be one a year, the median center. So it's being concentrated more in the high volume expertise centers, and that's a good thing. We look at the procedural outcomes, they're quite good. You look at the things that go wrong, like device embolization, LVOT obstruction, perforation, quite low. And again, expertise is growing. And most of the people carrying out these procedures are very comfortable in the left atrial space and doing these procedures or variations of these procedures. You look at the 30-day and 1-year outcomes, very good. From the transeptal, approximately 5% mortality at 30 days, and at 1 year, 15.8, sort of similar to the mid-range intermediate of TAVR. And so very good results in the good hands. Stroke risk is low, and other issues are quite low as well. So a trans approach to a mitral valve and valve using the SAPIEN 3, low mortality at 30 days. And it's a good alternative to redo mitral surgery. And it should be considered the standard care in well-selected patients who have favorable anatomy. And sometimes there's not favorable anatomy, but that's why an expert team has to review these patients using CT, transesophageal echo, or echo, depending on their center and their expertise. Now, how about transcatheter mitral valve in ring? Well, if you can do it in a valve, why not in a ring? So people have been doing it. However, all rings are very different. And it's incumbent on the center to understand what their surgeons are doing and what is actually being placed in these patients. Because trying to do a valve and ring on an incomplete ring that is, if it's flexible, if it's elliptical, the results are not as good. You see over approximately 5 years, 341 patients in the TVT registry at 128 sites. Again, the median is 2. So very low volumes, and maybe these centers below that shouldn't be doing this. 30-day outcomes, 10% mortality. So double what it is for valve and valve. So a little bit more care has to be thought out in these patients, and selection has to be better. 10% is approaching results that probably we shouldn't think of doing, so we really have to select these patients appropriately. The mitral regurgitation aspect afterwards, again, if they're selected well, there doesn't seem to be mitral regurgitation. So it may just be the patient subset that's also causing this issue, because we know that frail patients with significant comorbidities don't do as well. Technical challenges, again, not all rings are adequately anchored. Rigid rings have a high risk of underexpansion, so you have to size these properly, and CT is the best for that. Adequate sizing important to make sure you anchor in place. You don't want this thing to embolize. And the risk of LVOT obstruction is a real phenomena. Not as much in the valve and valve, but it can be, but more so in valve and ring. And then you'll see later more so in valve and MAC. So these can be done. This is early experience for most centers and low volume for the centers. 30-day mortality, lower than predicted in the STS score, but still high. So again, well-selected patients, it is an option. And it should be done in specialized centers. How about patients with severe MAC? Well, these are the patients that surgeons don't like to operate and interventionalists don't like to treat either if they don't have to. And for a number of reasons, and the surgeons in the room and online know this. You can take a, quote, simple severe MAC patient and it can go badly quite quickly. Risk of stroke, risk of paravalvular leak, a risk of the heart essentially falling apart, as my surgical colleagues have told me. And that's a bit scary. And many of these patients, by the very nature of having severe MAC, are elderly and they have a lot of comorbidities. So they're very high STS score patients. And MAC's not the same. Again, anytime these are being assessed, proper CT imaging has to be done. Circumferential calcium acts very differently than half of the circumference calcium. And we know that you won't anchor it well if there's not enough calcium around. You look at Myra's retrospective data. This was published in 2016 and updated in 2018. But suffice to say, 20% of the patients undergoing valve and MAC had severe complications. And many of them died because of these complications. They just can't survive reoperation if something goes wrong or there's something catastrophic and they don't even try. So when you look at the one-year outcomes, average age 73, a lot of them have a lot of comorbidities, previous bypass, previous AVR. People do not want to go into these patients a second time. The chest is hostile in many cases. STS score 15.3. Now, to get into partner 1, the STS score above 8 was considered non-surgical. So when 15%, these patients, we have to think twice about whether or not they should even be treated. And in fact, when even in these expert centers, because this isn't being done just anywhere, 30-day mortality, 22%. So extremely high, and we have to question ourselves whether we should be doing this. The predictors of one-year mortality, technical success, essentially. Because LVOT obstruction, valve embolization, conversion to surgery is because you weren't technically successful. So, is it feasible? Yes. Very high mortality? Yes. And we know that if you don't do it right, that the patient's not going to do well. So in my mind, is it worthwhile to use these non-dedicated devices? Because a TAVR valve is not meant to be put in here in the first place. Can we do better? Well, LVOT obstruction, calcification, paravalvular leak, these are all issues that need to be assessed. And there's different ways to do that and different treatments. So in a center that is doing this, you have to be prepared to do certain things, whether it's pre or post septal alcohol ablation because LVOT obstruction, lampoon procedure, and often a transatrial resection may be the best approach. And that's what we're doing at our center most of the time now with these patients if we feel they can be put on FEM-FEM. And the surgeon can go in, take out the anterior leaflet, can put in a few sutures, they can band around, and they can do it this way, as you can see, and have a fairly successful result. So we've been successful in that point of view. However, we have to avoid futility. We have to evaluate properly. Positioning has to be perfect. We have to worry about embolization, late valve embolization, and the durability. But proper devices are coming, and they will be better. Because of issues with organization here and availability of some of our speakers, some of them have already spoken, but they will talk about these devices and how they are dedicated to treat these type of patients or patients similar, and I think really this is the way we need to go. And on a personal note, I started the TAVI program at our center in 2008. There's our team. I think just after Costa started doing TAVI in Greece. And on the right, we have a very important patient, 87 years old. He was born in Florina, Greece. And he had a permanent pacemaker placed 14 days before his TAVR there. And that's my father. He had a same-day discharge. It was my colleagues that did it, not me. He did very well. So, us being involved in this, we're looking after our patients, but also our family are being looked after. Thank you.
Thank you, James. Great presentation. Thank you for the update and for your personal touch at the end. It's our pleasure to have you here every year. We are sorry for the small interruption we had due to technical problems earlier. That's why we went offline for about 5 minutes for those of you who are watching us online. So if there are any questions from the audience. Okay, so we go to the end because we have this additional delay from the technical issues. And That's the perfect timing in the order of the talks, because the next lecture will be, I suspect, very much related to what James told us earlier. We have Dr. Pitsis, who has probably the greatest experience in Greece about the hybrid approach in MAC patients. Adonis, are you with us? Dr.
I would
Pitsis?
like to thank.
Welcome. We're all ears for you.
Thank you. Thank you. I would like to thank very much Kostas and Grigoris for the kind invitation and congratulate them on the very, very successful meeting, which is we are used to expect from this meeting. So I'm going to share my screen. I hope that you can see my screen. Okay. So my topic is the hybrid TMVR in MAC, and I'm going to refer mainly to the hybrid approach, the way that we are doing it, the modern way. And I know that Grigoris is very, very keen on this approach, and we are talking about the endoscopic approach. So this is the list of my disclosures. And I'm very, very happy that my short talk follows Dr. Velianos' very, very nice talk, because we are going to be discussing the same topic about MAC, and MAC is very, very common, as we all know, seen in almost 10% of the population, up to 40% of the septuagenarians, but obviously not all these people will require surgery. Surgery is going to be required in a small minority of these people. And obviously, the distribution and prevalence of MAC in the annular plane varies, as we all know, from horseshoe, rings, and so on. But also we have a distribution of the extent of MAC. Quite often is confined within the mitral annulus, but sometimes extends to the subvalvular apparatus and also to the leaflets. And the worst type is when it extends in the ventricular myocardium. So how we treat MAC? There are the same way that we treat most of the things in surgery and in interventional cardiology, either with a resect technique or a respect technique. Either we're going to resect the annular calcification, this bar of calcium, and to replace the valve most of the times, but also there are some techniques that we resect and repair the valve, or we're going to respect the annular calcification, and obviously in those cases, most of the times we are doing mitral valve repairs, but there are also respect plus mitral valve replacement. Both of the techniques have the pros and cons, as everything in surgery and in interventional cardiology. Resection techniques have the risk of, they have many risks really, the risk of disruption of the annular ventricular continuity, which is a complication that it is lethal really most of the times, and also the risk of obstructing the circumflex artery and the coronary sinus, which lie just a couple of millimeters next to the calcific bar. And obviously the respect techniques, again, they have more of those risks. This is a case of ours. Actually, this is this week's case. You can see the MAC. This is a horseshoe, as you can see here. This is not actually the technique that we are referring to. The patient also had hypertrophic cardiomyopathy, so we had to do a myectomy. Here we resect the anterior leaflet. We do a resection of the hypertrophic cardiomyopathy next. A huge LVOT obstruction. In this particular case, the LVOT obstruction, the gradient was something like 160. Here we carry on again. We continue the myectomy, which is done endoscopically, as you can see. This is not open surgery. This is closed surgery. And next, in this particular patient, we decided, because the area here was very, very small, and we couldn't be able to implant the correct size of valve that we wished to implant. And also there was the issue of the hypertrophied intraventricular septum. We decided to resect actually the calcium bar, and you can see here the resection, and replace the valve with a mechanical prosthesis. This is an endoscopic approach, but obviously this is a mitral valve replacement approach. This is not the hybrid approach that I'm going to present later. Also there are some respect strategies that they are extra anatomical, trying to connect the left atrium to the apex of the heart, but I don't think that anyone uses these techniques nowadays. Most of the people have moved towards either the endoscopic surgical approaches or the hybrid approaches. And Dr. Velianu has already alluded us in the transeptal approaches, so I'm not going to talk about those in the interest of time. Certainly there are registries today, and I would like to refer very quickly in this one from the Mayo Clinic, and as you can see, 92 patients with MAC and only 31 patients treated. 2/3 of the patients were not treated, and the reason being that they found to be unsuitable for this type of procedures, that they were including transatrial approach, transapical approach, and also transeptal approach. And as Dr. Velianu said, the mortality was extremely high, one year mortality, 40%, 30%, and the transapical patient, which was just one, also was a mortality. So very, very bad results indeed, and we should be questioning ourselves whether we should be doing these cases. But certainly there are younger patients, there are desperate patients, and I think that these are patients that we should offer them a chance. So a lot of issues with either the approaches. There are pros and cons, as we have already said. Certainly, cardiac surgery has moved to minimally invasive and especially totally endoscopic approaches. And we are doing this type of operations not only for cosmesis. Cosmesis is important, but it's not the most important thing. We are doing this type of procedures because we believe that we can do a better job. Why we can do a better job? Because we see better, and we see better because we have the endoscopic vision, which is a huge magnification, the right angle towards the mitral annulus, and therefore we can do a lot better job than we used to. So this is a patient with very severe MAC, as you can see. This is ring, and actually the patient had been implanted with a TAVI in 3 or 4 years ago. So this time came back for his mitral stenosis and some also mitral regurgitation. And here you can see the severe mitral stenosis. This mitral valve hardly opens. And this is one of the cases that we have treated with the hybrid approach. Today we have about 20 cases with the hybrid approach. This is the latest version of our approach, because when we started, we were implanting valves 100% ventricularly, 0% atrially. Then we moved towards a 70 to 8% ventricular implantation, 20% atrial implantation, 20 to 30. Still, we had problems with LVOT obstruction. So finally, we decided to move to this third version of our approach, and this is the third version. So you can see the TAVI valve that works very well, a tiny leak over there. So what is this version? This version, we are using a collar, so we can do a 50-50% implantation atrial ventricular. So this is, I think, the most important thing, because this way we are dealing with 2 issues. The first issue is the LVOT obstruction, so we try not to leave any gradient at all. And the second issue is the paravalvular leaks. So these are the 2 most important issues with the valve-in-MAC hybrid approaches. So again, periareolar incision, this is a totally endoscopic approach, cross-clamping of the ascending aorta. The operation is done on cardiopulmonary bypass, fem-fem cannulation, femoral cannulation, the left atriotomy. All these steps are the same steps that we use also in endoscopic mitral valve surgery that we do every day, mitral valve repairs and so on. The next thing that we do is to resect the anterior mitral leaflet. Why we do that? Because we want the cells of the TAVI prosthesis that we're going to implant later to be open cells. So we don't want to close by the anterior mitral leaflet. So we totally resect the anterior mitral leaflet. If the patient has got hypertrophic cardiomyopathy or a bulging septum, then we do a myectomy at this stage as well, as we have already showed in the previous video. The next thing to do is to put 4 anchoring sutures to implant a collar from Gore-Tex. This is a Gore-Tex tube graft of 6 millimeters, and we do that so we can do a high implantation. And the next thing to do is to implant the prosthesis. So with the Gore-Tex, we are giving ourselves space. It is like a chimney, so we can have a high implantation towards the atrium, obviously. And the next thing to do is to implant the prosthesis, which is a TAVI prosthesis. In this particular patient, we have chosen my valve at 27.5 millimeters. We are first, obviously, have sized the valve with a balloon, as we do in the transeptal approaches. So from a different port, as you can see, we insert the my valve in order to be coaxial with the long axis of the left ventricle. And next, this is the endoscope. This is a 3D 30 degrees endoscope. And next, as you can see, we do this implantation without a wire because we have endoscopic vision. So, and obviously because the heart is arrested, we can take our brass. So we implant slowly, making sure that we are going to achieve a 50-50% implantation. And as we have already said, the collar allows us to do that, to do such a high implantation, because this is the area of the valve which is not covered by the skirt of the valve. So if we hadn't implanted the collar, then we would have a huge paravalvular leak with a 50-50% implantation. And this is the water test that we are testing for paravalvular leaks. If there is any paravalvular leak, we can fix it at this stage. We can put an extra suture or a patch or whatever. Usually there are none. And then we use these anchoring sutures also to stabilize the prosthesis onto the collar. So the collar is stabilized on the annulus, and the prosthesis is also stabilized on the collar, is anchored on the collar. So there is no way this prosthesis can migrate towards the left atrium, which is another issue of this, potential problem of this approach. So, and this is the closure of the aortotomy as we do in endoscopic mitral valve surgery. And this is very straightforward. And the post-op echo, and you can see that there is no paravalvular leak. Also, you can see, I'm going to play that again, that the valve appears to float. Why the valve floats? Because here is the Gore-Tex, which has no echo shadowing. So despite the fact that the valve, it is a paradox, the valve seems to be floating inside the left atrium. Obviously, there is no paravalvular leak at all. So this is a perfectly working valve. And we are very, very happy with this approach. Obviously, this doesn't mean that we're going to do this type of approach and achieve survival of 99% as it is with mitral valve repairs. This is far from true, and the reason being that these are very, very sick patients, and despite the fact that we are doing a perfect operation, we are still going to have, unfortunately, mortality. And the mortality in our population is 20%, unfortunately. So,
Andonis, if you can conclude like in 2 minutes.
This is
if it's
actually
possible.
yes, and actually, Kostas, thank you very much. And this is actually my conclusion. So certainly we should be questioning ourselves, as Dr. Belianou has already suggested. But on the other hand, I believe that 80% survival is better than 0 survival. So I think we should, and certainly with the time, we're going to become better. So thank you very much for watching.
Andonis, congratulations for this mounting experience and your excellent results. I want to ask you, do you see any difference in the delivery of the valve if you go endoscopically versus with sternotomy? The alignment, is it a favorite on both approaches, or you believe there is a difference in between?
It's a huge difference. It is a huge difference, Kostas, and this is a very nice question. I'm sure that Grigoris would agree with that. Why? Why there is a huge difference? Because with the endoscope, we are aligned. We are right angle to the mitral annulus. This is the first issue, which is extremely important. We can see all the angles. So we take the endoscope and go around and see how the balloon, while the balloon expands the stent of the valve, we go around and make sure that we have the exact percentage that we want of implantation. The second reason is that the huge magnification. So even with our surgical loops, we magnify it 2.5, 3.5 times, but with the endoscope, we can magnify optical zoom 10 times and digital zoom up to 40, 50 times. So this is huge, really huge. It is unthinkable. If somebody would tell me that we would do this type of procedure, 20 years ago, I thought I would tell him that he's crazy. I wouldn't have anticipated and expected that. Thank you. Thank you for the
Dr.
question.
Pritsis, it's a fantastic talk, and I think it opens a lot of questions. We could sit here and ask questions for an hour. I'm going to ask a question, and then we see from the audience if anybody has a question. My question is, as you said, I believe you said around the 20% mortality rate, which is what the literature says, unfortunately. And I think that this is a marker of the fact that, as with many other things in the heart, as with end-stage tricuspid regurgitation, et cetera, sometimes the problem is not just what we see, but this is the marker of an end-stage patient. So my question for you is, which patients do you believe that even if technically possible, we should reject them for surgery? Do you think that there's such a thing as an inoperable patient in this category? This is one of the hardest groups of patients that we see as surgeons.
Obviously, thank you very much, Gregory, and this is an excellent question. There is a huge difference of our 20% with the literature 20%. Why is that? Because in the literature, the 20% is for the 1/6 of the population that finally received the treatment. So it is 20% out of the 1/6, but the other 5/6 died due to this disease, which is extremely, so ourselves, we are doing these operations really to all comers because there are no technical issues with surgery, because we cut the anterior leaflet. We don't care, if there is a hypertrophic cardiomyopathy. We don't care if there is a bulging septum, because we can still, resect the septum and so on. So we treat all comers. So this 20% is different 20%. We are talking about a different population. But I quite agree with you that we should develop further better selection criteria, and this 20% has to come down to 5% in order to be successful and in order to be happy. It is very difficult for a surgeon or for interventional cardiology to accept 20% mortality in one operation.
I think it's a wonderful approach that you showed, and I think it's one of the few cases that really highlights the benefit of the heart team, where the cardiac surgeon and the interventional cardiologists are both sides are doing amazing work together. So thank you very much for showing us this.
Thank you.
I think we should move on, Gregory. We have 15 minutes in this session, and we have 3 pre-recorded lectures of 10 minutes each. So we'll go 15 minutes delayed after the session. So let's go with the video song, starting with the presentation of Dr. Bapat. We don't need to introduce him. Everybody knows him, pioneer in the field. So transfemoral TMVR update, potential. Is the potential realized? We can start.
Good morning, everyone. I'm Dr. Vinny Bapat, Chief of Cardiac Surgery at Abbott Northwestern, Minneapolis, and past professor in Columbia University, New York, and Guy's and St. Thomas's, London. Our topic of today is of great interest to all of us. Where are we today in terms of transcatheter mitral valve replacement with less access? These are my disclosures. Mitral regurgitation indeed remains very challenging. Unlike aortic stenosis, where we have medical treatment, surgery, and transcatheter aortic valve replacement, for mitral, within transcatheter treatment, there could be repair, replacement, chorda enlargement, and leaflet augmentation. This is because mitral valve, as we know, is an extremely dynamic structure, very large, and with multiple pathologies. TMVR was introduced in 2014. I was fortunate enough to participate in the first-in-man with Fortis device. Since then, the progress has been slow, but definitely in forward direction. And we are anticipating now in the next 2 years a rapid evolution of this treatment. TMVR also gives us an opportunity not just to reduce MR, but eliminate MR completely, and may be applicable to more patients than at present what TR treats. MitraClip and Pascal has served really well. A lot of our patients, and in the United States and Europe, we have seen a rapid growth. I was fortunate enough to moderate a session in China, where again, TR treatment has really taken off very, very well. But there are many mitral patients who are not suitable for this, and many mitral patients, when even we attempt a TR, it doesn't lead to a good result. Dr. Scott Lim has put an extremely useful document in terms of what treatment should patients receive. You can see that patients are classified according to green, yellow, and red zone. Straightforward TR anatomy should be considered for TR. Complex TR anatomy will probably go for either side, and then prohibitive TR anatomy should be considered for other forms of treatment, mainly TMVR. However, because TR at present, which is MitraClip and Pascal, are approved, majority of these patients get a TR device. We know that suboptimal results with these devices are not good because we surgeons see these patients, and the only option at present is surgery, and hence these high-risk patients are not served very well by TR. TMVR, in my mind, will be a great option for these patients to start with, because if it is safer and reliable to use, probably that should be the first choice of device. So we can avoid open heart surgery and at the same time provide them with a complete reduction of mitral regurg. This can only be a reality if it's not a transapical procedure. And these are the devices in descending order of patient experience: Intrepid from Medtronic, M3 for Edward Life Sciences, UltraValve, which is called also 4C, High Life, CardiaQ, Cephia, and CardioValve devices. Extremely promising landscape as we go into next 2 years. Intrepid device is something I've got the maximum experience with. This is a 2-frame device. This has also been implanted in Greece. You can see that the outer frame is conformable and inner frame is the functioning valve, which is 27 millimeter bovine pericardial valve. We introduced this device way back in 2014 as a transapical device, and it has undergone multiple iterations. Apollo trial, which is the largest trial enrolling at present in the United States with over around 350 patients now. And you can see that the trial has also evolved and taking into account co-op results and approval of MitraClip. The transfemoral TMVR device with Intrepid is extremely promising, and this is the first generation device which we are currently using in the EFS. You can see that it's more or less like any other transeptal mitral device. with functionality to maneuver the device into mitral position and deploy it reliably. The device design hasn't changed. It is same as the transapical with minor modifications. This is just a case example. It's an 85-year-old male patient with a class 2 NYHA on GDMT, severely symptomatic, and now as the device size compatible with a 48 millimeter device. You can see it on the echo. Ejection fraction in this severe MR patient is around 49%. And you can see that there are multiple jets, and hence the operator felt that a TEER device will not give this patient a good result. You can see the mechanism of MR is type 3B. And we also went ahead and did a CT analysis. You can see that this patient fits with the 11% oversizing for a 48 millimeter device. And then we, of course, do a neo-LVOT assessment. In here, neo-LVOT is more than 1.6, which is suitable for this device. As it's a transfemoral approach, we are embarking on analyzing the access, which is the venous access. And here we felt that the venous access was adequate. The first step, of course, in any of this is transeptal puncture. You need to have a septal height of at least 4.5 centimeters. Once the septal puncture is done, we dilate it with a 14 millimeter balloon. Delivery catheter at present is quite large, and this was the initial apprehension to use this device. However, with methodical steps and standardization of technique, this has been extremely successful in 25 patients. We use multiple dilators, then get the sheath up into the left atrium. We ensure that there is wires manipulated very carefully and there is no air embolism. Once the deliver catheter is in, we insert the device. You can see the device is not over a wire. And this is pretty interesting that the device is completely in a capsule, which you can see very well in the left atrium. This device currently is completely retrievable. Once the capsule is maneuvered, similar to that of what MitraClip and Pascal does at present, we get the valve in a coaxial position, and then under rapid pacing, we deploy the device. And you can see the rapid pacing usually is between 30 seconds to 50 seconds, and it's very well tolerated by the patients. This being a transeptal device, usually when we manipulate this device, it is literally 1 centimeter above the target area, and hence it can be precisely deployed in the target. This is again to show you the deployment of the device under echo and fluoro guidance. Here you can see in this particular case, it was 46 seconds, pacing at 160. The valve was extremely stable with no PV leak. The catheter is then carefully guided out of the device and then the septum. And here you can see we are assessing the septal closure. Interestingly, over a period of time now, a lot of centers are not doing septal closure. And this is assessed whether the shunt is right to left or left to right and the nature of the septal tear. This is to highlight a very beautifully working device with no LVOT obstruction and no PVL. Interestingly, the case times of such a device being deployed are only 34 minutes from insertion to removal. And the early case time, which shows it just for planning and discussions around septal closure. This is a discharge CT, a very well seated device. And then again, we can see the transesophageal echo or transthoracic echo at 30 days shows no PVL and well functioning valve. We have had a very good EFS experience now, as I mentioned earlier. Similarly, there has been experience with other systems. Briefly, this is a Evoke system, size 44 and 48 device, but a 28 French delivery system. This is owned by Edwards Lifesciences. Again, the trial is being enrolled. Sapien M3 valve, which we know is a modification of the S3 valve. This is a two-step device, one with a M3 dock, and then you deploy a S3. This is just to highlight two steps. The left side panel shows delivery and positioning of the dock, And the right side panel shows the end result where a very familiar looking S3 device implanted in the dog. There are some limitations in terms of how large an annulus you can treat, because if you try and treat a very large annulus, the dog doesn't take into account the leaflet gathering and then can lead to some PVL. Cephea system, which is acquired by Abbott now, is also going to start an early study in United States. The advantage of this device, it's a low profile device, so may have a less impact on LVOT. This is one of the first cases done by a close friend, Dr. Thomas Modine in France, which had a really good result. Valve has a large experience now of transeptal. This is a slightly out of box concept with a supraannular valve and a cage which stabilizes the valve. Again, this is the first in man case in the United States. You can see beautifully seated valve with a supraannular position and no mitral regurgitation. And lastly, but not the least, ring and valve concept from High Life. Again, to highlight transfemoral arterial placement of the dock, followed by the transeptal delivery of a dedicated device with very good result. So I think as the transeptal TMVR device becomes a reality, the yellow zone is slowly going to shift towards TMVR, as what we don't want, as I mentioned earlier, patients to have a TR device, not do well, and then go for open heart surgery. So to conclude, I say that transeptal TMVR now is a reality. There's a rapid shift from TA to TS access. Intrepid device has shown excellent results in 25 patients. And I think other devices and increasing experience and smaller device delivery systems, we are going to get a boom in and rapid adaptability of the transeptal TMVR. Thank you.
Bapat, clearly a leader in the field, and as cardiac surgeons, we are grateful that we have representatives such as this in the transcatheter valve arena. Our next talk will be by Dr. Mack, who will discuss transcatheter mitral replacement, patient eligibility, and clinical trial considerations. Dr. Mack was connected with us online earlier, but now is on a plane to Boston, so we have his talk as a pre-recorded talk.
For asking me to participate in the meeting again this year. I'm only sorry that it's still virtual, at least for us from the United States. Hopefully next year it will be in person, but I certainly appreciate the opportunity of participating. I've been asked to speak on transcatheter mitral valve replacement, patient eligibility, and clinical trial considerations. These are my conflict of interest disclosures. I am the study chair of the Apollo trial of a TMVR device, Intrepid, for Medtronic. So this is the current landscape of mitral valve intervention in the United States. On the top is all surgical mitral valve operations. There are 37,000 of them done last year. Isolated surgical mitral valve repair and replacement is about 20,000, and there are about 14,000 TEER procedures performed. Also, there were a number of TMVR procedures, but since there's no commercially approved device in the United States, these are all valve-in-valve with a SAPIEN 3 device. So there are now 507 sites performing TEER in the United States, and this is the total of 14,000 performed last year. There has been a dramatic increase in the number performed. This is mainly due to the regulatory approval of secondary or functional mitral regurgitation by the FDA in the past couple of years. And that's shown in this slide. You can see that now about 30% of patients undergoing transcatheter intervention in the United States are secondary or functional mitral regurgitation, with another 10% having a combined disease. So primary MR is only about 60% of patients treated at the current time. So with this rapid expansion of TEER, why would you consider TMVR? Well, of course, it's less invasive than surgery. So if you're going to perform a mitral valve replacement, why wouldn't you consider it transcatheter rather than surgery? It enables treatment of more patients, especially those with secondary MR. It's predictable and durable elimination of MR across a wide range of anatomies and pathology. So it's pretty much agnostic to the etiology of the disease. With the transeptal approach now, it's become a relatively straightforward procedure for experienced operators, and both the devices and the delivery systems are continuing to iterate and improve. And then lastly, there's many patients who are not eligible for TEER or have suboptimal outcomes with TEER that may likely be better treated with TMVR. So this is from experience in the EVERS 2 trial, and this was published in JACC in 2009. And we knew back at that time that there were patients that are not optimally treated for TEER. And that has to do with the coaptation length, the coaptation depth, the flail gap, and the flail width. If any of those were too great, then a less than optimal TEER result was obtained. And that was further codified in 2013 into a green, yellow, and red zone. And I don't expect you to read this slide because I'll go through it in more detail later on. But the green is patients that are suitable for TEER. Red are patients that are not suitable for TEER and therefore treatable with TMVR in a lot of instances. And then there are patients in yellow in which they may be treated by TEER but may not be optimal or get less than optimal results. So this has been more recently updated and codified in this publication by Scott Lim, a consensus document by experienced operators on the non-suitability for TEER and therefore patients that may best be treated by TMVR. This was done at the request of the FDA in the United States so that they could understand which patients were being entered into the TMVR trials. And so those patients that are not suitable for surgery are then subsequently considered whether they're suitable for TEER. And patients in green are straightforward anatomy, and most operators should be able to get a good result with zero or trace mitral regurgitation residual at the end of the procedure. Those on the right are red, and therefore those patients are not considered suitable for TEER, and perhaps a lot of those could be treated with TMVR. Then there's a yellow zone in the middle in which there's variability based upon the anatomy and based upon the experience of the operators. What may be on the green side of yellow for experienced institutions may fall more in the orange range for folks with less experience in performing the procedure. And this is a dynamic area that will continue to be defined as time goes on. So we know that MR is bad and worse MR is real bad. This is the original Serrano publication that shows the more MR you have, the worse that your survival is. And therefore, the better you can do at correcting the mitral regurgitation, the better your survival is going to be. So optimally, you don't want to leave any mitral regurgitation behind. And that was shown in this series, again from Mayo Clinic, that showed that if you have residual mitral regurgitation after surgery, your survival or your reoperation rate is higher than if you have no residual mitral regurgitation at the completion of the procedure. Saibal Kar looked at the COAP trial and looked at the outcomes based upon how much residual mitral regurgitation you had. Gray on the bottom is patients that had no or trace mitral regurgitation afterwards. And you can see that the more complete you correct the mitral regurgitation, the greater your survival is. If you leave patients with 3 or 4 plus mitral regurgitation, all-cause mortality or heart failure hospitalization exceeds 70% at 2 years. This was also shown in this TVT registry study by Paul Saraja. The unity line in the center is the reference 2 plus MR. And you can see your survival at 1 year is better if you completely correct the mitral regurgitation, and it's worse if you leave patients with 3 to 4 plus mitral regurgitation. And these are examples of a couple patients that are not suitable for TEER. A patient with a flail P3 and mitral annular calcification, the small mitral valve area. This is a patient that is not suitable for TEER and should be considered for TMVR. Again, this is another patient with a severely fibrosed bound down posterior leaflet that would be difficult to grasp and not suitable for TEER. So this is the red light, yellow light, green light publication by Scott Lim, and this shows some of the patients who are not suitable for TEER, such as rheumatic heart disease, radiation therapy, chronic inflammatory conditions, severe MAC, severely fibrotic leaflets, prior annuloplasty, and prohibitively small mitral valve areas. And these patients should be considered for TMVR as an alternative. These are other patients that have inadequate reduction of MR, such as perforation from endocarditis, a short restricted posterior leaflet of less than 5 millimeters, and when the MR is primarily due to clefts. And again, these patients should be considered for TMVR. We've also see from the choice mitral registry which patients are actually being treated by TMVR. So these are 229 of the 746 patients undergoing transcatheter therapy. And you can see those that were treated by replacement are characteristically secondary mitral regurgitation, patients with larger left ventricular dimensions, and some patients with mitral annular calcification. So there are currently 5 devices in trials in the United States at the current time. 4 of these 5 can be delivered by a transseptal. Approach. This is the Intrepid device in the Apollo trial, the early feasibility trial, and you can see that that only 26 patients were approved of 192 screened. And the major reason for patients not being eligible now are a prohibitive risk of left ventricular outflow tract obstruction, as you can see on the right side in the dark blue area, and mitral valve annulus too large. However, this is being addressed by having larger size valves available. So there's, unfortunately, there's still a large number of patients that don't qualify for these trials. This is the characteristics of 22 patients in the early feasibility trial, 78 years old, 3/4 male, and STS score mean of 4.9%. So the current landscape for TMVR, that TEER adoption is accelerating in the United States, mainly due to treatment of secondary mitral regurgitation. There has been a risk creep of TEER into lower risk patients, and that's adversely affecting enrollment in the TMVR pivotal trials. However, we now have 4 devices that can be implanted by a transseptal approach, and hopefully that'll facilitate trial enrollment going forward. So final considerations, that TMVR is agnostic to etiology. Large annular size and LVOT obstruction are the major challenges to eligibility currently. TMVR completely corrects MR, which is better than partially correcting MR. So in other words, yellow zone patients who's not going to get a good result, we shouldn't try TEER first. Those patients probably should be considered for TMVR. The early transeptal trial results are excellent, and therefore I think that anyone in which the a priori decision has been made that this patient's going to get a surgical mitral valve replacement, why don't we consider entering those into the TMVR trials since the results have been so excellent to date. So thank you again for the opportunity of participating in this meeting, and I look forward to the discussion.
Okay, we thank Dr. Mack for his presentation and the update. We've learned many things today from his presentation and the earliest talks. And now it's clear that we have the criteria for saying when a patient is not for TEER. This is well defined from this consensus group in the Structural Heart publication, something that we didn't have before. So this is very helpful. And the second is that we're moving completely to transfemoral transeptal TMVR devices, and with the hope that this will facilitate further investigation of these devices, because the transapical adoption was very difficult so far. And what we've seen that when we have in these trials is when we have a transeptal device of more than, let's say, 30 friends, then the need to close, to plug the iatrogenic ASD at the end is very high, it's more than 50%. But when we fall to below 28%, which is the evoke EOS, then this closure rate falls considerably to like 20%. And with this comment, we'll move on to the last pre-recorded presentation, Dr. Maisanos, who is a very good friend of our meeting, and his presentation will wrap up all the other probably presentations of this session, mitral regurgitation guidelines, and roundtable discussion.
Ladies and gentlemen, dear colleagues, I will briefly summarize what is new on mitral regurgitation in the new ESC CTS valve guidelines 2021. This is my disclosure statement. And I would summarize that the guidelines have been focusing on some main messages. Message number one, probably the most important, there is a strong message on trying to intervene earlier than before. There are some new evidences which are improving or increasing the level of indication for some pathology. There is the role of transcatheter edge-to-edge repair, as well as the role of the heart team. The guidelines for primary MR have two main novelties. One is that there is an increase of the level of evidence from C to B. So it is not anymore an opinion. There is data supporting that repair is better than replacement if the results are expected to be durable. And also there is a 2A class, but with level of evidence B, so increasing level of evidence for earlier indication in patients who are asymptomatic and low risk with a normal ejection fraction. The size of the left atrium is going to be an important driver for indication, which means that there is a stronger focus on preventing not only AV function but also atrial function. And then finally, in the algorithm, transcatheter edge-to-edge is considered as an option in those patients who are inoperable or at high surgical risk with degenerative mitral regurgitation, or let's say primary mitral regurgitation. So you can see here the revised guidelines have been changing the end-cystoid diameter threshold for recommendation from 45 to 40. You see the number basically has been changed in all the small recommendations. And this is basically coming from the NIDA risk score. The NIDA mortality risk score has been developed in Europe on several centers. We've been working on this important project showing that there are a number of risk factors which are predicting mortality in the natural history. And as you can see, beyond the age, symptoms, atrial fibrillation, the size of the left atrium, the pressure in the pulmonary system, also the size more than 40 has been identified as a predictive factor. And so these data have been presented in a number of papers. What is actually interesting is that although 40 millimeter has been associated with some predictive factor in the univariate analysis, in multivariate analysis, actually this number has not been confirmed and validated. What is also important is that the NIDA score has been showing the importance of measuring the size and the amount of mitral regurgitation. So again, all this effort from the NIDA group has been recognized in the guidelines with the increased level of evidence. You can see that the NIDA score also is predicting mortality better than Euroscore, and so it's becoming a useful addendum to the decision making. In secondary MR, again, transcatheter edge-to-edge enters in the algorithm. What is interesting is that overall, valve surgery or interventions are recommended only in patients with severe secondary MR who are still symptomatic despite the guideline-directed medical therapy, including CRT. And this has to be decided in a structured collaborative heart team. So there are many important messages in a very simple sentence. I would say that there is also an important message here that severe MR means an MR which is measured with the ERO more than 0.4. Again, transcatheter edge-to-edge is included in the discussion. Transcatheter edge-to-edge for functional MR has been associated with a class of indication 2A or 2B according to the presence of a coapt-like or a mitral FR-like phenotype, and always considering these patients as high risk or inoperable. So this has been somehow replicated also in the heart failure guidelines. What is very important, again, is to underline the fact that the guidelines have been revising the threshold for severity for mitral regurgitation in functional MR or in secondary MR, going from 0.2 to 0.4 EROA square centimeters. The decision has been mainly driven by the confusion created by the different threshold in evaluating trials which are run overseas. And basically, although there has been this change in the notes, in the text of the guidelines, still lower degrees of MR, so whether a EROA more than 20 millimeters square defines severe secondary MR remains controversial. So in principle, there is still an ongoing discussion whether severity is associated with less or more degrees of MR. Last but not least, the guidelines have been highlighting the importance of center of competence. These are more and more well defined. The network of care is also very important, and it is an important support for heart team decisions to make sure that the patient is involved in a program which is defined by high quality, by respect of guidelines, and a system which is also respecting the wishes of the patients in a concept of shared decision making as well as of lifetime management. So in principle, these are the important novelties in the guidelines, and it's now time for discussion. Thank you very much.
Great. We thank Francesco for his excellent presentation and update on the guidelines. And happy to discuss with the audience if there are any questions of any of these presentations. Michael. Yeah.
My question is whether in patients with intermediate MIDA score, whether in those patients who are operable but maybe considered higher risk, whether we could foresee an Everest trial in 2022, in this day and age, where we've made so much progress with edge-to-edge repair, whether we could replicate a study like that, considering patients over 65 with an intermediate risk for surgery, whether we could, and anatomically feasible for edge-to-edge repair, whether we could consider comparing surgery to edge-to-edge repair outcomes.
I think there's a randomized study that is ongoing now in Europe. I think Francesco is involved, directly comparing surgical mitral valve repair to MitraClip in this type of patients, like high risk but not prohibitive risk for surgery. And if I remember well, there's a second trial just examining this. I don't remember the names of the trials now. I cannot bring them up.
We have a lot of data coming up, but I do have to stress that, you know, as you've seen, Mike, you're in the operating room with us. We, you know, routinely perform mitral valve repair on 70-year-old patients, and there's a lot of literature to suggest that they equally benefit from mitral valve repair, especially in an elderly population. It's good to be able to avoid anticoagulation with Coumadin warfarin. So even though some of these patients may be considered elsewhere for valve replacement, we still consider here at Hygieia patients who are over 70 years old for mitral valve repair. But I hear what you're saying, and I think a lot of data is going to be coming out. And much as happened with TAVI, I think we may have some trickle down of MitraClip to younger and lower risk patients in the future. Thank you.
Great, and with that I think we should conclude this session. We learned a few new things, and we thank all the contributors to this session, and we're ready to move on to the next session, and we call the panelists and the chairman to start immediately.
Dear colleagues, we continue with next session. It's entitled Tricuspid
transcatheter edge-to-edge repair for tricuspid valve. After TAVI, mitral valve repair, transcatheter techniques for tricuspid valve have emerged as a very interesting alternative therapeutic options. We have the pleasure to have with us three very experienced colleagues in this field. And first of all, I ask to Professor Kapadia from University of Cleveland, Ohio, to present his topic entitled TTVR Patient Eligibility and Clinical Trial Considerations. Professor Kapadia. Please to unmute your microphone. You don't have still unmute your microphone.
Yeah, I got it. Perfect.
You
hear me now?
Perfect, excellent. We hear you.
Oh, wonderful, wonderful. First of all, thank you for the invitation, and it is my great pleasure to present actually live, because instead of recording it, I thought that maybe I'll present it live because it was a weekend today. So what I'm going to talk about today is talk about the patient eligibility and clinical trial considerations. So if you look at the tricuspid regurgitation currently in United States and in Europe, both places, if you have the prevalence of tricuspid regurgitation is very large. It is, it's close to 4 million people, and every year we identify about 300,000 patients. So out of the 300,000 patients, we are only having about 10,000 patients undergoing valve replacement or valve repair for these particular purposes. So this is a very small number considering the large number of patients that are available for tricuspid regurgitation. If you look at the tricuspid regurgitation, the most of the tricuspid regurgitation is functional tricuspid regurgitation, and the primary tricuspid regurgitation is rare. Important thing to understand about the tricuspid regurgitation is associated with worse outcomes in both kinds of patients with heart failure. So if you take the patients with reduced ejection fraction, and if you take the patients with normal ejection fraction, either of these two, either the HFpEF or HFrEF, both of them have a problem with tricuspid regurgitation. So this is very important information to keep in mind. If you look at the mitral regurgitation patients, so now not only heart failure patient, but also take the patients with mitral regurgitation, the outcome, meaning survival probability, is less in the patients who have tricuspid regurgitation. And as you can see, as the mitral regurgitation increases, the tricuspid regurgitation, the mortality increases. And if you add the tricuspid regurgitation to it, the mortality is very high. So this is an important information to keep in mind, that the tricuspid regurgitation is not benign. There are several new classifications to say that what is the correct way to say that what is a low risk, intermediate, and high risk just of the tricuspid regurgitation. So we are not talking about the surgical risk patient, but just tricuspid regurgitation itself. So if you have a large volume, so if you look at the high risk first, if you look at the large volume of tricuspid regurgitation, meaning that if you have the regurgitant volume of more than 45 ml, or your regurgitant fraction is more than 50%, then the mortality is almost 2.5 times higher. If you take the volume which is moderate, 3 to 44 ml per big, or 30 to 49% regurgitant fraction, then it's intermediate. And low risk is the patients who have lesser tricuspid regurgitation and regurgitant fraction is less. Now, there's another concept that has been very popularized in the recent times, and this is a nice paper to review, to say that what are the kind of patients that we want to enroll in the clinical trials. Because what is happening now is that the patients are presenting very late with tricuspid regurgitation, with ascites, with lot of RV dysfunction. And these patients sometimes are too far gone, and trying to replace the tricuspid valve sometimes is fairly dangerous, especially if the RV function is very reduced. So this is an important thing to keep in mind, that now what we have been able to do, as you see here in this particular slide, is that we can do the TAPSE and PASP ratio. So this is the baseline RV-PA coupling. So if you take the TAPSE divided by the peak systolic pressure of the pulmonary artery, and if that number is more than 0.40, remember the TAPSE normally is 16 and if it is 40, so this will be 0.4. This is what number is. So if the systolic pressure is less and the TAPSE is higher, then these are the patients who do better because they have a preserved RV function along with less of a RV dysfunction. If you look at this, the higher value versus the lower value of this coupling index, then the mortality of the patients, this is from the Tricuspid Valve Global Registry, TricValve Registry, you can see that the mortality is less in the patients who have a higher RV-RA coupling, RV-PA coupling, compared to those with lower value, which is this mortality. If you look at what happens once you treat these patients with the coupling, what happens to their coupling? So the patients who do better, so these are the blue are the patients who do better, and if you look at their coupling, so the TAPSE versus PASP decreased. Interesting. And then the TAPSE also decreased because you decrease the afterload, you increase the afterload, so that's why the TAPSE decreases, but the PASP increases, meaning the forward flow increases. So the TAPSE versus PASP will decrease. So this is a healthy response, somewhat of a healthy response to the treatment of the tricuspid regurgitation. And if you look at when the RV afterload is increased, because if you close the tricuspid regurgitation, and if the PA pressure does not increase and PA pressure also decreases, that means RV is failing. And those are the patients who don't do well, and they will have a decrease in the cardiac output rather than increase in the cardiac output with treating the tricuspid regurgitation. So this RV-PA coupling is an interesting concept, which is now more and more used to some extent to say that which patients we should enroll in what trials. Because if you are going to replace the tricuspid valve, you decrease the regurgitation suddenly. So you have a very high afterload afterwards. So patients who have a RV-PA coupling in the reverse way will not do well with this kind of a treatment. So this is an important thing to keep in mind, that how we select the patients. Now, when we design the trials, how are we going to design the trials? So this is a very common question that comes up, is to say that we are going to, so I'll show you that we have already finished the early feasibility trials. So now we are in the pivotal trial group. So we are no longer in the early feasibility group. So when we are doing a pivotal trials, we have to have a comparator group. If we are going to compare it, we have to compare it to the medical management. Because as you know, the surgical treatment for isolated tricuspid regurgitation, there is no class 1 indication for that. Only class 1 indication in the guideline for tricuspid regurgitation is when you are doing other surgeries on the left side. That's the only time we do tricuspid. That is the only class 1 indication. So if you are going to have a medical treatment, what is the medical treatment? And so medical treatment is diuretics, sodium restriction, and inotropes. So these are the only medical treatments that are shown to have some benefit. But again, we are not going to give people inotropes, and diuretics and sodium restriction is the only thing that we can use. I just want to show you one patient so we understand when we enroll the patient. This is a patient that was referred in 2004 for bypass surgery. And now this is the 2004 data. And as you can see, a very trivial tricuspid regurgitation, but dilated end. Now, if you look at 2005, the patient developed atrial fibrillation, and there is more tricuspid regurgitation. Of course, we didn't do anything at that time. Now, 2010, 5 years later, the tricuspid regurgitation is now significant. But the patient is not doing poorly. Patient does not have a right heart failure. There is a RV is dilated, functional class 2. and patient is doing okay. So again, we didn't treat this patient. And now in 2017, the patient has lower extremity edema, renal insufficiency, severe TR, and now this patient is referred to us for consideration of tricuspid valve therapy. This was in 2017. So my question is that at what phase should we treat this patient? When do we enroll these patients in the trial? This is a very difficult question. So guidelines, as I said, only green, which is a tricuspid valve repair or replacement, is with at the time of left-sided surgery. There is nothing to say that we should do something to the tricuspid valve based on the symptoms or otherwise as class 1 indication, because there is no data to say that surgery also helps these patients. So if you really look at the stages of tricuspid disease, to say the stage 1 where there's an annular dilatation, stage 2 where there's a TR with no clinical heart failure, and then stage 3 with the heart failure. This is the patient. Stage 3 patients are the patients that we are enrolling. But if you look at if you had to do study in the stage 1 or 2, as I said, we saw the patient first time in 2005 or 6, and now in 2017, or they are symptomatic. So we are not going to follow this patient for 10 years. So this is the challenge, that we will have to use some non-clinical outcomes if you are going to use these early patients, which is like CTSN trial that you know for the surgery, use non-clinical outcomes to say that how much TR it develops on the follow-up. But this, again, for the FDA approval trials, this is not possible. So first we have to have an approval of the device with the clinical outcomes. So that's where we have to have the stage 3 patients in the clinical trials. And now, once the devices are approved, we can maybe go to a stage 1 or stage 2 TR with relatively early stages of TR where the treatment is possible. And in these stages, we can use non-clinical outcome, meaning that RV remodeling or development of heart failure, hospitalization, or even the progression of TR. Heart failure readmission is going to be tough. So we have to have non-clinical outcomes. For tricuspid valve surgery as a comparator, as you know, this is not a good comparator because, you know, when you see the repairs with the tricuspid valve, there is severe recurrence of the tricuspid valve regurgitation. This is, of course, data from Cleveland Clinic. Several new therapies of the tricuspid valve treatment, as listed here, and you are going to hear about it in the next 2 presentations, the first about TEER and then the tricuspid valve replacement. I just want to highlight this. This is a simple thing, but the tricuspid valve registry, the TRI-valve registry, is a global registry. And if you go from 2014 to 16, then 16 up to 18, and then up to 20, what you see is that the MitraClip use is increasing. You know, the TEER is increasing. And if you look at all other things, they are not that significant, 17%. So all the major things are less and less. The CAVI has seen an increase in 2018 part. And if you look at all these different devices that you will hear about, these devices have all been tested in EFS. So there is 20, 30 patient studies in the early feasibility trial for the tricuspid valve repair. And the consistent message is that these therapies are safe and these therapies are feasible, but the response rate is in the 60 to 80%, depending on how you classify that. So if you say a significant reduction of TR, maybe not just 1 grade, then it is in that range. If you say 1 grade reduction of TR or heart failure by improvement by 1 grade, then it can be up to 80%, 85%. So the definitions are very important in terms of how we design the trials. This is replacement now. So that was all repair. This is replacement. So there is again early feasibility data. This is the Navigate valve that we developed in Cleveland Clinic, and the first in man was done in Cleveland Clinic. And if you look at this, you can see that the TR goes away. So this is the advantage of the tricuspid valve replacement, is that despite the pacemaker, despite everything, there is no TR at the end. This is difficult to achieve with a repair. And of course, you can do it from the neck. And as you can see, this is an excellent therapy if you are going to replace the tricuspid valve. These are the data from the Navigate valve. The TriSen, also similar. So this is again done in a beautiful delivery system. We have been using this now for the tricuspid valve replacement. Again, it comes in a size is a limitation because, you cannot treat currently very large dilated annuli. So, but again, you can treat the right kind of patients. You will have an incredibly safe procedure. Pacemaker rate is only 8%. Again, SN2, we are part of this study where we are enrolling patients randomized. So we are randomizing to the medical therapy, which is diuretics in these patients. Challenges are tremendous. Challenges are tremendous in the clinical trials because, how you select the patient. When you, as I said, if you're taking symptomatic TR patients, you are going to find patients which have a very large gap. It is very hard to clip them. Just the success is to say that only 1 grade reduction in TR. So if you go from torrential to 4+ or 4+ to 3+, again, this is not what patients are looking for. So this is a difficult thing to enroll these patients in. And size, as I said, is very important because most of these patients are too large annuli. So what is happening now is that there is an interest again in the heterotropic valve replacement, meaning the CAVI, putting the valves in the superior inferior vena cava, because as you say, there are favorable and unfavorable conditions for each of these trials that I have listed here. And pacemaker leads is another challenge. So trick valve, as you know, the bicaval CAVI system, these are the pre-mounted valves. You can put in superior inferior vena cava. Very simple procedure. So if you see this, you just put a wire and then inflate the just self-expanding stent, put the SVC, self-expanding stent in the IVC with a transthoracic echo. And both of these stents do not come out into the right atrium. So you don't eliminate any of the problems, any of the future options. So even though the patient has TR, the future, the kidney function improves, the edema improves, patients feel better. And then if you want to do something future to the tricuspid valve, you can still do it. Or if you try to do something to tricuspid valve and if they fail, like failed clips, you can definitely put this device, very simple thing to do. Conscious sedation, local anesthesia, no TE, just transthoracic echo. And so this system is now being used. As you know, that trial is completed in Europe and it will be published fairly soon. We are planning to do a pivotal trial in the United States by the end of the year. Dr. Rishi Puri working with me, and we are going to start this trial because this is another renewed interest in this particular group because we are only able to enroll 50-60% at the most of our patients who are referred for tricuspid regurgitation in clinical trials. So there is a large unmet need. It is evolving fast. Patient selection is the key to success. Patients should be treated early, but we don't have a mechanism to do that right now. And the comparative data on treatment modalities are limited because we are just doing one versus the other. Thank you for your attention, and it's a great pleasure to be part of your symposium.
Thank you very much, Professor Kapadia, for your lecture and all this new data you presented to us. I think there is already a question from the audience, and Dr. Patakos has the question.
Thank you very much, Dr. Kapadia, for being with us. It's a real pleasure. Greg Patakos, thanks for joining us, and thanks for your patience while we were a few minutes behind.
No problem.
It was a wonderful talk, but to me, it opens up a lot of questions. These patients, I'm a cardiac surgeon. A lot of times, if we see them early and they have no TR or other things are not going on, no one's going to take them to do a procedure. Sometimes they come to us and it's too late and we feel that the RV is burnt out. So really, what is your advice to the cardiologist in the community who's looking to you for the leadership to say, what's the sweet spot? When should we send them to you? And then my question is two-part, which is, okay, then you get them at that sweet spot. When the technology eventually evolves in 5 years, who do you think is going to be getting clips? Who do you think is going to be getting TMVR? Who do you think is going to be getting cable valves? And where is the role for surgery?
No, I know this is a very practical question, and I do agree and I appreciate your insight. So the first step is, that's why I presented in the beginning, that the TR is not a good news. So when the patients have even moderate TR, asymptomatic, this is the good time to refer the patient to the experts. The reason why, I know not that other people are not experts, but the idea is that we want to be able to identify the RV function, RV size. We want to follow the dilatation of the RV, and even some hemodynamic data can be very helpful to understand that this TR, which you see in the echocardiogram, is important to the patient or not. So the first step is that. So early referral is the most important message if I want to, and refer them to the structural team, surgeons, whatever it takes. So in your community or in your practice, whoever is the right expert of this particular area, you should refer them. The second question is that what do we do about these patients? If you are an expert and if you are getting these patients with 2+, 3+ TR, what I recommend to the patients, so first, number one, is to see that what is the etiology of this TR, right? So a proper echo, TEE, or sometimes MRI to quantitate the RV function, amount of TR, and sometimes hemodynamic studies to see the PA pressure, cardiac output. All of these things are very essential because at an early stage, right now, the treatment can be surgery. Because if the patients are referred early, the surgical risk is not so very high. Yeah. And these patients can potentially be treated if they are getting in trouble by other measures, other than having edema and ascites and liver failure. These patients can potentially be treated with surgery. So this is where the first step is. If they have primary TR, so many people with biopsies after whatever reasons, they have cardiac biopsies, they develop TR, or they have a trauma to the chest and they develop TR, or they have TR because of prolapse, tricuspid valve, like how the myxomatous mitral valve is. All of those patients, surgery is a very reasonable choice. Now, once we get to the level where we are going to treat these patients with moderate TR or severe TR, which is better? So should we do first the repair or we should do the replacement? Younger patients, repair like mitral valve is going to be helpful because the valve durability is a challenge. Valve durability is not going to happen. Whatever we say, the tricuspid valve is not going to last for a long time. Of course, they have valve-in-valve options and all those things, but this is a challenge. So I would suggest that we will have some kind of a repair happening first in the tricuspid technology. If you have repaired the valve, can you replace them? And there are also several new technologies happening to say that if you even had put clips, can you put a valve in, and potentially you can. So this would be my thinking, that it will be first repair, then replacement. CAVI valves, the superior inferior vena cava valves, are going to be only for the patients who do not have any other options. So this is not, of course, treating the tricuspid regurgitation. So if you are presenting very late to improve the renal function, this is what you will need.
Thank you. Thank you so much. Thanks for being with us.
Once again, thank you, Professor Capadi. It was a pleasure to be with us. And we move on to the next speaker. It's a video, it's a live box. He will be presented by Professor Sitges of the University of Barcelona. And the title is Tricuspid TR is sufficient for most patients. May we have the video, please?
Hello, my name is Marta Sitges and I am a cardiologist working in the University of Barcelona. I will discuss on the topic of tricuspid TR is sufficient in most patients with tricuspid regurgitation. As you well know, we have learned something about the tricuspid valve in recent years. Previously, tricuspid regurgitation and globally speaking, tricuspid valve disease was a neglected disease. But more recently, we have learned that this is indeed a prevalent disease involving elderly patients with comorbidities, and its prevalence is going to increase as of the aging of the population. Typically, these patients had a late surgical referral, and therefore they showed indeed a poor prognosis because of this disease and also because of the late referral of these patients for surgery. In recent years, there has been a complete change in the landscape of tricuspid regurgitation therapy, as many advances have been performed in the surgical field, but particularly in the transcatheter field by treating tricuspid regurgitation. The most experience comes, as you know, from the transcatheter edge-to-edge repair, which is a technique based on a catheter with a device that gets the leaflets of the tricuspid valve inside, mimicking the Clover technique or the Alfieri stitch surgically performed. Currently, there are 2 devices approved, the Pascal system and also the TriClip system from 2 different companies. Both of them, what they do, as said before, is they wrap the leaflets of the tricuspid valve inside so they can fix and they reduce tricuspid regurgitation. The first study to show the efficacy of one of these devices, the TriClip device, was the TruIlluminate study, which was a feasibility study with already 2 years follow-up reports, and showing that these patients, when they with severe tricuspid regurgitation, when they are treated with this therapy, they show significant reduction sustained at 2 years of the degree of tricuspid regurgitation. This is observed together with an improvement in the New York Heart Association functional class, and improvements also in the 6-minute walking test and also in quality of life reported by these patients. Another early feasibility study with the other available device, the Pascal system, was the CLASP study that showed exactly the same results with significant reduction at 6-month follow-up of tricuspid regurgitation, and also clinical improvements as determined by the improvement in New York Heart functional class, in the 6-minute walk test, and also in the quality of life scores. We have already experienced from real-world practice, and this comes mainly from the TriClip device, and experience from this shows also that the initial results of the TruIlluminate study were reproduced. So more than 90% of patients reduce the amount of tricuspid regurgitation. And again, this was observed together with an improvement in functional class, also in quality of life. But the most important thing is that, again, this therapy has shown a strong safety profile, as there are very, very few reported adverse events when using this therapy. So to sum up, TR is effective in reducing tricuspid regurgitation. This translates into clinical improvement and right ventricular reverse remodeling, with reduction in the number of hospitalization and potentially in improved survival of these patients that are indeed typically elderly patients with very increased surgical risk and increased comorbidities. And the good news also is that this therapy shows a very good safety profile. Currently, there are undergoing randomized studies comparing the efficacy or the added value of TR as compared to medical therapy, and we will have to wait to this, as I have said, currently ongoing studies to see these results. The important thing to apply this therapy is an adequate patient selection, and for that we have anatomical factors which include the etiology of tricuspid regurgitation, the geometry of the valve, of the tricuspid valve, with the size of the coaptation gap, the length of the leaflets and the flexibility and mobility of the leaflets, the number of leaflets, and particularly the indentations that exist in the leaflets of the tricuspid valve, and the origin of the jet. Of course, also there are clinical factors that influence the clinical response to this therapy, including the amount of tricuspid regurgitation, the status of the right ventricle, and particularly the presence of pulmonary hypertension, and also the presence of leads. Finally, imaging factors such as ensuring, as this is a completely imaging-based procedure, the quality of transesophageal echocardiography and transgastric views are essential also. With this, a classification has been proposed defining what would be the ideal patient with TR amenable to be treated with this therapy, and those patients with TR that should probably not be treated with this type of therapy, and those who can be considered but require further study or further experience. And typically, we have it has been proposed that the ideal patient is that patient with a perfect echocardiographic window, that patient with severe tricuspid regurgitation but not so severe, with dilated and mildly reduced right ventricular function, but not so enlarged right ventricle, and no pulmonary hypertension, and no leads with structurally normal leaflets, and particularly those with small coaptation gaps inducing this tricuspid regurgitation in valves with 3 leaflets. However, there are many patients that indeed are not in this group and also can be also considered to this therapy. And for that, indeed, with gaining more experience of operators, we have been learning that indeed, ideally, it's good to have both echocardiographic views, for example, to grasp, and a perfect echocardiographic window. But as you can see, we can do both graspings, both in the transesophageal views, or also, as you can see nicely in this video, nice graspings also using the transgastric view. So at least with more gain experience, we have learned that indeed with having at least one of the 2 windows might be enough in experienced hands. Of course, if any of them is available, the guiding of the procedure is going to be very tough. Here, massive or even torrential, but particularly massive, so 4 grade in a 5 grade scale of classification of TR. This therapy can be considered, and successful procedures can be performed, like this patient that showed this large piece here, vena contracta, with massive tricuspid regurgitation, which is not in the really on the ideal patient. But even with a large gap, we could perform this procedure, putting 2 clips and having very trivial residual tricuspid regurgitation. Also, the problem of leads has been discussed as a potential source of restriction of this therapy. And let me show this example. This was a patient with also severe massive tricuspid regurgitation who was wearing a pacemaker lead, but as you can see in this transgastric view, the pacemaker lead was located between the septal and the posterior leaflet, and indeed had nothing to do with the origin of the regurgitation of the tricuspid regurgitant jet, which was located between the septal and the anterior leaflet in the more close to the anteroseptal commissure. So this patient was successfully treated with 2 clips, and as you can see, tricuspid regurgitation was almost completely eliminated with just trace residual tricuspid regurgitation. Indeed, this is the experience that has been observed in the BRIGHT study, which is the observational study and the real-world practice registry for the 3-clip device, where a large number of patients have successful procedures even if they are wearing right ventricular leads. So only 6% of the patients had failed procedures of triclip implantation. Also, similar results have been observed even in a wide variability of annulus sizes. So that means that these, if we go to the right side of this graph, these are patients with very large annulus, so large coaptation gaps also. And even in this patient, the implantation of triclip device was successful in reducing tricuspid regurgitation. Finally, even we know this is data from the Leipzig group, where they show that patients with pulmonary hypertension, as shown in the dark blue line, had worse prognosis in terms of survival after triclip implantation as compared with those patients who had the same procedure but had no baseline pulmonary hypertension. However, they subanalyzed this group of patients with pulmonary hypertension, and even in those patients with pulmonary hypertension that, as you can see here in the red curve here, that had post-capillary pulmonary hypertension, even though in those the prognosis was not that bad. So when we are saying that we exclude pulmonary hypertension patients, we really need to further characterize them and to select those with post-capillary pulmonary hypertension who can indeed have not so bad prognosis and can be adequately treated by with this therapy, at least in those patients who have no other alternative. So, according to the observational studies, according to the real-world data that we have, I think that at this moment where we have gained more and more experience in this therapy, we can say that tricuspid TR is sufficient for most patients with tricuspid regurgitation. This is important to take into account that this is true when timely indication is followed. Of course, if the patient has a very, very advanced disease with very, very advanced right ventricular dysfunction, maybe the prognostic impact is much lower. What do we need for that? Indeed, what we need is enough flexible tissue in the tricuspid valve with enough tissue to grasp or to clasp into the device. And we are lucky here because in most patients, tricuspid regurgitation is functional disease. So there is very few patients with organic and primary involvement of the tricuspid leaflet. So it will depend mainly on the amount of the formation of the valve and the length of the leaflets and the presence of indentations, which in experienced hands can be also overcome. Of course, we also need experienced imagers who show us an adequate visualization of the tricuspid valve and can guide during the procedure. For that, it is of most important to have a systematic evaluation of the tricuspid valve and on the understanding the mechanism underlying the dysfunction of this valve. If we don't understand what's happening to this valve, we are going to be probably unable to treat it. And for that, definitely we need a dedicated team, both of imagers and interventional cardiologists or cardiac surgeons to treat these patients with this potential very successful therapy. Thank you very much for your attention. If you have any questions, I'd be happy to answer them on the email. Thank you very much.
We'll proceed next after this very nice overview of TR in real-world practice. We will have Dr. Modin present transcatheter tricuspid replacement, an upcoming contender.
Νομίζω δεν έχει εμφανιστεί αυτός, άρα πας στο
βίντεο. Βίντεο είναι.
Όχι, πας στο ταμπουρίνο.
Okay, we want to go with Do we have a video from Dr. Modine?
Good morning. I am Corrado Tamburino. Thanks to the organizers for inviting me to this very interesting meeting. My talk today will be on TAVI, low-risk patients and alternative access. I will be starting with the first slide showing where we stand and where we are moving. This is the trip of the TAVI. And down the west.
So we will proceed with our next speaker, Corrado Tamburino from University of Catania, who will address the issue of TAVI in low-risk patients and alternative access.
Good morning. I am Corrado Tamburino. Thanks to the organizers for inviting me to this very interesting meeting. My talk today will be on TAVI, low-risk patients and alternative access. I will be starting with the first slide showing where we stand and where we are moving. This is the trip of the TAVI, and now we are here in 2022, and thanks to the low-risk studies, we are allowed to perform a TAVI in many patients that till a few years ago were not possible to be treated with TAVI. And we will see which are the studies that allowed us to join this excellent result. But where we are going also is important. We are moving to asymptomatic aortic stenosis patients, moderate aortic stenosis, and very young patients, even though in US we are already at 65 years as cutoff for discrimination between TAVI and surgery in determined patients. What we see here is the result of the partner to TAVI low-risk patients that shows that there is a clear advantage in terms of 1 year all-cause mortality, stroke, and reosp for patients undergoing TAVI versus patients treated with surgery. So there is an advantage of TAVI versus surgery, and even if it is not significant, the same trend is shown in also in the Evolut platform trial that clearly show that there is an advantage of TAVI versus surgery. If we analyze and the granular some aspects and some points, we see that the age of the patient in these studies is very low and the STS score is very low as well. So thanks to these studies, we have a clear indication of the guidelines for the TAVI. You see here that for the first time, TAVI is recommended in older patients equal or over 75 years in class 1A. So regardless the risk profile, all patients that are 75 or more than 75 are good candidates for TAVI, that is preferred to surgery. And there are many other indications of patients where the discussion between surgeon and cardiologist and the heart team role is important in determining the choice of the patient. Another indication is for the patients that are asymptomatic. We have two kinds of asymptomatic patients. Patients asymptomatic with good ejection fraction. In this case, we have the progression of the disease, the severe calcification progression, the increase of BNP level is, or the very severe aortic stenosis that are markers for indication for TAVI, even though the patient is asymptomatic. And another indication is for patient with no symptoms, but initial LV dysfunction. In this case, we have another indication for going to TAVI. All other cases have to be discussed with the surgeon. So the role of the heart team is of paramount importance, as well as the role of the patient's consensus and the patient choice. So, first part of my talk is indication. In Europe, all patients over 75 are good candidates to TAVI, regardless the risk profile. All other patients are surgical patients at low risk for surgery or younger than 75. All other patients, even though younger than 75 but intermediate risk or with other comorbidities, are patients that should be discussed for TAVI or surgery according to the center options. Let's move to the access. The non-transfemoral access may be considered in patients that are inoperable or unsuitable for transfemoral TAVI. And when we have to evaluate an alternative access in two conditions: when we have the diseased iliofemoral access or when we have small iliofemoral vessels. In the first case, we can try to treat the disease affecting the vessels and to try to go, in any case, via transfemoral. But when we have small iliofemoral vessels, we need to evaluate an alternative access. The last therapy that has improved the rate and increased the rate of patients treated via transfemoral access, even in presence of diffuse disease, is the intravascular lithotripsy. Thanks to intravascular lithotripsy, we observed in the last year, and if you see in the left side, in the blue columns, you see that there is an increase in transfemoral TAVI, and in red column, you see that there is a parallel decrease in non-transfemoral TAVI, and there is an increase in intravascular lithotripsy-assisted TAVI in green columns. So the role of intravascular lithotripsy is very clear and has increased the role and the place of transfemoral access by reducing dramatically the alternative access that, in any case, remain an option. Which are the alternative access? We have many alternative access. You see in the right side of the slide how many access. We have 8 possibilities. But we know that some of these accesses are not as good as others. Let's start with transthoracic access, transapical and transaortic. In the TBT registry news, US registry, you see that the transapical access and the direct access, aortic access, decreased across the years. And in parallel, we had an increase in axillary, subclavian, carotid, and other access. This is important because it's the consequence of the higher mortality that we have observed in all cases treated via transthoracic approach. We know that the transfemoral approach, when compared with transapical approach, has shown a better outcome in terms of vascular complication, pacemaker, in terms of in-hospital mortality, kidney injury, and major complication. So this is very important. The transthoracic access should be avoided whenever possible. There is another access that is transclavian or axillary access that is very good because it's a similar from a technical standpoint to transfemoral access by using another access that can be adopted in conscious sedation, in surgical cut down, so also in general anesthesia in this case, and is very, I would say, accessible to the patient, feasible, especially in presence of a good vascular surgeon, and has shown similar complication and similar results, good results, similar to the transfemoral access. So it's something that we can use when transfemoral access is not suitable. Another access is the transcaval and transcarotid access. We are using even more than transaxillary and transsubclavian access, because our vascular surgeon prefers to use the transcarotid, especially the left carotid access. And when you have a surgeon that is used to the transcarotid surgery, this is a very good access. And there are some indications and contraindications that make this procedure very clear in terms of indication when the transfemoral access is not suitable. So we have the transfemoral first approach, transaxillary and transcaval and transsubclavian as a second approach. In this registry, the transcarotid access from the France study registry, you see that the procedural mortality is very low, 1%, and the rate of complication is really acceptable, as well as the survival at 1 year. That is similar to transfemoral access. If we move to larger numbers, we see that the transfemoral approach is the preferred approach in any case when compared with other accesses, but again, transsubclavian, transaxillary, and transcarotid approach are very good approaches with satisfactory results. The last is the transcaval. When we don't have any other possible access, we can go to the cava, inferior cava. We can cross the retroperitoneal space. We go with a wire into the descending abdominal aorta. We can capture a wire via, thanks to a loop catheter. And then once we have the lead across the aorta, we can go likewise a transfemoral approach using a vein instead of an artery. The only difference is that at the end of the procedure, we need to close the hole and the fistula between the abdominal aorta and ascending the inferior vena cava. And this can be performed thanks to the closure device. And at the end, the results are very good because we have a very low mortality, considering that these are very, very, very complex patients. We have a very low rate of bleedings. And the only concern we can have is the destiny, the fate of the transcaval access. And in this case, I tell you something that I didn't know before performing this procedure. We know that the pressure in the retroperitoneal space is very high, so there is no formation of retroperitoneal hematoma in case of minimal bleeding, residual bleeding or residual leaks, and there is no fistula between the descending aorta and the lower caval vein. So the results are very good across the time. We don't have a fear when we have some minimal residual leakage between the two major vessels, arterious and venous vessel in the abdominal aorta. So the take-home message is that the TAV is now recommended for patients starting from 75 years, regardless the risk profile, especially if transfemoral approach is feasible. The alternative access should be evaluated if transfemoral approach is not feasible and there is a high or intermediate risk, surgical risk. The preferred alternative access are the transcarotid, the transsubclavian approach that are the most used because they have similar results and outcome to the transfemoral access. The transcaval access is the last remaining access. When there are no other access, should be evaluated by a clear preparation, finding a good spot for the fistula, if possible, and requires an expertise for the surgeon and for the interventionalist in order to being able to treat any potential complications in case of vascular damage when there is some complication. But this is a very good procedure that has shown excellent results considering the very high risk profile of the patient. Thank you for your attention.
We have room for discussion, or not really?
Okay, on behalf of my co-chairman, Dr. Chrysoheris, we thank you all for your presence. I think that at the end of this roundtable, we all agree that tricuspid edge-to-edge repair is something anthropovetas is coming. And I guess that probably at the end of the summer, or at least before the end of the year, regulatory authorities in Greece will permit in very selected, limited number of very selected heart valve centers these procedures to be performed also in our country.
Κυρίες και κύριοι συνάδελφοι, καλησπέρα και εκ μέρους του συμπροέδρου μου, του καθηγητού κ. Ηλιόπουλου. Να συγχαρώ και να ευχαριστήσω για την εξαιρετική διοργάνωση για άλλη μια φορά του Transcatheter Heart Valves Greece, αυτή τη φορά 2022, τους διοργανωτές και ειδικότερα... Ωραία. Και ειδικότερα τον κύριο Σπάρια και τον κύριο Παδακό, και συμμετέχει, είναι μαζί μας διαδικτυακά και ο καθηγητής κ. Βαβαρανάκης. Να δώσω αμέσως το λόγο στον πρώτο μιλητή, μια που έχουμε ένα πολύ πυκνό session με 9 παρουσιάσεις μέσα στην επόμενη ώρα. Ο κύριος Καλατσής θα μας παρουσιάσει το πρώτο περιστατικό.
Καλησπέρα σας και από μένα. Να ευχαριστήσω την Οργανωτική Επιτροπή και το Προεδρείο για τη τιμητική πρόσκληση. Και, δεν ξέρω αν φαίνονται οι διαφάνειες.
Ναι, βεβαίως.
Ξεκινώντας το περιστατικό, θα αφορά μια γυναίκα ασθενή 83 ετών με ατομικό αναμνηστικό κολπικής μαρμαρικής και πολλαπλών νοσηλιών το τελευταίο εξάμηνο λόγω δύσπνοιας προσπαθίας. Προσήλθε σε εμάς λόγω σταδιακά επιδεινούμενης δύσπνοιας στη μικρή προσπάθεια και αναφερόμενης κελιακής συμφόρησης. Από την κλινική εξέταση, η ασθενής ήταν αιμοδυναμικά σταθερή, είχε διάταση των σφαγητίδων φλεβών με έντονο σφαγητιδικό σφιγμό, όπως βλέπουμε εδώ και στο βιντεάκι δεξιά. Το αναπνευστικό ψιθύριο ήταν φυσιολογικό άμφο. Είχαμε ολοστολικό φύσιμα ακουστό στο αριστερό χείλος του στέρνου, μόλις υποσημενόμενη ασκητική συλλογή, διατεταμένο ψηλαυτό ύπαρ, ενώ είχε απουσία ειδημάτων των κάτω άκρων. Στο καρδιογράφημα παρατηρήσαμε χαμηλά δυναμικά και ατελές μπλοκ δεξιού σκέλους, ενώ από την ακτινογραφία είχαμε αύξηση των δεξιών ορίων της καρδιακής σκιάς. Προχωρώντας στο διαθωρακικό υπέρηχο καρδιάς, βλέπουμε εδώ στην αριστερή επιμήκη παρασθενική τομή, αριστερή κοιλία φυσιολογικών διαστάσεων με διατηρημένη σπαστικότητα, ενώ η δεξιά κοιλία είναι διατεταμένη. Στην τομή των 4 κοιλωτήτων, οι δεξιές κοιλώτες είναι διατεταμένες, η κορυφή της καρδιάς σχηματίζεται ουσιαστικά από την δεξιά κοιλία. Παρατηρούμε μικρή περικαρδιακή συλλογή πέριξ του δεξιού κόλπου και παράδοξη κίνηση του μεσοκολπικού διαφράγματος προς τα αριστερά. Και ακολούθως, εφαρμόζοντας έχρωμο Doppler, βλέπουμε ότι υπάρχει μια σοβαρού βαθμού ανεπάρκεια τριγλόχινας βαλβίδας. Εφαρμόζοντας συνεχές Doppler στη διατριγλοχνική ροή, παρατηρούμε πυκνό τριγωνικό σχήμα, ενώ η διαστολική πίεση της πνευμονικής αρτηρίας, στη δεξιά εικόνα βλέπουμε ότι είναι περίπου κοντά στο 24. Και ακολούθως, εκτιμώντας τη συστολική μετατόπιση του τριγλοχνικού δακτυλίου και το ιστικό συστολικό κύμα της δεξιάς κοιλίας, βλέπουμε ότι είναι οριακά διατηρημένη η λειτουργικότητα της δεξιάς κοιλίας και από την υποξεφοειδική τομή η κάτω κύλη φλέβα είναι διατεταμένη χωρίς αναπτυκτική διατικήμανση, με ιστολική αναστροφή στις υπατικές φλέβες. Ακολούθως, οι ασθενείς μας υπευλήθη σε αριστερό και δεξιό καθετηριασμό, όπου τα στεφανία αγκία ήταν χωρίς στενώσεις, ενώ βλέπουμε από τις αιμοδυναμικές μετρήσεις ότι στην διαστολική φάση έχουμε εξίσωση των πιέσεων στην δεξιά και στην αριστερή κοιλία, μια εικόνα ψευδοπεριοριστικού προτύπου, που πιθανότατα οφείλεται στη μεγάλη διάταση της δεξιάς κοιλίας, η οποία εξαντλεί τις εφεδρείες του περικαρδίου. Εδώ βλέπουμε στο δεξί κόλπο υψηλό κύμα V και προχωρώντας, ακολουθώντας τον αλγόριθμο της διαχείρισης της ανεπάρκειας τριγλόχινας, όπως αυτός προτείνεται στις τελευταίες κατευθυντήριες οδηγίες από την Ευρωπαϊκή Καρδιολογική Εταιρεία, βλέπουμε εδώ ότι η ασθενής μας δεν είχε στεφανία νόσου, ήταν δευτεροπαθής αιτιολογίας η ανεπάρκεια της τριγλόχινας, συνήθως πρωτοπαθής είναι η συγγενής ή η Epstein ανομαλία. Είχε διατηρημένη συσπαστικότητα της δεξιάς κοιλίας, ήταν συμπτωματική, οπότε καταλήγουμε στον αλγόριθμο, κατόπιν εκτίμησης και από την ομάδα καρδιάς στο νοσοκομείο μας, ότι η σύσταση ήταν να υποβληθεί σε διακαθετηριακή επιδιόρθωση της ανεπάρκειας της τριγλόχινας. Και έτσι και έγινε, εμφυτεύτηκε επιτυχώς ένα TriClip XT. Εδώ βλέπουμε μια εικόνα κατά τη διάρκεια της επέμβασης που έχει εμφυτευτεί το TriClip και στην επανεκτίμηση στον μήνα βλέπουμε βελτίωση των διαστάσεων των δεξιών κοιλωτήτων και βελτίωση και της ανεπάρκειας της τριγλόχινας. Και καταλήγοντας, πρόσφατα η διαδρομική επιδιόρθωση της τριγλόχινας, η επιδιόρθωση από άκρο σε άκρο, συμπεριλήφθηκε για πρώτη φορά και στις κατευθυντήριες οδηγίες της Ευρωπαϊκής Καρδιολογικής Εταιρείας. Πιο δύσκολη τεχνικά είναι όταν το gap είναι μεγαλύτερο από 1 εκατοστό και μετά από πετυχημένη εμφύτευση TriClip παρατηρούμε συχνά αναδιαμόρφωση της δεξιάς κοιλίας, βελτίωση της φυσιολογίας και κλινικοεργαστηριακή βελτίωση του ασθενούς μας. Ευχαριστώ πολύ.
Ευχαριστούμε, κύριε Καλατζή. Να σας συγχαρούμε για το πρωτοποριακή για την Ελλάδα αυτή επέμβαση, από τις λίγες που έχουν γίνει στη χώρα. Ακούσαμε εκτεταμένα το θέμα στο προηγούμενο 2ωρο, αλλά σαφέστατα και το να ακούμε την ελληνική εμπειρία είναι εξαιρετικά ενδιαφέρον. Πόσες περιπτώσεις έχετε κάνει τέτοιου είδους και τι follow-up έχετε μέχρι τώρα, μπορείτε να μας πείτε?
Η επέμβαση αυτή πραγματοποιήθηκε στο Ιπποκράτιο από τον καθηγητή τον κύριο Τσιούφη. Συμμετείχε η κυρία Αγγέλη. Ήταν η πρώτη εμφύτευση που έγινε στο νοσοκομείο μας και είναι το follow-up αυτό μετά από 1 μήνα ακριβώς.
Σε 1 μήνα. Άρα ένα περιστατικό έχετε κάνει.
Είναι το πρώτο περιστατικό.
Ωραία. Αν δεν υπάρχει κάποιο σχόλιο, ευχαριστούμε πολύ. Να δώσω το λόγο στην πρόεδρο, τον κύριο Βουρανάκη, να εισάγει το επόμενο μιλήτρια.
Εξαιρετικά το προηγούμενο περιστατικό, αλλά και τώρα η κυρία Δρακοπούλου με μεγάλη εμπειρία θα μας δώσει το περιστατικό που αφορά την διακαθετηριακή τοποθέτηση, αντικατάσταση μέσω της διακαθετηριακής, προφανώς θα είναι mitral clip, σε έναν ηλικιωμένο και μη χειρουργήσιμο ασθενή. Δεν ξέρω αν είναι το case 2, μάλλον δεν έχει τίτλο, έτσι. Κυρία Δρακοπούλου, βλέπω δεν έχω τίτλο εγώ. Δεν ξέρω αν είναι αυτός ή είναι του case. Μπορείτε να μας διευκολύνετε, γιατί δεν βλέπω. Λέω ένα case 2 μόνο.
Κάντε unmute, κυρία Δρακοπούλου.
Κυρία Δρακοπούλου, μ' ακούτε?
Ναι, σας ακούω.
Βλέπω ότι θα μας μιλήσετε για κάποιο περιστατικό. Πραγματικά και η εμπειρία σας είναι μεγάλη στην απεικόνηση. Λέει case 2, δεν έχω τίτλο.
Ναι, ναι, κύριε καθηγητά. Καταρχήν να ευχαριστήσω και εγώ με τη σειρά μου την Οργανωτική Επιτροπή για τη συμμετοχή σε αυτό το εξαιρετικό συνέδριο. Θα παρουσιάσουμε ένα περιστατικό από την Α Καρδιολογική Κλινική και την ομάδα του κυρίου Τούτουζα. Δεν ξέρω αν βλέπετε την πρώτη μου διαφάνεια. Πρόκειται για μία ασθενή στην οποία προχωρήσαμε για...
Κάντε share screen, κυρία Δρακοπούλου.
Πρέπει να κάνει share screen. Και full screen, ναι.
Τέλεια. Ωραία, ευχαριστώ πολύ και πάλι να ευχαριστήσω. Θα προχωρήσουμε λοιπόν στην παρουσίαση ενός περιστατικού. Μία ασθενή 53 ετών, η οποία προχώρησε σε διακαθετηριακή τοποθέτηση τριγλόχινας βαλβίδας, όπως θα δούμε στη συνέχεια. Πρόκειται λοιπόν για μία ασθενή 53 ετών, η οποία προσήλθε στην κλινική μας με προοδευτικά επιδεινούμενη δύσπνοια και αμφωτερόπλευρα ειδήματα κάτω άκρων. Από το ιστορικό της, το 1997 η ασθενής διαγνώστη με CA μαστού, οπότε και χειρουργήθηκε με μαστεκτομή, υποβλήθηκε και σε χημειοθεραπεία αλλά και σε θεραπεία με ακτινοβολία και εν συνεχεία το 2018, πιθανώς λόγω της ακτινοθεραπείας, παρουσίασε 2 βαλβιδοπάθειες, μεικτή νόσο μητροειδούς αλλά και σοβαρή ανεπάρκεια τριγλόχινας, για τις οποίες υποβλήθηκε σε χειρουργική αντικατάσταση μητροειδούς βαλβίδας με τοποθέτηση μεταλλική Σαντζούτ 23 mm και ταυτόχρονα έγινε και διόρθωση της τριγλόχινας βαλβίδας με τοποθέτηση δακτυλίου, όπως βλέπουμε εδώ, ένα δακτύλιο Edwards Physio μεγέθους 28 mm. Μετέπειτα το 2021 παρουσίασε, όπως βλέπετε, και περιφερική αγκιοπάθεια και υποβλήθηκε σε αγκιοπλαστική της αριστερής μυριάς αρτηρίας. Βλέπουμε εδώ ότι στην πρώτη της εκτίμηση στην καρδιολογική κλινική η ασθενής ήταν σε φουροσεμίδι των 40 mg με 3 φορές ημερησίως, πυρονολακτρώνη 25 mg μία φορά ημερησίως, ήταν σε β' μπλόκερ, έπαιρνε κουμαρινικά αντιπικτικά λόγω της μεταλλικής βαλβίδας και ταυτόχρονα ήταν και σε κλοπιδογρέλη των 75 mg. Η ασθενής λοιπόν παρουσίαζε τους τελευταίους 2 μήνες, όπως ανέφερε, σταδιακή αύξηση του βάρους της, είχε πάρει 25 κιλά, ήταν ειδηματώδης, ήταν σε πολύ πτωχό λειτουργικό στάδιο, κατά νάιχα 3 και είχε εκτεταμένα ειδήματα κάτω άκρων. Αιμοδυναμικά σταθερή με οριακές πιέσεις, όπως βλέπετε, καλές φίξεις, 60 με 70 φίξεις και από το καρδιογράφημα είχε φλεβοκομικό ρυθμό και ατελές δεξί μπλοκ. Από τις εργαστηριακές εξετάσεις βλέπουμε ότι είχε νεφρική ανεπάρκεια, μια κρατηρίνη στο 2,2 και ταυτόχρονα παρουσίαζε πολύ χαμηλό νάτριο, υπονατριεμέ 119 νάτριο ορού, ενώ είχε και παράταση του χρόνου ΕΝΑΡ, βέβαια ήταν και σε αντιπικτική αγωγή. Εδώ είναι η διαφορακική μελέτη, βλέπουμε από την παραστερνική τομή μια καλώς λειτουργούσα μεταλλική βαλβίδα στη θέση της μητροειδούς. Η αριστερή κοιλία είναι φυσιολογικών διαστάσεων με ικανοποιητική συσπαστικότητα, ένα κλάσμα που θα δούμε 50%. Η αορτική βαλβίδα είναι καλώς λειτουργούσα, ενώ ήδη φαίνεται η διάταση της δεξιάς κοιλίας, η οποία έχει μετρίως επηρεασμένη συστολική απόδοση. Από την τομία RV Inflow βλέπουμε ότι υπάρχει σημαντική δυσλειτουργία της τριγλόχινας με σημαντική ανεπάρκεια ορτοποίηση σήματος, αλλά και ταυτόχρονα μια διαβαλβιδική κλίση πίεσης. Και από το σορτάξις βλέπουμε συστολική και διαστολική επιπέδωση του μεσοκυλιακού όσο επιφόρτης της πίεσης και όγκου. Ένα τάψε υπολογιζόμενο στο 18 και βλέπουμε ότι το TDIS ήταν 10,5, διάταση της δεξιάς κοιλίας από την 4 κιλοτήτων 48 mm. Συζητήθηκε η ασθενή στο χάρτη, γιατί όπως βλέπουμε δεν απέδωσε η ενδοφλέβια διουρητική αγωγή. Ταυτόχρονα χορηγήθηκαν και ινότροπα για να ενισχύσουμε την συσπαστικότητα της δεξιάς κοιλίας, χωρίς όμως να έχουμε πολύ καλό αποτέλεσμα όσον αφορά το κλινικό στάτους της ασθενούς. Το χάρτη λοιπόν κρίθηκε υψηλού διαχειριστικού κινδύνου με ένα Euroscore 21,78. Ταυτόχρονα ήταν και μια ασθενής η οποία είχε ακτινοβοληθεί στο θώρακα, οπότε προχωρήσαμε στην πρόταση για να γίνει διακαθετηριακή τοποθέτηση valve ring στην τριγλόχινα. Και να σημειώσω ότι ο δακτύλιος ο οποίος έφερε η ασθενής ήταν, όπως βλέπετε, ένας ημιτελής δακτύλιος, semi-rigid δακτύλιος, ο οποίος, όπως θα δούμε, έχει αρκετές προκλήσεις όσον αφορά την τοποθέτηση. Η ασθενής υποβλήθηκε στο screening στον στεφανιογραφικό έλεγχο που δεν ανέδειξε σημαντικές στενώσεις, ενώ έδειξε και ο δεξιός καθητηριασμός ότι είχε μια wedge pressure γύρω στο 25. Βέβαια, η ασθενής ταυτόχρονα ήταν και σε απορρίθμιση σε εκείνη τη φάση. Έγινε λοιπόν optimization της ασθενούς, ταυτόχρονα έγινε και screening με αξονική καρδιάς για να υπολογίσουμε ουσιαστικά το μέγεθος του δακτυλίου και την επιλογή της βαλβίδας. Βλέπουμε ότι η μέγιστη διάμετρος ήταν 28,8 και έτσι έγινε επιλογή να προχωρήσουμε στην τοποθέτηση MyValve, που είναι μια balloon expandable valve, και βάσει της αξονικής αλλά και των μετρήσεων με το διεσοφάγιο προχωρήσαμε σε επιλογή 29 mm βαλβίδας. Εδώ βλέπουμε τους προβληματισμούς. Σίγουρα διαπεμβατικά υπάρχει ανησυχία για ουσιαστικά injury, βλάβη της δεξιάς στεφανίας με την έκπληξη της βαλβίδας. Υπάρχει ο προβληματισμός όσον αφορά τη βλάβη του bundle of his με την έκπληξη της βαλβίδας και να κάνει ασθενής πλήρη κορποκυλιακό αποκλεισμό. Προβληματισμός όσον αφορά την τοποθέτηση του βηματοδότη διαπεμβατικά. Όλα αυτά λοιπόν οι προβληματισμοί που τίθενται εδώ συζητήθηκαν προεπεμβατικά. Αποφασίστηκε να γίνει balloon inflation test για να δούμε αν συνεχίζει η ροή στη δεξιά στεφανία αρτηρία, να τοποθετήσουμε προσωρινό βηματοδότη στο coronary sinus και βέβαια η επέμβαση έγινε με γενική αναισθησία και ταυτόχρονα διεσοφαγική παρακολούθηση, ενώ υπήρχαν ταυτόχρονα stand-by και η χειρουργία για οποιοδήποτε ενδεχόμενο. Εδώ λοιπόν βλέπουμε έγινε η τοποθέτηση του προσωρινού καλωδίου του βηματοδότη από αριστερή υποκλείδιο φλέβα. Βλέπουμε από τον κύριο Σιδερή έγινε σκιαγράφηση του coronary sinus, το οποίο είναι και anatomic mark για να δούμε όσον αφορά και την θέση του σε σχέση με την τριγλόχυνα βαλβίδα. Ενώ στη συνέχεια προχωρήσαμε στο balloon inflation test και ταυτόχρονα έγινε έγχυση στη δεξιά στεφανία για να δούμε ότι πράγματι δεν υπάρχει πρόβλημα όσον αφορά την στεφανία ροή. Ταυτόχρονα με το balloon inflation test, με το διεσοφαγικό επιλογογράφημα, είδαμε τη θέση ουσιαστικά του μπαλονιού και ότι δεν υπάρχει υπολοιπόμενη ανεπάρκεια μετά το τέλος του inflation test. Βλέπουμε λοιπόν ότι έγινε η προώθηση ουσιαστικά ενός stiff σύρματος Ablat's wire stiff στην δεξιά πνευμονική αρτηρία. Βλέπουμε ότι ο στόχος είναι να τοποθετηθεί το σύρμα εντός του δακτυλίου της τριγλόχυνας και όχι στο σημείο το οποίο υπάρχει το έλλειμμα του δακτυλίου, να κεντραριστεί δηλαδή το σύρμα εντός του δακτυλίου και συνέχεια γίνεται αργά με μικρή βηματοδότηση, ήπια βηματοδότηση, ουσιαστικά η έκπληξη της βαλβίδας και ταυτόχρονα διεσοφαγική παρακολούθηση όπως βλέπουμε εδώ. Εδώ βλέπουμε την τελική έκπληξη της βαλβίδας, είχε ένα πολύ καλό αποτέλεσμα. Βλέπουμε πόσο σωστά λειτουργούν οι γλοχίνες της βαλβίδας. Δύο πολύ μικρές, μόλις αποσημενόμενες παραβαλβιδικές ανεπάρκειες και ένα πολύ ικανοποιητικό αποτέλεσμα και με την τρισδιάστατη απεικόνηση. Εδώ είναι το διαφορετικό υπηρεχογράφημα μετά την επέμβαση. Βλέπουμε ότι έχουμε ένα πολύ καλό αποτέλεσμα, χωρίς υπολοιπόμενη ανεπάρκεια και χωρίς να παρουσιάζει βαλβίδα στενοτικά φαινόμενα. Να πούμε ότι η ασθενής εισήχθη ουσιαστικά στο αιμοδυναμικό εργαστήριο σε optimized conditions, είχε γίνει πολύ καλή διούρηση, προετοιμασία με δοβουταμίνη προεπεμβατικά και μετέπειτα έγινε πολύ σωστό monitoring και έγινε και ενίσχυση της ασθενούς με όγκο, ούτως ώστε να βοηθήσουμε τη δεξιά κοιλία και να μπορέσει να ανακτήσει ουσιαστικά τη σπαστικότητά της. Να πούμε ότι έχουμε 6 μήνες follow-up αυτή της ασθενούς. Βλέπουμε ότι η δόση του φουροσεμίδης μειώθηκε σε 2 ταμπλέτες ημερησίως. Αυτή είναι η φαρμακευτική της αγωγή. Το λειτουργικό στάδιο είναι πλέον 1. Η ασθενής ουσιαστικά επανέλθει στο σωματικό της βάρος. Έχει χάσει περίπου 25 κιλά σε 6 μήνες και βλέπουμε ότι πλέον έχει βελτιώσει πάρα πολύ τα εργαστηριακά της, τόσο την νεφρική λειτουργία όσο και τον άτριο του ορού. Κλείνοντας, τα learning points είναι ότι ουσιαστικά η διακαθητηριακή τοποθέτηση valve ring στην τριγλόχυνα υπάρχει μικρή εμπειρία. Φαίνεται από κάποια case reports και μικρές σειρές ασθενών ότι είναι εφικτή. Υπάρχουν έντονοι προβληματισμοί όσον αφορά το μέγεθος της βαλβίδας, τον τύπο του δακτυλίου, το αν είναι rigid ή semi-rigid. Συνήθως οι δακτύλοι στην τριγλόχυνα είναι δακτύλοι οι οποίοι είναι ανοιχτοί. Προβληματισμός όσον αφορά την εμβολή της βαλβίδας, το να παρουσιάσει ο ασθενής para-annular leak ή και διαβαλβιδικό leak αν η βαλβίδα παρεκτοπιστεί προς το έλλειμμα του δακτυλίου και βέβαια θα πρέπει να υπάρχει πολύ εκτενής προεπεμβατικός έλεγχος και ένα πολύ οργανωμένο team και διεπεμβατικά για την υποστήριξη των ασθενών αυτών. Ευχαριστώ πολύ.
Ευχαριστούμε πολύ Μαρία. Εξαιρετική παρουσίαση, πολύ μεθοδική. Νομίζω ότι έθιξες όλα τα σημεία που θα μπορούσαν να δημιουργήσουν προβλήματα, έκανες τον έλεγχο στη στεφανιαία. Εγώ θα ήθελα να ρωτήσω, υπάρχει κάποιος δακτύλιος που, δεν ξέρω, είναι και ο χειρουργός, ο κύριος Ηλιόπουλος, που θα έδινε μεγαλύτερη αστάθεια, απλώς ονομάζοντας ημιρίζητη μη ανοιχτός, που δεν θα συνιστούσαμε να κάνουμε αυτή την επέμβαση? Αν φυσικά υπάρχει εμπειρία και αν μπορείς να το απαντήσεις, γιατί καταλαβαίνω ότι είναι και χειρουργικό λιγάκι το ερώτημα.
Εγώ να πω ότι εμείς έχουμε μικρή εμπειρία, να πω ότι αυτό είναι το πρώτο περιστατικό ουσιαστικά που είναι valve in ring. Έχουμε κάνει τοποθέτηση valve in valve στη τριγλόχυνα. Αυτό είναι ακόμα πιο challenging case. Από τη βιβλιογραφία αυτό που θέλω να πω είναι ότι περιγράφονται επιπλοκές σε αυτές τις περιπτώσεις και μάλιστα επιπλοκές όσον αφορά και το έλλειμμα που παρουσιάζουν οι δακτύλοι αυτοί, γιατί μπορεί να παρουσιάσουν ασθενείς παραβαλβιδική, παράνουλαρ, που ουσιαστικά ανεπάρκει από το σημείο του ελλείμματος. Και έχω δει βιβλιογραφικά ότι μπορεί να παρέμβουν και να το διορθώσουν με τοποθέτηση occluder device. Τώρα οι δακτύλοι έχουν μεγάλη ποικιλομορφία, πράγματι νομίζω η χειρουργία είναι πιο ειδική. Υπάρχουν όμως semi-rigid, rigid και βέβαια το πλεονέκτημα του να είναι rigid ο δακτύλιος είναι ότι έχει καλύτερο anchoring η βαλβίδα, αλλά δεν έχει τόσο καλή προσαρμογή όσον αφορά το valve shape. Αυτά έχω διαβάσει από τη βιβλιογραφία και νομίζω ότι ίσως μπορεί περισσότερο να πει ο κύριος Ηλιόπουλος.
Μανώλη και Μαρία, πρώτα απ' όλα να ξεκαθαρίσουμε ένα θέμα. Κάθε δακτύλιος, είτε είναι semi-rigid, είτε είναι rigid, μετά από 3 μήνες μέσα στον ανθρώπινο οργανισμό ουλοποιείται. Οπότε είναι rigid. Έτσι να το θεωρείτε αυτό ότι δεν έχουμε διαφορετικές, ας το πω, αντιδράσεις στο υλικό. Αυτό που είναι δεδομένο είναι ότι στην θέση της τριγλόχυνος οι δακτύλοι αναγκαστικά λόγω της ανατομίας δεμάτιο, coronary sinus, έτσι έχουν άνοιγμα, δεν είναι πλήρης δακτύλοι. Και αυτό είναι πιθανώς ένα πρόβλημα που υπάρχει στην τοποθέτηση. Και το εντυπωσιακό είναι ότι πώς εκφυλίστηκε για μένα τόσο γρήγορα αυτή η διόρθωση της τριγλόχυνος, και το ερωτηματικό είναι τι γίνεται αν έχουμε και ένα ηλεκτρόδιο εκεί. Καταλαβαίνεις τι εννοώ, δυσκολεύουν πολύ τα πράγματα.
Ναι, μετά είναι τρασάπικα, ίσως ξανατοποθέτηση, έχει πολλές δυσκολίες. Κάνανε μια σωστή επιλογή εδώ και πήγανε από το Στεφανείο κόλπο για να αποφύγουν την δίωδο, άρα νομίζω το αντιμετώπισαν σωστά.
Σωστά.
Να προχωρήσουμε, Δημήτρη, δεν ξέρω.
Ναι, να προχωρήσουμε.
Ευχαριστώ πολύ.
Να προχωρήσουμε με τον κύριο Λεοντιάδη, που είναι εδώ, με την περίπτωση της μητροειδούς στους ηλικιωμένους, σε έναν ασθενή που ήταν αδύνατο να χειρουργηθεί, υψηλού χειρουργικού ρίσκου. Καλησπέρα.
Συγγνώμη, έγινε. Καλησπέρα κύριε Πρόεδρε, ευχαριστώ την Οργανωτική Επιτροπή και κυρίως τον δάσκαλό μου, τον κύριο Σπάρια, που ξεκίνησε τα διακαθητηριακά στον Άσο πριν μερικά χρόνια, αρκετά χρόνια. Πρόκειται για μια ασθενή 81 ετών, γυναίκα με υπέρταση, δυσλιπιδεμία, χρόνια κολπική μαρμαρική. Είχε υποβληθεί το 2005 σε αντικατάσταση της αορτικής βαλβίδας με μηχανική βαλβίδα και 9 χρόνια μετά είχε μια γνωστή διεγχειρητική, μετεγχειρητική μάλλον φίστουλα μεταξύ του δεξιού κόλπου του Βαλσάλβα και της δεξιάς κοιλίας, η οποία της προκαλούσε δύσπνοια, πνευμονική υπέρταση και αναγκαστήκαμε να τη διορθώσουμε με ένα occluder, PDA occluder. Ήταν σταθερή και τα επόμενα χρόνια ξεκίνησε να έχει σοβαρού βαθμού ανεπάρκεια στην μητροειδή βαλβίδα, με αποτέλεσμα τα τελευταία χρόνια να μπαίνει στο νοσοκομείο. Είχε κάνει 2-3 νοσηλίες το τελευταίο εξάμηνο έως 9 το τέλος του τελευταίου χρόνου, με ορθόπνοια, νυχτερινή παροξυσμική δύσπνοια. Βλέπουμε έχει ένα ψηλό BMP και ψηλές δόσεις διουρητικών, οι οποίες τη βοηθούσαν να σταθεροποιηθεί, αλλά μετά από λίγο καιρό ξανά νοσηλευόταν στο νοσοκομείο. Αυτό είναι το διαθωρακικό υπερηχογράφημά της. Βλέπουμε ένα καλό κλάσμα εξώθηση στην αριστερά κοιλία, χρόνια κολπική μαρμαρική. Ίσως υπάρχει και μια συνιστόσα από άτρια λεμάρ σε αυτή την παθολογία της βαλβίδος. Επειδή έμπαινε στα νοσοκομεία, είχε πνευμονική υπέρταση, σοβαρό βαθμό ανεπάρκεια στην μητροειδή βαλβίδα, έγινε συζήτηση με το heart team Μάλλον ήταν υψηλού κινδύνου για ριντού επανεπέμβαση στη μητροειδή βαλβίδα με ένα ψηλό Euroscore και Euroscore 2, όπως βλέπετε. Μάλλον ήταν ακατάλληλη για edge-to-edge θεραπεία. Θα δείξω και παρακάτω γιατί είχε και ασβέστιο στην οπίστια γλοχίνα της μητροειδούς βαλβίδας, η οποία ήταν μικρή σε μήκος, και ασβέστιο του δακτυλίου, και προχωρήσαμε σε screening για διακαθιδριακή αντιμετώπιση της μητροειδικής ανεπάρκειας με μια χειρουργική βαλβίδα Tendyne, και βλέπουμε εδώ πέρα το screening. Πάνω δεξιά βλέπουμε αυτό που σας είπα, το ασβέστιο του μητροειδικού δακτυλίου, μικρή σε μήκος η οπίστια γλοχίνα, πρόλαψη της πρόσθετης γλοχίνας, το τμήμα Α2, με σοβαρό βαθμό ανεπάρκεια στην βαλβίδα. Στο 3D πάλι βλέπουμε το πρόλαψη της πρόσθετης γλοχίνας και το jet που κατευθύνεται στην οπίστια γλοχίνα. Κάναμε και στεφανιογραφία. Βλέπουμε εδώ πέρα στο κίτρινο βέλος στο κλούντερ τη μηχανική βαλβίδα. Δεν είχε στεφανία νόσο. Πνευμονική υπέρταση, όπως είπα. Ένα ψηλό κύμα β συμβατό με σοβαρή ανεπάρκεια μητροειδούς βαλβίδας. Και στα screening έγινε αξονική, όπως γίνεται για τη θέση της μητροειδούς. Βλέπουμε το νέο ελβότ, όπως αυτό υπολογίστηκε, όσο μπορούσε να αποκλείσει ότι θα υπήρχε απόφραξη στο χώρο εξόδου. Βλέπουμε κάτω αριστερά η περίμετρος, μάλλον η επιφάνεια ήταν 330 τετραγωνικά χιλιοστά. Ήταν αρκετά μεγάλος ο υπολογιζόμενος νέος LVOT. Και ένα simulation από την εταιρεία και αυτό, το οποίο δείχνει ότι δεν προκαλείται μεγάλο βαθμό απόφραξη στο χώρο εξόδου της αριστεράς κυκλίας μετά την επικείμενη τοποθέτηση της βαλβίδας. Και η εταιρεία, με βάση όλα αυτά τα στοιχεία που μαζεύει, δίνει ποιο νούμερο βαλβίδας ή ποιο θα βάζαμε στην ασθενή μας. Αυτή ήταν για το 33S, αυτό που έχει το standard profile. Το σύστημα Tendyne, όπως είπε το πρωί ο κύριος Περέας, είναι ένα σύστημα 36 French μεγάλο. Αυτή τη στιγμή τοποθετείται με transapical μέθοδο. Στο αιμοδυναμικό μετράμε τις διαστάσεις από την κορυφή της καρδιάς, κάνουμε διαθωραϊκό υπέρηχο, όπου ο χειρουργός θα έχει το transapical axis. Βλέπουμε δεξιά ότι είναι διαφορετική η κορυφή της καρδιάς από το πραγματικό access site, και αυτό είναι γιατί πρέπει το trajectory να είναι ακριβώς κάθετο προς το επίπεδο του μητροειδικού δακτυλίου, και αυτό αποφασίζεται και αυτό με το simulation της εταιρείας. Έτσι λοιπόν μπαίνει ένα θικάρι 8 French μετά από την θωρακοτομία από τους καρδιοχειρουργούς. Προωθείται ένα σύρμα από την κορυφή της αριστεράς κοιλίας διαμέσου της μητροειδούς στον αριστερό κόλπο. Γίνεται flossing του μπαλονιού με ένα swan guns καθετήρα. Το ανεβοκατεβάζουμε πάνω κάτω για να δούμε ότι δεν έχει μπλεχθεί στη στενότητα της χορδές και θα μπορέσει να ανέβει η βαλβίδα. Αυτό είναι πάλι το ίδιο. Βλέπουμε εδώ πέρα το μπαλόνι του swan guns. Αυτά είναι τα χέρια του κυρίου Περέα. Το swan guns με το σκιαγραφικό, το ανεβάζουμε πάνω κάτω για να δούμε αυτό που είπα προηγουμένως. Τοποθετείται το θικάρι της βαλβίδας. Βλέπουμε εδώ πέρα ότι είναι στην πρόστια medial θέση, με χειρισμούς του χειρουργού έρχεται στην κεντρική θέση. Αυτό είναι βασικό για να ξεκινήσει μετά η τοποθέτηση της βαλβίδας. Το πρώτο βήμα είναι το clocking. Ξέρουμε από το 3D τις γνωστές λήψη που έχουμε από το edge-to-edge repair στην μητροειδή βαλβίδα. Γίνεται alignment του anterior cuff, είναι αυτό εδώ πέρα, το Α2, όπως θα δείξω παρακάτω. Αυτό το cuff, το Α2, το anterior, πρέπει να πάρει αυτή τη θέση, να είναι ακριβώς συστήχως προς την πρόσθετη γλοχίνα της μητροειδούς βαλβίδος. Εδώ είναι ένα παράδειγμα στο οποίο δεν είναι αρχικά στη σωστή θέση. Βλέπουμε στην αρχή το Α2 cuff κοιτάει προς τις 10 η ώρα. Το γυρίσαμε ορολογιακά για να δείξει σωστά στη θέση αυτή που πρέπει να δείξει. Το clocking γίνεται και με το X-plane. Βλέπουμε εδώ πέρα από τις γνωστές λήψεις από το Mitral κλειπή, το Pascal. Αυτή είναι η intercommissural view στην βαλβίδα. Βλέπουμε υπάρχει ένα short cuff. Θα σας δείξω μετά τι είναι αυτό στο X-plane. Ένα short cuff εδώ, ένα short cuff αυτό εδώ και το long cuff που είναι αυτό εδώ πέρα. Αυτό έχει σημασία για το clocking, να παρακολουθήσουμε σωστά ότι είναι ακριβώς αυτό, είναι short και long. Οτιδήποτε άλλο δείχνει ότι η βαλβίδα έχει κάνει λάθος clocking και άρα είναι λάθος να συνεχίσουμε. Πρέπει να βρούμε το σωστό clocking για να προχωρήσουμε στο δεύτερο βήμα, το οποίο είναι η intraannular deployment της βαλβίδας. Πρώτα θα κουμπίσει πίσω, βλέπουμε εδώ πέρα το posterior cuff, μετά θα έρθουν μέσα θα έρθουν η γωνία αυτή της βαλβίδας μέσα στον μητροειδικό δακτύλιο και το τελικό αποτέλεσμα είναι αυτό. Θα έρθει πάλι αυτό που σας έδειξα προηγουμένως, το short και long cuff. Αυτή είναι μια σωστή θέση της βαλβίδας, ανοιγοκλίνουν καλά οι πτυχές της, είναι σταθερή, δεν έχει παραβαλβιδική διαφυγή. Και αυτές είναι εικόνες πάλι από την επέμβαση. Εδώ πέρα μέσα είναι η βαλβίδα μέσα στο θηκάι, το οποίο αποσύρεται σιγά σιγά και το τελικό αποτέλεσμα είναι αυτό εδώ πέρα της βαλβίδος. Και το τελευταίο κομμάτι είναι και το πιο σημαντικό πιθανώς. Θα πρέπει οι χειρουργοί να κλείσουν με αυτό το pad. Υπάρχουν δύο μεγέθη από pads για την μέθοδο αυτή. Κλείνουν αυτό και το άλλο είναι το Tether Load System, αυτό το TLS, με το οποίο ουσιαστικά κρατάει σε τάση με αυτό εδώ πέρα το tether, με αυτό το σκηνή, κρατάει σε τάση το pad, την βαλβίδα, που είναι πολύ σημαντικό για τους πρώτους 3-4 μήνες της βαλβίδας μέχρι να ενδοθυλοποιηθεί και να μην κουνιέται, και με ένα πολύ πολύπλοκο αλγόριθμο που κάνουν οι τεχνικοί της εταιρείας εκείνη τη στιγμή, αυξάνουν, μειώνουν την τάση. Ο σκοπός είναι να είναι η βαλβίδα σταθερή, να μην έχει obstruction στο χώρο εξόδου της αριστεράς κοιλίας, να μην έχει παραβαλβιδική διαφυγή, να παραμένει σε σταθερή θέση. Αυτό είναι το τελικό αποτέλεσμα που είχαμε από τη βαλβίδα μας. Ο ασθενής έφυγε από το νοσοκομείο σε 7 μέρες, δεν είχε προβλήματα. Άμεσα μειώθηκε η ανάγκη της για διουρητικά. Ένα υπερηχογράφημα που κάναμε πριν 2 περίπου εβδομάδες, βλέπουμε εδώ πέρα το δραστικό στρώμα της βαλβίδας είναι κοντά 3 τετραγωνικά εκατοστά. Αυτό είναι από το χώρο εξόδου της αριστεράς κοιλίας. Δεν είναι obstruction πραγματικά, γιατί να θυμίσω έχει και μηχανική αορτική βαλβίδα η ασθενής, έχει μια ταχύτητα στα 2 μέτρα. Εδώ βλέπουμε το 3D, το χώρο εξόδου της αριστεράς κοιλίας, ο οποίος με κανέναν τρόπο δεν παρακωλείεται. Εδώ πέρα είναι το tether που έδειξα προηγουμένως. Και στα 2 χρόνια, να πω, από αυτούς τους 100 ασθενείς, φάνηκε ότι 97% υπήρχε procedural success. Στα 2 χρόνια είχαν λιγότερες νοσηλίες, είχαν σχεδόν το 93% δεν είχε καθόλου ανεπάρκεια μητροειδούς, είχαν βελτίωση των συμπτωμάτων που κράτησε για 2 χρόνια. Βέβαια, στους πρώτους 3 μήνες παρατηρήθηκε μια αυξημένη θνητότητα, πιθανώς γιατί και οι ασθενείς αυτοί ήταν ψηλού διεγχειρητικού κινδύνου, και εμάς την πρώτη ασθενή που είχαμε στείλει για screening με 25 κλάσμα την απέρριψαν, και νομίζω σωστά έκανε η εταιρεία και την απέρριψε. Και τελειώνοντας με αυτό, να πω ότι δεν προτείνω ότι αυτή πρέπει να είναι η μέθοδος εκλογής, αλλά είναι και αυτή μια επιλογή όταν δεν βοηθάει η edge-to-edge θεραπεία. Ευχαριστώ πολύ.
Βαλβίδα, παρόμοιες βλέποντας την, καταλαβαίνω ότι το κόνσεπτ είναι ίδιο με την Intrepid, που ήταν και αυτήν transapical, οπότε βλέποντας την επέμβαση θυμήθηκα τις επεμβάσεις που κάναμε το 2016, είναι το ίδιο κόνσεπτ. Ήθελα να σε ρωτήσω και τον Μιχάλη του Χρυσοχέρη που είναι εδώ. Σίγουρα αυτή η ανατομία ήταν αποτρεπτική για mitral clip, γιατί είχε ασβέστιο στην οπίστια γλοχίνα και ήταν σχετικά κοντή. Πιστεύεις ότι ήταν αποτρεπτική για Πασκάλ αυτή η ανατομία, Μιχάλη? Μου φάνηκε ότι θα ήταν...
Ναι, δεν είδα την πλήρη χαρτογράφηση της οπίστιας γλοχίνας που κάνουμε με biplane, το sweep που πάμε από μια πλευρά στην άλλη. Ίσως αν είχε έστω υποτυπωδώσει 6-7 χιλιοστά να μπορούσε να πιαστεί με Πασκάλ. Αλλά δεν μπορώ.
Το mitral clip κλείνει σφιχτά. Αν φτάσει σε αυτό το ασβέστιο και κλείσει, υπάρχει υψηλό ρίσκο να σκίσει σε εκείνο το σημείο. Ενώ αντίθετα το Πασκάλ, επειδή έρχεται με τον άλλο το μηχανισμό.
Ομολογώ ότι την περίμενα την ερώτησή σου, γιατί ξέρω ότι το έχεις ως alternative για τα περιστατικά που δεν είναι. Εμείς δεν έχουμε καμιά εμπειρία με το Πασκάλ, οπότε υποχρεωτικά θα κάναμε κάτι διαφορετικό από αυτό. Αλλά σίγουρα, από ό,τι έχω δει και σε δικές σας δουλειές, θα μπορούσε να είναι μια εναλλακτική. Αλλά εμείς δεν έχουμε καμία εμπειρία με το Πασκάλ.
Ωραία, ευχαριστούμε πολύ, κύριε Λουντιάδη. Προχωράμε στην παρουσίαση του κυρίου Λάκα. Ο τίτλος «Take it or leave it».
Καλησπέρα και από μένα. Ελπίζω να μ' ακούτε και να φαίνεται και η παρουσίαση.
Ναι, σας βλέπουμε.
Φαίνεται η παρουσίαση αυτό.
Βεβαίως, βεβαίως.
Και ευχαριστώ πολύ. Να ευχαριστήσω για την τιμητική πρόσκληση. Το περιστατικό μας είναι ένας ασθενής 82 ετών. Ο γολγοθάς του ξεκινάει τον Αύγουστο του 2021 με μια μακρά νοσηλεία, όπως θα δείτε πιο κάτω, νύχα 3/4, τα επιδείνωση συμπτωμάτων το τελευταίο μήνα και στη θάχη, αν έπαιρνε κανείς προσεκτικό ιστορικό. Έχει μεγάλο ιστορικό, το πρώτο κάμπιτς ουσιαστικά έκανε κάμπιτς το 1996 με 3 μοσχεύματα, 1 αρτηριακό και 2 φλεβικά, όπως βλέπετε. Έκτοτε 2 νοσηλείες για νοσθέμη, η δεύτερη μετά από πολλά χρόνια από την πρώτη, με 2 γεωπλαστικές. Έχει πολύ σημαντική υπερλιπιδεμία, παρόλο που έπαιρνε αγωγή και αρτηριακή υπέρταση στο ιστορικό του. Αρχικά, επειδή ήταν σε πολύ κακή κατάσταση και πολύ απορριθμισμένος, το πρώτο που σκεφτήκαμε είναι να κάνουμε πάρα πολύ εντατική διούρηση και να φτιάξουμε και την υπόλοιπη του φαρμακευτική αγωγή, μήπως δούμε βελτίωση, σκεπτόμενοι ότι θα πρέπει να στείλουμε εργαστηριακά, να κάνουμε κρυοδράφημα και τηλεμετρία γιατί έχει ισχυμική καρδιακή ανεπάρκεια, να κάνουμε ένα υπέροχο καρδιάς και ένα six-minute walking test για να δούμε τη λειτουργική του κατάσταση. Στο βάθος της σκέψης μας ήταν και η στεφανιογραφία. Όταν έχεις τέτοιο βαρύ εγκιακό ιστορικό, σίγουρα οπωσδήποτε θα σκεφτόταν τη στεφανιογραφία σαν πλάνο. Από τα εργαστηριακά του δεν έχω να σας πω κάτι τραγικό. Κρατηνή του 0,8, αλλά με τα διουρητικά έφτασε 1,6 και λίγο πιο πάνω όσο περνούσαν οι μέρες. Είχε μια συνεχή μικρή κίνηση τροπονίνης, πολύ ψηλή LDL για όλο αυτό το ιστορικό, παρόλο που έπαιρνε ρεσούβα στα 40 και η σκέψη μας ήταν ότι αυτός ο ασθενής είναι σαφώς κατάλληλος για PCSK9. Το NT-proBNP ήταν δυσθεώρητο το μέγεθος, είναι 8.700. Στην τηλεμετρία του είχε φλεβόκομβο σε γενικές γραμμές, είχε σφίξεις 85, είχε διαταραχές στο ΕΣΤΕ, διάφορες έκτακτες χειλιακές στολές και διπλέτες και ένα επεισόδιο ενός ασθενή δυτή, το οποίο μας έβαλε σε προβληματισμό για το τι πρέπει να κάνουμε. Από τον υπέρηχο καρδιάς βλέπουμε μια κοιλία κακή, με ένα κλάσμα γύρω στο 30 με 35, με σοβαρή στένωση αορτικής βαλβίδας και σοβαρή ανεπάρκεια μετροειδούς βαλβίδας ισχαιμική λόγω τέδερινγκ της οπίστιας βλοχίνας. Εδώ σε αυτή τη διαφάνεια επιβεβαιώνονται και αυτές οι μετρήσεις. Η δεξιά του κοιλία είχε και αυτή επηρεασμένη συστολική λειτουργία με ενοριακό τάψη και διάταση. Παρόλο που κάναμε την εντατικά τη διούρηση και ρυθμίσαμε την αγωγή του, κάνουμε ένα six-minute walking test, ήταν 300 μέτρα, αλλά αυτά τα βγάλε με πάρα πολύ ζόρι, με δύσπνοια που αναγκάσαμε να τη διακόψαμε οξέως και να τον βάλουμε να κάνουμε ενδοφλέβιο λασίξ, οξυγόνο και σχεδόν νοσηλεία στη μονάδα. Παρέμενε ο ασθενής παρόλη τη διούρηση σε νύχα 3-4. Λόγω του επεισοδίου του ενός ασθενή δυτή, της σοβαρής συστολικής λειτουργίας αριστερής κοιλίας και της σοβαρής αορτικής στένωσης έδαφος και χαμηλής παροχής και της σοβαρής ισχαιμικής ανεπάρκειας μητροειδούς, αρχικά είπαμε θα δούμε πώς θα το κάνουμε, θα ξεκινήσουμε μια στεφανιογραφία και να δούμε πού θα φτάσουμε. Στη στεφανιογραφία, για να μην τα πολυλογώ, είχε αρκετά σημαντικά προβλήματα, με χειρότερη την περιοχή κατανομής του προστίου διάμεσου κλάδου μετά το στέλεχος. Γι' αυτό και με αυτό το ιστορικό, με την ήπια αύξηση τροπονίνης συνεχώς και με την όσα στενηβητή στην τηλεμετρία, αποφασίστηκε αρχικά να γίνει αγιοπλαστική στον στέλεχος διάμεσο κλάδο, όπως και έγινε επιτυχώς. Ο ασθενής συνέχισε να μην βελτιώνεται. Ουσιαστικά είναι λάθος αυτή η διαφάνεια. Ουσιαστικά παρέμεινε νύχα 3 μετά την βέλτιστη φαρμακευτική αγωγή και μετά από τόσες πολλές μέρες νοσηλείας χωρίς βελτίωση, θέλαμε να δούμε πια τι θα κάνουμε αυτή την αορτική βαλβίδα σαν δεύτερο στάδιο. Ο ασθενής προσπαθήσε, μια αλήθεια είναι αυτή, επειδή ήταν χαμηλής παροχής, να την κάνουμε ένα στρεσέκο για να αποδείξουμε ότι έχει ότι είναι αληθώς σοβαρή η στένωση. Δεν καταφέρουμε ποτέ, γιατί πάνω στο ΕΣΕΚ ο ασθενής έκανε πνευμονικό είδημα, του μεταφέρουμε οξέως στη μονάδα και διακόψαμε. Κάναμε μια αξονική θόρυβος για σκόρας βυστίου, το οποίο ήταν 3.500, οπότε δεν θέλαμε και κάτι άλλο για την σοβαρή στένωση. Το χαρτί μου βλέπετε, το Euroscore είναι πάρα πολύ μεγάλο. Αποφασίστηκε να γίνει τάβη επειγόντως κατά τη διάρκεια της νοσηλείας του, όπως και έγινε. Εδώ βλέπετε την επιτυχή τοποθέτηση τάβη, την προδιάταση και στο τέλος την επιτυχή τοποθέτηση τάβη. Όπως θα δούμε, ο ασθενής αυτός έλαβε μια βαλβίδα Evolut 34 mm, αλλά 3 μέρες μετά την τάβη τοποθετήθηκε στη CRTD, καθώς είχε το κακό κλάσμα εξώθησης. Είχε LBB μετά την τάβη, το οποίο επιδεινώθηκε με έναν τρίτο βαθμό κολπικυλιακό αποκλεισμό, οπότε έγινε και τοποθέτηση CRTD. Συνολικά 30 μέρες μετά την τοποθέτηση της βαλβίδας, ο ασθενής δεν είχε πάρα πολύ βελτίωση. Η αλήθεια είναι ότι εμείς θέλαμε να είναι συνεχώς εισαγωγή, ο ασθενής δεν άντεχε άλλο και ήθελε να πηγαίνει λίγο σπίτι του. Προσπαθήθηκε να τον παρακολουθούμε πολύ συχνά, είπαμε κάθε 5 μέρες, έγινε πιο συχνά αυτό γιατί έκανε μέσα σε πολύ λίγες μέρες 3 επανανοσηλίες, παρόλο που είχε κάνει αγκιοπλαστική, τάβη και CRTD. Το NT-proBNP από 8.500 ήταν 7.500, οπότε ουσιαστικά ο υπέρηχος καρδιάς του πρακτικά, αν εξαιρέσει κανείς το καλό αποτέλεσμα της τάβη, δεν είδαμε βελτίωση στην δεξιά κοιλία και στην σοβαρή ισχαιμική ανεπάρκεια μητρητούς βαλβίδας. Βλέπουμε το δεξί καθετεριασμό, ο οποίος επιβεβαιώνει την σοβαρή ανεπάρκεια μητρητούς βαλβίδας με το τεράστιο V-wave που είχε, δεν μπορώ να σας δείξω την καταγραφή. Και ουσιαστικά αποφασίστηκε να κάνουμε ένα διεσοφάγιο, να δούμε αν είναι κατάλληλος και για mitral clip. Αυτές είναι οι εικόνες του διεσοφαγίου, το screening ουσιαστικά του ασθενούς για mitral clip, που αποφασίστηκε ότι αυτός ο ασθενής είναι ένας ασθενής κατάλληλος για τοποθέτηση mitral clip, οπότε με Euroscore πλέον 18,7 λιγότερο από το προηγούμενο στο πρώτο χαρτί μου, αλλά παραμένοντας υψηλό, με κάποιο στο ιστορικό του και σαν mitral clip που είναι μέρος της σταδιακής προσέγγισης που κάναμε στον ασθενή με όλα αυτά. Προχωρήσαμε στην τοποθέτηση του mitral clip, όπου τοποθετήθηκε επιτυχώς, και αν δείτε στο κάτω βίντεο βλέπουμε ότι έχει, τώρα που θα φορτώσει, βλέπουμε ότι έχει μόνο ήπια παραμένουσα ανεπάρκεια με mean gradient υπολοιπόμενο 3, οπότε θεωρήσαμε ότι είναι όλα ασφαλή και μπορούσαμε να βγούμε και αφήνοντας το mitral clip στη θέση του. Ο ασθενής πραγματικά βελτιώθηκε και αυτή τη φορά βελτιώθηκε πραγματικά. Πλέον είναι νύχα 2/3, το νέο NT-proBNP είναι 1850, με θεαματική βελτίωση που θα παραμένει αρκετά υψηλό προφανώς, αλλά από 8.500 στους 1853 είναι πάρα πολύ καλό και ο ασθενής μας παραμένει πλέον 4 μήνες εκτός νοσοκομείου, εκεί που κάθε μέρα λέγαμε και τώρα είναι βαριά και τώρα θα καταλήξει και τώρα δεν κάπως πρέπει να αντιμετωπιστεί παραπάνω. Αυτός είναι ο υπέρηχός του πριν λίγες ημέρες. Βλέπουμε ότι αυτή είναι η συστολική λειτουργία της αριστερής του κοιλίας. Πλέον έχει βελτιωθεί η λειτουργία της δεξιάς του κοιλίας. Υπάρχει μόνο η ήπια ανεπάρκεια μητροειδούς. Οι πιέσεις πλήρωσής του έχουν πέσει. Παραμένει το mean gradient γύρω στο 2 με 3. Δεν έχει στένωση αορτικής βαλβίδας και δουλεύει πολύ καλά η τάβη. Και το συμπέρασμα ουσιαστικά που ήταν και δεκτικό για μας είναι ότι μπορεί να παραλαμβάνεις έναν άρρωστο, ο οποίος είναι σε αυτή την κατάσταση, σαν ένα ανοιχτό εργοτάξιο που δεν ξέρεις τι θα πρωτοφτιάξεις, και στο τέλος να παραδίδεις ένα εργαλείο που μοιάζει με αυτό το πολύ ακριβό και αυτοκίνητο, αλλά στο τέλος έχεις έναν άρρωστο που είναι πολύ ευχαριστημένος και προφανώς δεν έχει έρθει ξανά και στο νοσοκομείο. Γι' αυτό είναι και το μήνυμα και το ονομάζουμε Take it to live, γιατί αυτόν τον άρρωστο ή θα τον έλεγες από την αρχή ότι αυτός είναι ένας πολύ βαριά άρρωστος και θα καταλήξει με μια πολύ μεγάλη νοσηλεία, ή θα φτάσει μέχρι τέλους όπου μπορείς να φτάσεις, παρέχοντας ό,τι μπορείς να παράσχεις στον άρρωστο και βελτιώνοντάς τον όσο μπορείς. Σας ευχαριστώ πολύ.
Ευχαριστούμε πολύ, κύριε Λάκα. Ίσως μας διέφυγε την μαστική του, την απεικονίσατε στην...
Ναι, ήταν καλή.
Ήταν βατή και κάνατε μια PCI σε ένα διάμεσο.
Σε ένα στέλεχος προς διάμεσο κλάδο. Σε ένα διάμεσο.
Μάλλον ήταν ίσονος σημασίας, είχε άλλα προβλήματα ασθενής.
Εντάξει, αλλά όταν
η κοιλία του ήταν χάλια, η βαλβίδα του ήταν στενή, η άλλη βαλβίδα ανεπαρκούσε. Οπότε η στεφανία του δεν είχε ίσως τόσο ρόλο. Δύσκολο περιστατικό, πολλαπλές παρεμβάσεις. Το ένα έφερνε το άλλο. Συγχαρητήρια για την εξέλιξή του. Από τον κύριο Ηλιόπουλο έχουμε ένα σχόλιο.
Ένα γρήγορο σχόλιο. Απλά σκέφτηκα ότι αυτός ο ασθενής στα 58 του πήρε μια μαστική και 2 φλεβικά και νομίζω ότι όλα ξεκίνησαν κυρίως από την ισχαιμικού τύπου κατάσταση στη μητροειδή, έτσι, τη δευτροπαθή, και αυτό έφερε το ένα, έφερε το άλλο από πίσω. Να προσέχουμε λίγο τις πρώτες επεμβάσεις.
Κυρία Βορανάκη, παρουσιάσει το επόμενο.
Ναι, προχωράμε. Ο επόμενος ομιλητής είναι συνεργάτης και δικός μου, είναι ο Στρατής ο Κατσιάνος. Θα παρουσιάσει ένα πολύ ενδιαφέρον περιστατικό που είχαμε την ευκαιρία να πραγματοποιήσουμε τότε που ήμασταν στο Ιπποκράτιο. Στρατή, σε ακούμε.
Καλησπέρα από μένα. Μισό λεπτάκι να κάνω το share screen. Βλέπετε τις διαφάνειές μου?
Ναι.
Καταρχάς, ευχαριστώ πολύ και εγώ για την ειδική πρόσκληση σε ένα τόσο ενδιαφέρον συνέδριο και μέσα στα επόμενα λίγα λεπτά θα σας παρουσιάσω ένα περιστατικό το οποίο μας απασχόλησε και το αντιμετωπίσαμε στο αιμοδυναμικό εργαστήριο με τον καθηγητή και την υπόλοιπη ομάδα. Πρόκειται για έναν 82χρονο άνδρα, ο οποίος προσήλθε σε εμάς αιτιόμενος προοδευτικός επιδεινούμενη δύσπνοια προσπαθίας λειτουργικό στάδιο Ι3, λόγω μιας μη ισχαιμικής κατά βάση μυοκαρδιοπάθειας με χαμηλό κλάσμα εξώθησης της τάξης του 30 με 35%, προστατευμένος με διεστιακό απεινιδωτή στα πλαίσια πρωτογενούς πρόληψης. Στο μεσοδιάστημα είχε πέσει πλέον σε μόνιμη κολπική μαρμαριγή με στενό σύμπλεγμα QRS υπό αντιπικτικό νεότερης γενιάς και ένας ασθενής με προχωρημένη νεφρική νόσο καθώς και με προχωρημένη χρόνια υποφρακτική πνευμονοπάθεια με ένα χαμηλό FEV1 κάτω από 1 λίτρο. Ο ασθενής λάμβανε κατά το δυνατό ανεκτή πλήρη αγωγή καρδιακής ανεπάρκειας με χαμηλό κλάσμα εξώθησης, με εκπροσώπους και από τις 4 βασικές κατηγορίες φαρμάκων καρδιακής ανεπάρκειας. Η διαφορετική μελέτη του ανέδειξε ένα μειωμένο κλάσμα εξώθησης με μια αριστερή κοιλία αυξημένων διαστάσεων και με το έγχρωμο καθώς και με το συνεχές και παλμικό ντόπλερ ανεδείχθη αυτή η σημαντική ανεπάρκεια της μητροειδούς βαλβίδας με έκεντρο τζετ προς το πλάγιο τείχομα του αριστερού κόλπου με τις ακόλουθες μετρήσεις με ένα υπολογιζόμενο regard stand volume στα 45 ml, ένα αερόα στα 0,32 τετραγωνικά χιλιοστά, ενώ η τελοσυστολική διάμετρος της αριστερής κοιλίας στα πλαίσια της υπερφόρτης όγκου αλλά και της πρωτοπαθούς μυοκαρδιακής νόσου ήταν 45 χιλιοστά. Ο μηχανισμός της μητροειδικής ανεπάρκειας διερευνήθηκε περαιτέρω με διεισοφάγιο υπερηχοκαρδιογράφημα, όπου ανεδείχθη το έκεντρο τζετ προς το πλάγιο τείχομα του αριστερού κόλπου, λόγω κατά βάση καθήλωσης της οπίστιας γλοχίνας της μητροειδούς, ενδεχομένως και με κάποια στοιχεία atrial functional MR λόγω διάτασης του μητροειδικού δακτυλίου. Επομένως, μιλάμε για ένα μηχανισμό κατά Καρπεντιέ 3β και σε επίπεδο βαρύτητας μια severe ανεπάρκεια της μητροειδούς λειτουργικής αιτιολογίας. Όσον αφορά τώρα το screening για πιθανή δεκαθετηριακή θεραπεία, ο ασθενής μας τόσο σε επίπεδο του βαλβιδικού μηχανισμού όσο και σε επίπεδο της αριστερής κοιλίας θεωρήθηκε κατάλληλος για πιθανή διακαθετηριακή εμφύτευση, αντιστοιχώντας στην μελέτη COAP, δηλαδή σε έναν ασθενή με proportionate ανεπάρκεια της μητροειδούς βαλβίδας. Στα πλαίσια τα προεπεμβατικά διενεργήθηκε και στεφανιογραφικός έλεγχος που ανέδειξε αιμοδυναμικά μη σημαντικές στενώσεις. Όσον αφορά αυτή την νόσο στελέχος που βλέπετε στο άπος τέλεχος, διενεργήθηκε άιβους με ικανοποιητικό MLA. Συζητήσαμε το περιστατικό στην ομάδα καρδιάς. Ο ασθενής δεν είχε κάποια επιπλέον θεραπεία που θα μπορούσε να λάβει, στενό QRS υπενθυμίζω, όχι κάτι προς επαναιμάτωση και λόγω του χαμηλού FEV1 θεωρήθηκε ανεγχείρητος, οπότε προκρίθηκε η διακαθετηριακή θεραπεία ως η καταλληλότερη. Έτσι λοιπόν, λίγες εβδομάδες αργότερα προγραμματίστηκε η επέμβαση. Εδώ βλέπετε τις αρχικές εικόνες με έγχρωμο Doppler πριν από το Transeptal Puncture με μια χαμηλή πίεση λόγω της καταστολής, την οποία διορθώσαμε αμέσως με αγγειοδραστικά με νοradrenalίνη. Ασθενείς με χαμηλό κλάσμα εξώθησης, βλέπουμε το πολύ έντονο spontaneous contrast στον αριστερό κόλπο, ενώ το οτίο είναι ελεύθερο θρόμβων. Στη συνέχεια ακολούθησε η προσπάθεια παρακέντησης του μεσοκολπικού διαφράγματος, βλέπετε το tending σε biplane τομή και λόγω του έντονου spontaneous contrast και του χαμηλού κλάσματος εξωθήσεως δόθηκε η παρίνη 2.000 μονάδες προτού γίνει το Transeptal. Επιτυχής παρέντηση του μεσοκολπικού διαφράγματος και άμεση χορήγηση παρίνης με ένα επιτευθέν ACT στα 380 millisecond. Ωστόσο, ενώ έχει διέλθει το Amplat Super Stiff σύρμα προς την αριστερή άνω πνευμονική φλέβα, η περιοκαρδιογραφική μας ομάδα από την καθηγήτρια την κυρία Γκέλη και την κυρία Μολδοβάν εντοπίζει αυτό το κίνητο μόρφωμα πάνω στο stiff σύρμα συμβατό με θρόμβο. Γεγονός που επιβεβαιώνεται και στην τρισδιάστατη μελέτη, ενώ ταυτόχρονα βλέπουμε ότι έχει εισέλθει οριακά μέσα στον αριστερό κόλπο το steerable guide μαζί με τον διαστολέα του. Επομένως, έχουμε να κάνουμε με μια οξία δημιουργία θρόμβου εντός του αριστερού κόλπου πάνω στο Amplatz stiff σύρμα μας και αυτό σχεδιάσαμε να το αντιμετωπίσουμε ως εξής. Αρχικά αφαιρέσαμε οριακά τον διαστολέα του θηκαριού και στη συνέχεια υπό συνεχόμενη αναρρόφηση τραβήξαμε το stiff σύρμα ούτως ώστε να μπει μέσα στο θηκάρι και στη συνέχεια υπερηχογραφικά όλα αυτά, αφού έχουμε εξασφαλίσει ότι το σύρμα δεν είναι πλέον στον αριστερό κόλπο αλλά βρίσκεται μέσα στο θηκάρι, εν μπλοκ αφαιρέσαμε και το stiff guide και το stiff σύρμα μας με σκοπό να αφήσουμε τον θρόμβο ή τέλος πάντων υπόλοιμα αυτού μέσα στον δεξιό κόλπο, μειώνοντας το κίνδυνο συστηματικής εμβολής για τον ασθενή. Αυτό είναι το τελικό αποτέλεσμα. Φυσικά η μελέτη, φυσικά η επέμβαση διεκόπη. Ο ασθενής έλαβε πλήρη αντιπικτική αγωγή με αναστολή της βιταμίνης K. Υπενθυμίζω ότι ήταν ασθενής σε νεότερο αντιπικτικό, προσαρμοσμένη στην νεφρική του λειτουργία δόση NOAC. Αφού εξασφαλίσαμε ότι για ένα μήνα επέτυχε επιθυμητό INR, επαναλάβαμε την επέμβαση, δεν φαίνεται θρόμβος στον δεξιό κόλπο, είχε λυθεί και ακολούθησε η επιτυχής εμφύτευση ενός XT clip με πολύ καλό επεμβατικό αποτέλεσμα και κλινικό. Ασθενής σε ένα follow-up 3 μηνών είναι ολιγοσυμπτωματικός με πολύ μειωμένη ανάγκη για διουρητική αγωγή. Και δύο λόγια για την πιθανότητα θρόμβου κατά τη διάρκεια της επέμβασης Mitral Clip. Είναι μια επέμβαση η οποία μπορεί να οδηγήσει σε κάτι και πολύ χαμηλό incidence. Παρ' όλα αυτά μιλάμε για ασθενείς με βραδίες ροές, με κολπική μαρμαριγή. Από τη μία μεριά αυτοί είναι οι παράγοντες ασθενούς, από την άλλη μεριά χρησιμοποιούνται ούκο λίγα υλικά, σύρματα, καθετήρες, ενώ και το ίδιο το Transeptal αποτελεί ένα μικρό τραυματισμό για το μεσοκολπικό διάφραγμα. Σε μια πρόσφατη μελέτη από ένα πολωνικό κέντρο, το κλάσμα εξωθήσεως της αριστερής κοιλίας, το χαμηλό κλάσμα εξωθήσεως της αριστερής κοιλίας, ανεδείχθη ως ένας μοναδικός σημαντικός παράγοντας κινδύνου για θρόμβο κατά τη διάρκεια του Mitral Clip. Σε άλλη μια μελέτη που έγινε με σκοπό να να δει το υλικό που προκύπτει από διάφορα μικροεμβολικά επεισόδια κατά τη διάρκεια της επέμβασης, κατά βάση πρόκειται για θρομβωτικό υλικό, ενώ τα case reports που αναφέρονται στη βιβλιογραφία είναι πραγματικά μετρούμενα στα δάχτυλα του ενός χεριού. Κατά βάση η τακτική που ακολουθήθηκε είναι αυτή που ακολούθησε και ο καθηγητής ο κ. Βαβουρανάκης, και σε ένα άλλο περιστατικό με μεγαλύτερο θρομβωτικό φορτίο και σε ασθενή χαμηλού αιμορραγικού σχετικά κινδύνου χορηγήθηκε in situ low dose θρομβόληση με 0,3 μιλιγκράμμα ανά κιλόγραμμο αλτεπλάσης. Επομένως, κλείνοντας, ο σχηματισμός θρόμβου περιεπεμβατικά είναι μια σπάνια επιλογή, αλλά με μεγάλο κίνδυνο συστηματικής εμβολής για τον ασθενή. Φυσικά, οι ασθενείς με λειτουργική ανεπάρκεια της μητροειδούς, χαμηλά κλάσματα και βραδίες ροές βρίσκονται σε μεγαλύτερο κίνδυνο, ενώ ο ρόλος του διεισοφάγιου περιχογραφήματος είναι πολύ σημαντικός τόσο για την άμεση αναγνώριση του προβλήματος, όσο και για την καθοδήγηση του management που θα σχεδιάσει η ομάδα κατά τη διάρκεια της επέμβασης. Αυτό, σας ευχαριστώ πολύ.
Ευχαριστούμε πολύ, Στρατή, και την παρουσίαση. Νομίζω ότι